हाय
हाय
वर्कबुक पीडीएफ मिल जाएगा
हाय वर्कबुक पीडीएफ मिल जाएगा
you'll be getting the workbook pdf okay. So good morning to all of you and welcome to this INICET Marathon series. We start with the first lecture of anatomy. Okay. We have got a rapid revision plan. एक बार देख लो. So there are videos, question banks होते हैं इसमें, test series होती है. So that is an RR series, rapid revision. We have got a mentorship guide by INI alumni. That's a schedule of the entire lecture series that we are going to conduct from Saturday to Friday. ये पूरा sequence of lectures दिया गया है. Okay, so let us now begin with anatomy. Good morning to all of you. I'm Dr. Pradeep Pawar, Professor of Anatomy at PW MedEd. ठीक है, चलो, let us understand. Let it be an interactive session, बच्चों. Whatever you know, you can answer. Okay, we'll start with this first. हाँ, इसमें काफी visuals है, थोड़े से one-liners है. Everything we are mixed. We'll start. What is this clinical condition? Concept पे focus करो. We are focusing on the concepts. MCQs you will be able to solve. So we'll focus mainly on the concepts. Hi Gaurav. Hi Dharmesh. Samya. Samyak. Hi. Javed. So the first is wrist stop. Wrist stop. Tell me, wrist stop is injury to the radial nerve. Radial nerve. अगर radial nerve axilla में injury हुआ, radial nerve spiral groove में injury हुआ, or the radial nerve gets injured on the lateral aspect of the arm, you'll get a wrist stop, which is the main muscle involved in extension of the wrist. बोल सकते हो? The main muscle responsible for extension of the wrist. चलो बच्चों बोलो. The main muscle is ECRL. ये है wrist drop. Okay. So the main muscle responsible for extension of wrist is extensor carpi radialis longus. And ये जो extensor carpi radialis longus है, इसे कौन supply करती है? This is supplied by the radial nerve. Radial nerve. And where does the radial nerve supply? On the lateral aspect of the arm. Extensor carpi radialis longus को radial nerve supply करती है on the lateral aspect of the arm. इसके बाद the radial nerve enters the cubital fossa, divides into a superficial branch and a deep branch. ठीक है ना? Cubital fossa में divides into a superficial and deep branch. The deep branch of radial nerve is known as, बोल सकते हो? The deep branch. हाँ, तो cubital fossa में, I'll just write it down for you. Cubital fossa में the radial nerve divides into a superficial branch and a deep branch. Deep branch का नाम है posterior introitious nerve. Superficial branch is sensory. ये sensory होता है and injury to this posterior introitious nerve would lead to what? बोल सकते हो? हाँ. Injury to this posterior introitious nerve would lead to paralysis of this muscles. Extensor muscles of the forearm, extensor digitorum involved होता है. You get this. What is this known as? A finger drop. Finger drop. So अगर pin involvement होता है तो you get a finger drop. And अगर radial nerve injury होती है तो अगर radial nerve injury होती है तो you'll get a wrist drop and you'll get a finger drop also. बराबर है ना? अगर radial nerve injury होती है तो दोनों nerves गए ना, superficial भी गया, deep भी गया. So you'll get both a wrist drop and finger drop. But अगर posterior introitious nerve का injury होता है, so that you will be getting only a finger drop. Finger drop. Very good, Gaurav. Very good. ठीक है. So the just try to understand this. PDF मिल जाएगा बच्चे, PDF मिल जाएगा. Once this lecture is over, you'll be getting the PDF. Don't worry about that. So the first thing is wrist drop, injury to the radial nerve anywhere in the axilla, spiral groove or the lateral aspect of the arm. बस ये याद रखना. इसके बाद radial nerve divide होती है into a superficial and deep branch. अगर deep branch injury होती है तो we get a finger drop. Perfect है? Okay. Fine. So that's wrist drop. Answer this. What is this? This is the flattening of the thenar eminence. Flattening of thenar eminence. कभी मिलता है ये? Answer this. flattening of the muscles of the thenar eminence. What is that? This is a compression of the median nerve in the carpal tunnel. ये देख रहे हो ना? This is the flattening of thenar eminence. What is that known as? This is what we call as a carpal tunnel syndrome. Carpal tunnel syndrome. मीडियन नर्व कितने मसल्स को सप्लाई करती है हैंड में? कंप्रेशन ऑफ द मीडियन नर्व इन द कार्पल टनल इज नोन एज कार्पल टनल सिंड्रोम. हाउ मेनी मसल्स डज अ मीडियन नर्व सप्लाई इन द हैंड? 5 मसल्स. 5 मसल्स शॉर्ट में बोलो. abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, and first and second lumbrical. First and second lumbrical. So 5 muscles median nerve supplies in the hand. Compression of median nerve in the carpal tunnel को बोलते हैं carpal tunnel syndrome. ठीक है, मसल्स के नाम क्लियर है ना? abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, the first and the second lumbrical. Very good, very good. बहुत अच्छे से आंसर कर रहे हो. Just try to understand, try to correlate. Concepts पे जोर लगाओ. Be very clear with your concepts. MCQs you'll be able to solve. Fine. Okay, that's it. Tell me now, बच्चों, what is this clinical condition? What is this clinical condition? Any guesses? Yes? ये clinical condition क्या है? इसमें ना, see this shoulder. ये shoulder देखो, ये shoulder देखो. कुछ difference लग रहा है? कुछ difference लग रहा है? So this is the wasting of deltoid. Okay, इसको क्या बोलते हैं? What do you call this as? इसे हम बोलते हैं flat shoulder. Flat shoulder. Flat shoulder. ये जो कंटूर होता है शोल्डर का, कंटूर ऑफ द शोल्डर, द शेप ऑफ द शोल्डर, ये किससे होता है? डेल्टॉइड से. एंड दिस शेप ऑफ द शोल्डर इज बिकॉज ऑफ डेल्टॉइड. व्हेन द डेल्टॉइड इज पैरालाइज्ड, द शोल्डर बिकम्स फ्लैट. इसे हम बोलते हैं फ्लैट शोल्डर. अभी बोलो, डेल्टॉइड इज सप्लाइड बाय व्हिच नर्व? एक्सिलरी नर्व. वेरी गुड, वेरी गुड. एक्सिलरी नर्व, फ्लैट शोल्डर. यस, एक्सिलरी नर्व 2 मसल सप्लाई करती है. कम ऑन स्टूडेंट्स, एक्सिलरी नर्व के बारे में जो पता है, लेट अस डिस्कस. एक्सिलरी नर्व, इट्स अ ब्रांच ऑफ पोस्टीरियर कॉर्ड ऑफ ब्रेकियल प्लेक्सस. रूट वैल्यू ऑफ एक्सिलरी नर्व C5 C6. ऐसे कोई भी टॉपिक है ना, यू शुड बी एबल टू नो द पॉइंट्स. ठीक है, ब्रांच ऑफ पोस्टीरियर कॉर्ड, रूट वैल्यू C5 C6. एक्सिलरी नर्व पासेस थ्रू अ स्पेस. वो स्पेस का नाम बोल सकते हो? Axillary nerve goes to a space जिसका नाम है quadrangular space. Now the axillary nerve supplies 2 muscles. 2 muscles supply करता है ये deltoid and बोलो which is the other muscle? Yes, anyone? Deltoid and axillary nerve supplies 2 muscles. एक है deltoid, दूसरा yes. बोलो गौरव, जावेद. Yes, all of you answer. Be interactive, बच्चों. जितना interact करोगे उतना easy होगा आपके लिए भी. And even if you make mistakes, that's okay. है ना? यहाँ पे mistake करोगे तो that's fine. That's not a problem. Teres minor, very good. So deltoid and teres minor, ये 2 muscles को supply करती है axillary nerve. And axillary nerve एक cutaneous branch देती है. It gives a cutaneous branch. उसका नाम upper lateral cutaneous nerve of arm. याद रखना बच्चों, बहुत ज्यादा इंपॉर्टेंट है. upper lateral cutaneous nerve of arm. And injury to this nerve leads to trapezius नहीं बच्चे, trapezius नहीं. It supplies the deltoid and teres minor. एक cutaneous branch देता है जिसका नाम है upper lateral cutaneous nerve of arm. Injury to this nerve leads to, yes, बोलो, regimen batch साइन. रेजिमेंट बैच साइन, ये याद रखना, वेरी इंपॉर्टेंट. रेजिमेंट बैच साइन. यस, रेजिमेंट बैच साइन क्या होता है आपको पता है ना? द आर्मी दे पुट अ बैच, आर्मी पीपल पुट अ बैच, रेजिमेंट बैच. एंड ये जो बैच होता है ना, ये एरिया का स्किन को कौन सप्लाई करती है? अपर लैटरल क्यूटेनियस नर्व आर्म. यस, वेरी गुड. सो इंजरी टू दिस एक्सिलरी नर्व leads to regiment batch sign. बस that's very important. Deltoid, teres minor, regiment batch sign. ये याद रखना. Rounded contour of the shoulder is lost. इसे बोलते हैं फ्लैट शोल्डर. फाइन, परफेक्ट, वेरी गुड. नाउ टेल मी, व्हाट इज दिस? ये लास्ट देख लो. व्हाट इज दिस? बोलो, व्हाट इज दिस क्लिनिकल कंडीशन? सो कुछ क्लिनिकल कंडीशंस है ये. इसके कॉजेस याद रखिए. व्हाट इज दिस क्लिनिकल कंडीशन? The medial border of the scapula prominent है. Medial border of the scapula prominent है. What is this clinical condition? Winging of scapula. Very good, very good. Winging of scapula. वैसे winging of scapula is caused due to paralysis of 2 muscles. 2 muscles. Any guesses? हाँ, एक है सेराटस एंटीरियर. ओके, सो दैट्स विंगिंग ऑफ स्कैपुला. दो मसल्स के पैरालिसिस से होता है ये सेराटस एंटीरियर एंड ट्रेपीजियस. सेराटस एंटीरियर पैरालिसिस से भी विंगिंग होता है, ट्रेपीजियस पैरालिसिस से भी विंगिंग होता है. नाउ हाउ डू यू आइडेंटिफाई दिस? कैसे पता है आपको दिस इज विंगिंग ड्यू टू पैरालिसिस ऑफ सेराटस एंटीरियर और दिस इज विंगिंग ड्यू टू पैरालिसिस ऑफ ट्रेपीजियस? कैसे पहचानोगे इसको? You tell the person to perform a movement like push the wall. अगर वो वॉल को पुश कर रहा है एंड विंगिंग होता है, सो दैट इज विंगिंग ऑन attempting movement. So winging on attempting movement is because of paralysis of serratus anterior. And winging, a person is just sitting, ऐसे ही बैठा है, and this winging of scapula. So winging at rest, trapezius. ठीक है, winging at rest is trapezius. So winging on attempting movement करने पे अगर winging होता है तो that is paralysis of serratus anterior, and winging at rest, that's trapezius. ठीक है बच्चों, क्लियर है, समझ में आ रही है? हाँ, right. Just tell me the nerve supplying the serratus anterior. That's a long thoracic nerve. Long thoracic nerve arises from C5, C6, C7 roots of the brachial plexus. And trapezius को कौन सप्लाई करती है? स्पाइनल एक्सेसरी नर्व. वैसे स्पाइनल एक्सेसरी नर्व दो मसल्स को सप्लाई करता है, ट्रेपीजियस एंड स्टर्नोक्लीडोमास्टॉइड. तो काफी चीजें कवर हो जाती है इसमें, है ना, काफी चीजें कवर हो जाती है. जस्ट ट्राई टू कॉन्सेंट्रेट, लिसन, अंडरस्टैंड. एक टॉपिक के साथ बहुत सारे एमसीक्यूज डिस्कस हो जाते हैं एंड बहुत कंसेप्ट्स क्लियर हो जाते हैं. एनीथिंग कैन कम इन द एग्जाम्स. रोम्बॉइड्स बहुत माइल्ड होता है बच्चे. रोम्बॉइड्स पैरालिसिस से बहुत माइल्ड विंगिंग होता है, बट मेन विंगिंग इज, अगर रोम्बॉइड्स भी पैरालाइज हो गया ना तो ट्रेपीजियस है ना, उसको ट्रेपीजियस सपोर्ट करता है उसको, तो इतना विंगिंग नहीं दिखता. फाइन, अंडरस्टैंडिंग? फाइन, ओके. चलो, विल कम टू द नेक्स्ट स्लाइड. ओके बच्चों, कैन एनीवन टेल मी व्हाट आर दिस स्पेसेस? आई जस्ट मेक अ स्लाइड फॉर यू. एक स्लाइड ड्रॉ करता हूं मैं. हैव अ लुक एट दिस, अ वेरी इंपॉर्टेंट, यू नो, you'll get this. ये है अपना ह्यूमरस. फाइन. ये बोलो, ये मसल क्या है? एनी गेसेस व्हाट इज दिस मसल जो इंफ्राग्लिनोइड ट्यूबरकल से स्टार्ट होके इट गोज टू द अल्ना? ये कौन है? लॉन्ग हेड ऑफ ट्राइसेप्स. लॉन्ग हेड ऑफ ट्राइसेप्स. फाइन. टेल मी व्हाट इज दिस मसल which goes to the greater tubercle of humerus, and what is this muscle जो आगे की तरफ जा रहा है, आगे की तरफ, on the medial lip of bicipital groove. medial lip of bicipital groove की तरफ जा रहा है. See this is beautiful. wow, this is so nice. चलो, identify this. एक स्पेस यहां बन गई, ओहो सॉरी, एक स्पेस यहां बन गई, एक स्पेस यहां बन गई, and there's a space here. चलो, आंसर दिस नंबर 1, नंबर 2, नंबर 3. चलो बच्चों, दिस इज एक्सट्रीमली इंपॉर्टेंट. यह है लॉन्ग हेड ऑफ ट्राइसेप्स. हाँ, एक मिनट, लेबल करता हूं. यह है लॉन्ग हेड ऑफ ट्राइसेप्स. लॉन्ग हेड ऑफ ट्राइसेप्स. यह है अपना टेरिस माइनर. टेरिस माइनर. एंड यह है अपना टेरिस मेजर. टेरिस मेजर. So this space is the upper triangular space. ये है lower triangular space. ये है quadrangular space. आपको बस contents याद रखना है ये spaces के. Contents of the spaces. Any guesses? There's an artery here and there's a nerve here. बोल सकते हो what is this artery? What is this nerve in the quadrangular space? हाँ, the axillary nerve and the posterior circumflex humeral artery. Axillary nerve होती है and posterior circumflex humeral artery passes through the quadrangular space, right? Now you tell me what passes through the lower triangular space. Come on, bachcho, if you can answer this, lower triangular space. Very good, Chris. ये ठीक है ना? I'm not writing this. Axillary nerve, posterior circumflex humeral artery, quadrangular space. Lower triangular space से क्या जाता है? Radial nerve and profunda brachii artery. Profunda brachii artery. And what passes to the upper triangular space is यहाँ पे होती है circumflex scapular artery. Circumflex scapular artery. Contents बहुत ज़्यादा important है बच्चों. ये visuals आ सकता है. Visuals can also come on this. So be very clear. So ये upper triangular space formed by teres minor, teres major, long head of triceps. Lower triangular space formed by teres major, long head of triceps, shaft of the humerus, and quadrangular space formed by teres minor, teres major, long head of triceps, and the neck of the humerus. Contents of quadrangular space, axillary nerve, posterior circumflex humeral artery. Lower triangular space, radial nerve and the profunda brachii artery. Upper triangular space, circumflex scapular artery. Done. ठीक है, इंपॉर्टेंट है, याद रखना. Okay, चलो, we'll proceed. So that's the spaces. So just mention here, this is the quadrangular space, this is the lower triangular space, lower triangular space, and ये होगा upper triangular space, upper triangular space. Fine है. Now tell me, what is this area? ये area बताओ, what is this area? हाँ, चलो बच्चों, come on, if you can answer this, what is this area? That's the anatomical snuff box, anatomical snuff box. Boundaries of anatomical snuff box. This is another very important visual, very important clinical MCQ. चलो बोलो, anatomical snuff box के boundaries बोल सकते हो. Laterally कौन है? Laterally it is formed by abductor pollicis longus and extensor pollicis brevis. हाँ, बस ये याद रखना आपको. Lateral boundaries, abductor pollicis longus and extensor pollicis brevis. Medially it's extensor pollicis longus. The floor is formed by styloid process, scaphoid and trapezium. Styloid process, scaphoid and trapezium. इसका content कौन है? Content is radial artery, and roof में कौन होता है? Cephalic vein and superficial branch of radial nerve. Perfect है, पूरा स्नफ बॉक्स हो गया. देखो, सो स्नफ बॉक्स के बाउंड्रीज क्या होंगे? लैटरल बाउंड्री, abductor pollicis longus, extensor pollicis brevis. अभी है ना, दिस इज जस्ट अ क्विक रिवीजन लेक्चर. हाँ, तो यू शुड बी नोइंग दिस. जस्ट ट्राई टू कोरिलेट. abductor pollicis longus, extensor pollicis brevis, medial boundaries, extensor pollicis longus. ये स्टेनोसाइनोवाइटिस होता है इसमें. Floor is formed by styloid process, scaphoid and trapezium. So clinical MCQ क्या आ सकता है? Which is the bone fractured in the anatomical snuff box? Scaphoid. And non-union होता है scaphoid का, avascular necrosis होता है scaphoid का. ये याद रखना, ठीक है? Content is radial artery and roof में होती है cephalic vein and the superficial branch of radial nerve. Superficial branch of radial nerve is okay, Javed. Superficial branch of radial nerve is sensory होती है. It supplies the skin. ठीक है, perfect. Okay, great. So we proceed here. चलो बच्चों, एक ये मसल आइडेंटिफाई कर सकते हो मेरे लिए? चलो, आइडेंटिफाई दिस मसल. ये कौन है? व्हाट इज दिस मसल? व्हाट इज दिस मसल? बहुत इंपॉर्टेंट विजुअल स्लाइड है ये. ये क्या मसल है? ये क्या मसल है? ये नर्व कौन है? ये नर्व कौन है? एनी गेसेस? आर्म है ये. दिस इज द आर्म. फिर ये क्यूबाइटल फोसा है. सो विच इज दिस मसल इन द आर्म? बाइसेप्स के नीचे ये कौन सा मसल है? ब्रेकियालिस. एंड विच इज द नर्व बिटवीन द बाइसेप्स एंड द ब्रेकियालिस? आई वांट यू टू नो दिस यू शुड नो. मतलब बाइसेप्स को मैंने रिफ्लेक्ट किया. जैसे मैं बाइसेप्स को रिफ्लेक्ट करता हूं, आई सी अ नर्व. व्हाट इज दैट नर्व? नर्व का नाम बताओ. यस गौरव. There's a nerve lying between the biceps and the brachialis. That's the musculocutaneous nerve. Very good, very good. Be very clear with your concepts, बच्चों. Concepts clear है ना? कोई भी MCQ आंसर कर सकते हो आप, right? तो देखो, look at this. ये कौन है? ये biceps है. ये brachialis है. What is this nerve here? That's the musculocutaneous nerve. ये है अपना anatomical snuff box. I'm so sorry. ये है अपना cubital fossa. सॉरी, क्यूबाइटल फोसा के बाउंड्रीज बताओ. क्यूबाइटल फोसा के कंटेंट्स बताओ. कंटेंट्स. ओके, दिस इज नंबर 1 medial nerve. This is number 2 brachial artery. This is number 3 tendon of biceps, and that's number 4 the radial nerve. वो निमोनिक याद है ना? MBBR. बस सारे निमोनिक्स याद नहीं रखना. Some mnemonics is okay. Fine. So what are the contents of cubital fossa? Medial से lateral आप जाते हो तो first one is the medial nerve, second is the brachial artery, तीसरा है tendon of biceps, and the fourth is radial nerve. Fine है? Clear? So contents of cubital fossa याद रखना. So ये कुछ visual slides है. चलो विल गो टू द नेक्स्ट वन, ब्रांचेस ऑफ एक्सिलरी आर्टरी। बोल सकते हो ब्रांचेस ऑफ एक्सिलरी आर्टरी। वैसे एक्सिलरी आर्टरी इज डिवाइडेड इनटू थ्री पार्ट्स बाय अ मसल। नेम ऑफ द मसल पेक्टोरलिस माइनर। Pectoralis minor divides the axillary artery into three parts. So first part की branch कौन है? First part की branch है superior thoracic artery. Superior thoracic artery. Second part की branch है, second part की branch है lateral thoracic and thoracoacromial artery. Thoracoacromial artery. Third part की branch anterior circumflex humeral, posterior circumflex humeral and subscapular artery. बस ये याद रखना। Branches of axillary artery. Axillary artery is divided into three parts by a muscle. Name of the muscle pectoralis minor. Pectoralis minor. So what are the branches of axillary artery? First part की branch superior thoracic artery. Second part की branch lateral thoracic and thoracoacromial. Can anyone tell me this thoracoacromial artery pierces a fascia? जो thoracoacromial artery है वो एक fascia को pierce करता है. Name of the fascia. Anyone? चलो answer this. This thoracoacromial artery pierces a fascia. समझ में आ रहा है ना बच्चों? If anything is difficult, you tell me. हाँ, ये speed ठीक है? हाँ, speed भी ठीक है ना? This is a revision lecture बच्चों. हाँ, चलो बोलो. Clavipectoral fascia. Very good. So thoracoacromial artery क्या pierce करती है? Clavipectoral fascia. Clavipectoral fascia. This lateral thoracic artery is the main artery supplying the breast. So lateral thoracic artery is enlarged in females. ये females में enlarged होती है, right? This lateral thoracic artery accompanies a group of lymph nodes. Which lymph nodes? Very good, very good. Very good to all of you. सब बहुत अच्छे से आंसर कर रहे हो. Lateral thoracic artery accompanies a group of lymph nodes located on the anterior wall of axilla. बोलो कौन से lymph nodes है ये कुछ बहुत बहुत इंपॉर्टेंट चीजें हैं. This you have to know. So branches of axillary artery, first part superior thoracic, second part lateral thoracic and thoracoacromial. Lateral thoracic is the main artery supplying the breast. Lateral thoracic artery accompanies a group of lymph nodes जिसका नाम है anterior axillary lymph nodes. Anterior axillary lymph nodes जो mainly breast को drain करता है. ठीक है ना? Anterior axillary. Very good. Third part की branch anterior circumflex humeral, posterior circumflex humeral and subscapular. ये जो subscapular artery है, it accompanies the posterior axillary group of lymph nodes. That's very very important. इसको याद रखिए. The posterior axillary lymph nodes go along with the subscapular artery, और subscapular artery accompanies the posterior axillary lymph nodes. ठीक है बच्चों, फाइन है. हाँ, ये याद रखना. ओके. चलो, वेरी गुड. नाउ ये टेल मी, मस्कुलोक्यूटेनियस नर्व. मस्कुलोक्यूटेनियस नर्व क्या सप्लाई करती है? जस्ट द मेन कोर कंसेप्ट अपन डिस्कस करें. कोर कंसेप्ट, मस्कुलोक्यूटेनियस नर्व क्या क्या सप्लाई करती है? एक तो वो बाइसेप्स को सप्लाई करती है. बाइसेप्स, इट सप्लाइज द ब्रेकियलिस एंड इट्स ब्रेकियलिस का हाफ एंड इट सप्लाइज द कोरैकोब्रेकियलिस. Coracobrachialis. And what is the continuation? What is the cutaneous branch given by the musculocutaneous nerve? Musculocutaneous nerve, like ये clinical MCQ मैं आपको बोलता हूँ. Clinical MCQ देखो, a person comes to the clinic complaining of loss of sensations on the lateral aspect of the arm. Just one moment. हाँ, ये हैंग हुआ था. हाँ, हैंग हुआ था. ओके, सॉरी फॉर दैट. Okay. Fine, it's fine now. Just one moment. Okay, fine now. Okay, just one moment. Yeah, no. That's okay. Okay, चलो. Now you tell me, musculocutaneous nerve तीन muscles को supply करती है. Number 1, biceps brachii. Number 2, coracobrachialis. And number 3 is the brachialis. It gives a cutaneous branch. Cutaneous branch. हाँ, एक clinical MCQ. Person comes to your clinic, complains of loss of sensations on the lateral aspect of the forearm. Loss of sensations on the lateral aspect of forearm. The nerve affected is. So वो है musculocutaneous nerve. So musculocutaneous nerve का cutaneous branch क्या होता है? Lateral cutaneous nerve of forearm. Lateral cutaneous nerve forearm. That's a cutaneous branch of musculocutaneous nerve. Fine है? So musculocutaneous nerve बस याद रखना supplies 3 muscles: biceps brachii, brachialis, coracobrachialis. And it gives a cutaneous branch. वो cutaneous branch का नाम है upper lateral cutaneous nerve of arm. Upper lateral cutaneous nerve of arm. Is this clear to all of you? Hello. Okay, fine. That's okay now. Huh. Hello. Fine. Sensory nerve supply of the lower lateral aspect of arm is radial nerve. वो है radial nerve. Okay. So we coming back to this. Musculocutaneous nerve दो muscles को supply करती है: biceps brachii, coracobrachialis and brachialis. Cutaneous branch है upper lateral cutaneous nerve arm. ठीक है बच्चों? Lower lateral cutaneous nerve arm is a branch of radial nerve in the spiral groove में होता है ये. Okay, fine. Axillary nerve आपको पता है, axillary nerve supplies 2 muscles. एक है deltoid, हमने ये देखा था, deltoid teres minor, and उसका cutaneous branch है upper lateral cutaneous nerve of arm. Upper lateral cutaneous nerve of arm. ठीक है ना, ये आपको पता है. Now बच्चों, coming to the next part, hamstring muscles. Hamstring. Can anyone tell me hamstring muscles? नाम याद है आपको hamstring muscles के? Hamstring muscles कहाँ पे होते हैं? In the posterior compartment of the thigh. Fine. Posterior compartment of the thigh में hamstring muscles होते हैं. Hamstring muscles कौन से होते हैं? Number 1 बोल सकते हो? Anyone? चलो guess करो बच्चों. Hamstrings. That's in the lower limb. In the posterior compartment of the thigh. Posterior compartment of the thigh. Which are the muscles there? Which are the muscles there? Anyone? Semitendinosus, very good. Semitendinosus, semimembranosus, biceps femoris, and adductor magnus. Semitendinosus, semimembranosus, biceps femoris, and adductor magnus. So these are the hamstring muscles. Hamstring. Nerve supply बोल सकते हो? Hamstring का nerve supply of hamstrings. Okay, just tell me, semitendinosus, semimembranosus, biceps femoris का long head is a hamstring. Long head is the hamstring and adductor magnus. ये है hamstring muscles. Short head of biceps femoris is not a hamstring muscle. Any guesses why? Short head of biceps femoris is not a hamstring muscle. Short head of biceps femoris is not a hamstring muscle. Any guesses why? Because number one, all the hamstring muscles को कौन सप्लाई करता है? टिबियल पार्ट ऑफ शियाटिक नर्व. टिबियल पार्ट ऑफ शियाटिक नर्व सप्लाई करती है हैमस्ट्रिंग को. फाइन, बट शॉर्ट हेड ऑफ बाइसेप्स femoris को कौन सप्लाई है करता है? कॉमन पेरोनियल नर्व. कॉमन पेरोनियल नर्व सप्लाइज द शॉर्ट हेड ऑफ बाइसेप्स femoris. Secondly, the short head of biceps femoris arises from the linea aspera of femur. Linea aspera से arise होता है and उसका nerve supply होता है common peroneal nerve. Criteria for hamstrings क्या है? It should be supplied by the tibial part of sciatic nerve. Tibial part of sciatic nerve supplies the hamstrings. Yes, very good. It does not arise from ischial tuberosity. Very good. It arises from the femur. Very good, Javed. Linea aspera of femur. Excellent. Very nice. Okay. सो हैमस्ट्रिंग्स, बस वो उतना याद रखना. ग्लूटियस मैक्सिमस, कुछ बोल सकते हो ग्लूटियस मैक्सिमस के बारे में? कुछ बोल सकते हो? व्हाट इज द नर्व सप्लाई ऑफ ग्लूटियस मैक्सिमस? चलो बच्चों बोलो, नर्व सप्लाई ऑफ ग्लूटियस मैक्सिमस. नाउ दिस यू हैव टू नो. नर्व सप्लाई ऑफ ग्लूटियस मैक्सिमस बोल सकते हो? एनी गेसेस? यस गौरव, यस जावेद, बोलो. फहद, ARK. Nerve supply of gluteus maximus is in, yes, Ashutosh, inferior gluteal nerve. Inferior gluteal nerve. Nerve supply of gluteus maximus is the inferior gluteal nerve. Inferior gluteal nerve. Okay. What is the main action of gluteus maximus? Main action of gluteus maximus is extension. Extension, lateral rotation. Extension, lateral rotation and abduction at the hip joint. Extension at the hip joint. Gluteus maximus is the chief extensor of the hip joint. ये याद रखना. It also laterally rotates. It also abducts the hip joint. Yes. Very good, very good. First year MBBS याद आ रहा है ना? Okay. Right. हाँ, ठीक है. So the main extensor of the hip joint is gluteus maximus. ये याद रखना. When we stand up from a sitting position, आप बैठे हो, and when we stand up, that is done by gluteus maximus. जब आप stairs climb करते हो, दो stairs climb करते हो, तो this anti-gravity movement is done by gluteus maximus. It is a chief anti-gravity muscle. Anti-gravity muscle होता है gluteus maximus. Actions याद रखना बहुत ज्यादा important है. Nerve supply याद रखना, inferior gluteal nerve. Very good. ठीक है, बोलता हूं. Noob, let me just finish this. Gluteus medius and minimus. Tell me, who supplies the gluteus medius, minimus and the tensor fascia lata? Any guesses? First MBBS का बाद में बोलता हूं, अभी ये पहले सुन लो. Who supplies the gluteus medius, minimus and the tensor fascia lata? Come on students, ये बहुत बार पूछा गया है. INICET में, PG NEET में भी पूछा गया है. Nerve supply of gluteus medius, minimus and the tensor fascia lata is superior gluteal nerve. Very good. That's a superior gluteal nerve. It supplies the gluteus medius, it supplies the gluteus minimus and it supplies the tensor fascia lata. Fine, perfect. Tell me, what is the main action of gluteus medius and minimus? Anyone? Main action of gluteus medius and minimus. It is, any guesses? Main action of gluteus medius and minimus: abduction and medial rotation. Abduction and medial rotation. Abduction and medial rotation at the hip joint. Yes, it is abduction and medial rotation at the hip joint. Fine. So that's superior gluteal nerve. आपको याद है, there's one more action of gluteus medius and minimus. वो pelvis को support करते हैं. They support the pelvis when one foot is off the ground. They support the pelvis. मतलब मेरा right gluteus and medius and minimus is supporting which pelvis? Opposite side. Opposite side का pelvis, left pelvis को support करते हैं. Trendelenburg's test. Trendelenburg's gate. Trendelenburg's test. Paralysis of gluteus medius and minimus results in Trendelenburg's test. Fine. वो याद रखना. Fine. This you know. Excellent. Very good. ये सब याद रखना. लोअर लिम्ब में नर्व सप्लाई बहुत ज्यादा इंपॉर्टेंट है मसल्स के. राइट. सो ग्लूटियस मैक्सिमस इज डन, मीडियस मिनिमस एंड टेंसर फिशिया लैटा का नर्व सप्लाई आपको पता है. वेरी गुड. ये छोटे छोटे पेल्विक फीमोरल मसल्स होता है. यू नो विच इज द की मसल ऑफ द ग्लूटियल रीजन? KEY. की मसल्स वो बहुत ज्यादा इंपॉर्टेंट मसल्स होते हैं. इफ यू गेट दिस की मसल, यू गेट एवरीथिंग इन दैट रीजन. सब कुछ मिल जाता है वो रीजन में. सो विच इज द की मसल ऑफ द ग्लूटियल रीजन? एनीवन? की मसल ऑफ द ग्लूटियल रीजन. अगर ये मसल मिल गया मुझे, I get everything in this region. I get the superior gluteal nerve, inferior gluteal nerve, sciatic nerve, the nerve to quadratus femoris, सब कुछ मिल जाता है ये region में. So the key muscle of the gluteal region is, answer this. Any guesses? ऐसे pear shaped muscle होता है, pear shaped. हाँ, that's piriformis. Piriformis, very good. The key muscle of the gluteal region is piriformis. ये याद रखना. And piriformis, one is piriformis. Okay. And piriformis के नीचे होता है superior gemellus. फिर होता है obturator internus. Then is inferior gemellus. And then is quadratus femoris. तो ये जितने भी मसल्स होता है ना, all these muscles are present on the posterior aspect of the hip joint. Okay, just remove that spammer from the group. Remove that spammer. Okay, so all these muscles are present on the posterior aspect of the hip joint. ये जितने भी muscles है, ये क्या करते हैं? ये करते हैं lateral rotation at the hip joint. Okay, ये जितने भी muscles है वो क्या करेंगे? lateral rotation at the hip joint. इसमें the main muscle क्या होता है? piriformis. अब ये छोटे छोटे muscles होते हैं, superior gemellus, obturator internus, inferior gemellus, quadratus femoris. ये जितने भी मसल्स हैं, this muscles are going to do lateral rotation at the hip joint. ये याद रखना, lateral rotation at the hip joint. ये सारे मसल्स क्या करते हैं? lateral rotation. हाँ, ये याद रखना, this is lateral rotation at the hip joint. Okay, fine. ये पीछे होता है, posterior aspect of hip joint पे होता है, they do lateral rotation at the hip joint. बस ये याद रखना. ठीक है बच्चों, come on, is this clear to all of you? Yes. And which is the key muscle of the gluteal region? Piriformis. ये बोल सकते हो which is the key muscle of the infratemporal fossa. Key muscle of the infratemporal fossa. मतलब जैसे मुझे ये मसल मिल जाएगा infratemporal fossa का, I get everything. मुझे inferior alveolar nerve मिल जाती है, मुझे lingual nerve मिल जाती है. Which is that key muscle of the infratemporal fossa? पायरिफॉर्मिस तो आपने बताया, की मसल ऑफ द ग्लूटियल रीजन. इंफ्राटेम्पोरल फोसा का की मसल कौन है? लैटरल टेरिगॉइड. एक्सीलेंट, वेरी गुड जावेद. द ओनली मसल विच कॉजेस डिप्रेशन ऑफ द मैंडिबल, दैट इज लैटरल टेरिगॉइड. यस, द की मसल ऑफ द इंफ्राटेम्पोरल फोसा इज लैटरल टेरिगॉइड. याद रखना. एंड द की मसल ऑफ द ओरल रीजन, ओरल टंग, की मसल ऑफ द ओरल रीजन, हु इज दैट? मतलब अगर मुझे ये मसल मिलता है ना, I get the lingual nerve, I get the hypoglossal nerve, उसके पीछे होती है glossopharyngeal nerve, उसके ऊपर होता है submandibular ganglion. तो की मसल ऑफ द ओरल रीजन कौन है? चलो गेस करो गेस करो. ओरल रीजन. हाँ, हायोग्लॉसिस. वाओ, Hyoglossus is the key muscle of the oral region because hyoglossus के ऊपर होती है lingual nerve, hyoglossus के ऊपर होती है hypoglossal nerve, submandibular gland and hyoglossus के पीछे होती है glossopharyngeal nerve. So बच्चों बस ये याद रखना, key muscles number 1 gluteal region का piriformis, ठीक है, oral region का hyoglossus and इंफ्राटेम्पोरल फोसा का लैटरल टेरिगॉइड. दैट्स इट. ये इतना याद रखना. जीनियोग्लॉसिस इज द लाइफ सेविंग मसल. दैट्स जीनियोग्लॉसिस. फाइन. ओके, चलो, गुड टू ऑल ऑफ यू. वेरी गुड. सो पेल्विक फीमोरल मसल्स मैंने बोल दिया आपको. एक बोल सकते हो द टेंडन वाइडिंग अराउंड द मीडियल मैल्यूलस, ये एक एमसीक्यू पूछा गया था बहुत पहले. टेंडन विच वाइंड्स अराउंड द मीडियल मैल्यूलस, हाँ, सेफ्टी मसल ऑफ द टंग. यस, लाइफ सेविंग मसल, सेफ्टी मसल ऑफ द टंग इज जीनियोक्लॉसिस. वेरी गुड, वेरी गुड. बच्चों, come on, can if you can tell me the tendon winding around the medial malleolus. Medial malleolus समझ सकते हो ना, on the medial aspect. and एक tendon होता है which goes around the medial malleolus and वो जाके navicular bone पे insert होता है. name of the tendon. अगर visual आया तो, if this comes as a visual slide, आपको medial aspect of leg दिखाया, हाँ, and मतलब ये देखिए, this is the tendoacheal, I mean this is the medial malleolus and there's a tendon which winds around the medial malleolus. Who's that? That's tibialis posterior. Tibialis posterior. So tendon winding around the medial malleolus is tibialis posterior, and tendon winding around the lateral malleolus is peroneus brevis. Peroneus brevis. लैटरल मैल्यूलस पे पेरोनियस ब्रेविस होता है, मीडियल मैल्यूलस पे टिबियालिस पोस्टीरियर होता है. ये याद रखना बच्चों, बहुत इंपॉर्टेंट एमसीक्यू है. सो द टेंडन वाइंडिंग अराउंड द मीडियल मैल्यूलस, टिबियालिस पोस्टीरियर. टेंडन वाइंडिंग अराउंड द लैटरल मैल्यूलस, पेरोनियस ब्रेविस. ये याद रखिए. चीफ इंसर्शन ऑन navicular tuberosity is tibialis posterior. tibialis posterior. navicular bone होता है, navicular bone, so navicular bone पे जाके ये insert होता है, that's tibialis posterior. हाँ, so these are some very golden points, इसको याद रखिए. groove below the cuboid, हाँ, cuboid bone है. bones of the foot आपको याद है ना, bones of the foot, bones of the foot में calcaneum, talus, navicular, 3 cuneiforms, cuboid, metatarsals, phalanges. अब cuboid bone देखोगे तो there's a groove below the cuboid, and groove below the cuboid is by peroneus longus. It's produced by peroneus longus. So cuboid bone के नीचे there's a groove which is formed, and that is formed by which muscle? It is formed by the peroneus longus muscle. ये याद रखना बच्चों, ये बहुत इंपॉर्टेंट चीजें हैं, इसको याद रखना. So एक शॉर्ट में वापस बोलता हूं. The tendon which winds around the medial malleolus, tibialis posterior. tibialis posterior का मेन इंसर्शन कहां पे होता है? navicular tuberosity पे. The tendon which winds around the lateral malleolus, peroneus brevis. peroneus brevis है, longus नहीं है, it's brevis. And the groove below the cuboid is by which muscle? peroneus longus. peroneus longus. फाइन, समझ में आ रही है? कुछ डाउट्स है इसमें तो बोलो. एनी डाउट्स यू हैव इन दिस, यू टेल मी. These are very important things and this you have to know. ये कोई भी फॉर्म में आ सकता है. It can come as a visual slide or it can come as an MCQ. चलो बोलो, कुछ डाउट्स है यहां तक बच्चों? यस, ऋतिक, आशुतोष, गौरव, जावेद. ठीक है. ओके, नाउ लेयर्स ऑफ सोल. सपोज अगर आपको, सपोज इफ यू गेट विजुअल्स ऑन द लेयर्स ऑफ सोल, बहुत इजी तरीका बोलता हूं. लेयर्स ऑफ द सोल कैसे याद रखना है आपको? जस्ट सी दिस लेयर्स ऑफ सोल. हाँ, कैसे याद रखोगे? सपोज दिस इज द ग्रेट टो, ग्रेट टो, एंड दैट्स द लिटिल फिंगर. लिटिल फिंगर मतलब ये मीडियल हो गया, ये लैटरल हो गया. मीडियल एंड लैटरल. वी हैव गॉट 4 layers ऑफ द सोल. सोल में 4 layers होते हैं, 4 layers. इसमें से, हाँ, एक्सप्लेन कर रहा हूं बच्चे, बस इतना याद रखो. इसमें से द फर्स्ट एंड द थर्ड लेयर आर इंट्रिंसिक. इंट्रिंसिक का मतलब क्या है? दे बिगिन फ्रॉम द बोन्स ऑफ द फुट, दे आर इंसर्टेड ऑन द बोन्स ऑफ द फुट. मतलब फुट में ही होते हैं, दे आर प्रेजेंट इन द फुट. ऐसे छोटे छोटे जैसे हैंड वाले मसल्स है ना, स्मॉल मसल्स. व्हाट डू वी कॉल दिस मसल्स? एज इंट्रिंसिक मसल्स. इंट्रिंसिक, छोटे मसल्स, इंट्रिंसिक. ऑल द स्मॉल मसल्स विल एंड विथ व्हाट? ब्रेविस. छोटे मसल्स हैं तो ब्रेविस, छोटे मसल्स हैं तो ब्रेविस. समझ में आ रहा है? कंसेप्ट समझो, कंसेप्ट. सो ग्रेट टो, लिटिल फिंगर, 4 layers ऑफ सोल होते हैं इन द फुट. उसमें द फर्स्ट एंड द थर्ड लेयर आर छोटे मसल्स, तो ये हो गए इंट्रिंसिक मसल्स. दे विल एंड विथ व्हाट? ब्रेविस. ये ब्रेविस के साथ एंड होंगे. अब कैसे याद रखोगे? पुट एन एबडक्टर हियर, देखो इजी तरीके से बोल रहा हूं, सुन लो पहले, पुट एन एबडक्टर हियर एंड पुट अ फ्लेक्सर हियर, पुट एन एबडक्टर, एबडक्टर एंड बीच में फ्लेक्सर डाल दो बच्चों, इसका नाम क्या है, इसका नाम क्या होगा, एबडक्टर, हाँ एबडक्टर ग्रेटो हाल्यूसिस स्मॉल मसल ब्रेविस, एबडक्टर हाल्यूसिस ब्रेविस, इसका नाम क्या होगा, एबडक्टर लिटिल फिंगर डिजिटाई मिनिमाई ब्रेविस, एबडक्टर डिजिटाई मिनिमाई ब्रेविस। सो एबडक्टर हाल्यूसिस ब्रेविस, एबडक्टर डिजिटाई मिनिमाई ब्रेविस एंड बीच में एक फ्लेक्सर डाल दो, इसका नाम है फ्लेक्सर डिजिटोरम ब्रेविस, फ्लेक्सर डिजिटोरम ब्रेविस। समझ में आ रहा है, एबडक्टर एबडक्टर बीच में फ्लेक्सर। कम टू द थर्ड लेयर, थर्ड लेयर में फ्लेक्सस को दोनों साइड ले लो, पुट अ फ्लेक्सर हियर, पुट अ फ्लेक्सर हियर एंड पुट एन एडक्टर इन बिटवीन। एडक्टर कैसे याद रखोगे, देखो हाउ डू यू रिमेंबर दिस, flexor, so flexor of the great toe hallux small muscle brevis, flexor hallucis brevis, इसका नाम flexor digiti minimi brevis, flexor digiti minimi brevis, एंड ये है adductor hallucis, जैसे ये adductor pollicis है ना, adductor pollicis, वैसे ये adductor hallucis है, adductor hallucis। सिंपल है बच्चों, दो लेयर्स है, सिंपल क्लियर है, कैसे याद रखोगे, फर्स्ट एंड थर्ड लेयर छोटे छोटे ब्रेविस मसल होते हैं, सो फर्स्ट लेयर एबडक्टर एबडक्टर बीच में फ्लेक्सर, एबडक्टर हाल्यूसिस ब्रेविस, एबडक्टर डिजिटाई मिनिमा ब्रेविस, फ्लेक्सर डिजिटोरम ब्रेविस। अब थर्ड लेयर में ब्रिंग फ्लेक्सस ऑन बोथ द साइड्स, पुट अ फ्लेक्सर हियर, पुट अ फ्लेक्सर हियर, पुट एन एडक्टर इन बिटवीन, flexor hallucis brevis, flexor digita minima brevis, adductor hallucis। Okay, great। अब सेकेंड एंड फोर्थ लेयर्स में द मसल विल कम फ्रॉम द लेग, बाहर से मसल आएंगे, लेग से आएंगे, लेग से, हाँ, तो द मसल्स कम फ्रॉम द लेग, विच आर दिस मसल्स, फ्लेक्सर hallucis longus, flexor digitorum longus, flexor hallucis longus, flexor digitorum longus, ये posterior compartment of leg से आते हैं। अब flexor digitorum longus is similar to a muscle of the upper limb, flexor digitorum profundus, profundus याद है, profundus of the upper limb, and small worm like muscles begin, छोटे छोटे worm like muscles निकलते हैं profundus से, कौन है, lumbricals, lumbricals, ठीक है। एक और मसल है जिसका नाम है flexor digitorum accessorius, बस ये याद रखना है आपको, फ्लेक्सर डिजिटोरम एक्सेसोरियस। सो सेकंड लेयर के मसल्स कैसे याद रखोगे, फ्लेक्सर हाल्यूसिस लॉन्गस, फ्लेक्सर डिजिटोरम लॉन्गस, फ्लेक्सर डिजिटोरम एक्सेसोरियस एंड द लंब्राइकल्स, ये हो गए सेकंड लेयर, हाँ ठीक है। एंड लास्ट लेयर कैसे याद रखोगे, लास्ट लेयर में एक होता है टिबियालिस पोस्टीरियर, पेरोनियस लॉन्गस एंड इंट्राशाई, जैसे हैंड में इंट्राशाई होता है वैसे फुट में इंट्राशाई होता है। सो टिबियालिस पोस्टीरियर, पेरोनियस लॉन्गस एंड इंट्राशाई। बच्चों दिस इज द इजीएस्ट वे टू अंडरस्टैंड द फुट एंड दिस इज व्हाट आई हैव मेड। ओके फाइन है, समझ में आया ये, बस ये टेबल याद रखना, ये टेबल याद रखना। कुछ डाउट्स है तो बोलो, एनी डाउट्स यू हैव इन दिस यू टेल मी। ऋतिक क्लियर है, सिंपल है, दिस इज द बेस्ट वे, नहीं तो मसल्स ऑफ द सोल आर वेरी डिफिकल्ट टू रिमेंबर। एमबीबीएस में याद नहीं हुआ ना। आई मीन इट हैज टू बी टोल्ड लाइक दिस, ऐसे याद रखना आप, इट्स वेरी इजी, ठीक है। सो दैट्स अबाउट द लेयर्स ऑफ द सोल इन अ नटशेल, राइट, फाइन। चलो तो फर्स्ट सेकंड थर्ड फोर्थ लेयर्स याद रखना, कैसे याद रखोगे, फर्स्ट एंड थर्ड इंट्रिंसिक है, सेकंड एंड फोर्थ एक्सट्रिंसिक लेयर्स है, बाहर से आते हैं मसल्स, फाइन। चलो बस डन, आई प्रोसीड। ये क्लिनिकल कंडीशन क्या है, व्हाट इज दिस क्लिनिकल कंडीशन, बोलो व्हाट इज दिस क्लिनिकल कंडीशन। चलो बच्चों ये बहुत ज्यादा इंपॉर्टेंट है, हाँ ये क्लिनिकल कंडीशन, ओके दैट्स फाइन, बोलो बच्चों। ये देखो ना, द फुट इज प्लांटर फ्लेक्स्ड, Foot drop. Excellent. This is foot drop. Very good. Foot drop. This is due to damage to the common peroneal nerve. Excellent. Foot drop हुआ, common peroneal nerve damage हो गई. What is the type of gait? What is the type of gait in foot drop? Answer this. It's a high stepping gait. It's a high stepping gait or stamping gait or marching gait. Marching gait. Okay. A high stepping gait or stamping gait. Stamping पता है ना? Stamping. Or it's a marching gait. Marching gait. Soldiers marching gait. Fine. So that's foot drop. ओके एक है ना नर्व सप्लाई ऑफ द फुट. देखो नर्व सप्लाई ऑफ द फुट आना तो वेरी इंपॉर्टेंट, ये बहुत बार पूछा जाता है. नर्व सप्लाई ऑफ द फुट सोल है या सोल? हाँ सोल ऑफ द फुट है, सोल ऑफ द फुट. नाउ विच इज द नर्व विच सप्लाइज दिस मीडियल एस्पेक्ट ऑफ द फुट अप टू द ग्रेट टो. चलो ये बताओ, दिस इज वेरी इंपॉर्टेंट. मीडियल एस्पेक्ट ऑफ द फुट up to the great toe is supplied by which nerves? Cutaneous है, cutaneous sensory nerve supply. बोल सकते हो? Medial aspect of the foot up to the great toe. This is saphenous nerve. Saphenous nerve. नहीं, medial plantar नहीं है जावेद. Medial aspect of the foot up to the great toe is saphenous nerve. Saphenous is a branch of femoral nerve. The medial aspect of the great toe, medial aspect of the great toe is supplied by superficial peroneal nerve. Superficial peroneal nerve. Superficial peroneal nerve. ये जितने भी web spaces है, web spaces, this is supplied by superficial peroneal nerve. The web spaces, समझते हो web spaces, that is supplied by superficial peroneal nerve. The first web space जानते हो आप? फर्स्ट वेब स्पेस जहां पे अपन स्लीपर्स पहनते हैं, स्लीपर्स, दिस इज सप्लाइड बाय डीप पेरोनियल नर्व. बच्चों दिस इज वेरी इंपॉर्टेंट है, ये याद रखना. दिस इज वेरी इंपॉर्टेंट, बहुत एमसीक्यूज है इस पे, ये याद रखना. सो द फर्स्ट वेब स्पेस जहां पे अपन स्लीपर्स पहनते हैं, दैट इज सप्लाइड बाय द डीप पेरोनियल नर्व. बाकी जितने भी वेब स्पेसेस है, दैट इज सप्लाइड बाय सुपरफिशियल पेरोनियल नर्व. द मीडियल एस्पेक्ट ऑफ द ग्रेट टो इज सप्लाइड बाय सुपरफिशियल पेरोनियल नर्व. मीडियल एस्पेक्ट ऑफ द फुट up to the great toe, that's saphenous nerve. And the lateral aspect of the foot, बोल सकते हो ये, this is sural nerve. Sural nerve, ये है sural nerve. The heel of the foot is supplied by tibial nerve. Heel is supplied by tibial nerve. This 3.5 fingers, sole as sole, 3.5 fingers is supplied by medial plantar nerve, and this 1.5 fingers is supplied by lateral plantar nerve. Lateral plantar nerve. Okay. This is very important. इस पर बहुत MCQs आते हैं, clinical MCQs आएंगे. हाँ, a person comes with loss of sensations of the skin on the medial aspect of the foot. The affected nerve is a branch of. So affected nerve has saphenous nerve. It's a branch of femoral nerve. बोलो, कुछ डाउट्स है तो बोलो. Clear है? This is very important. Huh? This you should know. Fine to all of you. I'll proceed. Yes, Sudhir. Okay, got it. No. Okay. ये सोल है, सोल ऑफ द फुट है, मतलब डॉर्सम ऑफ द फुट को कौन सप्लाई करता है? सुपरफिशियल पेरोनियल नर्व. फुट का जो डॉर्सम है, फुट का डॉर्सम, दैट इज सुपरफिशियल पेरोनियल नर्व. ये प्लांटर एस्पेक्ट है, प्लांटर एस्पेक्ट. एक और चीज, दिस 3.5 फिंगर इज सप्लाइड बाय मीडियल प्लांटर नर्व. वैसे 3.5 फिंगर्स ऑफ द अपर लिम्ब को कौन सप्लाई करता है? मीडियल नर्व. 1.5 फिंगर्स को अपर लिम्ब को कौन सप्लाई करता है? अल्नार नर्व. राइट. सो मीडियल प्लांटर नर्व रिसेंबल्स टू विच नर्व? मीडियल नर्व. लैटरल प्लांटर नर्व किससे रिसेंबल करती है? अल्नार नर्व को. अल्नार नर्व को. पीडब्ल्यू मेडेड का बैच ले लो, पीडब्ल्यू मेडेड. ओके just wait now. I'll tell that later. Fine. Is this clear to all of you? बच्चों clear है यहाँ तक? चलो, we'll proceed now. We'll proceed to the bronchopulmonary segments. Bronchopulmonary segments बोल सकते हो लेफ्ट एंड राइट लंग्स के bronchopulmonary segments. इसमें काफी MCQs आते हैं लेफ्ट एंड राइट लंग के bronchopulmonary segments. That's the lingula. This is the lingula. यह है cardiac notch. चलो बच्चों, we'll start. That's a oblique fissure. Oblique fissure. यह है horizontal fissure. ब्रोंकोपल्मोनरी सेगमेंट्स पे बहुत ज्यादा एमसीक्यूज है. बी वेरी क्लियर अबाउट दिस. चलो, विल स्टार्ट. ब्रोंकोपल्मोनरी सेगमेंट्स ऑफ द राइट लंग अपर लोब. आंसर दिस. ब्रोंकोपल्मोनरी सेगमेंट्स ऑफ द राइट लंग अपर लोब आर अपाइकल, एंटीरियर, पोस्टीरियर. फॉर द मिडिल लोब ऑफ द राइट लंग ये है मीडियल एंड लैटरल. फॉर द लोअर लोब ब्रोंकोपल्मोनरी सेगमेंट्स आर अपाइकल, एंटीरियर बेसल, लैटरल बेसल, पोस्टीरियर बेसल एंड एक अंदर होता है मीडियल बेसल. मीडियल बेसल. फाइन. सो अपाइकल, एंटीरियर, पोस्टीरियर, मीडियल, लैटरल, अपाइकल, एंटीरियर बेसल, लैटरल बेसल, पोस्टीरियर बेसल एंड मीडियल बेसल. ब्रोंकोपल्मोनरी सेगमेंट्स ऑफ द लेफ्ट लंग अपर लोब आर अपाइकल, एंटीरियर, पोस्टीरियर. अपाइकल, एंटीरियर, पोस्टीरियर. ये लोब को क्या बोलते हैं? लिंगुलर लोब. This is superior lingular and that's inferior lingular. Superior and inferior lingular. Lower lobe का same है. Bronchopulmonary segments apical, anterior basal, lateral basal, posterior basal and medial basal is absent in the left lung. So bronchopulmonary segments of the left lung are कितने? 9. And this is 10. So right lung में 10 bronchopulmonary segments है, left lung में 9 bronchopulmonary segments है. ठीक है ना बच्चों? This you must be knowing. हाँ, bronchopulmonary segments of the right and the left lung you must be knowing. Tell me, if you have to resect a segment, आपको एक segment निकालना है. So what is that structure which we are going to trace? इसके बीच में क्या होता है? What is the structure between the segments? हाँ, आंसर दिस. व्हाट इज द स्ट्रक्चर बिटवीन द सेगमेंट्स? अगर आप ये स्ट्रक्चर को ट्रेस करते हो तो यू कैन डिफाइन अ सेगमेंट. आप उतने सेगमेंट को रिसेक्ट कर सकते हो. यू कैन रिसेक्ट दैट पर्टिकुलर सेगमेंट. सो व्हाट इज द स्ट्रक्चर व्हिच रन्स बिटवीन द ब्रोंकोपल्मोनरी सेगमेंट्स? ब्रोंकियल वेन्स नहीं है बच्चे, ब्रोंकियल वेन्स नहीं है. गौरव, समथिंग एल्स. गौरव सोनावने, वेरी गुड, यू आंसरिंग वेरी वेल, बट ब्रोंकियल वेन्स नहीं है. पल्मोनरी वेन्स. दीज आर पल्मोनरी वेन्स. ब्रोंकियल वेन्स हाइलम में जाते बच्चे, हाइलम में जाते हैं डायरेक्टली, है ना. सो दीज आर द पल्मोनरी वेन्स. एमसीक्यू है ये, बहुत ज्यादा इंपॉर्टेंट एमसीक्यू है. पल्मोनरी वेन्स आर, योर आंसर, intersegmental. Intersegmental. So pulmonary veins are intersegmental. हाँ, that's pulmonary veins. हाँ, ये याद रखना. ठीक है. Bronchial veins सीधे हाइलम में जाते. Fine. So these are the pulmonary veins. Okay. Each bronchopulmonary segment has its own artery, has its own tertiary bronchus. Veins are intersegmental. ये याद रखना. Now, दो MCQs. Foreign body entering the nose directly goes to which segment? अगर छोटा बच्चा है, foreign body डालता है nose में, तो वो foreign body enters into which segment? Answer this. That's a very important MCQ. ये किसी भी तरीके से clinical MCQ बन के आ सकता है. Foreign body entering the nose enters into which segment of the right lung? Answer this. नहीं, कौन से सेगमेंट, कौन से ब्रोंकोपल्मोनरी सेगमेंट में जाएगा? कौन से ब्रोंकोपल्मोनरी सेगमेंट में जाएगा? इट्स द पोस्टीरियर बेसल सेगमेंट ऑफ द राइट लंग. ये क्लियर है ना? दिस कम्स हियर, यहां पे आता है ये. फॉरेन बॉडी एंटरिंग द नोज एंटर्स इनटू द पोस्टीरियर बेसल सेगमेंट ऑफ द राइट लंग. Posterior basal segment of the right lung, because this is a continuation of the trachea. Trachea continues as right primary bronchus. Right primary bronchus continues as the secondary bronchus for the lower lobe. The secondary bronchus for the lower lobe continues as the tertiary bronchus for the posterior basal segment. तो वो सीधे फॉरेन बॉडी सीधे चला जाता है on the posterior basal segment of the right lung. Am I clear बच्चों? हाँ. And सुपाइन पोजीशन में एस्पिरेशन हुआ, अ पर्सन इज लाइंग सुपाइन, ओल्ड एज पेशेंट है, सुपाइन है, खांसी किया, खांसी वापस अंदर आ गया, एस्पिरेशन हो गया. एस्पिरेशन निमोनिया इज कॉमन इन विच सेगमेंट? Aspiration pneumonia is common in, come on, answer this MCQ, very very important. Aspiration pneumonia is common in, हाँ, क्या लिखा है निर्मल? apical segment of the lower lobe. Apical segment, this aspiration pneumonia is common in apical segment of the lower lobe. apical segment में होता है aspiration pneumonia, ठीक है. हाँ, अपाइकल सेगमेंट ऑफ लोअर लोब. और सुपीरियर सेगमेंट, उसका दूसरा नाम है सुपीरियर सेगमेंट. इसको सुपीरियर सेगमेंट भी बोलते हैं. अपाइकल सेगमेंट ऑफ लोअर लोब का दूसरा नाम है सुपीरियर सेगमेंट. याद रखना. क्लियर है बच्चों? 2 एमसीक्यूज है इसमें, बहुत ज्यादा इंपॉर्टेंट है. सी, एज फार एज ब्रोंकोपल्मोनरी सेगमेंट्स, पल्मोनरी वेन्स आर इंटरसेगमेंटल. कंसेप्ट याद रखना. Foreign body entering the nose enters into the posterior basal segment of the right lung. तीसरा, aspiration pneumonia is common in the apical segment of lower lobe, जिसको अपन बोलते हैं superior segment. Superior segment. Fine? Fine है बच्चों? Okay. तो ये है कुछ MCQs with respect to the bronchopulmonary segments. Fine. Okay, chalo. Tell me now. I'll just draw one slide for you. Just help me to identify this. Okay, we'll start. Chalo, we'll start. Very good, very good. Tell me now. एक एमसीक्यू आया था थोड़े साल पहले. स्टर्नोकॉस्टल सरफेस, हाँ, ये जो सरफेस आप देख रहे हो हार्ट का, दिस सरफेस, इसको अपन बोलते हैं स्टर्नोकॉस्टल सरफेस. एंड स्टर्नोकॉस्टल सरफेस ऑफ द हार्ट इज फॉर्म्ड बाय हाउ मेनी चेंबर्स? बोल सकते हो. स्टर्नोकॉस्टल सरफेस ऑफ द हार्ट इज फॉर्म्ड बाय, ये है राइट एट्रियम, ये है राइट वेंट्रिकल, एंड दैट्स द लेफ्ट वेंट्रिकल. सो स्टर्नोकॉस्टल सरफेस ऑफ द हार्ट इज फॉर्म्ड बाय 3 चेंबर्स, द राइट एट्रियम, द राइट वेंट्रिकल, द लेफ्ट वेंट्रिकल. एमसीक्यू था, स्टर्नोकॉस्टल सरफेस ऑफ द हार्ट इज फॉर्म्ड बाय व्हिच ऑफ द फॉलोइंग चेंबर्स? एक सिलेक्ट करना है आपको, एक सिलेक्ट करना है. व्हाट विल यू सिलेक्ट? Sternocostal surface of the heart is formed by which of the following chambers? अगर एक सिलेक्ट करना है तो क्या करोगे सिलेक्ट? लेफ्ट वेंट्रिकल नहीं बच्चे, लेफ्ट वेंट्रिकल नहीं. देखो ना, इसमें देखो ना, मेजर पार्ट ऑफ sternocostal surface is formed by right ventricle. आप सिलेक्ट करोगे राइट वेंट्रिकल. राइट वेंट्रिकल, समझ में आ रहा है? हाँ. So sternocostal surface of the heart is actually formed by 3 chambers, right atrium, right ventricle, left ventricle, but एक सिलेक्ट करना है तो you will select the right ventricle. Right ventricle. हाँ, that's no problem. That's okay. Base of the heart. Base पीछे, base is behind. Base of the heart is formed by how many chambers? 2 chambers, the left and the right atrium. Left and the right atrium forms the base of the heart. Base. Okay. I'll just tell you the grooves. आप है ना artery and vein बोल दो मुझे, if you can answer this. What is this groove? This is the anterior AV groove. Anterior atrioventricular groove. This is anterior interventricular groove. Anterior interventricular groove. This is the posterior interventricular groove. And this is the posterior atrioventricular groove. बच्चों, if this is clear to you, बोलो, नहीं तो this is the anterior atrioventricular groove. This is the anterior interventricular groove. This is the posterior interventricular groove. This is the posterior atrioventricular groove. I just want the name of the arteries. Name of the arteries and veins. कौन सी artery, कौन सी vein होती है इसमें? बोल सकते हो? Anterior atrioventricular groove. Just name the artery and the vein. इसमें artery कौन सी है? Vein कौन सी है? In this groove. In this groove. What is the artery? What is the vein? If you can tell me. Hello, hello, बच्चों. Come on. You must be knowing this. This is the anterior atrioventricular groove में artery कौन सी है? Right coronary artery. Right coronary vein नहीं है गौरव. यहां पे होती है ये राइट कोरोनरी आर्टरी एंड प्लस वेन होती है स्मॉल कार्डियक वेन, right coronary artery and the small cardiac vein. Huh? What is the artery in this groove? In this groove, what is the artery here? इसमें artery होती है left anterior descending. हाँ, right coronary artery is fine. And the small cardiac vein इस यहाँ पे होती है small cardiac vein. I'll draw that for you, small cardiac vein. Okay, अगर ये visual आया तो this is the LAD, left anterior descending. And what is the vein here? यहाँ पे vein होती है जिसका नाम है हाँ great cardiac vein. Great cardiac vein. हाँ, left anterior descending plus left cardiac vein. Fine. You can tell me what is the artery here? What is this artery? Just one moment. That's a left coronary. Left coronary की ये branch होती है. What is this branch of left coronary? This is the circumflex artery, circumflex branch of left coronary, and this is the, sorry, I'll make a different color. क्या color use करूं? This is the posterior interventricular branch of right coronary artery. Posterior interventricular branch of right coronary artery. Yes, posterior interventricular artery. So, one moment, again. In the anterior atrioventricular groove, artery है right coronary artery, vein है small cardiac vein. Anterior interventricular groove, artery है left anterior descending, vein है great cardiac vein. In the posterior interventricular groove, there's an anastomosis between two arteries, anastomosis between the LAD and the posterior interventricular branch of right coronary artery. यहाँ पे एक vein होती है जिसका नाम है middle cardiac vein. There's a vein here. The vein is middle cardiac vein. Middle cardiac vein. And posterior atrioventricular groove में there's an anastomosis between the circumflex branch of left coronary and the right coronary artery. यह है अपनी right coronary artery. And that's a circumflex. यहाँ पे there's a big vein. यहाँ पे एक बड़ी vein होती है. Can anyone tell me what is this vein here? यहाँ पे एक vein होती है. This is the coronary sinus. Coronary sinus. That's a coronary sinus. बच्चों समझ में आ रहा है? Yes. समझ में आ रहा है? Okay, thank you campus योद्धा. Thank you for answering. Okay. So एक बार वापस चलो बच्चों. Anterior atrioventricular groove. Anterior atrioventricular groove में artery है right coronary artery, vein है. What is this vein? Small cardiac vein. Anterior interventricular groove में artery है left anterior descending, vein है great cardiac vein. Posterior atrioventricular groove में there's an anastomosis between the right coronary artery and the circumflex branch of left coronary artery. Vein है coronary sinus. यहाँ पे होती है coronary sinus. And posterior interventricular groove में again there's an anastomosis between the left anterior descending and the posterior interventricular artery. Vein है middle cardiac vein. बच्चों बस ये याद रखना, ये विजुअल्स आ सकता है. You can get a visual on this. Fine है? Yes, all of you बच्चों बोलो, is this fine? समझ में आया ना? बस ये मेन चीज है, इसको याद रखिए. हाँ, just remember this. Yes, बच्चों बोलो. Fine, I'll proceed. कुछ डाउट्स है तो बोलो इसमें. कुछ if any doubts you have, you can please tell me. Right? Okay, fine. चलो, good. Gaurav, very good. Yes, the rest of you, Nirmal, ARK. Fine. चलो, we'll proceed then. Okay. You tell me now. कितने एओटिक आर्च आर्टरीज होते हैं? कितने एओटिक आर्च आर्टरीज होते हैं? यस, देयर आर 6 एओटिक आर्च आर्टरीज, एक डिसअपियर होती है, सो देयर रिमेन्स 5 aortic arch arteries, 5 aortic arch arteries. Now you tell me, एक मिनट, I'll just draw this for you. एक draw ही करता हूँ. I'll just draw this for you. So this is the aortic sac. Aortic sac. This are the aortic arch arteries. So that's the first arch artery. That's the second arch artery. That's the third arch artery. Fourth arch artery. Fifth gaya, and that's the sixth arch artery. Huh? So I'll just extend this. This is the first arch artery, second arch artery. That's the third arch artery, fourth arch artery, and sixth arch artery. Sixth arch artery. ठीक है, यह है aortic sac. This aortic sac and this are the aortic arch arteries. First, second, third, fourth, 5, 6. इसमें how many disappears? कितने disappear होती है? The first is gone. The first disappears off. The second disappears off. First is gone. Second is gone. Third remains. Fourth is remaining. Fifth is gone. Sixth remains. Fifth is gone. Sixth remains. ठीक है? Okay. I'll just finish this fast. ये बहुत important है. थोड़ा सा देख लो. So now, which is this artery left now? That's the third arch artery, fourth arch artery, and sixth arch artery. बस ये 3 arch artery बाकी है. Third arch artery, fourth arch artery, sixth arch artery. ये है aortic sac. इसके 2 parts बनते हैं, इसके 2 horns बनते हैं. Sorry, इसके 2 horns बनते हैं. Right horn, left horn of aortic sac. ये है left horn, ये है right horn of aortic sac. Third arch artery, fourth arch artery, sixth arch artery. This is the dorsal aorta. Bachcho, in short, I'll just quickly tell you. Now tell me, there are 2 arteries which comes and joins with the fourth arch artery. What is this? 2 arteries आके fourth arch artery को join करते हैं. इनका नाम है 7th cervical intersegmental artery. The 7th cervical intersegmental artery comes and joins with the fourth arch artery. Now, how is the arch of aorta formed? This is the aortic sac. This is the left horn. That's the right horn of aortic sac. So the left horn of aortic sac and the left fourth arch artery forms what? ये बनेगा arch of aorta. Arch of aorta. So left horn of aortic sac and the left fourth arch artery से बना arch of aorta. So the left 7th cervical intersegmental से क्या बनेगा? Left subclavian artery. Left subclavian artery is derived from the left 7th cervical intersegmental artery. Fine. This on this side, the fourth arch artery and the 7th together will form the right subclavian artery. So right subclavian artery is derived from the right fourth arch artery and the right 7th cervical intersegmental artery. ये बनेगा दोनों साइड्स पे. क्लियर है? सबक्लेवियन लेफ्ट साइड का बना 7th cervical से, राइट साइड का बना 4th and 7th से. The third arch artery forms what? The third arch artery forms the common carotids. ये बनता है common carotids. It gives a bud. यहाँ पे एक bud देता है for external carotid artery. So third arch artery forms the common carotid, gives a bud for external carotid, and now continues as internal carotid artery with the dorsal aorta. Dorsal aorta के साथ. So third arch artery से बनता है common carotid. ये बड़ देता है external carotid के लिए, and this is a continuation of third arch artery with the dorsal aorta. ये बना internal carotid artery. Internal carotid artery. ये connection गया, ये connection गया. What is the sixth arch artery form? The sixth arch artery forms the pulmonary artery. The sixth arch artery forms the pulmonary artery. It gives a bud. यहाँ पे एक छोटा सा bud देती है for the lung bud. The sixth arch artery forms the pulmonary artery. It gives a bud for the lungs. Now, on the right side, this part of the sixth arch artery disappears off. Right side पे ये disappear हो गया. Right side पे ये disappear हो गया. Left side पे ये बना अपना ductus arteriosus. Ductus arteriosus, right? Ductus arteriosus, right? So the sixth arch artery forms a pulmonary artery. It gives a bud for the lungs. On the right side, this part of the sixth arch artery disappears off. Left side पे ये बना ductus arteriosus. Fine, ये बन गया अपना arteries. What is this going to form? इससे क्या बनता है? इससे this is going to form the brachiocephalic trunk. Brachiocephalic trunk. ये बना brachiocephalic trunk, the right horn of aortic sac. Okay. Now this entire artery disappears off. ये पूरा dorsal aorta is gone. And what is this going to form? ये बना descending thoracic aorta. This forms the descending thoracic aorta. Fine. Now you tell me. हाँ, this is very important. ये बहुत important है बच्चों, समझ में आया ना? हाँ, एक बार वापस बोलता हूँ, देखो आर्च ऑफ द एओर्टा कैसे बनता है? लेफ्ट हॉर्न ऑफ एओर्टिक सैक एंड द लेफ्ट फोर्थ आर्च आर्टरी, ये बना आर्च ऑफ एओर्टा. सबक्लेवियन आर्टरी दोनों साइड्स पे अलग है. लेफ्ट साइड पे बना 7 सर्वाइकल से, राइट साइड पे बना 4th and 7th से. 6th आर्च आर्टरी से बनता है पल्मोनरी आर्टरी, छोटा छोटा बड देता है लंग्स के लिए. लेफ्ट साइड पे दिस पार्ट बिटवीन द 6th आर्च आर्टरी, लंग बड एंड द डॉर्सल एओर्टा से बनता है डक्टस आर्टेरियोसिस. ओके, फाइन है. Now you tell me, if this entire artery on the left side persistent रहेगा, if this right dorsal aorta remains persistent, क्या बनेगा? What happens? If normally ये right dorsal aorta disappear होता है बच्चों, अगर ये right dorsal aorta persistent रहा, तो then what will happen? Double aortic arch. Very good, excellent. If this entire right dorsal aorta remains persistent, ये बनेगा double aortic arch. And suppose if this disappears, ये ना ये disappear हो गया, ये fourth arch artery disappear हो गया. Now this right dorsal aorta with the 7th cervical intersegmental, इससे क्या बनेगा? The right dorsal aorta and the right 7th cervical, इससे क्या बनेगा? ये डिसअपियर हो गया, फोर्थ आर्च आर्टरी डिसअपियर हो गया, ये बनेगा एबनॉर्मल राइट सबक्लेवियन आर्टरी. ये बना एबनॉर्मल राइट सबक्लेवियन आर्टरी. यस, डिस्फेजिया लुसोरिया. वेरी गुड. हाँ, तो क्लिनिकल ऐसे आ सकता है, पर्सन कम्स टू यू विद डिस्फेजिया लुसोरिया ऑन, देन फिर वो क्लिनिकल बेस में एमसीक्यू आ सकता है. कंसेप्ट याद रखना बच्चों, कंसेप्ट इज द सेम, एमसीक्यू कैन बी पुट इन एनी डिफरेंट वे, है ना? ठीक है बच्चों, फाइन है. इज दिस क्लियर टू ऑल ऑफ यू? सो ओनली जस्ट रिमेंबर वन, अगर ये है, इफ दिस इज द फोर्थ आर्च आर्टरी एंड द 7th, ये नॉर्मली क्या बनाएगा? सबक्लेवियन. अगर ये परसिस्टेंट रहा राइट डॉर्सल एओर्टा, तो डबल एओर्टिक आर्च बनता है. नाउ परसिस्टेंस ऑफ दिस एंड डिसअपियरेंस ऑफ दिस, अगर ये डिसअपियर हो गया, then the right dorsal aorta and the right 7th से बनेगा abnormal right subclavian artery. परफेक्ट, वेरी गुड, बहुत अच्छा आंसर कर रहे हो आप लोग. वेरी गुड, चलो ग्रेट, वेरी नाइस. ठीक है ना? इज दिस क्लियर टू ऑल ऑफ यू? वेरी गुड. ये क्या है? कैन एनीवन टेल मी व्हाट इज दिस स्ट्रक्चर? ये क्या है? ये व्हाट इज दिस वेन? व्हाट इज दैट वेन? वेरी गुड. ये वेन बताओ कौन है? एनीवन? अभी हमने वेन्स डिस्कस किया था. नहीं, स्मॉल नहीं है वो, दैट्स नॉट स्मॉल कार्डियक वेन, नो. नहीं निर्मल, हाँ दैट्स कोरोनरी साइनस बच्चे, ये कोरोनरी साइनस है. ये पीछे से देख रहे हो ना आप, यू टर्न द हार्ट, दैट्स कोरोनरी साइनस. वेरी गुड, एक्सीलेंट. चलो, वेरी नाइस. ओके, नाउ कमिंग टू द नेक्स्ट टॉपिक बच्चों, कम ऑन, दिस इज वेरी इंपॉर्टेंट. ये क्लिनिकल सवाल आ सकता है. स्किन ओवर द एंगल, मैंने स्ट्रेट फॉरवर्ड बोल दिया आपको, ये क्लिनिकल सवाल भी आ सकता है. पर्सन कम्स विद numbness on the skin over the angle of mandible. बच्चे जूम नहीं कर सकता, I can't zoom this, I can't zoom that. ये स्क्रीन जूम नहीं कर सकता हूं मैं. चलो बच्चा, you tell me, the skin over the angle of mandible is supplied by the greater auricular nerve. This is supplied by the greater auricular nerve. Greater auricular nerve. याद है ना? The skin over the angle of the mandible, this is supplied by the greater auricular nerve. आपको याद है बच्चा, if there is perforating lesion of the skin over the parotid gland, if there's a lesion of the skin over the parotid gland, जब regeneration होता है तो fibers of auriculotemporal nerve जो है वो mix हो जाते हैं with the greater auricular nerve. When there is perforating lesions, मतलब ऐसे बच्चे खेल रहे, वो डार्ट होता है ना, डार्ट खेल रहे, डार्ट आके इधर लग गया, हाँ, the dart hits here, हाँ. Yes, very good. After some days, the what is the child complain of? sweating of the skin over the parotid gland, sweating of the skin over the parotid gland. So there's a mixing of the fibers of the greater-auricular nerve with the auriculotemporal nerve. ये auriculotemporal nerve क्या supply करती है? Parotid gland. The greater-auricular nerve supplies the skin and the sweat gland. So there's Fraze syndrome. Very good. Fraze syndrome. So Fraze syndrome involve which two nerves? Yes, very good, Sadia. Fraze syndrome involve which two nerves? The greater-auricular nerve and the auriculotemporal nerve. वैसे और एक है, what was that? Lacrimation during salivation. Lacrimation during salivation. Yes, बच्चा, करता हूँ. अच्छा, is not uploaded. Bhargav. Okay, I'll do that. मैं करता हूँ. I'll do that. हाँ. Crocodile tears involve which two nerves? Crocodile tears. हाँ, crocodile tears में कौन से nerves का वो है? Or which two glands does it involve? Crocodile tears involve the lacrimal and the submandibular gland. Lacrimal and submandibular. क्या होता है ना, when there's a high lesion of facial nerve का lesion ऊपर हो जाता है, there's a mixing of the fibers going to the lacrimal gland mixed with the fibers going to the submandibular gland. Very good, very good. So there's lacrimation while salivation. That's crocodile tears. Fine. That's crocodile tears. Okay, lag हो गया. Okay, I'm so sorry for that. Okay, fine. Okay, fine. Now it's fine. I'm so sorry for that. Okay, so that's about chorda tympani and greater petrosal. Fine. Okay. Ansa cervicalis. Yeah, ना एक बेटा, you tell me, यहाँ पे carotid sheath होती है, carotid sheath. Carotid sheath के ऊपर there's a loop of nerve. That loop is known as ansa cervicalis. Carotid sheath के ऊपर होता है ansa cervicalis. Ansa cervicalis supplies which muscles? Which muscles does ansa cervicalis supply? Strap muscles, है ना? Strap muscles. Which are those? Sternohyoid, sternothyroid, omohyoid. Sternohyoid, sternothyroid, omohyoid. Which strap muscle does the ansa not supply? Ansa cervicalis वो कौन सा strap muscle को supply नहीं करता है? बोल सकते हो? That's very important. Thyrohyoid. Very good, Nirmal. Excellent. Thyrohyoid को कौन supply करता है? समझ गए ना? You understanding no? ये यहाँ पे strap muscles है. Sternohyoid, sternothyroid, thyrohyoid and omohyoid. So इसमें से all these muscles are supplied by ansa cervicalis except thyrohyoid, which is supplied by बोलो, supplied by, yes Sadia, very good, C1. Excellent. C1 via the hypoglossal nerve. C1. Very good. All of you, you're answering very well. So thyrohyoid को कौन supply करता है? C1. Any other muscle which is supplied by C1? Any other muscle which is supplied by C1? एक thyrohyoid है, दूसरा geniohyoid. याद रखना, that's extremely important बच्चों. C1 क्या सप्लाई करती है? Thyrohyoid and geniohyoid. Thyroid and geniohyoid is supplied by C1. Excellent, very good. Okay, फाइन. अब यह है पोस्टीरियर ट्रायंगल ऑफ द नेक. आपको पता है पोस्टीरियर ट्रायंगल ऑफ द नेक. पोस्टीरियर ट्रायंगल ऑफ द नेक में बहुत ज्यादा इंपॉर्टेंट कंटेंट है स्पाइनल एक्सेसरी नर्व. स्पाइनल एक्सेसरी नर्व एंड दिस स्पाइनल एक्सेसरी नर्व लाइज ऑन द लिवेटस कैपिले. पोस्टीरियर ट्रायंगल पता है ना? स्टर्नोक्लेडोमास्टॉइड, ट्रेपेजियस, क्लैविकल. तो ये है अपना पोस्टीरियर ट्रायंगल ऑफ द नेक. इन दिस पोस्टीरियर ट्रायंगल ऑफ द नेक द मोस्ट इंपॉर्टेंट कंटेंट इज स्पाइनल एक्सेसरी नर्व. And this spinal accessory nerve lies on a muscle. बोल सकते हो what muscle is that? What muscle is that? If you want, I'll draw that. Muscle का नाम पता है? The spinal accessory nerve lies on which muscle in the posterior triangle of the neck? नहीं, sternocleidomastoid नहीं है बच्चे. Sternocleidomastoid नहीं है. नहीं. एक मिनट. I'll draw that for you. सुन लो. चलो फटाफट ट्राइंगल्स देख लो. जस्ट रिवाइज द ट्राइंगल्स फर्स्ट. हाँ, ये है मास्टर्ड प्रोसेस, ये है स्टर्नोक्लेडोमास्टर्ड आ गया। हाँ, ये है अपना ट्रेपीजियस, ये है ट्रेपीजियस। फाइन, जस्ट हैव अ लुक, दैट्स द बॉडी, दैट्स द रेमस ऑफ द मैंडिबल। ये है मिड लाइन ऑफ द नेक, ये है क्लैविकल, ये है, हाँ, तो ये बन गया साइड ऑफ द नेक। हाँ, सो यार लैग कैसे हो रहा है? ये वापस से लैग हो रहा है, देखिए ना। क्या करूं फिर, वो लैग हो रहा है। Okay. See this once again. I'll draw this for you. Okay, no, now. Fine. I'll draw this for you once again. Have a look at this quickly. एक फटाफट रिवाइज कर लेते हैं. ये देखो, that's the, tell me now. That's a mastoid process. ये है sternocleidomastoid. ये that's a sternocleidomastoid. ये है trapezius muscle. ये है बॉडी ऑफ द मैंडिबल, ये है रेमस ऑफ द मैंडिबल, दैट्स अ मिड लाइन ऑफ द नेक। ये होगा क्लैविकल, ये है इमेजिनरी लाइन, ये बन गया अपना साइड ऑफ द नेक। ये दो ट्राइंगल्स बन गए, एंटीरियर पोस्टीरियर ट्राइंगल बाय द स्टर्नोक्लेडोमास्टॉइड। ये है अपना हायोइड बोन। एंड नाउ यू टेल मी व्हाट इज दिस मसल? ये है ओमोहायोइड। That's the omohyoid. The omohyoid divides the posterior triangle into, ये बन गया occipital triangle and ये बना अपना supraclavicular triangle. बस ये boundaries याद रखना triangles के, ये पूछते हैं एग्जाम्स में। हाँ, very good. So that's the superior belly, that's the inferior belly of omohyoid. Inferior belly divides the posterior triangle into an occipital triangle and a supraclavicular triangle. Now you tell me बच्चों, what is this muscle? ये muscle का नाम बताओ, ये कौन है? हाँ, ये है डाइगैस्ट्रिक, दैट्स अ डाइगैस्ट्रिक। ये है पोस्टीरियर बेली ऑफ डाइगैस्ट्रिक, ये है एंटीरियर बेली ऑफ डाइगैस्ट्रिक, पोस्टीरियर एंटीरियर। सो नाउ यू टेल मी हु इज दिस? ये ट्रायंगल्स का नाम बताओ बच्चों। दिस इज नंबर 1, 2, 3 एंड 4। व्हाट इज नंबर 1? नंबर 1 ट्रायंगल कौन है? नंबर 1, हु इज नंबर 1 ट्रायंगल? नंबर 1, हु इज नंबर 1? ट्राइंगल्स के नाम बोलो, इसके बाउंड्रीज आर वेरी इंपॉर्टेंट है, ये याद रखना। दिस इज मस्क्यूलर, वेरी गुड, मस्क्यूलर। ट्राइंगल नंबर 1 इज मस्क्यूलर, नंबर 2 इज कैरोटिड, कैरोटिड ट्राइंगल, नंबर 3 इज डाइगैस्ट्रिक, 3 है डाइगैस्ट्रिक, एंड 4th इज सबमेंटल, 4th इज सबमेंटल ट्राइंगल। ठीक है ना? वेरी गुड। डाइगैस्ट्रिक का दूसरा नाम है सबमैंडिबुलर, डाइगैस्ट्रिक is also known as submandibular. So ये muscular, ये carotid, ये digastric या submandibular triangle बोलो, and that's a submental triangle. Fine. Now in this posterior triangle of the neck एक बहुत important nerve होती है, spinal accessory nerve, lies on a muscle जिसका नाम है levator scapulae. Levator scapulae, यहाँ पे बहुत सारे lymph nodes होते हैं posterior triangle of the neck में, बहुत सारे lymph nodes होते हैं। So this lymph node becomes matted in tuberculosis. ये matted होता है tuberculosis में. Now we are removing a lymph node. आप lymph node का biopsy कर रहे हो and the spinal accessory nerve gets damaged. अगर spinal accessory nerve, if it gets damaged in the posterior triangle of the neck, okay, I'll just make this for you. If the spinal accessory nerve gets damaged in the posterior triangle of the neck, which muscle is affected? Which muscle is affected? ये बहुत important है. देखो बच्चों, the spinal accessory nerve पहले sternocleidomastoid को सप्लाई करती है. हाँ, the spinal accessory nerve first supplies the sternocleidomastoid, फिर ये posterior triangle में आती है, supplies the trapezius. So first supplies the sternocleidomastoid, फिर वो posterior triangle में आती है to supply the trapezius. Now, अगर spinal accessory nerve is damaged here, if the spinal accessory nerve is damaged in the posterior triangle, which muscle is affected? Trapezius. Sternocleidomastoid को already supply हो चुका है. It has already been supplied. So sternocleidomastoid is intact. Who's paralyzed? Trapezius. ठीक है? हाँ, sternocleidomastoid is spared. That's very important. याद रखना, ये concept याद रखना. That's very important. Fine. Okay, that's it. So that was the. So damage to the spinal accessory nerve in the posterior triangle leads to paralysis of trapezius. Sternocleidomastoid is saved. Relations in the lateral wall of cavernous sinus. ये बोल सकते हो आप? Relations in the lateral wall of cavernous sinus बोल सकते हो बच्चों? If I draw this as the cavernous sinus for you, cavernous sinus, I draw this as the pituitary gland. I draw this as the sphenoidal air sinus. What is this? This and this structure. चलो स्टार्ट. ये इंटरनल कैरोटिड आर्टरी. चलो बच्चों बोलो, इस पे बहुत एमसीक्यूज है, इस पे बहुत ज्यादा एमसीक्यूज है. ये कैवर्नस साइनस है, मीडियली है पिट्यूटरी ग्लैंड, स्फीनोइडल एयर साइनस, हुज इन द लैटरल वॉल. ये है थर्ड नर्व, ये है फोर्थ नर्व, ये है ऑफ्थैल्मिक नर्व, थर्ड नर्व, फोर्थ नर्व, ऑफ्थैल्मिक नर्व. एंड व्हाट इज दिस? This is the maxillary nerve. Third nerve, fourth nerve, ophthalmic division and the maxillary division, and this is the sixth nerve. Sixth nerve is in the floor. Sixth nerve is in the floor of the cavernous sinus. ठीक है ना? Which is the nerve not related to the cavernous sinus? Mandibular nerve. याद रखना बच्चा, ये concept है, ये concept पे बहुत MCQs है. Mandibular nerve is not related to the cavernous sinus. Mandibular nerve बहुत, हाँ, latest edition में maxillary nerve भी cancel किया है. हाँ, very good. latest edition में maxillary nerve को भी include नहीं किया है. But कैसे ना बच्चों, आपको वो ऑप्शन देखना है एंड वैसे आंसर करना है. अगर मैंडिबुलर मैक्सिलरी दोनों ऑप्शंस में है, सिलेक्ट मैंडिबुलर. अगर मैंडिबुलर नहीं है, सिलेक्ट वन ऑफ द फॉलोइंग, एंड मैक्सिलरी दिया है तो देन सिलेक्ट मैक्सिलरी. ठीक है ना? ठीक है बच्चों. अभी तक वी वर सेइंग दैट मैंडिबुलर नर्व इज नॉट रिलेटेड टू द कैवर्नस साइनस. रीसेंट एडिशंस, यस वेरी गुड, रीसेंट एडिशंस में मैक्सिलरी नर्व भी इंक्लूड नहीं किया है. बट देन यू हैव टू सी द एमसीक्यू ऑप्शंस एंड जज अकॉर्डिंगली. हाँ, सिक्स नर्व एंड इंटरनल कैरोटिड आर्टरी फ्लोर में. ठीक है? ओके फाइन. हाँ ठीक है, दैट्स फाइन. ओके नो, क्लियर टू ऑल ऑफ यू. सो है ना, एक एमसीक्यू आया था. इन कैवर्नस साइनस थ्रोम्बोसिस ऑल ऑफ द फॉलोइंग आर सीन एक्सेप्ट. उसमें पेन अलोंग द डिस्ट्रीब्यूशन ऑफ थर्ड नर्व, पेन अलोंग द डिस्ट्रीब्यूशन ऑफ फोर्थ नर्व, ऐसे था, पेन अलोंग द डिस्ट्रीब्यूशन ऑफ सिक्स नर्व. एक ऑप्शन था लॉस ऑफ जॉ जर्क, वो आंसर था. जॉ जर्क इज दिस. यहाँ पे टैप करोगे तो दैट्स जॉ जर्क. जॉ जर्क इज मीडिएटेड बाय विच नर्व? मैंडिबुलर नर्व. Jaw jerk is mediated by mandibular nerve. So cavernous sinus thrombosis में all the following will be seen except उसका आंसर था loss of jaw jerk. ठीक है, जस्ट ये याद रखना. Just came to my mind, मैंने बोल दिया आपको. फाइन है बच्चों. Okay, this is fine. Okay, so this is 3-4 ophthalmic and maxillary is a question mark. Maxillary, हाँ, आपको देख के आंसर करना है. Fine. Okay. Now, if anyone can tell me what is ये है ना, लुक इफ यू कैन सी द स्लाइड, ये दिख रहा है क्या? व्हाट इज दिस स्ट्रक्चर? ये कौन है? ये स्ट्रक्चर कौन है? दिस वाज आस्क्ड इन वन ऑफ द एमसीक्यूज। ये विजुअल स्लाइड था, विजुअल स्लाइड। ये कैरोटिड शीथ देख रहे हो? कैरोटिड शीथ, कैरोटिड शीथ के मीडियल साइड पे देयर इज समथिंग, व्हाट इज दैट? कैरोटिड शीथ के मीडियल साइड पे ये जो देख रहे हो, व्हाट इज दैट स्ट्रक्चर? ईसोफेगस नहीं बच्चा, ईसोफेगस नहीं। ईसोफेगस तो ये है, ये थायराइड ग्लैंड है, ये ट्रेक है, ये ईसोफेगस। कैरोटिड शीथ के मीडियल साइड पे, हाँ गौरव, ठीक है ठीक है। inferior wall में नहीं है, it passes through the sinus, yes it passes through the sinus, separated by the dura mater, separated by the dura mater, fine. Okay, tell me what is this structure? ये है sympathetic chain, this is sympathetic chain ना, ये sympathetic chain है। ये एक visual slide आया था, just याद रखना sympathetic chain कहाँ पे है। हाँ, carotid sheath के medial side पे आप देख रहे हो, yes very good Ritik, that is sympathetic chain, वो याद रखना। बाकी carotid sheath के contents you know. Now you tell me what is this in red? What is this in red? This is the investing layer of the deep cervical fascia. ये जो red में है, that's the investing layer. What is this in orange? That's the prevertebral fascia. Prevertebral fascia, that's in orange. And what is this in blue? This is the pretracheal fascia. Pretracheal fascia. Fine. Okay. And fine. Okay, well then proceed. Fine. Which is the first branch of external carotid artery? First branch of external carotid artery, बोल सकते हो external carotid के branches क्या है? What are the branches of external carotid artery? उसको कैसे classify करते हैं? Anterior branches. Anterior branches में superior thyroid lingual facial. Posterior branches में it is posterior auricular and occipital. Medial branch में ascending pharyngeal, and terminal branches is superficial temporal artery and maxillary artery. Superficial temporal and maxillary. The first branch of external carotid artery is ascending pharyngeal. है। फर्स्ट ब्रांच इज ascending pharyngeal. अगर पूछा है फर्स्ट एंटीरियर ब्रांच तो आएगा सुपीरियर थायराइड। दो अलग अलग एमसीक्यूज हैं बच्चों, ये दो अलग अलग एमसीक्यूज हैं। फर्स्ट ब्रांच ऑफ एक्सटर्नल कैरोटिड ascending pharyngeal. फर्स्ट एंटीरियर ब्रांच सुपीरियर थायराइड, याद रखना। ओके फाइन। So branches of external carotid याद रखिए, easy है वो। Muscles of mastication are supplied by which nerve? ये temporalis, masseter, medial and lateral pterygoid. These are all supplied by the mandibular nerve. Mandibular nerve, that's fine. Just I'm interested in this. ये क्या है? This is the articular disc. Articular disc of TM joint. And this articular disc of TM joint is the degenerated part of which muscle? बोल सकते हो? Articular disc of TM joint is a degenerated part of, any guesses? Articular disc of TM joint is a degenerated part of lateral pterygoid. That's very important. Articular disc of TM joint is a degenerated part of lateral pterygoid. ये याद रखना। The only muscle of mastication which depresses the TM joint, ये जितने भी muscles of mastication है ये elevation करते हैं TM joint का। बस एक muscle है, मात्र एक muscle है which causes depression of the TM joint, and that is lateral pterygoid. Just remember that, lateral pterygoid is a depressor of the mandible. Yes, lobus. And articular disc is a degenerated part of lateral pterygoid. Perfect है? हाँ। वैसे और भी डीजनरेटेड पार्ट्स है बच्चों, बोल सकते हो डीजनरेटेड पार्ट्स ऑफ द मसल. कैन यू टेल मी दिस डीजनरेटेड पार्ट? sacrospinous ligament. Sacrospinous ligament is a degenerated part of which muscle? बच्चे एनिमल्स में टेल है, टेल विच इज द मसल विच गोज इन द टेल, कॉक्सिजियस मसल है टेल में. वो कॉक्सिजियस मसल इज वेरी स्ट्रांग, वो टेल से मारते हैं ना एनिमल्स. अब जैसे एंसेस्टर्स केम डाउन, स्टार्टेड वॉकिंग ऑन टू लेग्स, द मसल, द टेल वेंट ऑफ, मसल डीजनरेट हो गया, तो वो कॉक्सिजियस मसल का लिगामेंट बन गया, उसका नाम है सेक्रोस्पाइनस लिगामेंट. सेक्रोस्पाइनस लिगामेंट इज अ डीजनरेटेड पार्ट ऑफ कॉक्सिजियस मसल. Just you remember this. It's a degenerated part of coccygeus muscle. Sacrotuberous ligament. Sacrotuberous ligament is a degenerated part of what? Any guesses? Yeah, hello, bolo bachcho. Sacrotuberous ligament is a degenerated part of long head of biceps femoris. Long head of biceps femoris. बस ये याद रखना, sacrotuberous ligament is long head of biceps femoris. Sacrospinous is coccygeus muscle का degenerated part. Okay. Medial collateral ligament. Medial collateral ligament और tibial collateral ligament is the degenerated part of. Answer this. हाँ, medial collateral ligament पता है ना आपको? Tibial collateral ligament, that's a degenerated part of. Answer this. This is very important. Tibial collateral ligament is a degenerated part of. Any guesses? नहीं, व्रिस्बर्ग नहीं है बच्चे, व्रिस्बर्ग नहीं है. Ligament of Humphrey and Würzburg is something different. Tibial collateral ligament is a degenerated part of adductor magnus. Adductor magnus muscle का degenerated part है. Fibular collateral ligament is a degenerated part of peroneus longus. Peroneus longus muscle का degenerated part है fibular collateral ligament. हाँ, ये याद रखना सब. These are all degenerated parts. याद रखना. Then we have oblique popliteal ligament. Oblique popliteal ligament. Oblique popliteal ligament is a degenerated part of, ये popliteal fossa में होता है, popliteal fossa में होता है. Oblique popliteal ligament, that's a degenerated part of semimembranosus. सेमी मेम्ब्रेनोसिस मसल का डीजनरेटेड पार्ट है ये, बस पॉप्लिटियस का नहीं है. हाँ, वो ऐसे लगता है पॉप्लिटियस है. हाँ, ऑब्लिक पॉप्लिटियल लिगामेंट इज अ डीजनरेटेड पार्ट ऑफ पॉप्लिटियस. नहीं, इट्स अ डीजनरेटेड पार्ट ऑफ सेमी मेम्ब्रेनोसिस मसल. सेमी मेम्ब्रेनोसिस, जस्ट रिमेंबर दिस. दिस डीजनरेटेड पार्ट्स आर वेरी इंपॉर्टेंट, ये याद रखिए. जस्ट लेट दिस बी देयर इन द बैक ऑफ योर माइंड. फाइन है? ओके बच्चों, कम ऑन, विल प्रोसीड. राइट. Right. चलो, so let us go to the next. Answer this. ये कुछ foramens है. Structures passing to the foramens. If you can answer this quickly. Structures passing to the various foramen. चलो start. Superior orbital fissure. Superior orbital fissure से कौन-कौन जाता है? 3, 4, 6 nerves and ophthalmic division of trigeminal nerve. 3, 4, 6 ophthalmic division of trigeminal nerve passes through the superior orbital fissure. गौरव ठीक है ना? समझ में आया ना सब? हाँ बच्चों, is this clear now to all of you? Degenerated parts. हाँ, yes. 3, 4, 6 and optic canal से कौन जाती है? Optic nerve and ophthalmic artery. Optic nerve and ophthalmic artery. Okay, ठीक है. Foramen rotundum से क्या जाता है? Foramen rotundum से who passes is the maxillary nerve. Maxillary nerve passes to the foramen ovale. Foramen rotundum. Foramen ovale से MALE. You know this, no? M is mandibular nerve, accessory meningeal artery, lesser petrosal nerve, emissary vein. Okay, mandibular nerve, accessory meningeal artery, lesser petrosal nerve, emissary vein. Foramen spinosum, middle meningeal artery and nervous spinosus. Middle meningeal artery and nervous spinosus. Internal acoustic meatus में 7th nerve, 8th nerve and labyrinthine artery. 7th nerve, 8th nerve and labyrinthine artery. Anterior condylar canal is what? What is anterior condylar canal? Anyone? बोल सकते हो anterior condylar canal क्या है? MCQ आया था ये. दिस वाज एन एमसीक्यू, स्ट्रक्चर पासिंग टू द एंटीरियर कॉन्डाइलर कैनाल. क्या लगता है? यस, एनी गेसेस? अरे बच्चों, एंटीरियर कॉन्डाइलर कैनाल इज नथिंग बट हाइपोग्लॉसल कैनाल. हाइपोग्लॉसल कैनाल, यही है हाइपोग्लॉसल कैनाल. And what passes to this is hypoglossal nerve. Hypoglossal nerve. Hypoglossal canal. Anterior condylar canal is hypoglossal canal, and what passes through it is the hypoglossal nerve. Fine. Okay, there's one more thing left. जुगुलर फोरामेन. जुगुलर फोरामेन से क्या क्या जाता है? जुगुलर फोरामेन के 3 कंपार्टमेंट्स होता है. जुगुलर फोरामेन के 3 कंपार्टमेंट्स है, एंटीरियर, मिडिल एंड पोस्टीरियर. एंटीरियर, मिडिल एंड पोस्टीरियर कंपार्टमेंट. चलो बच्चों बोल सकते हो, एंटीरियर कंपार्टमेंट व्हाट पासेस? एंटीरियर कंपार्टमेंट ऑफ जुगुलर फोरामेन व्हाट पासेस इज द इंफीरियर पेट्रोसल साइनस. इंफीरियर पेट्रोसल साइनस. मिडिल कंपार्टमेंट इज 9th, 10th and 11th cranial nerves, and posterior compartment is sigmoid sinus. Sigmoid sinus. ठीक है, जस्ट रिमेंबर ऑल दिस फोरामेन्स, बहुत इंपॉर्टेंट है, ये पूछते हैं. सो जुगुलर फोरामेन के 3 कंपार्टमेंट्स हैं, एंटीरियर, मिडिल, पोस्टीरियर. एंटीरियर कंपार्टमेंट इंफीरियर पेट्रोसल साइनस गोस. पोस्टीरियर कंपार्टमेंट से सिग्मॉइड साइनस निकलती है. दिस सिग्मॉइड साइनस लेटर बिकम्स व्हाट? द इंटरनल जुगुलर वेन. मिडिल कंपार्टमेंट से जाती है 9th, 10th, 11th cranial nerves. फाइन. Okay, clear to all of you? Everything is clear? Okay, just quickly tell me, what is this fold? ये है vestibular fold, नीचे वाला fold vocal fold. Sensory nerve supply above the vocal fold. Sensory nerve supply above the vocal fold is internal laryngeal nerve. Sensory nerve supply below the vocal fold is recurrent laryngeal nerve. नहीं, internal jugular vein is derived from sigmoid sinus. Sigmoid sinus. Sigmoid sinus है वो. Okay. Which is the nerve of the first pharyngeal arch? बोल सकते हो nerve of the first pharyngeal arch. ये सब याद रखना. Nerve of the first pharyngeal arch is mandibular nerve. Mandibular nerve. Muscles derived from the first pharyngeal arch. Muscles of mastication. What else? Tensor palatii, tensor tympani, mylohyoid and the anterior belly of digastric. ये HFN embryo बहुत इंपॉर्टेंट है. फर्स्ट आर्च की नर्व है मैंडिबुलर नर्व. मसल्स है 4 मसल्स ऑफ मास्टिकेशन. फिर टेंसर पैलिटी, टेंसर टिम्पैनी, mylohyoid, anterior belly of digastric. These are the muscles in the first arch. Nerve of the second arch, facial. Nerve of the second arch is facial. Muscles कौन है? Muscles of facial expressions, stapedius, posterior belly of digastric and stylohyoid. Muscles of facial expressions, then stapedius muscle in the ear, posterior belly of digastric and stylohyoid. Muscles याद रखना बच्चों, muscles पे बहुत MCQs आते हैं. थर्ड आर्च की नर्व है glossopharyngeal nerve. मसल बोलो, जस्ट नेम. एक मसल है थर्ड आर्च में. There's only one muscle in the third arch. नाम बताओ, नाम बताओ. Muscle in the third arch. नेम. नाम बता सकते हो? स्टाइलोफैरिंजिस. वेरी गुड. मसल का नाम है स्टाइलोफैरिंजिस. बच्चों एक सवाल पूछूं मैं? I'll just ask you one question. Just tell me one thing. वो कौन सा न्यूक्लियस है ग्लॉसोफैरिंजियल नर्व का जो स्टाइलोफैरिंजिस को सप्लाई करता है? Which is that nucleus of glossopharyngeal nerve which supplies the stylopharyngeus muscle? बोल सकते हो? तो एक साथ सब हो जाता है. Everything gets done. Which is the muscle of, which is the nucleus of glossopharyngeal nerve जो stylopharyngeus को सप्लाई करेगा? सोचो. यस आदिया, निर्मल, गौरव बोलो. एनटीएस नहीं है बच्चे, एनटीएस नहीं है. You're close to it. You're very close to it. Nucleus of tractus solitarius is a sensory nucleus. NTS is for tongue. Sensory है वो. Which is the nucleus of glossopharyngeal nerve which is going to supply the stylopharyngeus. वो common nucleus है for the 9th, 10th and the cranial accessory. वो है nucleus ambiguous. इंफीरियर सैलाइटी नहीं है बच्चे. इंफीरियर सैलाइटी न्यूक्लियस पैरोटिड को सप्लाई करता है. सादिया बच्चे, न्यूक्लियस एम्बोलिफॉर्मिस सेरेबेलम का न्यूक्लियस है बच्चे. वो सेरेबेलम का न्यूक्लियस है, न्यूक्लियस एम्बोलिफॉर्मिस. फाइन. सी यू आंसर, यू विल मेक मिस्टेक्स, दैट्स ओके. यहां पे गलती करो, सो यू विल अंडरस्टैंड इट. समझ में आया? द नेम ऑफ द न्यूक्लियस इज न्यूक्लियस एम्बिगुअस. न्यूक्लियस एम्बिगुअस है वो. फाइन. Can anyone tell me what is the name of the nucleus of facial nerve जो muscles of the second pharyngeal arch को supply करती है? Anyone? Name of the nucleus of facial nerve जो muscles of second pharyngeal arch को supply करता है, वो nucleus का नाम क्या है? जिसमें वो facial colliculus बनता है, facial colliculus, वो nucleus का नाम बताओ. समझ में आ रहा है ना? What I'm asking, are you able to follow? हाँ, समझ में आ रहा है? ये ऐसे कोरिलेट करो बच्चों, ऐसे कोरिलेट करो. मतलब फेशियल नर्व के बहुत सारे न्यूक्लियस है. अब विच इज द न्यूक्लियस ऑफ फेशियल नर्व विच सप्लाइज द मसल्स ऑफ सेकंड फेरेंजियल आर्च? वो न्यूक्लियस का नाम है मोटर न्यूक्लियस ऑफ फेशियल नर्व. दैट्स अ मोटर न्यूक्लियस ऑफ फेशियल नर्व. समझ में आ रहा है? हाँ, समझ में आ रहा है? ये फेशियल नर्व का जो सुपीरियर सलाइवरी न्यूक्लियस है ना, वो ग्लैंड्स को सप्लाई करता है. न्यूक्लियस ऑफ ट्रैक्टस सॉलिटेरियस टंग से लेके जाता है सेंसेशंस. Nucleus of tractus solitarius is the common nucleus for 7, 9 and 10 cranial nerve. Tractus solitarius is 7, 9 and 10. बच्चों समझ में आया ये? हाँ, nucleus ambiguous and nucleus of tractus solitarius में फर्क है. हाँ, this is something which is difficult, which you should know. देखो एक मिनट, I'll just make it easy for you. Nucleus of tractus solitarius एक है and एक nucleus ambiguous है. This is sensory nucleus and this is a motor nucleus. This is common for which nerves? 7, 9 and 10 nerves. ये common nucleus है. And this is common for 9, 10 and 11 nerve. 9, 10 and 11. Fine है? Okay, fine. Fourth pharyngeal arch की nerve बोलो. Which is the nerve of the fourth pharyngeal arch? That's a superior laryngeal nerve. This is repeated. Sixth pharyngeal arch की nerve है recurrent laryngeal nerve. Recurrent. Fourth की superior laryngeal nerve. Sixth is recurrent laryngeal nerve. Superior divides into an external laryngeal nerve and an external laryngeal nerve and internal laryngeal nerve. External laryngeal nerve supplies what? External laryngeal nerve supplies cricothyroid muscle. External laryngeal nerve supplies the cricothyroid muscle, which is the tensor of the vocal cords. ये है tensor of the vocal cords. Cricothyroid. Rest all the muscles are supplied by recurrent laryngeal nerve. Recurrent laryngeal nerve. Perfect. Okay. Okay. Can you tell me what is this plexus? ये जो plexus है ना, what is this rounded thing? ये है medial wall of middle ear. Medial wall. Okay, ये देख लो. Anterior wall of middle ear. Anterior wall of middle ear. This is for the eustachian tube and that's for the tensor tympani muscle. दो openings है. Eustachian tube and tensor tympani. नीचे है internal carotid artery. Anterior wall. Posterior wall पे होता है adductus to the mastoid. Adductus to the mastoid. नीचे होता है ये jugular bulb. Middle ear cavity में नीचे होता है jugular bulb. Medial wall देख लो. Medial wall. ये है promontory. Promontory पे जो plexus है, that's a tympanic plexus. Tympanic plexus. This is the facial canal. This is the prominence of lateral semicircular canal. Lateral semicircular canal. That's a facial canal. This is oval window. This is round window. Oval window, round window. Fine. This you must be knowing. ये आपको पता होगा ना. What is the nerve supply of middle ear cavity? Nerve supply of middle ear cavity is tympanic plexus. Middle ear cavity is supplied by glossopharyngeal nerve through the tympanic plexus. Tympanic plexus कैसे बनता है? Tympanic branch of glossopharyngeal nerve with sympathetics. उससे बनता है tympanic plexus. Okay, fine बच्चों, come on. We'll then proceed. Okay. What is that? Fine. Jacobson's nerve, very good. Jacobson's nerve. Jacobson's nerve. What is Vidian's nerve? बोल सकते हो? Vidian's nerve. Jacobson's nerve is tympanic branch of glossopharyngeal nerve. What is Vidian's nerve? Nerve pterygoid canal. Very good. Nerve pterygoid canal is Vidian's nerve. And what is Alderman's nerve? Very good, very good. Alderman's nerve is the auricular branch of vagus. Excellent, very good. बहुत अच्छा preparation हुआ है आपका. वेरी गुड प्रिपरेशन एंड बेसिक साइंसेस जिसके अच्छे हैं ना, दे ऑलवेज डू वेल इन द एग्जाम्स, ठीक है ना। बेसिक साइंसेस पे कॉन्फिडेंस चाहिए, राइट, वेरी गुड। ऑरिकुलर ब्रांच ऑफ वेगस इज एल्डरमैन्स नर्व, ओके, और अल्नॉन्स नर्व और एल्डरमैन्स नर्व सेम, ओके। जस्ट टेल मी, ये फर्स्ट एंडोडर्मल पाउच से बनता है ट्यूबोटिम्पैनिक रीसिस। ट्यूबोटिम्पैनिक रीसिस से दो चीज बनती है, वन इज मिडिल ईयर कैविटी एंड यूस्टेशियन ट्यूब। ओके, ये फर्स्ट एंडोडर्मल पाउच है, ये ट्यूबोटिम्पैनिक रीसिस है, इससे बनता है मिडिल ईयर कैविटी एंड यूस्टेशियन ट्यूब। सेकंड से बनता है पैलेटाइन टॉन्सिल। द थर्ड एंडोडर्मल पाउच गिव्स टू थिंग्स, अ डॉर्सल एंड वेंट्रल। हाँ बोलो बच्चों, डॉर्सल एंड वेंट्रल। वेंट्रल से बनता है थाइमस एंड डॉर्सल से बनता है इंफीरियर पैराथायरॉइड्स। ये बहुत इंपॉर्टेंट है। थाइमस इज डिराइव्ड फ्रॉम व्हाट? Thymus is derived from the ventral part of the third endodermal pouch. Just remember this. First से बनता है tubotympanic rhesus, जिससे बनती है middle ear cavity and eustachian tube. The second forms the palatine tonsil. The third divides into a dorsal ventral. Dorsal से बनता है inferior parathyroids and ventral से बना thymus. ठीक है, fine. Then fourth divides into dorsal and ventral. Dorsal से बनता है superior parathyroids and ventral joins with the sixth and forms what? Ultimobranchial body. Okay, so the ventral part of the fourth joins with the sixth and forms the ultimobranchial body. Yes, D. George's syndrome. Fine. Okay, बस remember करना ये, just remember all this endodermal pouches, ठीक है। Okay, now we'll start with the next part. चलो बच्चों, we'll start with the next part. Last 1 hour left. Starting with Wernicke's area. नंबर बोलो Wernicke's area. Wernicke's area का नंबर, हाँ चलो start. What is the number of Wernicke's area? Functional area का नंबर 22. Where is the Wernicke's area located? Wernicke's area is located in, where is it located? In the superior temporal gyrus. Right. Broca's area 44-45. Where is this located? In the inferior frontal gyrus. Right. Broca's area 44-45, inferior frontal gyrus. ये याद रखना, this had come as an MCQ. ये MCQ आया था. This was an MCQ. Fine. Uncinate fasciculus. Uncinate fasciculus is also known as, इसका दूसरा नाम है arcuate fasciculus. What does it connect? Wernicke's and Broca's area. Uncinate fasciculus connects the Wernicke's and Broca's area. याद है, पता है ना ये? Uncinate fasciculus connects Wernicke's and Broca's area. Conduction aphasia. Very good. Conduction aphasia. What is the blood supply of motor and the sensory cortex? Can anyone answer this? Blood supply of motor or sensory cortex? ये सब MCQs आ चुके हैं. These are all very important things. Blood supply of the motor cortex. चलो answer this, बच्चों, answer this. Blood supply of the motor cortex or blood supply of the sensory cortex? Anyone? yes. Anyone? Middle cerebral बोल रहे हो ना? Blood supply of the motor area. एक मिनट, just see this. See the slide. ये है supralateral surface, ये है medial surface of the brain. Tell me बच्चा, what is this artery which runs in the lateral sulcus? ये artery का नाम बोल सकते हो? That's the middle cerebral artery. Fine, that's the middle cerebral artery. And the artery which runs in the callosal sulcus, ये कौन है? Who's this? This is the anterior cerebral artery. ये anterior cerebral artery है, right? इसमें ना बहुत गलती करते हैं बच्चे. ये है मोटर एरिया एंड ये है सेंसरी एरिया. मोटर एरिया, सेंसरी एरिया, ठीक है. नाउ टेल मी, द एंटीरियर सेरेब्रल आर्टरी सप्लाइज द एंटायर मीडियल सरफेस. पूरा मीडियल सरफेस को सप्लाई करते हैं एंटीरियर सेरेब्रल आर्टरी. एंटीरियर सेरेब्रल आर्टरी गोज टू दैट साइड. मतलब a small area here is supplied by whom? एक छोटा सा area on the supralateral surface is supplied by anterior cerebral artery. Middle cerebral artery supplies the entire superolateral surface. Entire superolateral surface is supplied by middle cerebral artery. अब बोलो this much part is supplied by middle cerebral, this much part is supplied by anterior cerebral. So blood supply of motor cortex will be what? Blood supply of motor or sensory cortex will be MCA plus ACA. MCA plus ACA, दो आर्टरीज है बच्चों, ये याद रखना. There are two arteries which supply the motor or the sensory area. MCA and ACA. ये clear है? This is very important. And the occipital lobe is supplied by what? Occipital lobe is supplied by PCA. मतलब visual cortex is supplied by PCA plus MCA. MCA supplies what? Macula. Macula. एग्जाम में एक ही दिया तो मेजर पार्ट चूज करना है बच्चा. एग्जाम में जावेद अगर एक ही दिया है ना, हाँ, तो मेजर पार्ट जो सप्लाई करता है वो लेना है. यस, एमसीए, देन एमसीए. बट आइडियली इट्स टू आर्टरीज. आइडियली दो आर्टरीज है. एंड visual cortex is supplied by whom? Major part PCA. The macula is supplied by middle cerebral artery. Hi Jayant, क्या हुआ? Clear to all of you? Okay, fine. Just याद रखिए ये. So ये clear है ना? So all these things are clear. Now we'll go to the next one. Have a look at this. मैं ना एक शॉर्ट में एक स्लाइड बनाता हूँ बच्चा, एक शॉर्ट में एक स्लाइड बनाता हूँ आपके लिए. सो ये ना आपका पूरा वीनस ड्रेनेज ऑफ द ब्रेन हो जाएगा उसमें. हाँ, कैसे बनाऊँ अब इसको? ओके, जस्ट हैव अ लुक एट दिस. दिस आर द टू इंटरनल सेरेब्रल वेन्स. है ना, एक है ना, एक इजी स्लाइड बनाता हूँ मैं आपको. दिस आर द इंटरनल cerebral vein. That's a deep vein of the brain. And this internal cerebral vein is formed by joining of three veins join होके ये internal cerebral veins बनते हैं. तीन veins कौन से हैं? एक है thalamostriate. बस ये याद रखना बच्चा, thalamostriate vein, ये सब veins हैं. choroidal vein and septal vein. Thalamostriate vein, choroidal vein, septal vein, ये तीनों join होते हैं. इसका बनता है internal cerebral vein. Two internal cerebral vein joins to form the great cerebral vein. The great cerebral vein of Galen. And this great cerebral vein of Galen drains into straight sinus. बस ये स्लाइड याद रखना. मतलब how is a great cerebral vein of Galen formed? It is formed by joining of two internal cerebral veins. ये deep veins है. दो internal cerebral veins join होते हैं, उससे बनता है great cerebral vein of Galen. Internal cerebral vein is formed by joining of three veins: thalamostriate, choroidal and septal. बस. And this great cerebral vein of Galen में what drains here on both the sides is basal vein. And this basal vein is formed by joining of three veins. ये जो basal vein है ना, that drains into great cerebral vein of Galen. And basal vein is joined by joining of three veins. बोल सकते हो? Anterior cerebral, deep middle cerebral, and striate veins. बस, that's it. ये पूरा venous drainage हो गया. देखो इसमें पूरा venous drainage आ गया आपका. मतलब इसमें basal vein कैसे बनता है? Basal vein is formed by joining of three veins: anterior cerebral, deep middle cerebral and स्ट्राइड वेन्स, 3 मिला के बनता है बेसल वेन. बेसल वेन drains into great cerebral vein. Great cerebral vein is formed by joining of 2 internal cerebral veins. Internal cerebral vein is formed by joining of 3 veins. ठीक है, इज दिस क्लियर? ये पूरा मतलब इन वन फ्लो चार्ट सारे वेन्स आ गए. दिस ओके, क्लियर? बोलो बच्चों, फाइन है? हाय स्नेहजीत, दिस इज नाइस. मतलब ये एक बार याद करोगे ना, दैट्स इट. सो स्नेहजीत, हाउ आर यू? फाइन, रिमेम्बरिंग फर्स्ट ईयर. ओके चलो, दैट्स ग्रेट. फाइन, दैट्स इट. सो जस्ट रिमेंबर दिस, सर्कल ऑफ विलिस आपको पता होगा. एक मैं बोलता हूँ, जस्ट टेल मी the artery which does not participate in the formation of circle of Willis. The artery which does not take place in the formation of circle of Willis. बस ये आंसर कर दो. आए बच्चे, गुड आफ्टरनून. The artery which does not take part in the formation of circle of Willis is, ये MCQ आया था. क्या है ये? पोस्टीरियर नहीं है बच्चे. अरे नहीं रे बच्चे, पोस्टीरियर सेरेब्रल नहीं है. नहीं, वैसे नहीं है. नहीं, एक मिनट. दैट वाज द एमसीक्यू. सी दिस, ये कौन है? अपनी इंटरनल कैरोटिड. हाँ, इंटरनल कैरोटिड. एक मिनट, आई जस्ट ड्रॉ दिस फॉर यू. ये कौन है? अपना एंटीरियर सेरेब्रल आर्टरी. ये है अपना मिडिल सेरेब्रल आर्टरी. मिडिल सेरेब्रल, ठीक है. अब यहां से आगे दो वर्टिब्रल से बना बेसिलर, बेसिलर से बना पोस्टीरियर सेरेब्रल. अब व्हाट इज दिस? posterior communicating, and what is this? Anterior communicating. So now you tell me. Answer is middle cerebral artery. So circle of Willis is formed कैसे बनता है? One is I'll write anterior communicating artery, anterior cerebral artery, internal carotid artery, posterior communicating artery and posterior cerebral artery. इससे बनेगा circle of Willis. Circle of Willis is not formed by middle cerebral artery. ये याद रखना. Circle of Willis is not formed by middle cerebral artery. Fine है? Just remember this. And this circle of Willis lies in the interpeduncular fossa. Interpeduncular fossa में होता है ये. Okay, that's fine. Fine, this is fine. Okay. Now you tell me what is this structure? ये कौन है? What is this rounded structure? ये इस पे भी बहुत क्या हुआ बच्चे? नहीं, that's okay. But you be very clear. MCQ अच्छे से पढ़ना and फिर आंसर करना. Because what is this rounded thing? Facial colliculus. Facial colliculus is formed by fibers of which? चलो अब बोलो ये कौन है? What's this number 1 and what's this number 2? That's facial colliculus. Very good, bacha. So facial colliculus is formed by the fibers of which nerve? Facial nerve. And ये nucleus का नाम क्या है? ये nucleus है motor nucleus of facial nerve. That's a motor nucleus of facial nerve. And what is this? ये कौन है? ये कौन है? Abducens nucleus. Very good. Abducens nucleus. So बहुत बार MCQ ऐसे आता है. Damage to the fibers forming the facial colliculus. तो involvement facial nerve का है. And if there's a damage to a structure beneath the facial colliculus, तो वो आता है abducens nucleus. दो अलग अलग things है. These are two different things. Damage to the structure beneath the facial colliculus. तो which muscle would be paralyzed? Yes. Which muscle would be paralyzed? अगर abducens nucleus गया तो lateral rectus is gone. And damage to the fibers forming the facial colliculus, तो उसमें एक आधा muscle of facial expression होगा. Rhizorius. Okay, fine. तो just remember these two things are very important. ये दो चीजें बहुत ज्यादा important है. Okay, fine. See, if this comes as a visual slide, ये बहुत ज्यादा. Okay, I'll just draw the slide for you. You tell me. I'll just draw the slide. That's a midbrain that's a pons, and that's a medulla. ये है pyramids, ये है olives, and that's the inferior cerebellar peduncle. This is pyramids, that's the olives, and that's the inferior cerebellar peduncle. Fine. Just tell me the nerves attached to the brainstem. Nerves attached to the brainstem. This is midbrain, this is pons, this is medulla. Chalo, start bachcho. What is this nerve? This nerve, which is attached to the midbrain. वैसे all the nerves emerge from the ventral aspect. The only nerve which comes from the dorsal aspect, पीछे से आती. What is this nerve? That's the fourth nerve. The only nerve which emerges from the dorsal aspect is the fourth nerve, right? So which is this nerve? ये कौन है? ये third है. So third nerve is attached to the midbrain at the level of superior colliculus. Fourth nerve is attached to the midbrain at the level of inferior colliculus. Right. Now you tell me what is this? ये है middle cerebellar peduncle. Middle cerebellar peduncle. So the nerve attached at the junction of pons with the middle cerebellar peduncle. ये कौन है? Fifth. Nerve attached at the junction of pons with the middle cerebellar peduncle is fifth nerve. Yes, trochlear comes from the dorsal aspect. Yes. Now, nerve attached to the pontomedullary junction. बोल सकते हो ये कौन है? A, B, C. Answer this. A, B. बोलो ये कौन है? A, B, C. Nerve attached to the pontomedullary junction is 6th, 7th, and 8th. 6th, 7th, 8th. Very good. What are the nerves attached between the olives? Sorry, what are the nerves attached between the olives and the inferior cerebellar peduncle? This is 9th, 10th, and the cranial accessory. 9th, 10th, and cranial accessory. And nerve between the pyramids and the olives is 12th. ठीक है ना? Between the pyramids and the olives is the 12th nerve. Between the olives and the inferior cerebellar peduncle is 9th, 10th, and 11th nerve. ये याद रखना. This is very important. Fine. Is this clear? The structures attached to the brainstem, the nerve attached to the brainstem. Just remember this. Okay. Very good. Very good. Fine. That's it. Okay. Can you tell me the fiber which passes to the middle cerebellar peduncle? Fiber passing through the middle cerebellar peduncle is, which is that fiber which goes through the middle cerebellar peduncle? Any guesses? बोलो 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 बच्चों. मिडिल सेरेबेलर, एक ही फाइबर जाता है मिडिल सेरेबेलर पेडंकल से. बोल सकते हो? हाँ, आंसर. Fiber passing to the middle cerebellar peduncle. What's that? Pontocerebellar. हाँ, pontocerebellar fibers है. Pontocerebellar fibers. Fine, that is fine. Now tell me, हाँ, pontocerebellar. क्लाइंबिंग नहीं है धर्मेश. क्लाइंबिंग फाइबर्स आर ओलिवोसेरेबेलर. क्लाइंबिंग फाइबर्स जो होते हैं ना वो ओलिवोसेरेबेलर होते हैं. फाइन. ओके, नाउ यू टेल मी व्हाट इज दिस रिंग. चलो ये तो आपको पता है. आई एम नॉट गोइंग टू दिस द सुपरफिशियल इंग्वाइनल रिंग व्हिच इज अ डिफेक्ट इन एक्सटर्नल ऑब्लिक एपोन्यूरोसिस. द डीप इंग्वाइनल रिंग इज अ डिफेक्ट इन फेशिया ट्रांसवर्सालिस. फेशिया ट्रांसवर्सालिस. रेक्टस एब्डोमिनस. जस्ट क्विकली टेल मी रेक्टस शीथ. रेक्टस शीथ है ना, इस पे शॉर्ट नोट आता है. रेक्टस शीथ बोल सकते हो. रेक्टस शीथ. एक क्विकली आई विल जस्ट मेक दिस रेक्टस शीथ फॉर यू. हाँ, रेक्टस शीथ इज स्टडीड इन, ये रिब्स है, रिब्स. हाँ, ये मैन्यूब्रम स्टर्ना है. Rectus sheath is studied in three parts. The first part is above the costal margin. Second part is below the costal margin and a line drawn between the umbilicus and the pubic symphysis. And the third part is here. So that's the first, second and third part. ये line का नाम है arcuate line. इस पे MCQs आते हैं बच्चे. So you have to know this. I'll just make it here. Rectus abdominis, rectus abdominis, rectus abdominis. Chalo, start. Now, this is the rectus sheath. Rectus sheath above the costal margin first. Rectus sheath below the costal margin and a line drawn between the umbilicus and the pubic symphysis. That's the second part. And the third part is rectus sheath below this line. This line is also known as the arcuate line. बोल सकते हो? ये तीनों areas में who forms the anterior wall? ये तीनों areas में anterior wall is formed by the external oblique muscle. तीनों areas में external oblique. In the first part, posterior wall is deficit, पीछे कुछ नहीं होता, पीछे are the costal cartilages. This comes in MCQs, बच्चों ये याद रखना, this is the external oblique. So the rectus sheath above the costal margin, anterior wall is formed by external oblique, posterior wall deficit होता है, the rectus abdominis lies on the costal cartilage. ये हो गया above the costal margins. Now come to the second part, below the costal margin and this line. The anterior wall is formed by, number one, external oblique, then internal oblique यहाँ पे आके divide हो जाता है ऐसे. So anterior wall is formed by the external oblique and the anterior lamina of internal oblique. Posterior wall is formed by the posterior lamina of internal oblique. फिर आएगा transverse abdominis and आता है fascia transversalis. Fascia transversalis. ये पता है ना आपको? So rectus sheath here in the second part, anterior wall कौन बनाता है? इस पे MCQs आते हैं बच्चों, ये याद रखना. Anterior wall is formed by the external oblique and the anterior lamina of internal oblique. Posterior wall is formed by the posterior lamina of internal oblique, the transverse abdominis and the fascia transversalis. Fascia transversalis. Fine. Okay, now coming to this, that's okay. Now coming to this third part, below this line, ये जितने भी मसल्स हैं वो आगे से जाता है. ये एक्सटर्नल हो गया, ये इंटरनल हो गया एंड ये ट्रांसवर्स एब्डोमिनस हो गया. ये तीनों आगे गए एंड द पोस्टीरियर वॉल इज फॉर्म्ड बाय फेशिया ट्रांसवर्सालिस. बस ये याद रखना. So anterior wall below this line is formed by all the three muscles of the abdomen. पीछे क्या होता है? Fascia transversalis. That's it. That's fine. It's clear now to all of you. बच्चों clear है? That's about the rectus sheath. ये याद रखना, ये MCQs भी आते हैं इस पे, हाँ, rectus sheath पे. Okay. धर्मेश क्लियर है? सादिया? यस. गौरव? चलो, we'll proceed then. That's about the rectus sheath. Now tell me. Chalo, come on students, come on. Now you can answer this. What is this opening here? Chalo, answer this. What is this opening? A very, very important MCQ. What is this opening? हाँ, foramen of Winslow. Very good. Foramen of Winslow और epiploic foramen. इसके boundaries बोलो. बहुत ज्यादा important है. Boundaries of epiploic foramen anteriorly. Anteriorly is lesser omentum. Lesser omentum में तीन चीजें होती है, hepatic artery, portal vein, bile duct. So anteriorly is the lesser omentum containing hepatic artery, portal vein, bile duct. पीछे posterior बोल सकते हो. Posterior is IVC. Posterior होता है IVC. Very good. Superiorly is the caudate lobe of liver. Caudate lobe of liver. And inferior is the first part of duodenum. Inferiorly is the first part of duodenum. Very good. बस इतना ही याद रखो. Anteriorly less omentum में तीन चीजें होती है, hepatic artery, portal vein, bile duct. पीछे होता है IVC और पीछे जाओगे तो body of T12 भी आता है and right suprarenal gland भी आता है. Superiorly is the caudate lobe, inferior is IVC. That's epiploic foramen of Winslow. Okay, that's first part of duodenum. Now coming to this fetal circulation. ये बहुत ज्यादा important है बच्चों. Fetal circulation, quickly I'll just go through it. Contents of umbilical cord बोलो. What are the contents of umbilical cord? 2 arteries and 1 vein. Which vein is that? The left umbilical vein. So 2 umbilical arteries and the left umbilical vein. हाँ, quickly draw कर रहा हूँ. ये portal vein है, ये बड़ा सा IVC है. चलो, I'll start. The left umbilical vein goes and joins with what? ये जो left umbilical vein है, it goes and joins with the left branch of portal vein. Left umbilical vein कहाँ से आती है? Placenta से आती है. The left umbilical vein comes from the placenta, goes and joins with the left branch of portal vein. This is carrying pure blood. अगर ये pure blood portal vein में गया, portal vein से it will go to the liver. The liver will use all this pure blood for its own metabolism. Liver पूरा blood utilize कर लेगा. So देयर हैज टू बी अ बाईपास। एक बाईपास होता है फ्रॉम द लेफ्ट ब्रांच ऑफ पोर्टल वेन टू द आईवीसी, नाम है डक्टस वेनोसिस। ठीक है, फ्रॉम द लेफ्ट ब्रांच ऑफ पोर्टल वेन टू द आईवीसी, दैट्स डक्टस वेनोसिस। आईवीसी से द ब्लड गोज वेयर, द ब्लड गोज टू द राइट एट्रियम, राइट एट्रियम से डायरेक्टली ब्लड जाता है लेफ्ट एट्रियम में थ्रू फोरामेन ओवेल, फोरामेन ओवेल। लेफ्ट एट्रियम से ब्लड गया लेफ्ट वेंट्रिकल में, लेफ्ट वेंट्रिकल से गया एओर्टा, एओर्टा डिवाइड्स इनटू टू कॉमन iliacs, common iliacs divides into external iliac and internal iliac, external and internal, and from the internal iliac दो arteries आती है, from the internal iliac two arteries come here. What are these? Umbilical arteries. ये है अपनी umbilical arteries, right? So umbilical arteries are branches of what? Internal iliac. So these are the umbilical arteries. Fine है बच्चों? Now suppose from the right atrium अगर blood right ventricle में गया, right ventricles में lungs में जाएगा, but the lungs are not functioning, so there's a bypass here. What is this? So sorry, right ventricle से pulmonary trunk में जाएगा, pulmonary trunk से वो lungs में जाएगा, so this is the pulmonary trunk, and pulmonary trunk से lungs में जाएगा, but it should not go in the lungs, so यहाँ पे एक bypass है. What is that bypass known as? Ductus arteriosus. That's ductus arteriosus. Fine. Now, just one last thing. ये जब umbilical arteries है, umbilical arteries are coming towards the umbilicus, तो बीच में आता है urinary bladder. बीच में आता है urinary bladder. So one umbilical artery goes from this side, दूसरा ऐसे जाता है. Both the umbilical arteries from the pelvis, they go towards the umbilicus on both sides of the urinary bladder. This is fetal circulation. ये है fetal circulation. अब बोलो आफ्टर बर्थ, आफ्टर बर्थ व्हाट हैपेंस? द लेफ्ट अम्बिलिकल वेन इज गॉन. इसका क्या होता है? आंसर दिस. द लेफ्ट अम्बिलिकल वेन बिकम्स व्हाट? लिगामेंटम टीरीज. लेफ्ट अम्बिलिकल वेन का बना लिगामेंटम टीरीज. डक्टस वेनोसिस का बना लिगामेंटम वीनोसम. हाँ, ये बना लिगामेंटम वीनोसम. फाइन. फोरामेन ओवेल का बना फोसा ओवालिस, फोसा ओवालिस. डक्टस आर्टेरियोसिस का बना लिगामेंटम आर्टेरियोसम, ligamentum arteriosum. Okay, that is ductus arteriosus. Fine. Now you tell me, this part of the umbilical artery disappears from the bladder to the umbilicus. ये obliterate होता है. What is that? What is this known as? This is the obliterated umbilical artery. No. Obliterated umbilical artery, इसे हम बोलते हैं medial umbilical ligament. Just remember this. ये बहुत ज्यादा इंपॉर्टेंट है. So what is medial umbilical ligament? It is the obliterated umbilical artery. अब जो non obliterated part है ना, ये वाला, the non obliterated part of umbilical artery, ये बनेगा superior vesical artery. Superior vesical artery. So superior vesical artery is the non-obliterated part of umbilical artery, and the obliterated part of umbilical artery becomes the medial umbilical ligament. Fine. Is this clear to all of you? Fetal life में from the bladder to the umbilicus, fetal life में from the bladder to the umbilicus एक communication होता है. What is that communication known as? Urachus. From the bladder to the umbilicus एक communication होता है, उसका नाम है urachus और allantois. After birth, this communication is gone. इसे बोलते हैं median umbilical ligament. So median umbilical ligament is the obliterated urachus. It's the obliterated urachus. ये याद रखना बच्चों. Median umbilical ligament is the obliterated urachus. The medial umbilical ligament is the obliterated umbilical artery. Clear hai? Yes, all of you clear? This fetal circulation is clear? Yes, Sadia, Nirmal, Gaurav, my clinical. Okay, fine. Clear to all of you? Just remember this. Yes. Okay. Chalo. that's about it. That's about it. हाँ, तो ये fetal circulation है, ये याद करना आप. Just remember this fetal circulation. Okay. Can you tell me which is the artery which lies behind the first part of the duodenum? बस ये सीधा MCQ में बोल रहा हूँ आपको. The artery which lies behind the first part of the duodenum. जब duodenum में अल्सर होता है first part of the duodenum के posterior wall पे. Ulcers are very common in the first part of the duodenum, posterior wall. जब ulcer होता है, it erodes an artery which lies on the posterior aspect of the first part of the duodenum. That is gastroduodenal artery. Very good. That's gastroduodenal artery. So artery which is present behind the first part of the duodenum is gastroduodenal artery. Very commonly eroded in ulcers. बस ये याद रखना. Okay. Fine. What is this defect? ये clinical condition है, बोल सकते हैं what is this defect? What is this defect known as? Annular pancreas. That's annular pancreas. This is another very important thing. Annular pancreas occurs due to, answer this, ये बहुत important सवाल है ना? Clinical question ऐसे आ सकता है. Small child is brought with a history of vomiting on MRI. It is seen that the second part of the duodenum is obstructed. Right? Double bubble sign. Yes. So annular pancreas is due to defective migration of. Yes, MCQ आता है. Annular pancreas is due to defective migration of ventral pancreatic bud. Defective migration of ventral pancreatic bud. Okay, that's annular pancreas. याद रखना, defective migration of ventral pancreatic bud. A non-fusion of the two buds, dorsal and ventral buds, results in pancreatic divisum. ये याद रखना. So ventral and dorsal bud अगर fuse ही नहीं हुए तो we get two pancreas, a divided pancreas, pancreatic divisum. And annular pancreas is due to defective migration of ventral pancreatic bud. ये याद रखना, ventral pancreatic bud. Fine. Okay. Again, I'll just draw one slide for you, बच्चों. Just quickly tell me this. ये ना, approach to the kidney from a posterior aspect. मतलब स्टोन है किडनी में और आपको पोस्टीरियर अप्रोच करना है किडनी को, तो ऐसे क्लिनिकल क्वेश्चन आ सकता है. तो इसीलिए यू हैव टू नो द पोस्टीरियर रिलेशंस ऑफ द किडनी. वेरी इंपॉर्टेंट, पोस्टीरियर रिलेशंस ऑफ द किडनी. चलो विल स्टार्ट. द फर्स्ट मसल, द सेकंड मसल, द थर्ड मसल. 3 मसल्स है. ये कौन है? psoas major, ये है quadratus lumborum, ये है transverse abdominis. पोस्टीरियर रिलेशंस ऑफ द किडनी. फर्स्ट psoas major, फिर quadratus lumborum, फिर transverse abdominis. Okay. You get something here and here. What is this? This is the medial arcuate ligament. And this is lateral arcuate ligament. This will give origin to the diaphragm. It's the diaphragm arise hota hai. Medial and lateral arcuate ligaments se. You got 3 nerves here. बोल सकते हैं, what are these nerves? Subcostal, ilio, hypogastric, ilio, inguinal nerve. Subcostal, ilio, hypogastric, ilio, inguinal nerves. अब बोलो बच्चों, which kidney is lower? Right kidney is on the lower side. So right kidney is related only to one rib. एक ही rib होता है, 12th rib. अगर लेफ्ट किडनी है, so लेफ्ट किडनी वुड बी रिलेटेड टू 2 रिब्स, है ना? ये 2 रिब्स आएंगे इधर, 11th एंड 12th. अगर ये लेफ्ट किडनी है तो लेफ्ट किडनी, राइट किडनी इज रिलेटेड ओनली टू 12th रिब. फाइन है. सो ये याद रखना, दिस इज वेरी इंपॉर्टेंट. यहाँ पे एक सबकॉस्टल आर्टरी भी आती है, सबकॉस्टल नर्व्स एंड वेसल्स. सो किडनी का पोस्टीरियर रिलेशन याद रखना बच्चों. psoas major, quadratus lumborum, transverse abdominis, medial arcuate, lateral arcuate ligament, subcostal nerves and vessels, iliohypogastric nerve, ilioinguinal nerve. Fine. Plus ये 11th 12th rib, if it's left, right है तो 12th rib. ओके दैट्स फाइन. व्हाट इज दिस क्लिनिकल कंडीशन? ये बोल सकते हो व्हाट इज दिस क्लिनिकल कंडीशन? छोटे छोटे सिस्ट होते हैं, छोटे छोटे सिस्ट. व्हाट इज दैट क्लिनिकल कंडीशन? हाय गौरव, किधर जाते हो बीच में? व्हाट इज दिस क्लिनिकल कंडीशन? छोटे छोटे सिस्ट है. इट्स अ क्या लिखा है? पॉलीसिस्टिक किडनी. ओके, कंजेनाइटल पॉलीसिस्टिक किडनी. बोल सकते हो इसका रीजन क्या है? हाउ डू यू गेट अ कंजेनाइटल पॉलीसिस्टिक किडनी? एम्ब्रियोलॉजिकल डिफेक्ट है ये. हाउ? फेलियर ऑफ कम्युनिकेशन ऑफ द कलेक्टिंग पार्ट एंड द सिक्रीटरी पार्ट. दो पार्ट्स है किडनी के डेवलपमेंट में, अलग अलग दो पार्ट्स होते हैं. वन इज द कलेक्टिंग पार्ट एंड द अदर वन इज द सिक्रीटरी पार्ट. Secretory part is the urine forming part. Collecting part is the urine collecting part. If the collecting and the secretory part do not communicate, you get a congenital polycystic kidney. दोनों communicate होने चाहिए. The collecting part and the secretory part, they should communicate with each other. Failure of communication of the collecting and the secretory part results in a congenital polycystic kidney. ये clear है? Failure of communication of the collecting and the okay, look at this. Secretory part of the kidney is derived from, ये कुछ बहुत important MCQs हैं. Secretory part of the kidney is derived from metanephros. Secretory part of the kidney is derived from metanephros. What is formed from this? इससे क्या बनता है? इससे बनता है Bowman's capsule, PCT, DCT, loop of Henle. PCT, this is Bowman's capsule, PCT, DCT, loop of Henle. Okay. Metanephros. इससे बनता है Bowman's capsule, PCT, DCT, loop of Henle. Collecting part of the kidney is derived from ureteric bud. इससे क्या बनता है? इससे बनता है collecting tubules, collecting ducts, minor calyx, major calyx, pelvis, ureter. याद रखना बच्चों, दिस इज वेरी इंपॉर्टेंट एमसीक्यू. एक्वायर्ड है, दैट इज एक्वायर्ड. ठीक है. So secretory part is derived from metanephros. ये याद रखना. Collecting part is derived from ureteric bud. Okay, fine. Structures emerging from the greater sciatic foramen and re-entering through the lesser sciatic foramen. That's another very important MCQ. बोल सकते हो students? Structure coming out through the greater sciatic foramen and entering the lesser sciatic foramen. Which are those structures? एक mnemonic है उसका, PIN, pin. बोल सकते हो what is pin? very good Sadia, very good. P is क्या? P is pudendal nerve. I is internal pudendal vessels and N is nerve to obturator internus. Very good. Pudendal nerve, internal pudendal vessels and the nerve to obturator internus. Fine. These are the structures. Pudendal nerve, internal pudendal vessels and nerve to obturator internus. Okay, openings in diaphragm बोल सकते हो. Openings in diaphragm T8, T10, T12. चलो start. T8 पे बोलो. T8. ये बहुत कॉमन एमसीक्यूज है. T8 वर्टिब्रल लेवल पे. T8 IVC and the right phrenic nerve. T8 is IVC and the right phrenic nerve. T10. Come on students, थोड़ा ही बाकी है. Come on, you can answer this. T8 is IVC and the right phrenic nerve. T10 is esophagus with the right and left vagus. Esophagus with right and left vagus. And T12 is aorta. T12 is aorta, azygous vein and thoracic duct. That's T12. Aorta, azygous vein, thoracic duct. That's T12. T10 पे esophagus with right and left vagus. T8 पे IVC with the right phrenic nerve. ये याद रखना. Okay. Dentate line and Hilton's line. Just quickly answer this. Dentate line and Hilton's line. एक मिनट, I'll just draw this for you quickly. चलो start. What is this? This is 15. This is 15 and this is 8. 15, 15, 8. What is this line known as? इसका line का नाम क्या है? Dentate line. dentate or pectinate line. What is the importance of this line? Shall I answer this? This is known as the watershed line of anal canal. So, watershed line of anal canal. बराबर है ना? Dentate line. What is this part derived from? This part is derived from endoderm, and this part is derived from ectoderm. Ectoderm and endoderm. Fine. Very good. Above is columnar epithelium, niche is epithelium is different. इसका nerve supply above the dentate line is sympathetic, below the dentate line is pudendal nerve. सब कुछ different है. Nerve supply, blood supply different है. Lymphatics above the dentate line is internal iliac lymph nodes. Below the dentate line, बोलो. Lymphatics below the dentate line drains into. Any guesses? Lymphatics below the dentate line drains into. This you should know. Lymphatics below the dentate line drains into. Come on, bachcho. Superficial inguinal. Very good. Superficial inguinal lymph nodes. Above the dentate line, internal iliac lymph nodes. Below the dentate line, superficial inguinal lymph nodes. Right. Above the dentate line drains into portal vein. Below the dentate line drains into systemic veins, venous drainage. ऊपर portal, नीचे systemic, है ना? बाकी nerve supply, sympathetics, and this is pudendal nerve. Fine. What is this line? This line is known as the white line. White line. White line represents the mucocutaneous junction of anal canal. Mucocutaneous junction of anal canal. White line is the mucocutaneous junction. Yes, very good. What is the epithelium here? यहाँ का epithelium क्या होता है? यहाँ का epithelium होता है stratified squamous non-keratinized, and this epithelium is going to be stratified squamous keratinized. That is known as mucocutaneous junction. So white line of Hilton is mucocutaneous. मतलब इसके ऊपर mucous membrane, इसके नीचे skin होता है. Mucous membrane का epithelium is stratified squamous and non-keratinized, and skin is stratified squamous keratinized epithelium. Fine है बच्चों? Clear है? So just remember all this. Okay, that's fine. So that's about the dentate line and Hilton's line, white line of Hilton. एक ये बोल सकते हो mesonephric duct. I'll just finish this fast. ये बहुत MCQs आता है इसमें. Fate of mesonephric duct and paramesonephric duct. एक अपन ऐसे मेल एंड फीमेल लिख देते हैं यहाँ पे. We'll start with mesonephric duct. Mesonephric duct. चलो start. Mesonephric duct gives ureteric bud. इससे बनता है ureteric bud. तो ये क्या बनाता है? Collecting part of the kidneys. Both for males and females. ये common है for both males and females. So mesonephric duct gives the ureteric bud. इससे बनता है collecting part of the kidneys, common for males and females. Now mesonephric duct in males क्या बनाता है? It forms the entire genital system of males. मतलब we start with epididymis. मैं short में लिख रहा हूँ epididymis, then vas deferens, seminal vesicles, ejaculatory duct, and prostate. Mesoderm of prostate. Mesoderm. So, mesonephric duct in males forms the entire genital system of males. This includes epididymis, vas deferens, seminal vesicles, ejaculatory duct, and mesoderm of prostate. In females, it obliterates off. It forms what? Gartner's duct. Gartner's duct. So, mesonephric duct का remnant in females is Gartner's duct. Gartner's duct. Fine. अब paramesonephric duct बोल सकते हो? Paramesonephric duct. Paramesonephric duct. What does it form in females? In females, it forms the fundus, body, cervix, and the upper 2/3 of vagina. Upper 1/3. I'm so sorry. Upper 1/3 of vagina. I'm so sorry for that. Upper 1/3 of vagina. fundus, body, cervix, fallopian tubes, and the upper 1/3 of vagina. बच्चों बोलो, lower 2/3 of vagina is derived from, lower 2/3, upper 1/3 of vagina है. Lower 2/3 of vagina is derived from urogenital sinus. Sino-vaginal bulbs होते हैं. It is derived from urogenital sinus. Upper 1/3 is mesodermal. It is derived from paramesonephric ducts. Lower 2/3 is derived from sino-vaginal bulbs, which is derived from urogenital sinus. It is endodermal in origin. Endodermal होता है. Fine. पैरामीसोनेफ्रिक डक्ट मेल्स में क्या बनाते हैं? मेल्स में बनाते हैं बोलो, appendix of testis, appendix of testis and prostatic utricle, prostatic utricle. हाँ, fine. Can anyone tell me this? Genital tubercle, ये बोलो, genital tubercle, genital swellings and genital folds, ये क्या बनाते हैं? ये ना, ये MCQs आता है इसमें. Genital tubercle, what does it form in males and females? Males and females. Males में बनाते हैं penis, clitoris, genital tubercle. ठीक है. Genital swellings in males form the scrotum and in female forms the labia majora, and genital folds in female forms the labia minora, and males में form करता है ventral aspect of penis. ठीक है. Ventral aspect of penis. बस ये याद रखना. This is very important. So I've told you everything as far as the embryological part is concerned. Fine है बच्चों? Clear? So genital tubercle, males में penis, clitoris, females में males में penis, females में clitoris, genital swelling, scrotum, labia majora, and genital folds. Fine बच्चों, clear to all of you? Yes, Javed, Gaurav, Dharmesh, Nirmal, Snehajit. Okay. Fine. This is fine. Okay. So we've done all this. Now you tell me, bacho, some clinical conditions. Quickly tell me, what is this? What is this clinical condition? What is this clinical condition? Come on, students, come on. Last part is left. Come on, answer this fast. Snehajit, this is INICET का marathon series चल रहा है. Okay, चलो start. What is that? ये क्या है? This is due to persistence of primitive streak. वैसे primitive streak क्या बनाता है? Primitive streak forms 3 germ layers. 3 germ layers बनाता है. Primitive streak forms a notochord. Notochordal process बनाता है. This is what we call as a sacrococcygeal teratoma. Sacrococcygeal teratoma. And this is due to persistence of primitive streak. ये अगर primitive streak persistent रहा तो ये बनेगा sacrococcygeal teratoma. What is the function of primitive streak? एक तो वो 3 germ layers बनाता है, 3 germ layers. It forms the 3 germ layers and it forms the notochordal process. Notochordal process. 3 germ layers बनाता है, ectoderm, mesoderm, endoderm. ये तीनों germ layers बनाता है primitive streak and वो बनाता है notochordal process, जिससे वो बनता है notochord. नहीं, you can revise, no problem. नोटोकॉर्ड प्रोसेस से बनता है नोटोकॉर्ड. फाइन है. प्रिमिटिव स्ट्रीक डिसअपीयर हो जाता है. इफ इट परसिस्ट, इट फॉर्म्स व्हाट? सैक्रोकॉक्सिजल टेराटोमा. सैक्रोकॉक्सिजल टेराटोमा. एक मिनट बोलता हूं मैं. ऋतिक, व्हाट इज दिस? व्हाट इज दिस? दिस इज एनेंसेफेली. This is anencephaly and this is spina bifida. Anencephaly and spina bifida. एक है ना न्यू see, I must be having that slide. एक मिनट. I'll just tell you this. Okay, ये है ना ectoderm. When the ectoderm folds like this, ectoderm folds, ये fold ऐसे separate हो जाता है and this is what forms a neural tube. ये है neural tube. Neural tube is derived from ectoderm. मतलब न्यूरल ट्यूब इज डिराइव्ड फ्रॉम एक्टोडर्म, न्यूरल ट्यूब ऐसे फोल्ड हो जाता है, एक्टोडर्म ऐसे फोल्ड हो जाता है, एक्टोडर्म सेपरेट हो जाता है, दैट फॉर्म्स द न्यूरल ट्यूब. दिस न्यूरल ट्यूब इज ओपन इन फ्रंट एंड ओपन बिहाइंड. आगे जो ओपन है दैट इज नोन एज द क्रेनियल न्यूरोपोर, पीछे जो ओपन है दैट्स कॉर्डल न्यूरोपोर. द क्रेनियल न्यूरोपोर क्लोजेस बाय 25th डे ऑफ इंट्रायूट्राइन लाइफ. अगर ये क्लोज नहीं हुआ तो देन वी गेट दिस एनेनकेफाली. Okay, so this anencephaly is due to failure of closure of the cranial neuropore. Cranial neuropore close nahi hua, तो we get anencephaly. Closes by 25th day. The caudal neuropore closes by, yes, Gaurav, answer this. The caudal neuropore जो है, it closes by 28th day of intrauterine life. अगर वो close नहीं हुआ, then we get spina bifida. Spina bifida. Okay, so failure of closure of caudal neuropore, that's 28th day. Yes, we get this spina bifida. Fine, clear. Frog sign clear to all of you. Okay, intraembryonic mesoderm मैं बोलता हूँ आपको. This is fine. So cranial and caudal neuropore. जब ये neural tube बनती है ना, when this neural tube is formed, a small group of cells gets separated from the ectoderm, and this is what we call as the neural crest cells. Neural crest cells. ये neural crest cells से बहुत चीजें बनती है. Neural crest cells से there are plenty of things which are formed. One is the adrenal medulla, the leptomeninges, the odontoblast, the Schwann cell, the melanocytes. Then what else? AV cushions of the heart, endocardial cushions of the heart. The aorticopulmonary septum, आपको याद है वो aorticopulmonary septum जो pulmonary trunk and aorta बनाता है, aorta and pulmonary trunk बनाता है, the aorticopulmonary septum, जिसमें ये neural crest cells जाते हैं. अगर neural crest cells इसमें नहीं गए तो we get defects of this aorticopulmonary septum, जिसमें अपने को मिलता है Fowler's tetralogy. Fowler's, हाँ, कोनोट्रंकल सेप्टम, Fowler's tetralogy, या फिर ट्रांसपोजिशन ऑफ ग्रेट वेसल्स, या फिर पर्सिस्टेंट ट्रंकस आर्टेरियोसिस. हाँ, दैट Fowler's tetralogy एक बहुत इंपॉर्टेंट टॉपिक है. हाँ, याद रखना. वेरी गुड धर्मेश. हाँ. Fine. Then the skeleton of the face and the corneal stroma and parafollicular C cells of thyroid. Parafollicular C cells of thyroid. अगर MCQ आता है, parafollicular C cells of thyroid are derived from, your first answer is neural crest cells. अगर वो ऑप्शन में नहीं है, so what is the other option? Boot shaped heart. Yes. Parafollicular C cells of thyroid are derived from, your first answer is neural crest cells. अगर neural crest cells ऑप्शन में नहीं है, what is the other option? बोलता हूं, सादिया बोलता हूं. What is the other option? Ultimobranchial body. Ultimobranchial body. हाँ, very good Ritik. Neural crest cells are derived from, पहला आंसर होगा neural. Parafollicular C cells of thyroid are derived from, your first answer is neural crest cells. अगर ऑप्शन में नहीं है तो ultimobranchial body. ठीक है ना? ये देखो, see, अगर neural crest cells, see, this is the aorticopulmonary septum. Aorticopulmonary septum. इसमें क्या जाते हैं? न्यूरल क्रेस्ट सेल्स जाते हैं. अगर न्यूरल क्रेस्ट सेल्स इसमें नहीं गए तो द फर्स्ट थिंग इज द सेप्टम गोज टू राइट साइड. सेप्टम शिफ्ट्स टू राइट साइड. तो इसमें क्या होता है? पल्मोनरी स्टेनोसिस. सेप्टम गोज टू द राइट साइड. सो पल्मोनरी स्टेनोसिस हो गया. पल्मोनरी स्टेनोसिस हो गया तो आरवीएच हुआ. आरवीएच हुआ तो इंटरवेंट्रिकुलर सेप्टल डिफेक्ट हो गया. इंटरवेंट्रिकुलर सेप्टल डिफेक्ट हो गया एंड फिर हो गया ओवरराइडिंग ऑफ एओर्टा. ये हो गया Fowler's tetralogy. ये हो गया Fowler's tetralogy. So if the neural crest cells do not enter the septum, aorticopulmonary septum जो सेंटर में रहता है, it shifts to the right side. So pulmonary stenosis हो गया. Main cause of TOF क्या है? Pulmonary stenosis. Because of pulmonary stenosis, RVH. Because of RVH, interventricular septal defect, and because of that, overriding of aorta. अगर न्यूरल क्रेस्ट सेल्स नहीं गए तो द सेप्टम डजंट स्पाइरल प्रॉपरली. व्हाट इज दैट? ट्रांसपोजिशन ऑफ ग्रेट वेसल्स. एंड द थर्ड वन इज पेटेंट ट्रंकस आर्टेरियोसिस. मतलब वो सेप्टम डिवाइड ही नहीं करता, दो पार्टीशंस बनते ही नहीं है. द ट्रंकस आर्टेरियोसिस इज सिंगल चेंबर, तो दैट इज नोन एज पेटेंट ट्रंकस आर्टेरियोसिस. fine. If the spiraling does not take place properly, normally क्या होता है, the neural crest cells enter into the septum spirals like this. Now that is known as a spiral septum. aortic को pulmonary septum को spiral septum बोलते हैं. अगर वो spiraling ठीक से नहीं हुआ तो aorta opens in right ventricle, pulmonary trunk opens into left ventricle. That is what we call as transposition of great vessels. सादिया, ठीक है ना? I hope this is clear to all of you. Fine. Okay, so this is our master plan, which you have recorded lectures, interactive sessions, question banks है, grand test होती है, and test and discussion होता है, and that's our faculties for all 19 subjects, 19 faculties की list है. Okay, I hope this is clear to all of you. I mean, ठीक है, that's fine. कुछ डाउट्स है बच्चों? इज दिस क्लियर टू ऑल ऑफ यू? ओके, थैंक यू जावेद. ओके, आई होप ऑल दिस थिंग्स आर क्लियर. काफी रिवीजन हो गया. रिवाइज करो. इफ यू हैव एनी डाउट्स यू कैन एनी टाइम आस्क. ओके, वी आर देयर टू हेल्प यू ऑल द टाइम. All the very best from the entire PW team. Thank you so much. Thank you so much for your patient listening. I hope this lecture is clear to you. कुछ doubts हैं तो you can send on the group. You can send on the group. There's no problem. स्नेहचित, रिवीजन हो गया? Okay. I hope things are clear to you. Thank you. To all of you, thank you so much. Bye bye. We'll stop here. We'll stop. ठीक है, कुछ डाउट्स हैं तो you can tell. I'll just wait for 1 or 2 minutes. कुछ डाउट्स है तो बोल सकते हो. गौरव, आप सबका मतलब सभी बच्चों का प्रिपरेशन इज रियली गुड. बहुत अच्छे से आंसर भी कर रहे थे एंड यू न्यू मोस्ट ऑफ द थिंग्स. ओनली थिंग इज दैट कंसेप्ट पे फोकस करो. MCQs can be framed in any different way. Your concept is something which has to be very clear and it goes with you throughout your life. Okay, we'll stop here. Gaurav Sonavne, where are you from? Yes, Dharmesh, very good. Sadia, Javed, all of you have been answering very well. कुछ डाउट्स है बच्चों? आई फिनिश्ड ऑन टाइम. नहीं तो हमेशा ओवरलैप होता है. ठीक है बच्चों, दैट्स फाइन. थोड़ा सा सी ब्लंडर यहाँ पे गलत करोगे ना, दैट्स ओके, बट दैट्स ओके. न्यूरो एनाटॉमी सादिया, इंपॉर्टेंट चीजें पढ़ लो. हाँ, वेरी गुड महाराष्ट्र. इंपॉर्टेंट चीजें पढ़ लो बच्चे. हाँ, लाइक देखो, लाइक टॉपिक्स लाइक वेंट्रिकल्स, सर्कल ऑफ विलिस, ब्लड सप्लाई ऑफ ब्रेन, वीनस ड्रेनेज, हमने वो सब देख लिया है. एंड देन फंक्शनल कंपोनेंट्स कर लो. फंक्शनल कंपोनेंट्स यू शुड नो द नेम्स ऑफ द न्यूक्लियस. लाइक हमने 2 न्यूक्लियस देखे, न्यूक्लियस एम्बिगुअस एंड न्यूक्लियस ट्रैक्टस सॉलिटेरियस. Like one nerve, say for example, I'll just tell you one small thing, like one example. Hi Ritik, sorry I forgot you. एक example, glossopharyngeal nerve. देखो कैसे याद रखना है, जस्ट इन 2 minutes I'll tell you. ग्लॉसोफेरेंशियल नर्व वो क्या सप्लाई करती है, तो उसका न्यूक्लियस कौन सा है. सो ग्लॉसोफेरेंशियल नर्व क्या सप्लाई करती है, पैरोटिड ग्लैंड. वो पैरोटिड ग्लैंड को सप्लाई करने के लिए व्हाट इज द न्यूक्लियस ऑफ ग्लॉसोफेरेंशियल नर्व, इंफीरियर सलाइवेटरी न्यूक्लियस. ग्लॉसोफेरेंशियल नर्व इज एन ऑफ थर्ड फेरेंशियल आर्च. एक मसल सप्लाई करती है स्टाइलोफेरेंजिस. टू सप्लाई द स्टाइलोफेरेंजिस वो कौन सा न्यूक्लियस है ग्लॉसोफेरेंशियल नर्व का, न्यूक्लियस एम्बिगुअस. Glossopharyngeal nerve also supplies the tongue, posterior 1/3 of the tongue, special sensations. Name of the nucleus, that's nucleus of tractus solitarius. है ना, ऐसे उसको याद करना. मतलब HFN and neuroanatomy साथ पढ़ लो, it will become easy for you. मैराथन में बच्चे जितना हो सका ना उतना I've tried to incorporate. मनोज, जितना इनकॉर्पोरेट हो सका उतना मैंने इनकॉर्पोरेट किया है, बस बाकी के PYQs वगैरह भी देख लो ऑफ द INICT। विजुअल्स पे ध्यान दो, विजुअल्स बहुत आते हैं एंड एनाटॉमी विजुअल्स। ठीक है, ओके। Once again, thank you so much, my dear children. Thank you and all the very best from all of us, the entire team of PW. Thank you. I'll stop.
Yes, can you hear now? Okay, yeah, thank you for that. And video, there is no issue, right? Yes, okay, very good. So we are late by some 5 minutes. Okay, okay, then let's start it without a delay. So this is the marathon, as I've already told you. So we are going to discuss everything what you know, nothing new. Okay, so we are going to revise this quickly so that we have to complete it by 5, right? And I think you all know what is PW MedEd's mission is all about. So this is our we have various batches, and this is our marathon schedule starting from today till November 7th. We are going to continue and finish all the subjects. So now let us start orthopedics, which is very important and a very important for scoring. Like, it is a very good subject for scoring marks, right? So the first, let me start with the trauma, because it is very important that you know the trauma in details. Most of the 5 questions are asked in ortho, 3 of them will be from trauma. So I have put trauma as the first chapter in the workbook, so that even if you want to revise it quickly, it is done there. Okay, so that is it. And starting with the trauma, so I am starting with the score. As you all know, always trauma starts with ATLS, right? You know what is ATLS? You have to always check the airway, breathing, circulation. So first always ABCs, and then when you come to the orthopedics, the first thing you have to check is the spine. So in spine, what is the most important thing which you check? It is the cervical spine. So major attention is given to ABCs as in every other department, or mainly in the casualty. And then when it comes to ortho, when you're starting to check the appendicular skeleton, then the axial skeleton, so we are going to first check the C-spine. Yes, good doctor 4129. That all we'll see it later. First, let us concentrate on ortho. Yeah, the most important classification is always Gustello-Anderson classification. Is very good. So what I was telling is, the first thing what you check is the C-spine, right? So how do you stabilize the C-spine? You always use a collar. So hard collars are usually used for stabilizing your C-spine in case of the casualty, right? So that is the first thing you have to always put in your mind. Then comes the thing of open fracture. So always whenever there is a fracture, our detailing or our management starts whether this is an open fracture or a closed fracture. So always remember, there is always a difference in the treatment or the management whenever it comes to open fracture or a closed fracture. So what is an open fracture? We all know open fracture is nothing but where the fracture is exposed to the environment. So how it is exposed, how the fracture is exposed to the environment plays a very important role. So for that, what has come up is this scoring system. So that is your Gustello and Anderson's classification. So Gustello and Anderson's classification. So what actually the classification takes into account is, mainly what you have to remember is the wound size. So wound size is the main thing, but it will also tell you what is the energy of the mechanism and what is the thing with the soft tissue, right? So energy and that is the mechanism of injury. That actually means, what is the energy means the mechanism of the injury, and what is the force which is used to cause that particular wound, right? So wound size is the first thing which you have to always keep in mind whenever you're dealing with Gustello-Anderson's. Then it will give you the information about the energy, that is the how much amount of energy has been used in it, and it will give you information about the soft tissue injury as well, right? And then based upon all these things, you can assume what is the contamination, what is the comminution or the fracture pattern, and then you will deal with vascular injury and the soft tissue coverage. So here Gustello and Anderson has put a very important role for vascular injuries. So vascular injuries straight away get the status of 3C. So you all know that there are 3 grades, that is type 1, type 2 and type 3. And 3 is again divided into A, B and C. So whenever somebody is talking about a vascular injury, so straight away the wound gets the status of 3C, right? And somebody has to put it in 3B, then that means there is a more amount of soft tissue damage which has happened. So you're going to do a plastic surgery approach. So this is where orthoplastic has come into existence. So you're going to deal with one more surgeon, the plastic surgeon also come into role to help us with this soft tissue reconstruction. So that is about 3B. And what is 3C? 3C. 3C is nothing, 3C is vascular, 3B is plastic surgery involvement, and when it comes to 3A, it is just the soft tissue where you can, the orthopedic people, the orthopedic surgeon himself can treat the soft tissue. That is just a suturing the soft tissue. But how do we know that is a grade 3 injury? So that is depending upon the size. So if it is more than 10 centimeters, more than 10 centimeters wound, it is straight away into 3. If it is less than 1 centimeter, that is called what? Just a pinhole wound. So there is a pinpoint track, just a small wound that is less than 1 centimeters. If it is between 1 to 10 centimeters, it is 2. It is understood, right? And now tell me how the energies are distributed. So whenever the wound is too high, whenever there is vascular injury, that means more energy is required. So it is a very forceful injury, high velocity injury. So that is called as a 3C injury. It is a minimal injury. So it is 1C. So that is why the wound is less. But whatever the wound, whatever may be the size of the wound, all these fractures have been connected or been contaminated with some amount of bacteria or any other organisms to that point, because there is a communication of the fracture to the outside environment. Hence these are called as the open fractures, right? Is that clear, guys? Yes, so this is the open fractures, and this is they will give you directly clinical questions are asked in this. So whenever they ask you about the clinical questions, what usually they ask is, so once a patient has a wound and there is a vascular injury, so which category is this particular injury put into according to the Gustello-Anderson's classification? So you are going to answer it as 3C. And next, the patient has come with so and so injury. So the amount of the wound size is almost between, less than 10 centimeters. So what is the status of the wound according to Gustello-Anderson? It is 2. Write that. Okay, that is the thing about the Gustello-Anderson's classification. And if you see the comminution and the fracture pattern, the complexity increases as it goes to type 3. Right? So that's it. And then because we have got so many questions on Gustello-Anderson's classification, and all these open fractures, this is mainly for the fracture. This is mainly for the fracture, which is, just to expose to the environment, and whether it is a lot of, whenever there is a soft tissue injuries involved and vascularity is involved. But when you want to decide between amputation, when there is a crush injury, when there is a severe crush injury, and you want to decide between amputation and the limb salvage, I think Gustello-Anderson does not play a very important role in that. Then you have to go for other categories, other scoring systems, which is called the MES, which is Mangled Extremity Severity Score. Okay, and here what you take into account? Same, you take energy, the limb ischemia, then you take shock, and then you take age. So we remember this as ELISA, right? ELISA is the test which is used to detect, right? So it is used in microbiology, right? So the same ELISA, you use a mnemonic for treating your yes, very good, Dharmesh. The treatment for any open fracture is always triple antibiotic res. The treatment, the management always is triple antibiotic. So here we have not discussed about the management, so I have not mentioned it. So Dharmesh is right? Yes, ELISA. ELISA is energy. So first, what is the amount of energy it will be used? Is it a low energy? Is it a high energy? Or it is a very high energy? And then we talk about limb ischemia. So limb ischemia is usually, you say it is less than 6 hours or more than 6 hours. 6 hours is considered as the arbitrary time. So why they have taken the 6 hours time? Can somebody answer me? This is just a test for your general knowledge. So usually we say whenever the patient comes with the within 6 hours, we take directly, we take him to the OT and we do what is necessary for him, the general treatment. But if it is more than 6 hours, we take certain care for him, because the 6 hours is set as a bacteria doubling time. So even if it is contaminated, if the injury, if the wound has been come to us after 6 hours, that means there is a high contamination. So the doubling time of bacteria is 6 hours. Yeah, wound gets contaminated, but more than 6 hours, the bacteria gets doubled. Okay, if it is less than 6 hours, it is okay. You can still treat it as normal as an open fracture. So that is it. So the 6 hours is the arbitrary time. So that is why they have given, if you see this particular scoring, they say the limb ischemia time, the score is doubled if it is more than 6 hours. So the importance of 6 hours is this. So the bacteria doubling time, right? And shock better than me. So shock is mainly this circulation. So they will tell you about the status, the circulatory status. So whether the systolic BP, so usually we consider the blood pressure. So if the BP is more than 90 mm Hg, or if the patient is in hypotension, based upon that you score the person, and then the age. So this is how you remember for mangled severe extremity score. So they can ask you in integration with the surgical question also. So that is why I have put it here. So the first is Gustilo-Anderson classification, then is your mangled extremity severity score, that is MES. So here what is the importance of MES? Even though we have Gustilo, you have to decide whether between the amputation and the limb salvage, right? But now what had happened is we have shifted our focus main to the soft tissues, right? So the soft tissue doesn't only mean what is there inside it. So there are certain division for the soft tissues as well, like it comes with the skin, then they talk about the fascia, then we have to talk about the tendons, then we have to talk about the ligaments, right? And then comes your vessels and then your nerves. So they have done a detailed, thorough research on how this will damage plus the injury to the bone, right? So then this is called as a open fracture. So there is a damage at all the levels. But do you think that MES or Gustilo-Anderson is addressing all these issues there? No, it is not addressing. So this has been addressed by a famous hospital from our South India, that is called the Ganga Hospital. So it is called the Ganga Hospitals. They have given a very, very important scoring system. This is called as a Ganga Trauma Score. Ganga Trauma Score. So people from Coimbatore or Tamil Nadu knows that this is a very famous institute for orthopedics and plastic surgery as well. So the plastic surgeon and the orthopedic surgeon there, they both are brothers, and they have done extensive research on the open fractures, and they have developed this particular score, which is called the Ganga Trauma Score. This has been not asked in any competitive exam, but it's a sure short question, can be asked, a potential question. So this will give you a detailed history about what injury has happened to which level. So it is at the skin level, the fascia level, the tendon, ligaments. So it is a very good scoring system. You do not want, say, like, it is not important for you to understand everything, but what is important is there are many scoring systems, but what we use mostly is the Ganga Trauma Score, and this is the scoring system. If it is below 14, we go for limb salvage. If it is more than 16, you go for amputation of the limb. That is what you have to remember. So 14 and 16 is the standards. So below 14 it is salvage, that is limb salvage. Above 16 it is amputation. Below that it is the gray zone where you can decide. Okay. And what are the advantages? I have given the small box. If somebody has time, you can read it. Right. So just remember, there is one more important scoring system which is designed by our Indians. So that is your Ganga Trauma Score. Yes, that completes your trauma scoring system. And as Dharmesh has told us clearly, what is the management of any open fracture? So first you have to always clean. So thorough wash should be given. So clean and wash, and then you will treat them with the triple antibiotics. So use the triple antibiotics. So this is covering the anaerobic infection as well, right? So triple antibiotics, and then the treatment is always external fixation. So the treatment is always external fixation, right? So you don't put implants inside, you put implants from outside, hence it is called external fixation. So whenever you put the implants inside, it is called as internal fixation. So if you go back in your wards, you have heard this term, that is ORIF, that is open reduction and internal fixation, right? So we are going to open the fracture, that is open, and then we are going to reduce it, so that is reduction, and then we are going to fix it with an implant, that is internal fixation. You're not going to see the implant from outside, but when it comes to the open fractures, it is external fixation. That means you're going to see that whatever is used from the outside. So there are two types of X-fix. So over the class we'll see what are the types of X-fix. So just for now, remember, this is rail track, or you have rods or pins, and the second one is ring, that is your Ilizarev. So these are two types of external fixations which we use for your open fractures. So first one is the rods and pins. It is rail track or something like this, right? So this is the pin which we use. These are the threads of the pin. And if it is a ring, it is like this. So this is the Ilizarev, and this is your limb inside, and they will use the rings like this. So this is called the ring fixation. That is called your rods and pins type of fixation. So this is the external fixation. So that is a treatment for your open fractures, right? Clear? Any doubts? So you have any doubts, you want to clarify anything, please put in the comments. Don't hesitate. And in between, when I ask if it is clear, then please answer yes or no, so that it gives me that sign to proceed. Okay, is it clear now? Open fractures, that scoring systems. Yes, thank you. Proceeding further. So further proceedings are towards the upper limb. So we'll start with a very, very important topic, the anterior dislocations. I am pretty sure that you know everything about this, the anterior dislocations, but I have told you marathon is only about knowing what is already known. We are going just in detail. You just sit back and relax and just keep listening. Okay, so anterior dislocation of the shoulder is one of the most important topic usually asked in the exam. So what are those important things you have to remember? First, mechanism of injury. So abduction, external rotation. So whenever somebody is doing abduction like this, external rotation like this, the ball comes out anteriorly. So the ball is a humeral head. So that is called as dislocation. And in shoulder, the most common type of dislocation is anterior dislocation. When I say the most common type of dislocation is anterior, then there are two other types. The other types are posterior dislocation and inferior dislocation, right? So inferior is the rarest among them. Okay, so the mechanism of injury for your anterior dislocation is abduction and external rotation, and the nerve which gets damaged here is your axillary nerve. So whenever I say axillary nerve, you are very pretty much sure that it is supplied to the deltoid. And what is the loss of the action? So the abduction is lost. So this is the abduction is lost. So somebody talking about axillary nerve, all this should run in behind, right? So it is supplied by the axillary nerve, it supplies the deltoid, so there is a loss of abduction. And what is the regimental badge area? The sensory supply is the regimental badge area, right? So this is all for anterior dislocation. And how do you reduce it? You reduce it by traction. So any dislocation is an emergency. You have to reduce it by traction. So they will give traction, then they external rotate it, then adduct, and then they do internal rotation, right? So there is a traction, then they will external rotate, and then they will adduct like this, and then they will internal rotate the hand. So once they do this maneuver, the head comes and falls back into your glenoid fossa, and now you do immobilization. So you use a immobilization, shoulder immobilizer, which is used for 6 weeks, So that is about anterior dislocation of the shoulder. So whenever this dislocation is about more than 3 times or 4 times, and if that particular person is able to relocate himself, it is called as your habitual dislocation. This is called as a habitual dislocation. And now if the person is unable to relocate, it is called as a recurrent dislocation. It is called as a recurrent dislocation. So what is recurrent dislocation? Recurrent dislocation is bar. Okay, habitual dislocation, it is dislocated and then the person himself he is only treating himself, so that is habitual, right? Yes, team. So I have told you internal rotation, so you can do M as the medial rotation, right? Same thing. Okay, so now there are 2 important complications of your habitual or recurrent dislocations. So the first one is, so you have to imagine that this is a humeral head and then the ball is going and sitting inside there, and whenever there is an anterior dislocation like this, so the head is coming towards you like this is, let us assume this is the position. So here the labrum which is there, so this is your glenoid fossa, and the labrum is nothing but an extension of that particular area, right, to accommodate the head. So whenever this particular head like this is coming forward number of times, so there will be a tear. In this labrum. So that particular tear in the labrum is called as your Bankert's lesion. So this is called as your Bankert's lesion. So what is Bankert's lesion? It is nothing but a tear in your labrum, and now you have to tell me where actually the tear is there, the position of that particular tear. So it is an anterior dislocation, and usually the ball goes inferior, so there is an anterior inferior tear in the labrum, which is called as the Bankert's lesion. So according to the Newton's law, if you have studied in your 10th or intermediate, you know, for every reaction there is an equal and opposite reaction. So what I have told you, this is happening in the glenoid labrum. So now you have to ask me, if the labrum is damaged so much, then why? What is happening to the head? So head also there is a damage. Now in the head there is a defect in the head which is called as the Hill-Sachs lesion. This is called as the Hill-Sachs lesion, and this is in the posterolateral part. So there are two important terminologies. One is Bankert, second one is Hill-Sachs. But what is more important to remember is the anterior inferior, the posterior lateral. These terminologies are very, very important. So humeral head, H, Hill-Sachs, right? Bankert's for glenoid labrum. So these are the two images they can ask you. So how do you identify it? The investigation of choice is always MRI, and then you do arthroscopy. Then you do arthroscopy of the shoulder, and then you fix the labrum. So you treat or you suture the labrum. So that is the procedure which we use. Okay, so this is by MRI and arthroscopy. Be very, very sure. So whenever they ask you how do you confirm it, you know, gold standard is always arthroscopy, right? And then how do you confirm it? It is always by MRI. Okay, so that is about your shoulder, Bankert's and the Hill-Sachs lesion. So anterior dislocation of the shoulder. And now what is this? One more important question here. Yes, what is this about? E. I'm asking you about the image X-ray E. So what is this fracture? Yes, quickly. So this is your Holstein-Lewis fracture, is it not? Yes, very good. Javed, no question mark. It is Holstein-Lewis fracture. Very good. So what do you mean by Holstein-Lewis fracture? This is a fracture of humerus shaft. And now if you want to be more precise, you can be, it is distal and the middle. So it is junction of the distal and the middle. So junction of distal. So now if you divide this will be the proximal, this will be the middle, and this will be the distal, right? So this is the junction between the middle part and the distal part. So that particular area, whenever there is a fracture, you see this fracture will result in what? This fracture will result in damage to the radial nerve. Very good. This will damage the radial nerve. So whenever there is a radial nerve, what is the consequence? This will result in the wrist drop, because the radial nerve will supply all the extensors and it will cause the loss of the extension of the wrist. That is the wrist drop. So whenever you see a fracture of the humerus with the wrist drop, there is this particular name which is called as the Holstein-Lewis fracture. Now you tell me what is the treatment for this? You go for the cock-up splint, because if it is a closed injury, the injury is only neuropraxia. If you go back to the nerve injuries, we have three types, right? The neuropraxia, the axonotemesis, and the neurotemesis. So here the type of injury, if it is a closed fracture, we consider it as a neuropraxia and we treat it with the cock-up splint. So that is about the Holstein-Lewis fracture. And now coming to this, what is this? So you have seen the shoulder dislocation. Now this is your elbow dislocation. So this is your elbow which is getting dislocated. And can you see something else with the elbow dislocation? Yes, can you see something else with the elbow dislocation? Yes, quickly. Yeah, the other one is Essex Lopresti, but I'm asking you this particular image. What do you see? Yes? Yes, Essex Lopresti is this. This is Essex Lopresti, as you all told me. This is right. I'm asking you about this particular elbow dislocation. Can you see something else? So this elbow dislocation, you can see there is a radial head fracture, right? So there is a radial head fracture, and if you are very, very keen in knowing things, so you can see there is a coronoid fracture as well. So there is a coronoid fracture. So there is a coronoid fracture with the radial head fracture, and this is an elbow dislocation together. This is called as the Yeah, 3-point bony tendon is disrupted. Very good. So this is called as the terrible triad. So this is called as the terrible triad of elbow. So this is called as the terrible triad of elbow. Right. So elbow dislocation, the most common dislocation is again posterior dislocation in elbow, and whenever there is an associated radial head fracture. So here you see there is a radial head fracture, there is a coronoid. Coronoid is this particular part, so anterior of the olecranon fossa. So if this is your olecranon fossa, you see the anterior area, you have extension that is called the coronoid. So there is a damage to that or fracture of the coronoid. So all this put together, it is called as the terrible triad. And now what is the SX lopricity? SX lopricity is, yes, SX lopricity is there is a tear in the interosseous membrane. So what is the interosseous membrane? So interosseous membrane is nothing but whenever there are two bones which are present. So for example, your tibia fibula, your radius ulna. So these are the two bones which are present, right? So these two bones, there is a membrane in between them. So because of this membrane, you have this supination and pronation as well. So there is a tear in this particular membrane, and whenever there is a damage to the radial head and associated distal end also, there is a fracture because there is a rupture in the interosseous membrane. This is called as the radial head. This is called as SX lopricity. What is this radial head fracture in IM tear and distal? Yeah, that is your SX lopricity. Yes, radial head with distal radioulnar joint and associated your intermembranous rupture. Yes, very good, Bharat. So that is your SX lopricity. Is that clear? Can someone tell me the similar representation in the lower limb? So lower limb also there would be ankle fracture, and then there would be fibular head fracture, because that is also through the membrane, interosseous membrane. So what is this called? Ankle fracture associated with the your fibular head fracture or fibular neck fracture. Yes, similarly the representation in the lower limb. So in upper limb we have radial head fracture with the distal radioulnar joint involvement along with intermembranous rupture. This is called as SX lopricity fracture. Similarly in the lower limb, what is that called? It is called as the mesonevis fracture. It is called the mesonevis fracture. Wait, let me write it correctly. Mesonevis fracture, right? NEUVE, mesonevis fracture. Okay, so that is similarly in the lower limb. So this is the upper limb. Similarly, you have in the lower limb, that is, yes, very good, Javed. It is the mesonevis fracture. So SX lopricity, mesonevis. So these are the important things. The upper limb, that is dislocation we have discussed, Holstein-Lewis fracture, and your elbow dislocation. So these are the potential questions, and the complications of them, the Bankards and the Hill-Sachs. And now coming to the forearm and the hand. So forearm and the hand, this is the forearm fracture. So what you see in this forearm fracture? Yes, quickly. So you can see that there is a fracture, ulna, right? And there is a radial head dislocation. So there is a radial head dislocation. So what is this called? Fracture ulna plus radial head dislocation. So this is a very, very important fracture of necessity, which is called as the Monteggia fracture, So Monteggia fracture is nothing but, yes, Monteggia fracture is fracture dislocation. So this is nothing but your fracture dislocation. So what is the fracture? The fracture is ulna. What is the dislocation? The dislocation is radial head. So this is proximal radioulnar joint which is disturbed here. So PRUJ is disturbed, right? So this is called the Monteggia. Yes, the classification name is the Bedo classification, right? The Bedo classification, and the nerve which can be involved is your pin, that is posterior interosseous nerve. So whenever there is this involvement, there would be finger drop. So pin is involved, it is finger drop. So whenever there is wrist involved, radial nerve involved, it is wrist drop. If it is only one pin, that is, it is finger drop. That's it. Okay. Yes, it is Monteggia, fracture of necessity. Why they call this as fracture of necessity? Because there is a dislocation which is involved. It is the fracture, it is not the fracture that we treat the dislocation first. So when you reduce the fracture, the radial head will fall in will fall on its own into its particular place, right? So that is why this is called as the fracture of necessity. And next one, what is this fracture? Yes. So in the thumb, that is your metacarpal base. So metacarpal base, you have two important fractures. So one is your Bennett's fracture. The second one is your Rolando, right? So Bennett's fracture, you know there are two bi. So Bennett's is B bi. So there are two fragments, right? And Rolando is 3. Okay, it is in the shape of Y, in the shape of T, like that. So this is Rolando, this is Bennett's, but Bennett's is our importance because it requires a clean reduction. It requires a very clean reduction, right? So this is a comminuted fracture. So Rolando is a comminuted fracture. Here Bennett's, yes, first metacarpal base. So first metacarpal base is the thumb where you have Bennett's, and there is a pull of adductor pollicis. So you have this adductor pollicis here which pulls. So it is attached to the longer fragment. So that is the tendon which is there. So the adductor pollicis is the tendon which is attached and it keeps pulling the fragment. Hence you need a very careful reduction in case of your Bennett's. Okay, so we do a immediate reduction in case of Bennett's, whereas in the case of Rolando it's a comminuted fracture. You can see there are 3 fragments here. So there are 3 fragments here in the, this is called the Rolando. You can see that it is a T shape or it can be called as a Y shape, right? So T or Y, both are. Whereas in the Bennett's, it is just a bifragment like that. Okay. And next, what is this? This is the 5th metacarpal neck. So this is the head, this is the neck. So this is your head, neck, and this is your base. So neck fracture in the 5th metacarpal, what is this called? Yes. Yes, this is called as the boxer's fracture. So this is called as the boxer's fracture. And sometimes you can do pinning for this particular fracture as well. So this also you do pinning. For Bennett's you do pinning because it requires a very meticulous reduction. So you require meticulous reduction. So you go for pinning, and then this is your 5th metacarpal neck, which is your boxer's fracture. So these are very important as they have names, the eponyms of the fracture. That means some fractures are named. So whenever they're named, it becomes important because somebody wants to ask what is the name of that, and they will ask you what type of fracture is that. And they can also put a column like this, very famous for your INICETs. So they will put first Ronaldo, Bennett's, boxes, and then they will try to match. So that is why you have to be very well thorough with all these names. So Ronaldo is comminuted, so 3 fragments. Bennett's is bi, 2 fragments, right? And boxers is 5th metacarpal neck fracture. That is your boxer's fracture, right? And then this is about the upper limb fractures, right? And now let us see what are the few important complications of the fractures, which is very important topic again. So coming to the complications of the fracture, so this is there are first important complications. What you have to always remember is these complications can be divided into an early complications or a late complications, and sometimes in the early you can also add it as an immediate complications, right? So whenever it is immediate or early, immediate, it could be again a vascular injury, right? Immediately. And in the early, you have the compartment syndrome, right? It is the compartment syndrome, right? Whereas in the late, we have certain things such as your non-union and the malunion. So here what happens is the union is not happening. So whenever there is a fracture, the fracture has to unite, right? So whenever there is a delay in the union, we will call that as a non-union. Then what is malunion? Malunion is loss of alignment in the union. So whenever there is a loss of alignment in the union of a bone, it is called as the malunion. It is called a malunion. So here non-union is delayed Delayed union. Malunion is loss of alignment in the union, right? So again, in the non-unions, we have two types. So one is called the hypertrophic non-union. This is very important for INICT topic. So atrophic and hypertrophic. So INICT mainly asks this type of questions where there are concept oriented. So whenever I say hypertrophic and atrophic non-union, what is the thing what I'm talking about? So here whenever they should be a union. So coming to union, so whenever I say the word union, so it means that there is a lot of callus which is formed. Okay, so callus is mainly by the nutrients, so it is the vessels. And then how for the formation of callus you require the strength or the, so instead of writing strength I will write you need support. So how you are going to give the support to the particular fracture? Through the implants, right? So whenever I say union, that means there is a unification of the fracture. So the fracture has healed. So how does the fracture heal? There are two important things which you have to remember for healing of the fracture. The first one is there should be callus formation. So this callus formation is through the vessels, that is the nutrition. And the second one is it should be supported in such a way that the callus is built around it. Okay, so that strength or that support is given by the implants. So by this you might understand that two important things. So even if the support is not good, there is no union. Even if the nutrition is not good, there is no union. Clear that? Is it clear? So here in case of hypertrophic, there is a lot amount of vascularity. So there is, so this will lead to increase in the callus. So callus is increased, but the support or the implant is weak. Support is weak. So that is why even though the nutrition is high, even though vascularity is high, even though callus is forming, but because the support is weak, there is no union. This is called as hypertrophic non-union. And whenever I say atrophic means no vascularity, no vascularity. Even though the support is there, even though the support is present, but because of no vascularity, there is no callus. Okay, because there is no support there, because there is no vascularity, there is no callus, but the support is still present. Okay, but in case of hypertrophic, the support is weak. Now can you tell me the treatment for so and so? So how do you treat it? So you already know that there is high vascularity, but the support is weak. So how do you rectify it? Yes, if you answer this, that means you have understood what is it. So how do you treat it? Yes, Sagar, Bharat, Javed, Dharmesh. I want you all to answer now. Somu. Yes. Traction, counter traction, palmar flexion, ulnar deviation. Javed, what is that? No, I'm not asking about the treatment of the Colles fracture. Yes, Dharmesh is right. So now what you do is you will rectify your implant. You will check for the implant. So you will see whether the implant has given proper support, or if the implant you are going to increase the support, that you are going to add another implant. So if there is already an implant, you will add one more implant. If there is no implant, you are going to treat it with implant. Okay, so that is the treatment for your hypertrophic. Then what is the treatment for your atrophic? So how do you treat the atrophic non-union? Yes, so here I told you there is no vascularity, no callus, but the support is there. That means the implant is already there, but here it is unable to form the callus. So what will you do? Yes. Yeah, no vascularity. Yes, correct. Dharmesh. So what is the treatment? Implant is still useful because the support is there, but there is no vascularity. But you have to add something to increase the vascularity of the bone. So what do you do? ABG. So here we do what is called as bone grafting. Yes, very good. We do grafting. Very good. So bone grafting is the treatment for your atrophic non-union. So delayed or hypertrophic non-union, you give implant plus or minus bone grafting. So just to be sure that next time the patient will not come with the avascular bone. And then here atrophic, whenever it is an atrophic, you always go for bone grafting. Yes, autologous bone grafting. Very good. Excellent. And now can you tell me the examples of non-unions? So these are certain examples of non-union. So what are the examples of non-union? So the first one is your scaphoid. The second one is your femoral head. Right? So the first one is the scaphoid, the second one is the femoral head. And the third one is? And the third one is your? Yes, your talus. So all this is because of the vascularity. So they have peculiar vascularity where the blood supply is from distal to proximal. So because of that, these all will end up in the non-union. The scaphoid, the femoral head, the talus, and then if you remember, even your lateral condyle, right? Lateral condyle of humerus. So all these are examples of non-union. And now coming to the malunion, I have told you that there is a malunion where there is no alignment. For example, if this is your bone and this has fractured here. So how it should unite? It should unite something like this, exactly like the normal. But what happens to this? This will unite as if it is like this. So this is the union. So what happened here? You were drawing a longitudinal line. So there is no matching to it. So the alignment of the fragments is lost, which is called as the malunion. So this malunion is usually seen in certain areas of the body. You have to remember the names. So the first and most important is the IT fracture. So the first one is IT fracture. Then it is your Colles fracture. And then it is your supracondylar fracture. Right, so these are areas where you see the malunion. So the IT fracture, the Colles fracture, and the supracondylar fracture. What you have to remember is I have told you the deformity it will result in. So whenever there is a malunion like this, it results in the deformity. So it results in the deformity. So in the Colles fracture, you call this as the dinner fork deformity. You call this as the dinner fork deformity, right? And in case of supracondylar fracture, you call this as the gun stock deformity. You call this as the gun stock deformity. Right, so these are two important deformities. And now coming to the supracondylar fracture humerus, very, very important because the first thing what you have to remember here in the supracondylar, yes, the clavicle also, very good. So the clavicle also, it results in the malunion. So the clavicle also, it results in the malunion. So in case of supracondylar fracture, what you have to remember is this is above the condyles. So the first and foremost important thing is the 3-point bony relationship is maintained. So the 3-point bony relationship is maintained here, right? And the most important complications are early complications where you see that there is a vascular injury and a nerve injury, right? And there are immediate complications as well for this. So in case of immediate complications, what you have to remember is one important thing, that this might also lead to compartment syndrome. It may lead to compartment syndrome, right? And the late complications, as we are discussing, so this leads to the malunion, and this will result in the deformity or gun stock deformity. So this is about the supracondylar fracture. Can now somebody tell me what is the vessel which is getting injured and what is the nerve which is getting injured? Yes, which vessel is injured in case of supracondylar fracture humerus? Quick. Quickly. Yes, quickly. I know, you all know this answer. Yes, it is the brachial artery. Very good. And then the nerve you have to remember in an order: anterior interosseous nerve, the median nerve, the radial nerve, and the ulnar nerve. Very good, Pratyusha. Very good, Dharmesh. Very good, Javed. And this is your gunstock deformity. So this will be asked in the exam. So identify this deformity. So this is your cubitus varus. So cubitus varus deformity. And this is called the gunstock deformity as well. And how do you treat any deformity? You have to break the bone. So you do osteotomy. So name of this osteotomy, it is called the French osteotomy. This is called the French osteotomy. So now you remember cubitus varus. And then whenever there is a lateral condyle fracture humerus, so lateral condyle fracture of humerus, that results in non-union, which will give you a deformity that is called as the cubitus valgus deformity. So whenever there is cubitus valgus deformity, there is one more important terminology. This is the tardy ulnar nerve palsy, which you have to remember. So tardy ulnar nerve palsy, what do you mean by word tardy? Tardy means slow. So whenever there is ulnar nerve palsy, you will have claw hand. So a patient of 8 years come to you with the claw hand deformity, and in the past he has injury to the elbow. So you have to suspect about the lateral condylar fracture, because in the lateral condylar fracture, so if this is your medial condyle, this is your lateral condyle, and this is not growing. So there is a damage in the physis. Hence the medial will grow like this and it will push into valgus, and as the medial is growing, there is a stretch of the ulnar nerve. So this stretch of the ulnar nerve will damage or cause neuropraxia and result in the claw hand. So this is called as the tardy ulnar nerve palsy in case of your lateral condylar fracture, that is cubitus valgus. In case of supracondylar fracture, it is your gunstock deformity, which is called as the cubitus varus. So this is what I'm talking about, cubitus varus. And important things I've told you for malunion, IT fractures, Colles, supracondylar, clavicle. And for non-union, it is scaphoid, femoral head, talus, lateral condyle fracture of the humerus. Right? Yes, clear? And now the questions on the scaphoid fracture. So scaphoid fracture is again, so this is your dinner fork deformity, right? So this is your dinner fork deformity, and now this is your Colles fracture. So Colles fracture is supposed to be the osteoporotic individuals, and the treatment, as some Javed has mentioned, so there is a palmar flexion and the ulnar deviation. So you do palmar flexion and then you give ulnar deviation, then you set the distal fragment. That means you reduce the distal fragment by palmar flexion and ulnar deviation, and you put a Colles cast. So Colles cast. But if it results in the malunion, then that will cause your dinner fork deformity. So if it is a malunion, it is a dinner fork deformity, right? And coming to the scaphoid. So coming to the scaphoid, important things is your anatomical snuff box. So you have to always palpate for the anatomical snuff box in case of your scaphoid. Then you're going to take an oblique view of scaphoid X-ray to identify the fracture, and glass holding cast. The glass holding cast you use for 14 days. If you're not sure of the fracture, also as a preliminary treatment, you always go for the glass holding cast for 14 days, and then you review. So this was the question which was asked. Whenever you're not sure about the fracture in the oblique view of the X-ray, you still go for the glass holding cast. Okay, and tell me, for the non-union, what is the investigation of choice in case of non-union? All the non-unions. So this is the MRI. So always non-union, you have to go for investigation of choice, that is MRI. So you will see on the MRI that the whatever, the femoral head or the talus and the scaphoid, you can see there is a black tissue. There is an increase of the darkness in the particular area. So that is called the dead bone. That is because of the avascular necrosis or the non-union. Okay. Yes. Everything clear? mal and non-union. So we are going to most important topic again, the complications. So these three are again very, very important. We are going to quickly review about fat embolism. As you all know, always the question starts with the, yes, any doubts? Pratisha, doubts or you're clear? What is rota? RTA. Okay. So Dharmesh is ahead. He's in fat embolism. So fat embolism, let us discuss in detail. So always fat embolism is nothing but the, I'll tell you what is the pathology behind, then you can understand it clearly, right? So in fat embolism, what happens is, what is actually fat embolism? Whenever there is a fracture of the long bones, as you all remember, this is a marrow which is replaced by the fat. So in the marrow, it is replaced by the fat, and this fat escapes in the form of globules and it enters the circulation. It enters the circulation, right? So this circulation, and it triggers inflammation of the capillaries. It triggers the inflammation of the chota capillaries. So what are those chota capillaries you have to remember? So it goes to the lung capillaries, it goes to the brain capillaries, and hence people will tell you that there is a confusion or disorientation, and then they will tell you shortness of breath, and ultimately petechiae or conjunctival hemorrhage. So this is the pathology. So always INICET you should start understanding this way. Okay, so what actually is fat embolism? So whenever there is a fracture of the long bones, because there is a fat in the marrow, it escapes in form of globules and it will enter the circulations, and whenever it enters the circulations, all the small capillaries, it creates the inflammation. All the fat will go and irritate those capillaries. So whenever there is an irritation in the body, there is a lot of inflammation which is flaring up, and this inflammation will result in your confusion, disorientation, shortness of breath, petechiae. But why these fat globules escape? Why these fat globules escape? They usually escape because of the long bone fracture. So long bone fractures. And when do they escape? When do the long bone fracture happen? So where usually the long bones happen in the RTA. And do you think as an early complication it occurs? So as soon as the patient hits with the fracture, the globules escape. It will take some time, right? So they should be fractured, then it could escape, then it should find its way to the capillaries, then it will irritate the capillaries, then the irritation comes out. So remember, it will take some time. So what is that time? So 24 hours to 72 hours for the fat embolism to set in. So the fat embolism to set in, it is taking some time. So how do you find it? So you will first see the X-ray as the patient arrives to the casualty. So you will find the fracture of the femur. So femur fracture. Usually this RTA or the bike riders have this injury. So bike riders is usually the young males. So young males, and the males, they eat more, so the fat is more in them and it is stored in the bone. So this is the so young males with the femur fracture, and after 72 to 72 hours, then they present with symptoms, as we have mentioned, the triad of the symptoms, where there is an involvement of neurological symptoms or pulmonology, and then your rash. So this triad, whenever they're discussing this triad, so this particular patient is having loss of orientation today, and there is shortness of breath or decrease in SpO2, and there is some rash over all the body, then you can think about this particular complication, that is your fat embolism. Then how do you confirm it? So for confirmations, you have 𝐒𝐿's criteria. There are major and the minor criteria. If you go to the major criteria, it is again involvement of your brain, involvement of your lung, involvement of your rash, that is conjunctival hemorrhages. And then the minor criteria, there are many, where you have fever, where you have tachycardia, all the systemic complaints, right? And then how do you treat it? So first you will confirm it by the flat globules in the urine, in the blood, and then you can do a D-dimer but the confirmation is by CTPA. CT pulmonary angiography is the gold standard for confirming, and once you confirm, you will treatment. So how do you treat it? So you know that you have to give the anticoagulants because the capillary is going and irritating, and then you will treat it with the lot of hydration. Hydration and anticoagulants is the usually the treatment, and then sometimes you can fix the fracture, because as the fracture is continuously moving, there is further escape of the marrow fat. So then you can treat also directly with the fixation of the fracture. So this is about the fat embolism, right? Anything, any doubts? Clear? Yes, guys, just a thumbs up quickly. So I have told you the other way around. First I have told you the pathology, then I have told you why actually this occurs, and then you have to look for this triad of symptoms, right? Clear, very good. So there was a question asked in the Neet PG, what is the diagnostic confirmation for your pulmonary embolism? It is CTPA. Okay. Then compartment syndrome. So once you're done with the once you're done with fat embolism, then comes the compartment syndrome. So this is one more important interesting complications, or very important complications. See, whole of orthopedics, this is one important complication where as a surgeon you can do more than any other department. So when it comes to fat embolism, usually it is managed by the anesthetist or the ICU people. Only we fix the fracture and then we give back them to the patient, right? So usually they manage it. Fat embolism is completely managed by them. Only the thing is, we will be sure that it is fat embolism, not pulmonary embolism, right? Then comes the compartment syndrome. Compartment syndrome is very very special to us. Why? Because this starts with the basic of knowing what is actually a compartment. So you have to know what is a compartment. As you know, the bone is surrounded by the muscles, and these muscles are divided by an important structure which is called as the fascia. So this is the very important fascia which is present between the boundaries of which compartment is what, right? So you have anterior compartment, posterior compartment in case of your hand, anterior compartment, posterior compartment, lateral compartment in case of your leg. So very important in forearm and your leg, right? So whenever there is any pathology which is triggering, so there is various ways of pathological triggers. It could be tight bandages, or it can simply be snake bite, or it can be burns, or it can be trauma, or it can be post-surgical, or it can be vascular injury. So all this, what will happen is they will trigger the compartments. So they will trigger the compartments. How do they trigger the compartments? Simply what they will do, whatever in the body should happen, it will always start with the inflammation, right? So what happens is, so for example, let's take trauma. So let's take trauma because we are dealing with trauma. So there is an injury which is happening, and that injury is irritating the compartment. So how does the irritation occurs? It will land up with edema. So what is edema? There is increase in the fluid. So edema is nothing but there is increase in the fluid. So what is actually increase in the fluid? That means, so for example, if this is the compartment, imagine, and now blood supply should come like this. So this is the blood supply. It is coming like this, right? Why the blood is flowing towards the compartment? Because pressure low, this is high pressure, right? Very simple mechanics, fluid mechanics. So from high pressure to low pressure, always the fluid flows that way. Similarly, the blood also flows that way, from high pressure to low pressure. So from a high pressure system, it is flowing to compartment, happy they are. Now what happened? There are some insides. So like tight bandages, snake bites, burns, trauma, post-surgery, vascular injury, anything can trigger. And what will happen in the compartment? So in the compartment, what is happening? There is an increase in the fluid. So whenever there is an increase in the fluid. Fluid doesn't always go like fluid, right? It will pull some proteins also. So there will be increase in the pressure because of the fluid, right? So the oncotic pressure, if you remember, the pressure rises because of the presence of the fluid. The pressure rises here. So because of the increase in the pressure, now what happens? Because of the increase in the pressure, there will be decrease in the blood flow, right? Increase in the pressure will always call decrease in the blood flow. Clear, everybody? Any doubts? So whenever there is decrease in the blood flow, again there is edema, right? Again there is increase in the fluids. So whenever there is increase in the fluids, again there is increase in the pressure. Again increase in the pressure, decrease in the blood flow. Again decrease in the blood flow is what? Decrease in the blood flow is nothing but ischemia, right? So ischemia, again the body has to respond. Again the body responds with raising in the fluids. So this is the vicious cycle which the compartment undergoes, right? Vicious cycle which is undergoing, and the only help which this can get is releasing the pressure. If you remember, everything is happening because of there is an increase in the pressure, right? So this increase in the pressure is causing decrease in the blood flow. Again decrease in the blood flow causing increase in the ischemia, edema. Again there is increase in the pressure. So now what we have to do? We have to relieve the pressure. So how will you relieve the pressure? We will relieve this pressure by cutting the fascia. So fasciotomy. So the treatment is fasciotomy. Clear, everybody? So this is the story behind your compartment syndrome. And now compartment syndrome story, yes, fasciotomy, correct. And now the patient, first the patient will be all right. So some pathology setting in it. So there is an increase in the fluid. So some slight pain the patient will have. So the first and foremost symptom is pain. Then he will tell you that he is having pain. Then what will you do? You will give them analgesic. As usual, we know one analgesic, always we give diclofenac to him. And then he'll again say there is an increase in the pain. Again you give analgesics here. Okay. Again he will say there is an increase in the pain. And now this increase in the pain should raise the suspicion. Okay. Whenever there is an increase in the pain, even with the excessive usage of the analgesic, is first and foremost symptom for your compartment syndrome. And then now you want to check whether you're on the right track. So how do you check? You check with the stretch pain. You check with the stretch pain. So you check with the stretch pain. So now you stretch. For example, if there is a flexor compartment syndrome, then what you do? You extend it. So you're stretching the muscles. If it is an extensor compartment syndrome, then you flex it. So you're stretching them. Whenever you're stretching the muscles, if the pain is increased, that means it is confirmatory for your compartment syndrome. So that is the first and foremost sign. So symptom is increased pain, stretch pain. Right? Stretch on, pain on stretch. For example, you write this symptom as pain on stretch. Right? So these two are very, very important. Then comes your theory. After pain, there is palar paralysis. Right? And what is the one more P? So finally, we have this pulselessness, which is very useless. Okay, so nothing to do with this pulselessness, because this is the last and foremost sign which we elicit, and once we see pulselessness is nothing but the complete limb is dead. So it is very, very useless, nothing to do with, and this is the last one to occur. So there is a pain, and then probably you will have paresthesias, and then you can elicit some amount of palar and paralysis, and then finally it is the pulselessness. Okay, and the treatment I have already told you, the treatment is your fasciotomy. Clear? Yes, thank you. It's not parathesis, it is paresthesias. Yeah. So the treatment is fasciotomy. So this is no signs and symptoms or no test for it. It is a clinical diagnosis. So it is always the clinical diagnosis. Sometimes you can measure the compartment. If it is more than 30 mm of Hg, it is called compartment syndrome. So you can measure the pressure of the compartment which is more than 30 mm of Hg. Clear? Yes. Yes, everybody, is it clear? Any confusion? Yes, I'm waiting for your clearance. Is it okay? Not okay? Clear? Yes. WAC dressing for what? For compartment syndrome? No, it's not helpful. WAC dressing is for open injuries. No, no comparison with the mean arterial pressure. It is just the rise which we see. So usually arbitrarily they have said the compartment pressures are between 15 mm of Hg. So whenever there is a rise of more than 50, and if it is between 50 and 30, usually we say it is an impending compartment syndrome. But if it is more than 30 mm of Hg, it is confirmatory of your compartment syndrome. Is that clear, Jayant? No, WAC dressing is not helpful for your compartment syndrome. Shall I proceed to crush syndrome? Yes, so for I'm coming to the crush syndrome, what will happen is there is no confusion about crush syndrome. It is a great combination. So what you have to remember is this is again a compartment syndrome only, right? Plus your fat embolism together. So here what happens in the crush syndrome is, so there will be a very, very high velocity injury. High velocity injury where they will completely damage your compartment. All the muscles are damaged. So whenever there is a damage to the muscle, you remember the muscles have two important components, that is your myoglobin and the potassium. So here what you have to remember is there is an increase in the potassium, that is hyperkalemia, and there is an increase in the myoglobin which is called as myoglobinemia, and this myoglobin will pass through the kidney which is resulting in myoglobinuria. Okay, so these are all the terminologies which you have to remember. So first there will be complete damage to the muscles. So here it was the fat which was escaping. Here it is the muscle, that is myoglobin, and the potassium which is rich in case of your what? Muscles, right? So myoglobin is increased, which is called hyperkalemia. Hyperkalemia, that is increase in the potassium, and myoglobinemia, which is increase in the myoglobin. So this myoglobin will go through the kidneys, right? It will go to the kidneys and they present as myoglobinuria, and again they damage the kidneys as well. So they will result in renal tubular acidosis, which is damaging of your proximal tubules, right? So they damage your proximal tubules. And this will result in damage of the kidney, that is renal tubular acidosis. And there will be increase in the potassium, increase in the myoglobin. All this will result in the crush syndrome, right? So there is an increase in that is hyperkalemia. I am talking about hyperkalemia. I am talking about myoglobinemia, myoglobinuria, and finally there is a damage to the kidney, especially the renal tubule, the proximal tubular acidosis it will result in. And then this is a combination of all these symptoms, that is the crush syndromes. And how do you treat it? So you will go for dialysis. Again, severe hydration is required, and then you go for dialysis. If the kidney is completely damaged, this will result in dialysis. So that is your crush syndrome. So what was the question which was asked in the crush syndrome is which element, that is the which cation has increased in the crush syndrome, that is your potassium. So it will lead to hypokalemia. And what is that other thing which you see is myoglobinemia and myoglobinuria, right? So that is about the crush syndrome which you have to remember. Clear? Yes, any doubts? Yes, then it is the Workman's ischemic contracture. So this is very again important in case of your supracondylar fracture we have dealt. So in case of supracondylar fracture humerus, so you know there is an injury to the brachial artery, right? So there is an injury to the brachial artery, and this might lead to the compartment syndrome. So in damage to the artery, and it is leading to compartment syndrome. And now if this is neglected, all the muscles are converted into a fibrous tissue, right? And this fibrous tissue gets contracted, and this will result in Workman's ischemic contracture. So that is your VIC. Yes. So there is a supracondylar fracture humerus, and then there is a brachial artery injury, and this will result in compartment syndrome, and there is a damage completely to the muscles, and these muscles will be converted into the fibrous tissue which gets contracted, which is called as Workman's ischemic contracture. And here you have to remember the famous Workman's sign. So you have to remember there is a famous Workman's sign. So what is this Workman's sign? So here if you see the compartment here, if the flexor compartment is involved, so the complete contracture will cause the closure of the fingers like this. So there is a drawing of the fingers into like this, and once you relax, so this is because of the wrist extension. So whenever you're extending the wrist, the fingers get flexed like this, and now when you relax the wrist into flexion, you can see there is a relaxation or the extension of the fingers. So on the wrist extension there is a finger flexion, on wrist flexion there is a fingers extension. So this is called as the Workman's sign. This is because of the contracted fibrous tissue of the flexors. So flexors get contracted. Why are they getting contracted? This is sequelae of the compartment syndrome. So when you don't treat the compartment syndrome, it is dead completely. So the muscles they have been converted into a fibrous tissue, right? So that is your VIC, Workman's ischemic contracture. And now you have the Workman's splint for it. So you have the Workman's splint which you can use if it is a mild deformity, but severe deformity, you have max page sliding surgery. This you have to remember. So max page sliding surgery is for your severe deformity, right? So that is it of your VIC. Then coming to the myositis ossificans. So what is this myositis? Your myo is muscle, and whenever the muscle is itis is inflamed, so inflammation of the muscle will result in ossification. That means there is a formation of the bone, right? Formation of the bone. So whenever the bone is formed, this is called as ossification. So but here the bone is formed from the muscle. So this is called as myositis ossificans. So how do they form? Because they form, there is a massage component. So usually this is mainly seen in the elbow and then in the hip. So these are the two important joints where you usually see the myositis ossificans, and this is actually occurring in the joints. So the bone is formed in the joints. They will cause restriction of movement. So they will cause the restriction of the movement. So which joints are involved? The elbow joint and the hip joint, and in particular which tendon? That is extens brachialis. Sorry. The brachialis is the tendon which is involved in case of your elbow. That is myositis ossificans. And how do you treat it? So the treatment is always excision. So you will try to excise that particular fragment or particular bones which are present in the joint. So whenever you see that joint has to be free. So because of the freeness, it will move. So whatever way you want, it will move. But if the joint, you have anything inside the joint, especially in case of this, you have bony fragments in the joint. So the joint cannot move. So you have to remove that particular bone. So that is by the excision. But sometimes you can still prevent this. So you can use indomethacin. This is the drug which is used to prevent myositis ossificans. So if you're any patient, he has gone to some osteopath and massage has been given and still the myositis has not set in, you can treat them with the Indocap SR. The drug name is indomethacin, which can sometimes be as a preventive measure for your myositis ossificans. But the pathology is the muscle gets transformed into the osteoblast because of the inflammation and it forms the bone. Right? Clear, everybody? Yes, what is Sudeck's dystrophy? Yes, what is Sudeck's osteodystrophy? So here, this is one of the important complication of the Colles fracture. This is important class of complication of the Colles fracture. Here, what happens in the Sudeck's osteodystrophy? So here, there is an autonomous, autonomic system, autonomic nervous system. So autonomic nervous system over action or this sympathetic system overaction. So what happens in that? Here the patient will have all the symptoms. So a patient will have the symptoms of hyperalgesia, dryness of the skin because sweat is absent, right? Hyperalgesia, hyperanesthesia. Okay, so the sensations are increased, the pain is increased, the dryness is increased, right? And then sometimes they will have atrophy of muscles. And on the X-ray, you see there is osteoporosis, which is local osteoporosis of the bone. So all this overaction they will have. That means because the patient will come with the Colles fracture and you treat it, and then after the treatment they will say this pain, there is still a lot of pain, there is still a lot of, even if you touch, there are hyperesthesias, there are loss of, altered sensations over that particular area, and then they will have dryness, and then they can even result with the nail atrophies, the nail get damaged, right? And then there will be muscle atrophy and all the symptoms they will have. You can't do anything for the symptoms because this is a very dreadful treatment, dreadful condition for the doctors as well, because there are no particular treatment for it. There is no treatment for it. It is an sympathetic overactivity which is happening there. So sometimes you can just tell them that this is the thing which is happening, and if they are still not able to take it, you can go for sympathectomy. That is some whatever is the stimulations they are getting it, you can remove that particular sympathetic system there, and you can treat it. But this is you usually shift them to the pain management people so that they will treat it better. So for us, it is only the diagnosis which we make, the Sudeck's osteodystrophy. It is diagnosis of exclusion. So you have to treat all the particular things which is happening, and then if the patient is still not reacting, and if you see all this particular symptoms of excessive pain, excessive sensations and dryness, nail atrophy, and on the X-ray you see osteoporosis, this is called as Sudeck's osteodystrophy, right? This is called as Sudeck's osteodystrophy. Yes, clear? Usually we see this with the Colles fracture. Yes. Can you one more name of Sudeck's osteodystrophy. It is also called as complex regional pain syndrome. Okay. So now again there are two important complex regional pain syndrome, CRPS1 and CRPS2. Whenever we say CRPS2, that means it is associated with the nerve injury. So it is associated with the chronic condition. So this is a chronic condition which is associated with the nerve injury. So we have type 1 and type 2. Okay. Yes. So that is it for the complications. And then we have certain fractures. So whenever you deal about the trauma in the upper limb, so what is important is your shoulder dislocation. We have dealt with it. And then fracture eponyms. So some important fracture eponyms like the Monteggia fracture, the Galeazzi fracture, the Boxer's fracture, the Rolando fracture, the Bennett's fracture, the terrible triad. Okay, all these names of the fractures. And then we have classifications of that particular fracture. Right? So certain classification names are also very, very important. So for example, the proximal humerus classification is the Neer's classification. So there is a name for it. It is called the Neer's classification. Similarly, the femur head. So femur head, what is the classification name given to it? So there is a neck and there is a head. So head, it is Pipkin's classification, right? And then acetabulum, it is laternal and Judet classification, right? And Judet classification. And Monteggia, oh sorry, this is Monteggia Bedo classification. This we have already dealt. And supracondylar is again Gartland's classification. Okay. And calcaneum, we have two. We have Essex Loprisetti classification for calcaneum, and then we have Sanders classifications for CT. And then femur neck, as I've told you, it is Garden's classification, Powell's classification, right? Garden's and Powell's classification. So lateral condylar, we have Milch classification. So these are certain names. Just to remember, what is most important here, if you ask me, first one is this. So the femur neck classification is important. Supracondylar they have asked, and they have also asked the talus classification, the Neet PG, which is by the Hawkins. Talus fracture is by Hawkins. So this was asked in the Neet PG, right? So there are certain classification names which you have to Then coming to the lower limb classification, right? In case of lower limb, what we have is the first one is the pelvis fracture. So in case of pelvis fracture, the first important question what they have asked in the Neet PG is what is the first and foremost step you do. So whenever there is a pelvic injury, we do it with the pelvic binder. We use the pelvic binder. So why this pelvic binder? Because pelvis is like a ring, right? It is completely like a ring. So here you have the sacrum, and here you have the pubic symphysis. So you have to protect this ring. So there are certain important vascular structures which are present in the ring. So you use the pelvic binder. If it is not available, you use the bed sheets and drape it around the greater trochanter. So you drape it around the greater trochanter. Right, at the level of 2 greater trochanters, you drape it. So that is a pelvic binder which we use mainly for our pelvic fractures, and pelvic fracture is a high velocity injury. Always remember ABC. So you have to first secure the airway, breathing and circulation. That is mostly you have to check for the shock, because high amount of blood loss is suspected in pelvic injury fractures. And then coming to the local part, you have to use the pelvic binder. So the first and foremost thing is pelvic binder. Yes. Then what is this attitude? So this attitude is flexion, adduction and internal rotation. So where do you see this attitude? This attitude is seen in your posterior dislocation of hip. So you see this in the posterior dislocation of the hip. So posterior dislocation of the hip is very, very important. I have told you the anterior dislocation, and now this is the hip joint where you see posterior dislocation. So how do you know it is internal rotation? On the X-ray you see the lesser trochanter here, right? So here there is an absence of the lesser trochanter. So on the X-ray you don't find the lesser trochanter. So whenever there is an absence of lesser trochanter or lesser trochanter is not visible, that means the limb is internally rotated. So this is the attitude which we called. This is the attitude which we called. This is the limb that is farther. The dislocation is a posterior dislocation, and the nerve which is damaged is the sciatic nerve. So nerve which is damaged is the sciatic nerve. Yes, clear? Yes, very good. This is seen mainly in the dashboard injuries. So as somebody has mentioned, what is dashboard injuries? So dashboard injuries is again a triad. So you see there is a damage to the posterior dislocation of the hip, and then you have your patella fracture because there is a direct hit to the dashboard, and then you have your PCL injury. So posterior cruciate ligament also get damaged in case of your dashboard. So this is a triad that is called as a dashboard injury. Very good. And then coming to two important fractures of your femur neck. This is very, very important. So the first and foremost is your IT fracture, and the second one is your IT fracture. So if you see the fracture patterns, so here the fracture is in the neck, that is femoral head is separated. Here the fracture is in the neck again, but it is between the trochanter. So if you see, this is the greater trochanter and this is the lesser trochanter, and the fracture is extending from the GT to the LT. Hence this is called as intertrochanteric fracture. So inter means in between the trochanters. This is intracapsular, because if you go back to the anatomy, you see the capsule is attached somewhere here. So this is the attachment of the capsule, right? So let us assume this one, and the capsule is attached like this. Okay, and now the fracture is happening here. So it is inside the capsule. This is outside the capsule, because I have told you the capsule is attached to somewhere here. This is outside the capsule. So this is called as extracapsular. So this is intracapsular fracture neck of femur. This is extracapsular fracture neck of femur. So why have you to differentiate between these two? Anyways, it is fracture in the proximal femur. Yes, there comes the point why you have to differentiate, because IC fracture will result in avascular necrosis of the femoral head, because the supply of the head is disturbed. So the blood supply is disturbed in case of IC fracture. If you go back to anatomy, here it is maintained. So here the treatment is replacement of the head, that is hemi, half, ortho, that is joint replacement. So you're going to do hemiarthroplasty. Here the blood supply not disturbed. The blood supply is not disturbed, right? Because it is outside the capsule. Hence you go for the treatment which is called as proximal femoral nail, PFN, that is a nailing system. And what is the complications you assume here? Here the head goes for avascular necrosis, that is non-union. Here it goes for malunion. So here the complication is avascular necrosis, that is non-union, and in case of IT fracture the complication you expect is malunion. If you remember, go back, we have decided that in IT, in the malunions, the one of first thing is your IT fracture. In non-unions it is your femoral head. Because of the blood supply, it results in non-union and avascular necrosis. The treatment is very, very important. The treatment here in case of IC fracture is hemiarthroplasty. So how do you do the hemiarthroplasty? Hemi is half of the joint is replaced. So what is that half of the joint? The half of the joint is your femoral head. So whenever the femoral head is replaced, it is replaced by prosthesis. It is replaced by prosthesis, right? And then if you replace the acetabulum, this is called as total hip replacement. So if acetabulum is also involved, it is called total hip replacement, which is nothing but THR. Hi Nishu, good evening. And if there is no replacement of the acetabulum, it is called as hemiarthroplasty. In case of IT fracture, the treatment is proximal femoral nails. So you put the nail and the screws into the head, that is called as PFN. Right, and then when it is a femur shaft fracture, whenever it is a femur shaft fracture, one of the most common fractures, so you have to be very careful because the fat embolism sets in, right, and then you are going to treat it with an implant which is called as intramedullary interlocking nail. So identify the implant. So this is your intramedullary interlocking nail. So you introduce the nail from the GT, right, introduce the nail from the GT, and you're going to fix this with the screws here and here. Right, so this is the intramedullary nail. Then what is the difference between PFN and intramedullary nailing? In case of PFN, if you go back and see, this is the, if this is your femur. So in case of PFN, you will see the nail inside it and then screws into the head. So there are screws into the head. This is PFN. But in case of interlocking intramedullary nail, you see the nail is not into the head. So the screw, there is nothing into the head. There is no head screws. So the screws are into the shaft. So that is your differentiation between the intramedullary interlocking nail and your proximal femoral nails, right? And here you can first, what you can use in case of femur shaft, first the Thomas splint you can use. So what is a Thomas splint? Again, you have a ring and two things, and then you have something like this, and this is outer, which is accommodated for the GT, right? So this is mainly for immobilization. So limb is put inside the Thomas splint like this, and then you're going to put a bandage. So just for immobilization, and then you take to the surgery. So what is the surgery you do? The surgery is intramedullary interlocking nail, right? And if it is in the children, you go for hip spica. You go for hip spica. And if it is more than 5 years of age, the femur shaft, the treatment is TENS. What is TENS? TENS is titanium elastic nailing system. Titanium elastic nailing system, that is your TENS. So that depends upon the treatment, depends upon the age. If the patient is just less than 2 years, you go for hip spica. More than 5 years, you go for TENS. For adult, you go for intermedullary interlocking nail. That is just, you can say, femoral nailing, right? And then what is this? Yes, very important, your ankle fractures. So ankle fractures are very important, and now you have to see, whenever you're commenting on the ankle, there are three views: the epilateral and the mortise view. The mortise view is the one which is very important. Will tell you the detailing about the joint lines, So here you have the medial malleolus, right? And you have the lateral malleolus, and then you have your posterior malleolus, right? So whenever there is a damage to your medial malleolus and the lateral malleolus together, we call this as a bimalleolar fracture. So bimalleolar fracture is nothing but your Cotton's fracture, right? So whenever it is trimalleolar fracture, it is your Pott's fracture. Trimalleolar is your Pott's fracture. Is that clear? Ronaldo is what? Ronaldo is there back in the first metacarpal based comminuted fracture, right? So here, did I use the word Ronaldo anywhere here? No, I was telling Cotton's and Pott's. Cotton's is bimalleolar, Pott's is trimalleolar. So to comment on the trimalleolar, it is always seen on the lateral view, right? So this is your AP view, where you see your medial malleolus and lateral malleolus, right? And this is your mortise view. It is an internal rotation, so you can see the joint lines very clearly, right? And then this is your lateral view, where you comment upon your posterior malleolus, right? Yes, Dharmesh, I want you, like, what is Rolando? What is that question mark for? And this is the classification. This is the Long-Hanson's classification. Hanson's classification based upon the position of the foot. If it is supinated or pronated, if it is external rotated or adduction. We have various fractures, right? If it is supination and external rotation, which is most important, you will have the fracture. you will have the fractures at the level of syndesmosis. So what do you mean by syndesmosis? Syndesmosis is nothing but this particular area. So this is called as syndesmosis. So this is anatomy again, where there is a where there are ligaments which are passing between the tibia and the fibula. So that is syndesmosis. So that shouldn't be ruptured. If there is a fibula fracture at the level of syndesmosis like this, then it is supination and external rotation. When you come to the other one, pronation and adduction, it is suprasyndesmotic. If you see, the fracture is above the syndesmosis, right? And one important thing which you have to remember, it was asked in the INICET, it is the vertical fracture of the malleoli. So whenever it is a vertical fracture of the malleoli, it is the separate entity. It is a separate entity, right? Vertical fracture of the malleoli, it is supination and adduction injury. So supination and adduction, you have your vertical malleolar fracture, right? So that is it about the ankle fractures. The classification name is Launch-Hassen's classification. Okay. Next, coming to the spine, very, very important. Okay. So important in the spine is again very important. I have told you that we deal more with the C-spine with the hard collar. And usually the neurosurgeons will deal with this. And then coming to the thoracic vertebrae is mainly seen in the osteoporosis. And you can see there is a wedge-shaped fracture. Right? Right? And now we have types, and here you have to remember the eponyms. Again, the fracture names, right? The fracture names. So the burst fracture. So the first one is the burst fracture, where you see more than half of the vertebra is damaged. And if you remember the Dennis 3-column concept, and this is the posterior one. So Dennis 3-column is anterior, middle and posterior, right? So anterior, you have your anterior ALL ligament with the vertebra. Middle, you have only the vertebra. Posterior, you have the structures, the facet joint, the pedicle, all you have in the posterior. So this is based upon your Dennis 3-column concept, right? Yes, Dennis 3-column concept. Yes. Guys, are you with me or you're sleeping? Okay, now I'll tell you the names. What is a burst fracture? Burst fracture, if it is more than half of the vertebra is damaged, so the complete vertebra is involved, right? It is type of a comminuted fracture in case of spine. Okay, then we have chance fracture. This is very, very important. This is also called as seat belt fracture, where you see a horizontal line which is extending in the vertebral column, and one of the most unstable one because it extends into the posterior column. So the posterior column is the one which has a spinal canal, right? So something extending in the posterior canal is an unstable fracture. So chance is the first important thing. Then 𝐒𝐿-Chauvin's fracture. What is the 𝐒𝐿-Chauvin's fracture? C7 vertebrae. Fracture of the C7 vertebrae, right? And what is the dense fracture? It is the odontoid fracture. Odontoid fracture, right? And Hangman's is traumatic spondylolisthesis of C2 over C3, right? That is traumatic spondylolisthesis. Hangman's, the two words, remember it as C2. And Jefferson's, it is Atlas burst fracture of the ring. Okay, C1, the first vertebrae. Yes, very good. What is a whiplash injury? Whiplash injury is nothing but it is an hyperextension injury. So whenever you are going in a car and you just stop it like this, so there is a sudden flexion and then you go into hyperextension like this. So there is a complete ligament which is damaged. So this is nothing but a ligamentous injury with no bone injury. So there is no damage to any bone, but there is a damage to the ligaments which are present, hence the patient will have severe pain. But the x-rays are all quite normal. So this is a whiplash injury. What is the undertaker's fracture? Undertaker's fracture is again a fracture of the vertebrae, cervical vertebrae, whenever they're shifting the corpus, that is after the death, the postpartum, right? It is a postmortem injury. It is a postmortem injury, right? So once they have, the patient has been shifted from the for the postmortem, they do not, and then they shift to put it somewhere secured, then mishandling of the dead body, there will result in the undertaker's fracture, right? Is it clear? So this 𝐒𝐄𝐝 fractures can be a lower vertebrae or upper thoracic, especially what is the spinous process. This is the one which is damaged here, the spinous process. Okay, that is the 𝐒𝐄𝐝 fracture. So this is all you have to remember. And now answer me, what is that this A and what is B? What is A? And wedge fracture, I have told you there will be a decrease in the height of the vertebrae like this. So actually the vertebra has to be like this, but it becomes like this. So this is the decrease in the vertebral height, that is wedge fractures. It is usually seen in the osteoporotic people. And this is your first one, is your burst fracture. If you see, there is a damage to more than two columns, right? Anterior and the posterior column. So this is the burst fracture. And here if you see, this is a horizontal line which is extending into the posterior. So this is an example of your chance fracture. So burst fracture and the chance fracture. Yes, wedge fracture is osteoporosis. And 𝐒𝐄𝐝, I'm repeating it again, the spinous process of C7 vertebra, lower and upper thoracic as well, can be a 𝐒𝐄𝐝 fracture. Burst chance we have done. Dents is odontoid fracture, you can remember. Jefferson's and Hangman's, very important. You see the word F is there. So the first, that is C1. Hangman's. So there is two words which is traumatic spondylolisthesis. Okay. Usually they don't ask about the undertaker's fracture, nothing to worry about it. Now spine trauma is done, then we do a simple cases of the spine. So the first one is prolapsed intervertebral disc. So in case of prolapsed intervertebral disc, what they usually ask is, so this is because of the disc degeneration, right? So there is a disc degeneration which is happening, and this disc degeneration will cause damage to the nerves. So damage to the nerves which is crossing. So for example, if there is a damage to the L4, L5 disc, which nerve is involved? Yes, faster. Which nerve is involved? So the nerve which is involved here is L5. So the lower nerve is getting involved. How this is happening? So there, let's look at this diagram. So here this is the L4 and this is the L5 nerve root, and here this is the L4 and L5 disc. This is L4 vertebra, this is L5 vertebra, right? Clear, right? So above one is L4 vertebra, the below one is L5 vertebra, and this disc which is there is the L4 L5 disc. Now I am telling you that there is a damage to this particular disc, that is L4 and L5 disc as damaged. Now see, the L4 nerve is already going above the disc, right? So this is going above the disc, but the L5 nerve is coming over the disc and going below it. So whenever there is a damage to the disc, so there is a problem to the L5 nerve root. So this L5 nerve root is called as the traversing nerve root. So whatever nerve which traverses the disc will get damaged. So in case of your L4 and L5 disc problems, the damage is mostly to the L5. The lower nerve gets damaged, right? Similarly, can you tell me if this is your L5 and S1 disc, which nerves gets involved? Which nerve gets involved? The traversing nerve root here is the, very good. So it is the S1. So the S1 nerve gets involved, right? So that is the answer for this. So whenever there is an MRI which is given to it and you see there is an L4, L5 disc degeneration, so which nerve is affected? L5 nerve is affected, and in L5S1, S1 nerve is affected. So the nerve which is exiting is called the exiting nerve root, that is L4. So at the level of L4, L5 disc, the L4 will act as exiting, and which comes down is called the traversing. So this coming down nerve is one which get damaged, that is called as traversing nerve roots. Understood? Yes. And then what is this? This is your straight leg raising test. So what is a straight leg raising test? So this knee has to be kept straight. Right, the knee has to be kept straight like this, and then you're going to stretch the sciatic nerve. So whenever the surgeon is lifting the knee, your leg up, that is straight leg is raised with the knee straight, means there is no bending of the knee, complete knee extension. So the sciatic nerve gets stretched. So this stretch of the sciatic nerve will cause irritation in the disc. So whenever there is prolapsed intervertebral disc, the sciatic nerve gets irritated, and this test will become positive. So whenever the patient is having a wincing pain after lifting the leg more than 60 degrees, sorry, less than 60 degrees, not more than. If the patient is having wincing pain, as we lift the leg, it is below 60 degrees and the patient is having pain, that means it is positive straight leg raising test. What does that mean? What is positive here? Positive means the sciatic nerve getting stretched and it is irritating the disc. So less than 60 degrees, if pain present, this is positive, right? Straight leg raising test. This is called SLRT. And now this was asked in the exam. So what is this? Always read the x-rays. And now if you see, there is a slip of the vertebrae. This slip of the vertebrae is called what? This is called as spondylolisthesis. So this is called as spondylolisthesis. So what is listhesis? Listhesis is forward protrusion of the above vertebrae. And here you see this Scottish dog sign, and this will be explained in the radiology even better. So the pedicles are taken as the eyes of the dog, right? And the spinous process is there, and the pars interarticularis is taken as the collar. So pars is a very important part in the vertebra, in the posterior vertebra. So whenever there is a damage to the pars, that means the connection between the anterior and the posterior vertebra. So if you assume this as the vertebra, this is the connection, and then you have something like this. So this is the pars interarticularis. So whenever there is a damage to this particular pars, there is a provision for the vertebra to slip forward. So hence this is called as spondylolisthesis, right? And the pars interarticularis break is fractures result in this spondylolisthesis, right? Always identify this as sacrum S, and this is L5 and L4. So this is L4 over L5 spondylolisthesis, right? Clear? This was asked in the exam. And now what is this? So there is one more important conditions in the spine which is called as the lumbar canal stenosis. So this is called as the lumbar canal stenosis, and in this what happens is the canal is compromised. So the canal is compromised, that means there is a diameter which is decreased. So the cord gets compressed. And now the patient presents with one which is called as a neurogenic claudication. That means as the patient moves, he will have pain, he will have tingling and numbness, and then he sits for some time and then it gets relieved. So this is called as neurogenic claudication. Similarly, like what? Your vascular claudications, right? So this is neurogenic claudication. So you have to know the difference. So claudication here is after some distance. So if they walk for some distance, then they have this pain in the legs with the tingling and numbness, and once they sit, it gets relieved. And when the spine is flexed, the pain is relieved, because on extension the diameter becomes narrow. On flexion, the spinal canal is improved. That means on flexion the spaces is increased, so the compression is relieved, hence the patient wants to flex and walk. So this is called what? This is called as the shopping cart sign which was asked in INICET 2 years back. So this sign is called as the shopping cart sign, which is seen in lumbar canal stenosis. Why? Because the flexion of the spine will cause decrease in the symptoms, decrease in the pain. Hence the patient wants to bend. So this is called as the shopping cart sign. Now these are certain implants which are present. So these implants, if you can identify, this has been asked. So this is patella fracture. So whenever there is a patella fracture, we do this treatment which is called as TBW. That is your tension band wiring. So this is called as your tension band wiring, where we use implants which are called as the K wires and your SS wire. So this wire, SS wire, is present in the shape of the 8, and then this fracture is held with 2 K wires. So this is called as the tension band wiring in the patella fractures. The other example is olecranon, your medial malleolus, and your greater trochanter. So these are other areas where you can do the tension band wiring. Why? Because this is done. This is the tendon which is getting attached here, and this is another tendon which is attaching to the lower pole of patella. And whenever there is a fracture, now these tendons will pull the fracture fragments. Now what we are going to do, we are fixing this with the figure of 8 like this. And the fracture, first we fix with the K wires, and then we fix the K wires with the SS wire. So this is called as tension band wiring, right? This is the lateral view. You can see the 2 K wires. So these are the wires, and this is the SS wire. SS is nothing but stainless steel, nothing more. Okay, stainless steel. And now identify these implants. So now tell me, what is this? This is A and this is B. Now tell me, these are nails, right? So there is a nail here. If somebody can read the X-ray, so there is a nail plus the screw is present where? The screw is present in the head. So I have told you, if there is a nail and the screw in the head, what is that called? This is called as proximal femoral nail. Yes. And now if you see, there is a screw in the head. So there is a screw in the head, but there is a plate. There is no nail. There is a plate with screws in the shaft. Right? So whenever there is a plate, yes, this is dynamic hip screw. Very good. So this is dynamic hip screw A, and proximal femoral nailing is B. These two are used for what? These two are used for a famous IT fracture. So whenever there is an IT fracture, if it is an uncomplicated fracture, you go for a DHS. Okay, if it is a comminuted, you go for PFN. And now you know the difference between PFN and IMIL. So this is intramedullary or femoral nails. Any long bone nails, the screws are in the shaft only. So you can see the screw here in the shaft, the screw here in the shaft. So there is no screw in the head. The screw in the head is PFN. And then this is what I have told you, if the patient is more than 5 years, and now this is a long bone which is growing, right? So this long bone is growing. So you have to accommodate the nails which are growing too. So then we are treating this with the TENS, which is called as titanium elastic nailing system, which is TENS. These are expandable nails. Expandable nails. So these nails also grow along with the bone, and later you can remove it after the fracture has united. So mostly within less than 1 year we try to remove these nails, right? So this is about the implants, various implants which can be asked in the exam. Then prosthesis. I have told you that there is a hemi-arthroplasty which can be done with this prosthesis. When there are 2 holes, you have to do this as Moore's prosthesis, right? So this is a Moore's prosthesis, and whenever there is a collar over the head, this is your Thompson's prosthesis. So this is the Thompson's prosthesis, but nowadays we are not using these two. We have shifted to a bipolar prosthesis. So what do you mean by a bipolar prosthesis? Once there is a head and there is certain one more head, so there is a dual mechanism. So there is a dual movement which is happening. So with the stem like this, the stem is little slimmer. So this is the bipolar prosthesis. And then we have 3 important prostheses for hemi-arthroplasty. I have told you what is arthroplasty, replacement, right? So you are going to replace the femoral head with this prosthesis. The first one Moore's, second one Thompson's, and the third one is bipolar prosthesis. And these are 2 plates which we use, whenever you see an oval hole like this is called the DCS. So dynamic compression plate. So this is dynamic compression plate, right? And now when you see a thread in the hole, so you see a hole like this, and then there is a one more hole where there are threads. So this is called as the locking compression plate. So why this has been invented? So initially we were using DCS, that is dynamic compression plate, but here whenever we are using in the osteoporotic bones, these osteoporotic bones will not have hold. So the bones are very, very weak. If you put the screw itself become loose. So now we have introduced the locking mechanism for it. Now what happens is that screw which is there, it also has threads on the head, right? And now the threads are there in the plate. So all these threads get locked. All these threads gets locked. So this is called as locking compression plate, and this is called dynamic compression plate. And the length, or what you have to calculate the holes. This is 1, 2, 3, 4, 5, 6, 7, 8. So this is 8 hold plate. And this is mainly used for your humerus. So humerus, you can have the fracture here, 4 screws above, 4 screws below. So this is 8 hold plate. Okay, and if you have 6 holes like this, then this is used for forearm. Forearm, 3 screws above, 3 screws below. So that is your 6 hold. This is 8 hold. And this is also based upon the holes. 1, 2, 3, 4, 5, 6, 7, 8, 9. This is a 9 hold plate. Okay. That is what you are asking, Nishu. So next important topic is tumors. Okay. Next important topic is tumors. Now just identification of the tumors we'll do, nothing more, and few other important points. So first one is identify quickly osteochondroma. So what is osteochondroma also called as? It is called as exostosis, right? Exostosis, and here it is usually in multiple areas. So you can think that diaphyseal achalasia is the term which is given for multiple areas. So what is the main important thing about this osteochondroma or exostosis? It is the tumor which is covered with the cartilage cap. So it is covered with the cartilage cap, right? And here if you see, the marrow is continuous with the growth. Okay. So here if you see, let's go back to this. So this is the extension of this, and here you have the marrow. So the marrow also goes like this. So there is a cortex, there is a marrow, and this is your cartilaginous cap. So what they tell is, they tell that whatever the size you're seeing on the x-ray, it is much, on the reality it is much bigger, because cartilage is not seen on the x-ray, right? So the cartilaginous cap is about that growth. So the tumor what you see on the x-ray is usually the size lesser when compared to the in real. Okay, so the two important things I want you to remember is, this is it is seen in multiple areas, which is called as diaphyseal achalasia. Osteochondroma is not a tumor itself, but it is an aberrant growth disturbance. So the important thing, it is one of the major important growth disturbance in the growth plate. Hence it is going away from the joint, away from the joint. So if you see, the growth is away from the joint, covered by cartilaginous cap. If the cap is more than 2 centimeters, it might turn into malignancy. The malignancy which we see is chondrosarcoma. Chondrosarcoma, that means cartilaginous malignancy of the cartilage, right? And then what is this? What is this? Yes, this is your shepherd crook deformity, right? So this is seen where? This is seen in your fibrous dysplasia. So this is fibrous dysplasia, shepherd crook deformity, and your McCune-Albright syndrome was asked in the exam. So what do you mean by McCune-Albright syndrome? Where this complete is replaced by the fibrous tissue. So the marrow is completely replaced by the fibrous tissue with your precocious puberty and your cafe olate spots, right? So these are cafe olate spots with precocious puberty with your fibrous dysplasia, that is your Shepherd-Crook deformity. Whenever it is with this syndrome, that is called the McCune-Albright syndrome. Very good. Then what is this? This is your osteoid osteoma. This was again asked in the exam. So this is your osteoid osteoma. So what do you mean by osteoid osteoma? Coast of Maine. Yeah, coast of Maine. M-A-I-N-E. Yes, in neurofibromatosis, it is coast of California. Okay. So osteoid osteoma is nothing but here what happens, you will see a lucency, right? And this is covered by the cortex. Okay. Yes, very good. In osteoid osteoma, you see pain in the night. And the pain in the night which is relieved by NSAIDs. Yes, very good. This is very important terminology. They will present to you for asking the history. Yes, it is like the nidus. So this is the nidus. So this nidus in the cortex, mainly we go for CT scan. So this is seen as the CT scan, not in the X-ray or the MRI, because this is the osteoid. The cortex is seen mainly in the, this nidus is mainly seen in the CT scan. On the bone we have to see. And now, yes, the treatment is RF ablation. Very good. The treatment is radio frequency ablation. Radio frequency ablation. And you have to remember this occurs in the diaphysis. This occurs in the diaphysis. So, osteoid osteoma is again a benign tumor. Nidus is seen. This nidus usually identified by the CT scan. And patient will have pain which is relieved by NSAIDs and usually seen in the diaphysis. Treatment is radio frequency ablation. Very good. And then what is this? This is your very important, your giant cell tumor. The most important thing is occurring in the epiphysis. So one more tumor which occurs in the epiphysis is your chondroblastoma. Not to forget, the one more tumor is your chondroblastoma. And how do you identify this giant cell tumor? So yes, it is a very eccentric, that means not in the center, and it is very expansile, that means expand even out of the cortex. And then you see it is eccentric, expansile and very aggressive tumor, and it is usually sitting on the joint but will never cross the joint, seen in mature bone. Whereas chondroblastoma is seen in immature bone. So this is usually seen in mature bone. It is eccentric and expansile, and the treatment is very important, that is extended curettage. So what do you mean by curettage? Curettage is removing the bone. So when you applied liquid nitrogen bone cement such an adjuvants to, so this is one of the erratic GCT. GCT is very aggressive tumor. Why it is aggressive? Because it is recurrence. The recurrence is the problem with GCT. So to avoid this recurrence, what we do is we put liquid nitrogen or bone cement into the lumen, into the tumor, so that it will not again recur. So this is called as the extended curettage. Extended curettage. Okay. And what is this? The last one. Usually whenever they put tumors which are lucents in hands and toes, okay, small bones, cartilage which is present there, this is called as enchondroma. And again you can see in multiple areas which is called as enchondromatosis. Simple enchondromatosis is Olliers disease. Olliers disease is simple enchondromatosis. Whenever they are present with hemangioma, this is called as Maffucci's syndrome. So this is called as Maffucci's syndrome, and there you see as phlebolith. That means stone shaped. There are literally which are hard enchondromatosis. So you can have certain terminologies, that is enchondroma. Enchondroma is a cartilage tumor usually seen in small bones, which is very seen in the small bones, and you can easily identify it as a lucent. So it is lucency, and in center you have some cartilaginous pluff. Okay. So this is multiple enchondromatosis is called the Olliers disease, and whenever they are associated with the hemangiomas and present as phlebolith, this is called as the Maffucci's syndrome. This is called as the Maffucci's syndrome, right? And then coming to the tumors. The tumors we have here, the first one is what? Yes? Here the first one is your This is nothing but your ABC. This is your aneurysmal bone cyst. This is not the GCT. It is your aneurysmal bone cyst. So now you will understand why the term expansile has come. So if you see, this is actually the cortex. But it is going beyond that. So this is called as again an eccentric and an expansile tumor. Right, eccentric and expansile tumor. So this is called as the aneurysmal bone cyst. So this is called as the aneurysmal bone cyst. Okay, and now the investigation of choice for your this is your MRI. So in the MRI, what you will find? You will find multiple fluid levels. So multiple fluid levels are seen on the MRI. So the investigation of choice is the, what is investigation of choice? It is MRI. Again, aneurysmal bone cyst is called ABC, and in the ABC you find eccentric and it is an expansile tumor. Usually we get confused with the GCT, hence we go for an MRI where you see the multiple fluid levels. So these are the multiple fluid levels we see, right? So these are the multiple fluid levels. Okay. Yes, in this particular thing, both lead is not still fused. Then what is UBC? UBC is a simple bone cyst. So UBC, what we do is, this is a simple bone cyst, and here what we see is just a fluid filled cavity. Fluid filled cavity. Why are we worried then? This SBC, if there is nothing, it's just a fluid filled cavity, but this will make the bones weak. So this will make the bones weak and they will result in a pathological fracture. So they will result in pathological fractures, right? So this pathological fracture, whenever present in the UBC, will produce fragments in that fluid, which is called as the fallen leaf sign or the trap door sign. Fallen leaf sign or the trap door sign. Right? So mainly for the pathological fractures, we have to concentrate on the SPC or the unicameral bone cyst. And aneurysmal bone cyst is the vessel. Vessel is involved and the leakage of that vessel will result in the blood which is filled in the cavity. So this is the blood filled cavity, right? That is the aneurysmal bone cyst. Okay. So UBC you can treat with the steroid. Sometimes in that lesion, you can go with the steroid inflation into that. Okay. And then the malignant tumors. In case of malignant tumors, we have osteosarcoma. And this is your, this is your Ewing's sarcoma. And this is your osteosarcoma. So what is the difference? So osteosarcoma is mainly seen in the second decade, right? In the second decade we see, and what are the two important things we see? So one is what we see is the sunburst appearance. And the second one, what we see is your Codman's triangle. So sunburst appearance and the Codman's triangle. What is the sunburst appearance? The sunburst appearance, usually it is the osteoid forming tumor. So this osteoid forming tumor we see around the capillaries or around the Sharpie's fibers, and this is called as osteosarcoma. And Codman's triangle is elevation of the periosteum. Elevation of the periosteum. And this osteosarcoma is mainly treated with chemotherapy and then your surgery, right? And then we have your adjuvant and the neoadjuvant chemotherapies, right? So that is about your osteosarcoma, what they usually ask. And coming to the Ewing's, it is a tumor of the first decade, and usually you will get surprised that this Ewing's sarcoma usually presents as with raised fever, raised ESR, CRP and WBC count. So you will have fever, ESR and CRP which mimic infections, and on the X-ray you have the onion peel appearance, and this is a category which is responsible for the PNET, that is neuroectodermal tumors, that is PNET. And round blue cells are seen on the biopsy. So on the biopsy you see there are round blue cells completely on the biopsy. So this is the Ewing's sarcoma. Yes, there are certain immunohistochemistry which you have to remember, that is yes MIC 299. Yeah, even mix 299 and the translocations T11 2022 is the translocations which you have to remember for the Ewing's sarcoma, and usually remember it is for the first decade, and confirmation is always by the biopsy. So confirmation is always by the biopsy, right? So there is no chemotherapy and radiotherapy for your Ewing's sarcoma. Only surgery is the treatment, right? And coming to the nerves. That is about the tumors. Then we have important nerves. So we have three important nerves here. So the first one is the median nerve. Then we have the ulnar nerve. And then we have the radial nerve. So how do we remember all this? So radial nerve, you know, all the extensors are supplied by the radial nerve. And median nerve, you know, there are all the flexors except FDP and FCU. And in the hand, they supply the thenar muscles and your lumbricals, right? First and second. And ulnar or the exception flexors, that is your FDP, medial half, and your FCU. And in the hand, it supplies all these interosseous muscles. There are two important interosseous muscles, the palmar interossea, the dorsal interossea. Then we have the lumbricals, right? So the third and fourth lumbricals, especially the medial lumbricals. And then what we have, the most important, after interosseous, we have the hypothenar muscle. So the thenar is supplied with the median nerve, the hypothenar is by your ulnar nerve, right? And in the thenar, the exception of the adductor pollicis. The adductor pollicis is again supplied by your ulnar nerve. Clear, guys? Any confusion? I'm going a little fast because we are running late on the time. So I'm not asking you much questions, but as I keep on telling you, also keep revising from your end, right? So these are the nerve supply, very, very important, asked especially in the exams. So all the flexors are supplied by the median nerve except your FDP and FCU, and in the hand, the thenar and the lumbricals, right? Now what is important for us is the pathology, right? So median nerve, whenever the flexors are damaged, especially the thumb is damaged, it will result in the ape thumb deformity. So it will result in the ape thumb deformity, right? And then it will result in the, what is this? This is the Pope's sign or the benediction sign. The Pope's sign or the benediction sign. The Pope's sign or the benediction sign. And then this is the pointing index. So please be careful. So whenever they're asking you about the thumb and the index finger, it is the median nerve. So the pointing index is by the median nerve. And here the ape thumb or thumb in line with the other fingers. So thumb usually has to be perpendicular like this, but it is in line. So this is the ape. Ape is mammals before us. So the whale and all have the feet like this, right? There is no thumb for them. Now that is the ape thumb deformity. And whenever you are asked to flex your fingers, so they will flex like this. So they can't completely flex like this. So what they do is they slightly flex like this. So this is called the Pope sign or the benediction sign. So they usually do like this, no? The Pope, that is called the Pope's sign, right? And then what is the test which we have for the median nerve? This is called the pen test. So pen we usually use for identifying the adductor. So this is the opponent's pollicis. So this is the opponent's pollicis which we can do, or the abduction, right? So the flexion, abduction and the opponents, all these are by your thenar muscle. So this is the pen test which is testing the thenar muscle. So the thenar muscles have been testing like this, okay? And then the branch of the median nerve. So there is a branch of the median nerve which is called as the anterior interosseous nerve. So this is called the OK sign. This is called the OK sign. The perfect oval shape is called the OK sign or the Kilonovin sign. So the Kilonovin sign or the OK sign is specific for your anterior interosseous nerve, right? So that is about the test of the median nerve. And coming to the ulnar nerve, this is the claw hand deformity. So partial claw hand is a deformity which is seen in case of your ulnar nerve. So whenever there is a claw hand deformity, you see there is a damage to the ulnar nerve. And how do I identify it? It is identified by the cart test. So cart test is mainly for your the palmar interossea. So what does the palmar interossea do? They do adduction like this. So this is called the palmar interosseous. So pad muscles are tested. And how are the dab muscles are tested? That is dorsal interosseous with the abduction. That is called as the 𝐒𝐿. It is called as the 𝐒𝐿 test. So there is an 𝐒𝐿 test, there is a card test for your ulnar nerve, and then you have your book test. So what is this book test for? Book test is mainly for your adductor pollicis. So test your adductor pollicis. So whenever there is a weakness of the ulnar nerve, you will see the flexion of the thumb. So this flexion of the thumb is called as what? This is called as the Fromen's sign. So this is called as the Fromen's sign. Is that clear? So book test is for the ulnar nerve, where you test the adductor pollicis, the flexion of the thumb. This is called as the Fromen's sign. And what is this? This is called the knuckle bender splint. So this is the knuckle bender splint which we use for the ulnar nerve, right? Clear, guys? And coming to the radial nerve, we already know that there are two important things which you have to remember: the Saturday night palsy, and then we have your Holstein-Lewis fracture. The Saturday night palsy and the Holstein-Lewis fracture I have discussed, that will result in the wrist drop. This will result in the wrist drop, right? So there's a radial nerve neuropraxia which is resulting in the wrist drop, and this is called the cock-up splint. So this is called the cock-up splint. There are two types of cock-up splint which you have to remember. The first one is the static cock-up splint, whereas there is no movement, just a support. And then we have the dynamic cock-up splint, where there is a movement with the help of springs. So you can extend the fingers, you can extend the wrist, and then you can flex like this and extend. So that is the dynamicity of that particular splint, which is called the dynamic splint, right? And the other one is just for the support, which is called as the static splint or the cock-up splint. And this is very important, the CPN, the common peroneal nerve. So whenever there is a fracture of the tibia, fracture of the fibula, or the fibular neck is fractured, fracture of the fibular neck, the CPN is surrounding the neck. It is like the surrounding the neck, around the neck of the fibula. So whenever there is a fibular neck fracture or fracture to the knee, so this will result in damage to the common peroneal nerve. So this common peroneal nerve will result in the high stepping gait. So the gait which we see here is the high stepping gait. Why we see the high stepping gait? Because there is a damage to the dorsiflexors and the everters. Okay, dorsiflexors and the everters are damaged, hence it will result in the high stepping gait whenever there is a damage to your CPN, the common peroneal nerve. And the splint which is used is the foot drop splint. Yes, it is the foot drop splint, and this is called what? Whenever there is a damage, it is called the foot drop which is happening, and this is the high stepping gait. Yes, everybody? And this already we have dealt. This is the regimental badge area, where this is in which damage. Which nerve is involved in the regimental badge area? Yes, it is the axillary nerve. This is the axillary nerve, right? This is the regimental badge area. And now this is your brachial plexus, which is called as the Erb's palsy. This is called the Erb's palsy, where there is damage to the Erb's point. So there is damage to the Erb's point, and there are certain nerves which get damaged in the Erb's point, mainly the musculocutaneous nerve, right? So this will result in, yes, it will be available. Yeah, it is there in the YouTube always. Okay, so this is the musculocutaneous nerve which is getting damage on your supraspinatus. So there is a loss of abduction and there is a loss of internal rotation. So now what happening? It is adducting and externally rotating like this, and then musculocutaneous nerve is involved. Hence, it is resulting in extension, right? It is resulting in pronation and extension. So that is the Erb's palsy or policeman tip deformity. So policeman tip deformity. Okay, so that is it. So what is the deformities we see? So the limb is adduction, internally rotated, and elbow in extension and pronation. right? So these are the deformities we see in the Erb's palsy. And what is the splint which we use? This is called the aeroplane splint. Aeroplane splint is mainly for the brachial plexus injury. So whenever there is a brachial plexus injury, we use this particular splint. So now you can see the splint. If you see exactly opposite the splint, you can see there is an abduction, right? So there is an abduction of the hand. So it was an adduction, right? So it was an abduction, and external rotation you can see, and flexion of the elbow with the supination, right? So this is supination. Okay, guys. So that's it about the nerves which are involved. And now what you have to remember is there are certain syndromes where this nerves gets trapped. That is, the carpal tunnel is mainly for the median nerve. So this you have to remember. So whenever there is a median nerve involvement, that is called the carpal tunnel. And one important test which you have to remember is your Durkan's test. So Durkan's test is the one which you have to remember, that is for the carpal tunnel syndrome. And then you have this Phelan's test and the Tinel's sign. So these are all for your carpal tunnel where the median nerve gets compressed. So the median nerve gets compressed in case of carpal tunnel, right? And then your Guyan's canal, it is your ulnar nerve. So Guyan's canal is mainly for the ulnar nerve. And piriformis syndrome is by your sciatic nerve. So sciatic nerve is going beyond at back. So the piriformis is the one, is the piriformis is nothing but your, what is it? It is a muscle, right? It divides. So this is the piriformis. Whenever it gets compressed, there is a sciatic nerve also gets compressed. That is called as piriformis syndrome. So pronata syndrome is median nerve. So median nerve travels between two heads of the pronata teres. Hence, when it gets compressed, it results in the pronata syndrome. And cubital tunnel is your ulnar nerve. If you go back and read your anatomy, the course of the ulnar nerve, it passes through the cubital tunnel here at the elbow level. So this cubital tunnel syndrome is ulnar nerve. Then tarsal tunnel, you all know the posterior tibial nerve, right? The posterior tibial nerve. And then meralgia parasthetica is your lateral cutaneous nerve of thigh. So this is the lateral cutaneous nerve of thigh. And then your chiralgia parasthetica is your superficial radial nerve. Superficial radial nerve. So meralgia is lateral cutaneous nerve of thigh and chiralgia is a superficial radial nerve. Okay. And some splints which you have to identify. This is the hard collar. I have discussed this again. This is the hard collar which we used for C-spine. And then we have discussed this about the Thomas splint, right? This is the Thomas splint. And then we have told that is used for immobilization. So this Thomas splint is used for the immobilization, right? And then we have this Bowler's-Brown splint, which is the BB splint. This was asked in the recent exam of FMGE. So this is the Bowler-Brown splint, and it is again used for your skeletal tractions. And this is your, what is this? This is a traction, right? So this is a traction. What is this traction called? Yes, anybody? What is this traction called? So BB splint, what we use, this is the limb which we put here, and then we have the pulleys. So this skeletal traction we give, and this pulley we put the weight here. So this is the weight we put here. Okay. So that is your, yes, it will be on YouTube. Don't worry. This will be on YouTube. So this is the weight which we put here. So this gives the traction and counter traction. So this is mainly for the BB splint where we use for the skeletal traction. So this was asked in the exam. So again, they might ask you. So what are the things used for skeletal traction was the question. So we use the pin, which is pins, that is your Denham's pin or your Steeman's pin. So these are the two pins which we use, and then we use this stirrup, and then we use this BB splint. So this is the setup which we use for skeletal traction. Yes, what is this under traction? Yeah, this is the gallows traction. So this is the gallows traction. This is mainly used for kids less than 2 years. So less than 2 years with the femoral shaft fractures. With the femoral shaft fractures, right? So it is put on the two limbs. This is put on the two limbs. So you use the two limbs for the traction. And remember that buttocks has to be raised from the couch. So that is the criteria. So the buttocks has to be raised. So that will provide the traction and the counter traction in case of your gallows traction. Okay. And what are all these? These are various splints which we usually use. So the first one is your Milwaukee brace. So this is the Milwaukee brace which we use. And the second one is the Boston's brace. Second one is the Boston's brace. So these two are the braces which is used for your scoliosis. This is used for your scoliosis. And then what is most important is your Taylor's brace. So this is your Taylor's brace which is very, very important. And this is mainly used for your tuberculosis or the fractures, the thoracic or the thoracolumbar fractures, osteoporotic fractures, right? At the dorsolumbar junction. So this is your Taylor's brace. The first one is the Milwaukee. The second one is the Boston brace. Boston's brace and Taylor's brace. And you should also remember, Nishu, that this whole data of my brain was not from one day. You know, this is all accumulation. Yes, very good. The Taylor's brace is the thoracic or the osteoporotic at the DL junction. And this is the 4-post collar, as you see. Right, so there are 4 posts like that, and this is the 4-post collars. Okay, right, and this is Somai brace. So this is the Somai brace. This is Ash brace, anterior spinal hyperextension. This is the Ash brace. Okay, sorry, I have wrote it wrong. Okay, this is the Ash one and this is your Somai. This is the Somai. So this is occiput and the mandible. So this, you see, this is occiput at the back and this is mandible in the front. So this is Somai, right? And this is one Ash. This is anterior spinal extension in the anterior part. Okay. Yes. And now some soft tissue disorders. So what is the first one? So the first one is, this is your tennis elbow. So this is your tennis elbow. So what is the test they are doing? The test which they are doing is the Cosen's test. So the test which we are doing is the Cosen's test, right? So the tennis elbow and the Cosen's test, the tendon which is involved is in extensor carpi radialis brevis. So ECRB is the tendon which is used here. And then we have the second one. This is called as the de-Quervain's. This is called the de-Quervain's test. So this is the de-Quervain's test, and mainly for your APL EPB. So these are important tendons: extensor abductor pollicis longus and extensor pollicis brevis. So APL EPB, the first compartment tendons which are used, and this is called as the de-Quervain's tenosynovitis. So what is the test which we use here? Finkelstein test. So this is called the Finkelstein's test, right? So Finkelstein's test is the de-Quervain's tenosynovitis. I'm sorry, I'm actually little nervous because we have crossed 5. I think Sanchit Sir would be waiting for his session. I'll just complete it in more 10 minutes. Okay, so this is de-Quervain's tenosynovitis. Okay. So the first compartment tendons are used, that is Finkelstein test. Very good, Nishu. It is APL and EPB, right? And what is this? This is Dupuytren's contracture. This is Dupuytren's contracture. So what do you mean by Dupuytren's contracture? So there is a fibrous tissue which is getting condensed, and now you can see there is a pull on the third finger like this. So this is the pull which we see. There is a cord-like structure which is formed. The palmar fascia gets condensed and there is a cord-like tissue which is formed, which is called as the Dupuytren's contracture. So you can treat it with the steroids. Okay, you can treat it with the steroid injection into the fibrous cord. Yes, it is a fibrous tissue content, usually seen in patients with alcoholics and liver diseases. Okay, and then, so what is this again? This is the trigger finger. So this is the trigger finger. So trigger finger is the tendon which slips, right? Tendon slips through the tendon sheath. Now this sheath is forming into this sheath has become condensed, or there is a trap in this sheath, so that the tendon is not moving freely. Hence there is a sound whenever there is a movement of the tendon, which is called as a trigger finger. This is called a trigger finger, and the pulley which is usually at disturbance is the A1 pulley. So you remember the A1 pulley, and here this is what? This is ulnar collateral ligament injury. It is the gamekeeper's thumb, right? Whenever you talk about the gamekeeper's thumb, the ulnar collateral ligament is damaged, and adductor pollicis, when comes in between that ligament, this is called as Steiner's lesion. So this is called as Steiner's lesion. So this is the adductor pollicis which is coming in between the healing of that particular ligament. So that is called as the Steiner's lesion. So that is called Steiner's lesion, and gamekeeper's thumb is all because of your ulnar collateral ligament. And I have told you all about this, the carpal tunnel syndrome, and these are the tests. So carpal tunnel syndrome, and these are all the tests for it. So we have already discussed the Phelan sign, the canal compression. This is nothing but your Durkan's test, right? And you can also do whatever you're doing. What you're doing is the flexion of the wrist. So the symptoms evaluate. So the symptoms will increase on flexion of the wrist. So that is the test which we use for carpal tunnel syndrome. And we have two important fingers. One is the mallet finger. Mallet finger is whenever there is a rupture of the extensors. Extensors are ruptured. So this finger becomes like this. This is the mallet finger. So the extension cannot be done. So it remains in flexion. Whereas jersey finger, there is a loss of flexors. So it stays like this. So it cannot flex, but you will not find any deformity. So this is called the jersey's finger, and this is the mallet finger. Mallet finger, remember, there is a loss of extensor tendons. Extensors are lost, right? So hence it goes into flexion, which sees as mallet. Okay, these are flexors lost in case of jersey. Jersey is hold of your this like this jersey, and this is pulling of that. So this is called the jersey finger. It is not the nerves, it is the tendons which are connected. That is the idea of the lumbricals. If you go back and read the hand anatomy, the lumbricals and the flexors, so you will understand why this is going like this. Okay, only this index finger is completely free, right? But all these are connected because of the flexor digitorum profundus. Okay, flexor digitorum profundus give rise to your lumbricals also. So that is the connection between these three. Okay. So that is why in case of your median nerve palsy, we will get this pointing index, because all the three are interconnected, right? And this is very independent. So this will not flex. All other three are flexed. Okay, now I have to tell about the one more test. So I have told about the Cosen's test here. So this is the Cosen's. Sorry, in the tennis elbow I have told about the Cosen's test. So here I have to tell about the Thompson's test. So Thompson's is for the Achilles tendon. So Thompson's is for the Achilles tendon integrity. If the Achilles tendon tear is there, the Thompson test is positive. That means you will squeeze the muscles, that is gastrocnemius and soleus of the leg, and then you will result in the what happens? The plantar flexion happens. So this is called as the Thomas test, right? So there is a plantar flexion which is happening in the tendo Achilles. So if the Achilles is not intact, there is no plantar flexion, right? So this is called as the Thompson's test. This is called as the Thompson's test. And then coming to the metabolic disorders, we have two important metabolic disorders. So one is called the osteoarthritis, and the second one is called your rheumatoid arthritis. I'm sorry. So this is your rheumatoid arthritis. Okay, actually this is joint disorders, not metabolic. Okay, two important things I want to tell you is osteoarthritis and rheumatoid arthritis. So osteoarthritis is a disease of degeneration, right? It is a disease of degeneration. So what happens in the disease of degeneration? So there is a wear and tear mechanism which is happening. So there is a wear and tear mechanism. In rheumatoid, it is inflammation, right? It is the inflammation which is happening. So there is damage levels are high. Damage levels are very, very high. And in osteoarthritis, it is the medial compartment which is involved. And in rheumatoid arthritis, it is medial and the lateral. So it is bilateral. And it is symmetrical. Right? So this is the basic difference which you have to understand. Right? Yeah, it is a basic difference. And here the involvement are the main important are the MCP and the PIP, right? MCP, PIP, wrist are the ones which are mainly involved. And here if you remember, the PIP and the DIP are involved, and then the important knee is involved. So wrist is usually not involved, right? So PIP, DIP, knee and MCP is not involved here. But on the rheumatoid, on the other hand, you see MCP and the wrist are involved, right? And PIP, DIP, you know that there are PIP is for the so there are two important nodes. So HD, Herbedens node is HD. So high definition, HD is high definition, and PB, that is BP. Bouchards, BP Bouchards is for your PIP. So these nodes are usually seen at these joints, that is PIP and DIP joints. Bouchards and the Herbedens nodes are seen in osteoarthritis. Whereas in the rheumatoid arthritis, you see two important deformities. So one is your Bouchards deformity, the second one is a swan neck deformity. Swan neck deformity is, again, if you remember, swan neck is like this. So it is like flexion at the DIP. So whenever you remember FD, so FD is fixed deposit. So flexion at the DIP is your, and similarly extension at the PIP. Just remember this, and the opposite is for your Bouchards. So swan neck deformity, this is the picture, right? So this picture FT, you remember, that is fixed deposit, flexion at the DIP and extension at the PIP. Similarly opposite for the Bouchards deformity. And there are other deformities which you see. There is a ulnar deviation, complete ulnar deviation of all the MCP joints, and then you have the Z deformity of the thumb, and there are various stages which they occur, and these are deformities are very much seen in case of your rheumatoid arthritis because the damage is very high. So you will see very much of destruction in case of rheumatoid arthritis, right? So that is about the rheumatoid arthritis. And then you have your ankylosing spondylitis. So there is an ankylosing spondylitis. So in case of ankylosing spondylitis, what we see is, so you see one important, that is the dagger sign. So one thing you see is the dagger sign, right? So and then what is mainly ankylosing spondylitis is involvement of your axial skeleton, not the appendicular skeleton. So axial skeleton is involved, and especially the SI joints, the sacroiliac joints are involved, and then your spine is involved. So there is a calcification of the tendons which is called as enthesitis. Enthesitis is nothing but inflammation of the tendons, that is enthesitis, and these tendons get attached to the, these tendons get attached to the bone. So there is a dagger sign I have told you. So this is the dagger sign of PLL. So the complete ossification of the posterior longitudinal ligament is called the dagger sign. And then what is this? This is the Schauber's test. This is the Schauber's test. So what is Schauber's test? So you will measure, there is loss of lumbar flexion. So there is loss of lumbar flexion, and whenever you measure, you will see that there is a decrease in the lumbar flexion. So this is called as the Schauber's test. And what is the one more thing which we see? Which we see is the bamboo spine. So bamboo spine is also ankylosing spondylitis. It is HLA-B27 positive and usually seen in males, right? And other systems are also involved, such as your eyes, where you see uveitis, and then pulmonary complications are also noted. So there is pulmonary involvement, and then there is uveitis which we see, and you can also have cardiac symptoms as well. cardiac symptoms as well in case of your ankylosing spondylitis. And what is this? This is DIP involvement. Whenever there is involvement of DIP with the nails, with the involvement of the skin, as per the Casper's criteria, what do you want to tell about this? So there is involvement of DIP joints, involvement of nails and skin lesions, and then as per the Casper's criteria, this is nothing but your psoriasis. This is nothing but your psoriasis, right? This is nothing but your psoriasis. And then complete sclerosis, increased level of sclerosis is seen in fluorosis because there is a calcium fluoride which is formed and this cannot be resorbed. Hence, there is increased level of sclerosis in the body, which is usually seen as yellow teeth, and the spine is completely calcified like this, right? So this is called as fluorosis, and which is very high in Nalgonda, and you know the technique, the Nalgonda technique. Lime is used for fluorosis, which is a very important question from biochemistry, right? And then we have these two important components, that is rickets and scurvy. So these are self-explanatory. So rickets is nothing but there is decrease in calcium, decrease in phosphorus, because there is an decrease in the vitamin D levels, right? And you can see the cupping, fraying and splaying in case of children. And in case of scurvy, this is all because of vitamin C deficiency. So this vitamin C deficiency is seen, and this is mainly important for collagen cross-linking. So there is a damage in collagen cross-linking. So the collagen is not formed properly. Hence, this will result in this particular scenario where the calcifications are seen. So this calcification around the epiphysis is seen as nothing but your ring epiphysis, right? So the bone is weak, but the calcification is present. Hence, in scurvy, you see white structures around lucency. But in case of rickets, as the calcium itself is low, you see all the lucency. So you see here all the darkness here. So this is all about the rickets. So this will be present as a cup, and this is the splay extensions of it, and then this is the fray. This is the frame, and here what you see, the bone itself is weak here, the epiphysis, the collagen is weak, but the calcification is there. So hence you see this as ring epiphysis, and you'll see the provisional calcification, and then this lucency is nothing but your scobatic zone, and because the periosteum is very weak, that will result in subperiosteal hemorrhage. So this is about the scurvy, and this is about the rickets, right? And then coming to very important sports medicine, where they usually ask about the ACL and the tests which are involved in it. So whenever we talk about ACL, it is mainly the anterior drawers test which is mainly done, right? And anterior drawers test, similarly we have the Latchman's test. So there are two important tests, the anterior drawers test and the Latchman's test. Anterior drawers test is complete flexion of knee up to 90 degrees. In Latchman's, it is up to 15 degrees. It is up to 15 degrees in case of your Latchman's, and in acute conditions usually we go for Latchman's test, right? And then the investigation of choice is MRI for ACL, but almost the gold standard is again arthroscopy. And under anesthesia, we have the pivot shift test to confirm. So the most sensitive, or this is the most specific test. This is the most specific test is your pivot shift, and this is the most sensitive test. So this is the sensitive test is your Latchman's test, right? So this is sensitive and this is specific. And MRI and absence of ACL. So this is the ACL which we see in the MRI, and whenever there is an absence of this ACL, you confirm this as a ACL tear, right? And then this is the PCL. PCL, you see, it is like a structure like this. So this is something like this. PCL is something like this. It is cord-like structure, right? So this PCL is again the absence of the PCL you see as the PCL tear. And again the test for PCL is posterior drawers test. So this is ACL and this is PCL. So this is the anterior drawers test, ADT. This is the posterior drawers test, similarly pushing back. Okay, and then what is this? This rotations is mainly for the meniscus. So whenever they talk about the rotations, this is meniscus. So meniscus, we have again two type of tests. One is your Apley's grinding test, where we put the patient in the prone position, right? Prone position, we do the test, right? And then we have your Pacelli's test, and then we have your McMurray's test. So McMurray's is all about rotations. Then we have Thessaly, the standing test. So Thessaly is standing test, and this is the prone position, right? And then we have, this is Apley's. So what I was talking about, this is your Apley's, and this is your McMurray's. And finally, we have our collateral ligaments. We have MCL and LCL, where we do the stress test. So we are doing the stress test for MCL and LCL. So what we do, we open the joints. So for the collaterals, what we do, we open the joints. So there are two collaterals. One is the MCL and one is the LCL. So now we are putting the patient and subjecting it to varus and valgus stress, so that whenever you do this valgus like this moving, so MCL gets opened up. So this is the valgus stress for your MCL and varus stress test for your LCL, right? So these are the collaterals. So the collaterals are examined by the varus and valgus stress test, meniscus by the McMurray's test, Thessaly, Apley's grinding, and then your ICL by anterior draws test, Latchman's and the pivot shift, and PCL is by your posterior draws test, right? And coming to the rotator cuff. Coming to the rotator cuff, we have one. This is supraspinatus, mainly for your abduction, right? The supraspinatus is mainly for your abduction, and this is called as the MT can test. So this is called as your MT can test, fine. And then we have lift off test. So this is your lift off test or the Gerber's test. Yes, this is for what? This is for your subscapularis, right? So there are two. This is the lift off test, Gerber's test, and the belly press test. So the three things which you have to remember, one is the belly press, lift off, or the Gerber's test is the same. This is for your subscapularis. This is for your subscapularis. Yes, very good. And the third one, I want to tell you, this was asked in the INICET exam, PYQ, that is the presence of the meniscus. So whenever the meniscus is present, this is the blood supply for the meniscus, and you see this is the red zone and this is the white zone, because the blood supply is from outside to inside. So the outside area is rich in blood supply, which is called as the red zone, and this inside part of the meniscus is called the white zone, which is poor in blood supply. So whenever there is a tear in this RR zone or red zone, we go for meniscal repair. We go for meniscal repair. But whenever there is a tear in this white zone, we go for removal of that meniscus, which is called as meniscectomy. Yes, sure, understood. So meniscus, there is a blood supply which been asked. So the blood supply is from outside to inside. The outside blood supply is rich, which is called as the RR zone. The inside is white, which is less, that is WW zone, white zone. So whenever there is a tear in this thing, it is called as meniscal repair we do in the RR zone, and in the W zone, that is white zone, we remove. It is called meniscectomy, but both are done through arthroscopy only. Right, both are done through arthroscopy only. And coming to the pediatric orthopedics, so this is the first one is called the torus fracture. So there is a bend, if you see in the cortex, that is torus. The second one is called the green stick fracture. You can see there is a break in the cortex and bend in the other cortex. So why that is happening? Because there is an increased water content. So there is an increased water content in the pediatric bone. So whenever there is high water content, that means you can't break it as such. So whenever the sticks are wet, you can't break it, right? So whenever the sticks are dry, you can break it correctly. So this bending and breaking in one and one cortex is called a green stick fracture because of high water content. Just a bend in the cortex is called as torus fracture. And then we have a classification which is called as the Salter-Harris classification for the physis. So what is a physis? A physis is a growth plate. So physis is a growth plate, and this growth plate, whenever is damaged, will result in the disturbances in the growth. Hence we have come up with the classification. Salter is type 1, type 2, type 3, type 4 and type 5. So whenever it is type 1, it is a straight where it goes through the zone of hypertrophy. So if you go back to your growth plate, you will have zones in the growth plate which is called a zone of hypertrophy. So the fracture occurs in that particular area which is called a zone of hypertrophy. It is called a straight. And whenever we go above the physis is involving the metaphysis. It is type 2. And whenever you're going to lower the physis, I mean below the physis, it is the epiphysis which is involved. And type 4 is through. That means all the three are involved. And type 4 is a crush type of injury where there is a complete damage to the physis. Right? Through is all three. That is meta, epi and the physis as well. So this is the Salter-Harris type of classification. And you have to remember that the supracondylar fracture humerus is type 2. Which is involving the metaphysis, and your SCIFI is type 1, right? And type 4 is your Tilloch's fracture in the ankle, which we see. And type 3 epiphysis you can remember as the lateral condylar fracture humerus, or sometimes it is type 4 lateral condylar humerus fracture, right? Which involves the epiphysis. Okay. And then what is this? Yes, this is your nursemaid's elbow, where there is damage to the radial head dislocation. So there is a radial head which pops up from the annular ligament. So there is an annular ligament and this radial head pops up from that because of this daddy who is playing with the son and pulling the limbs. As he's tightly pulling the limbs and the whole weight is on the other side, right? So that is, there is a popping of the radial head outside of the annular ligament which will result in the nursemaid's elbow or the radial head dislocation, and you have to treat it immediately with the supination and flexion. So you supinate, you flex and supinate, and then it is reduced, right? So this is called nursemaid's elbow. Okay. Yes, and then we have our very own CTEV, which is again very important, and this is the treatment starts as early as first week, and then the treatment is CTEV, right? Congenital talipes equinovarus. So the deformities are CAVE, right? So that is cavus, adduction, varus and equinus. So this is what the deformity which we see in case of CTEV, and this CTEV is treated by Ponseti technique. So this is treated by the Ponseti technique with serial casing. So you treat with the serial casing, right? And then you treat, after treatment is done, you give them DB splint, that is Dennis Brown splint for maintenance. Once they start walking, then you go for your CTEV shoes. So these are the CTEV shoes, and you can see there are two important things, the outer raise and the no heel. So there is no heel which is there, and the outer raise is, and the straight inner border. So this is mainly to compensate for the deformities, as we have corrected the adduction, the varus deformity and the equinus deformity. So we will not put any heel. So these should be straight and the outer should be raised, and then there is a straight inner border. So this is all the CTEV shoes, and this is the DDH. So DDH, we have two important, Atterlany and Barlow's. These are two important tests. I think you know this very well. And this is the Pavlik harness. So this is the Pavlik harness, which is the splint which we use for DDH for the treatment of less than 6 months of age. If the patient is less than 6 months of the age, you have to use this Pavlik harness, especially putting the limbs in the abduction, right? And then we have two important, again, the Perthes and your SCIFI. So coming to the Perthes, it is usually the painless limb which they usually ask, and it is usually seen in 4 to 8 years of age. So painless limb with 4 to 8 years of age, there is necrosis of the femoral head. So there is necrosis of the femoral head. Yes. And the treatment is containment surgery. So the treatment is containment surgery. And then we have SCIFI, that is slipped capital femoral epiphysis, and here you see there is a slip in the epiphysis, right? And usually we see this in the obese patients, especially the males, and they are associated with certain endocrinopathies, that is diabetes, So some diabetes, some hypogonadism, so all this they are associated with, and they come with the pain in the knee usually, and in both of them there is abduction and internal rotation which is limited in both SCIFI and your Perthes disease, right? So there is abduction and internal rotation which is restricted here, and SCIFI you go for pinning. This is called pinning which we do. So we correct the slip and we fix it with the KYS, which is called as pinning. So there are two important conditions. One is Perthes, the second one is slipped capital femoral epiphysis, right? Yes, and I have told you about the avascular necrosis of the femoral head. There are certain other avascular necrosis. One is Kienbock's, that is lunate. Remember it as lock and key. Lock is lunate, key is Kienbock's. Okay, Panner's, pan card, capitulum. We use the pan card, right, for the income tax payment. So pan and card, it is pan card. Panner's is capitulum. Then Sever's is calcaneum. Sever's is calcaneum. Press, and Perthes we know it is femoral head. So femoral head is Perthes, right? And then Iceland's is fifth metacarpal base. Fifth metatarsal base. Okay, and this is second metacarpal heads. So this is mainly the metatarsal heads. Freeberg's is head, Iceland's is base. Okay, and Kohler's, remember Virat Kohli, that is navicular. So you can see navicular Virat Kohli. Okay, navicular is Kohler's, and Johnson's larynx is patella. So whenever there is avascular necrosis of patella, lower end of patella is Johnson's and Larson's syndrome. Okay, so these are certain avians which you have to remember. Scaphoid is Preecier's disease. Okay, like that. And two important image based questions. So this all, I think this is the triad which you all know. What is this triad? So this is the Springel's deformity. And this is your favorite Klippel-Feil syndrome. So this is Klippel-Feil syndrome. This is Springel's deformity. Self-explanatory. You can see the scalpel, the scapula at the higher level. So there is a scapula at the higher level. Why the scapula is at higher level? Because there is a failure of descent of scapula. So there is a failure of descent of scapula, hence it is at a higher level. So you will find that there is some problem in the shoulder as well. The movements of the shoulders are disturbed. That's it, nothing more. But it's Klippel-Feil syndrome. There is a loss or there is no fragmentation of the vertebra. So loss of fragmentation of the vertebra, that is cervical vertebra, will result in fusion. So you will have all these three. So there is a low hairline, there is a short neck because of the fused cervical vertebrae, and there is a loss of or decrease in the movements, right? So this is the triad of the Klippel-Feil syndrome. That's it, which you have to remember about these two pictures. And then coming to the infections, very important. One is the chronic infections, that is chronic osteomyelitis. So what they usually ask is about the sequestrum. It is nothing but the dead bone, right? And the treatment, that is saucerization, right? And then this is the tumor mimic. So this is tumor mimic, but this is localized infected, which is called as the Brody's abscess. So you have to be careful about the explanation in the exam. So they will give you a history of so and so patient, and now this is the Brody's abscess, which is usually seen in the tibia, well localized. You will see there is no periosteal reactions as such. So it's well localized because there is a increase in the immunity of the host, or the virulence is low. So whenever a low virulent organisms giving in a high immune patient, so the infection gets localized, will present as this Brody's abscess. And coming to the tuberculosis, which is very important, there are always 4 stages which you have to remember in the TB, right? The first stage is stage of synovitis, right? The second is stage of early arthritis. The third one, late arthritis, and the fourth one is the advanced arthritis, right? So these are the 4 stages which are present for the TB hip. And what you have to remember is in synovitis, there is increase in this space. So the limb grows into abduction and external rotation, whereas in all these it is flexion, adduction and internal rotation, right? And whenever it comes to advanced arthritis, there is joint destruction which is occurring, and this joint destruction can be present as two motor or pestle appearance, and then you have your wandering acetabulum. So because the head becomes very small and the acetabulum is big, so it gets wandered, or it can be present as the motor and the pestle appearance. So these two are important image based questions. So one is the motor and pestle, this is the motor and pestle, and this is their wandering acetabulum, empty acetabulum. So these two are image based questions usually asked in the TB. So in the tuberculosis, you see there is a lot of destruction again here, but remember the roof of the acetabulum, the TB starts. So what is the one point where the TB can occur in the hip joint is the focus is the acetabulum, right? So that is the TB. So these are the 4 stages, and when it comes to TB knee, again there are 4 stages, but it will result in a complex deformity which is called as triple deformity of the knee. So this triple deformity is there is a posterior flexion which is happening there, and there is an external rotation and the adduction, and all this triple deformity can be seen in all this condition which are being kept in the triple, that is tuberculosis, rheumatoid arthritis, iliotibial band contracture, polio and hemophilia. So these are the 5 conditions where you see triple deformity of the knee, right? Yes, then comes the most important, the metabolic disorders. So here what we see, the first one is osteomalacia. So how did I identify this as osteomalacia? This is nothing but there is a rickets in adults is osteomalacia, right? So you will see what is called as the Looser's zone. So there is a Looser's zones which we see, and this is called as the protrusio acetabuli. So this is called as the protrusio acetabuli, right? So you can see that the acetabulum here is, the femoral head is pointing far from the acetabulum, pointing inside from the acetabulum, and these fractures, the small fractures are called the Looser's zone, and these two are seen in the osteomalacia where there is a decrease in the vitamin D levels in case of adults, right? And which we usually identify in the biopsy also, right? Tetracycline method, okay? And then what is this? This is hyperparathyroidism. Though there is an increase in the PTH, so this is called hyperparathyroidism. So there will be resorption here, especially in the phalanges, So this is weakness which we see, and sometimes this we seen as the Brown's tumor. So this is Brown's tumor which we see, and this is also called as osteitis fibrous cystica. Osteitis fibrous cystica, right? So this is the Brown's tumors and hyper increase in the parathyroid level. So hyperparathyroidism will see in resorption of the phalanges, and you will see one more tumor like condition which is called as the Brown's tumor. All these the liquefaction happens and this gets aggregates into tumor like condition which is called as osteitis fibrous cystica. So there is an increase in the parath hormone, that is PTH, which will increase in the calcium resorption, but there will be decrease in the phosphorus. This you have to remember, right? And sometimes you can see that there is this picture frame vertebrae. Where do you find this picture frame vertebrae, or the ivory vertebrae, or the rugged jersey spine? So everything in the metabolic is imaged based. So I've come up with so many images, just go through the images. So picture frame vertebra is nothing but your Paget's disease. So what happens in the Paget's disease? So the osteoclast cannot resorpt. So there is an increase of ALP only. So there is an increase of ALP, which is very, very important. And then they will give you certain buzzwords. What you say is like there is an increase in the hat size. So there is an increase in the hat size, or head size has increased, and patient is presenting with the deafness. So all these are for the Paget's disease. So picture frame vertebrae and your ivory vertebrae, your rugged jersey spine is for Paget's disease, right? So the osteoclast deficiency, and you can see this is a codfish vertebrae or the fish mouth vertebrae. And what is this? This is nothing but your favorite favorite, osteoporosis. Very, very important topic. And osteoporosis, what are the important? They will do chemical analysis and everything is normal. Chemical analysis, all are normal. Then they will do DEXA scanning. DEXA scanning is for your bone mineral density, right? So DEXA scan, chemical analysis is done for identifying the osteoporosis, and the treatment is bisphosphonates. The treatment is bisphosphonates, right? Clear? Yes, very good, Javed. This is osteoporosis. So codfish or fish mouth. And now they have asked about FRAX. So FRAX is what? FRAX is fracture risk assessment. So here they give you questionnaire, and this is mainly used for treating your osteoporosis. This has been asked twice in INICET recently. What is FRAX? Fracture risk assessment tool, right? And this is completely, what is this? This is called the marble bone disease, right? Osteopetrosis. This is marble bone disease or osteopetrosis, right? And what is this? This is deformity, multiple fractures. You see, this is osteogenesis imperfecta. So this is osteogenesis imperfecta, where you see deficiency of called A1 and A2 gene, and usually seen in children with multiple fractures, but recently they have asked a question regarding the battered baby syndrome. So what is that battered baby syndrome? You see that there are also multiple fractures present, but accordingly you will have head injuries also. Head injuries also will be present, and they are not associated with any trauma. So they will tell that this has, the patient has been fallen from the bed or something, and the violence will be more in that patient. So that is called the battered baby syndrome, and this is called as osteogenesis imperfecta. This is because collagen deficiency or defective collagen. And here also with the trivial falls, you see that there are fractures present, and on the X-ray you see there is a deformity, and there are multiple stages of healing. So you see there are multiple stages of healing, right? But you have to be very careful while reading the question, because they can confuse you between the battered baby syndrome and osteogenesis imperfecta. Here you will be witnessing blue sclera as well as a triad, and with deafness, and dentigenous imperfecta, that is with the teeth. Right? So that is about the osteogenesis imperfecta. Then few implants to identify. So the first one is the periosteum elevator. This is called the periosteum elevator. So whenever you want to deal with the bone, first you have to strip off the periosteum. The periosteum is slipped, and then you will find the cortex, then you can plate. Then these are all what? Bone spikes. So different types of spikes which are used for treating, right? You have to use these spikes to clear off the area, then you can treat. Then these are osteotomes. So you have a bent osteotome and a straight osteotome, right? And then this is the curettage, right? This is the curettage. And then bone holding forceps. So there is a, this is smooth, right? So this is the bone holding forceps. But if you see, this is the two. One is the straight, one is not so straight. So this is the plate holding forceps. So once you fix the fracture, you fix the plate, and then you use this for the plate holding forceps. So this is very, very important, the bone holding forceps and the plate holding forceps. And then finally we have the levels of amputations, which they usually ask. This is the levels of amputations. So first, at the level of the ankle, we have what is called as the Symes amputation. So Symes amputation, you will have heel which is present, and this heel is clearly used for your prosthesis fixation, right? And then the Chopard's, and then the Lisfranc. So Chopard's is the mid-tarsal. So whenever somebody is amputated at the mid-tarsal level, it is Chopard's. Whereas Lisfranc is tarso-metatarsal. So the junction between tarsals and the metatarsal is your Lisfranc's amputation, right? And then we have two important prostheses. One is called the Satch foot, and the second one is called the Jaipur foot. So what is the difference between Satch and Jaipur? This is solid ankle cushioned, right? Solid ankle cushioned heel, and this is the Jaipur foot, which is prepared by the Jaipur by our own doctor, that is Dr. P.K. Sethi, has been done. So this ankle cushion heel cannot be used on the bare foot, right? So there are certain differences. So this can be used on the barefoot. So patient can walk barefoot, and patient can walk, he can squat, okay, and then he can use it barefoot. He has to use this only with the shoes. So shoes are compulsory, and he can walk an irregular land. He cannot walk on irregular area, only the land smooth areas. He can walk only on the smooth areas, and he will have here wooden heel is used. So the wooden heel, the keel is called the wooden keel block. Here they use the vulcanized rubber. So here what they have used is the vulcanized rubber which they have used. So it is malleable. So you can squat, you can do all the movements there, like plantar flexion, dorsiflexion, inversion, eversion, on all the movements you can do. So here no movements are possible. So that is the Indian modification for the Sach foot. So that is done in the Jaipur, and this is called as the Jaipur foot. Okay. Yes, that is the thing we have completed in a hurry, because this is what it has to be done like this. Initially I was a bit slow explaining. Anatomy class is done already, Sanju. Next we are going for ENT, so the ortho is done. So any doubts, guys? Anything you want me to repeat, or anything you want me to explain? We can do it as well. We have Telegram sessions daily happening on the Telegram channel, so you can pin us there. Javed wants to tell Tata bye bye. Okay, and we have the Instagram channel, so you can ask your doubts there as well. Dr. Alekhya Ortho and or PW MedEd ka Instagram channel. Okay, fine. Thank you so much. Yes, as Javed said, Tata bye bye. Okay, Sanchit Sir, if you're watching, I'm sorry for your time. You can now take up the class. Thank you. Your PDF will be provided, don't worry. Yes, this class will be available. Recorded class will be there on YouTube, Sanju. Yes, nothing to worry. You can watch it anytime at your comfort. So thank you guys for having your time. All the best for your INICET exam. Don't panic. Read the question properly. And usually in INICET, the concepts are tested. So please read the questions and the options properly, so that you will do it really well. Okay, bye. See you all on the recall session. Bye.
Hello everyone, very good evening to all of you, and great to see you all for the INICET, and I hope you guys have been grilled up. I hope you guys have got a good start to the INICET marathon. तो हम लोग कर क्या रहे हैं, हम लोग भाग रहे हैं लेके सब्जेक्ट्स को, एंड दैट इज व्हाट इज ऑल अबाउट द स्लॉगिंग ओवर्स. तो जैसे होता है ना, जैसे एक टेस्ट मैच और T20 में क्या फर्क होता है कि T20 में क्या होता है, टिल 15 ओवर्स यू प्ले प्रॉपर्ली एंड देन इन द लास्ट 5 ओवर्स यू स्लॉग. So in these days, in the last days, just a week away from the exam, these are your slogging days. These are your hustling days. इसमें आप जितना cover कर सकते हो about whatever you want to revise, that is going to be very beneficial in your exams. And trust me, जो भी आप last minute में देखते हो, maximum things actually click. That's what the rule is. Yes. Good evening, all of you. और इसी के साथ, with the same energy, with the same josh, I don't want you all to dim down. I don't want you all to be, half asleep. That's why the whole of ENT we are going to take up a little more diagrammatic, a little more in the form of कि आप ज्यादा चीजें देखें और फिर ज्यादा चीजें समझें. So we are going to keep it very simple and straight. जैसे हम हर मैराथन में मिलते हैं, हर मैराथन में एक ही बात करते हैं कि we are going to go around not only the chapter, but हम चैप्टर के अराउंड अबाउट जो भी क्वेश्चन फ्रेम हो सकते हैं वो हम सारी देखेंगे. एंड ट्रस्ट मी, आई एम गोइंग टू कवर ईच एंड एवरी सेगमेंट राइट फ्रॉम ईयर, फिर जाएंगे नोज में, फिर जाएंगे लैरिंक्स में, फिर जाएंगे फेरिंक्स में, और इसके साथ पूरी चीज खत्म करेंगे सो दैट यू डोंट नीड टू पिक अप ENT एनी टाइम एनीवेयर मोर देन दिस. चलो, सो लेट्स बिगिन. शुभारंभ करते हैं अबाउट व्हाट इज द होल इंपॉर्टेंट थिंग व्हाट यू नीड टू फॉर योर INICET एग्जाम्स. चलो, सो इन ENT first of all, we are going to focus upon what is the most important topic. तो अगर सब में से सबसे important देखा जाए, maximum questions are asked every year from otology and then comes laryngology. तो ये दो segments INICET के लिए बहुत important है. तो सबसे पहले आते हैं ear related things पे, right? What exactly are the questions asked in ear? Okay. Now, before going into anything, let me first come into what exactly are the embryology of the ear or embryology of ear से क्या आता है. तो what is this? सबसे पहले we need to discuss about what is the development of pinna. पिन्ना के डेवलपमेंट के लिए you need to remember the rule of 6. Rule of 6 का मतलब that the pinna develops at 6 weeks of gestation from 6 tubercles which we call as 6 hillock of His. तो पिन्ना develops from the first and the second pharyngeal arch और उसमें बनते हैं 6 swelling. These 6 swellings are called as 6 hillock of His या फिर इसे हम कहते हैं 6 tubercles of His and these are the ones which will form the whole pinna. Now the first tubercle या first hillock will form our tragus cartilage or simply called as tragus. So ये सामने का projection will be formed from the first hillock या first tubercle. The rest of the pinna, second to sixth hillock, will form the rest of the pinna. तो अगर हम देखें, the first hillock of His is going to form the tragus, and the rest of the tubercles are actually going to form the rest of the pinna. If there is a failure of fusion between the first and the second arch, or the first and the second tubercle, that particular thing will produce a deformity which is called as preauricular sinus. So preauricular sinus is a congenital anomaly that is present due to the malfusion between the first and the second arch tubercle. First or second arch fuse nahi kiya, there will be a small opening in front of your ear. Which syndrome is associated very commonly with the formation of preauricular sinus? Branchio-otorenal syndrome. Branchio-otorenal syndrome is the most common syndrome which is associated with three things. It is related with branchial cleft anomalies, जिसमें बहुत बड़ी-बड़ी swellings होती हैं, right? Second is oto, means there is going to be preauricular sinus. Renal means that there will be agenesis or hypoplasia of kidneys. So this is the most common syndrome or disorder where you see preauricular sinus in children. ठीक, चलो. Now let's move on. After the pinna, let's move on to the most important thing that they ask every year. That is from what is the embryology for external auditory canal as well as eustachian tube and middle ear किससे बनता है. So now for this, I want you all to remember कि हमारी first और second pharyngeal arch are the only ones which contribute to the formation of ear. सिर्फ first and second. Now each pharyngeal arch, मैंने यहाँ पे 1 बनाई, यहाँ पे 2 बनाई. Each pharyngeal arch has got an ectodermal side, a mesodermal side, and an endodermal side. The ectodermal side between the first and the second arch develops something called as a pharyngeal cleft. And the endodermal side of each pharyngeal arch develops something called as a pharyngeal pouch. अब एक important चीज, if this pharyngeal cleft, अगर ये मेरा pharyngeal cleft या first pharyngeal cleft starts to deepen, अगर ये अंदर चला गया, this will form my future external auditory canal. So my question is, from which side is the external auditory canal made from? It is made from the first pharyngeal cleft. What is the first pharyngeal pouch going to make? First pharyngeal pouch क्या करेगा? First pharyngeal pouch is going to form and it is going to expand into a recess. ये देखो, first pharyngeal pouch has expanded into a recess. This recess which is formed by the invagination of the first pharyngeal pouch, इसे हम कहते हैं tubotympanic recess. So first pharyngeal pouch is forming what? It is forming tubotympanic recess. Now, very important questions. ये दो question है, please note करना. You can see that this tubotympanic recess has got one distal end and one proximal end. Proximal मतलब जहां से start कर रही है. The distal expanded portion of the tubotympanic recess, which is formed from the first pharyngeal pouch, this is going to form my future tympanic cavity. ये middle ear की cavity बनाएगी. And the proximal, the starting portion of the pharyngeal pouch, the starting portion of the tubotympanic recess is going to form my future eustachian tube. So, जब भी question आए, proximal portion of tubotympanic recess forms what? It is eustachian tube. Distal forms what? Future tympanic cavity. Right? Now, can we see that here, यहाँ पे, इस जगह पे तीनों की तीनों layers मिल रही हैं? There is an outer ectoderm, बीच की is the mesoderm, and अंदर की from the pouch there is endoderm. That means all the three layers of the tympanic membrane, outer epithelial, middle fibrous, and inner mucosal, are contributed from the outer ectoderm side of the pharyngeal cleft, mesoderm side of the pharyngeal arch, and the endoderm side of the tubotympanic recess. ये तीनों मिलके तीन layer of tympanic membrane बनाती हैं. That is outer epithelial, middle fibrous, and inner mucosal layer. ठीक है? Fine. Now, very importantly, ये जो सेंटर की mesodermal layer है, this center में mesodermal layer, this is going to form my future ossicles. This is going to form my future ossicles. अब इसमें क्या इंपॉर्टेंट क्वेश्चन आता है? Malleus and incus किससे बनती है? Malleus and incus forms from first pharyngeal arch mesoderm. तो फर्स्ट pharyngeal arch की mesoderm से दो ossicle निकलती हैं, that is malleus and incus. Stapes suprastructure. What do you understand by stapes suprastructure? मतलब कि if this is your stapes, this is the foot plate of stapes, and this is the neck of stapes, this part, leaving the foot plate behind, the upper part of the stapes is called as suprastructure of stapes. So this part, the suprastructure of stapes is formed from second pharyngeal arch mesoderm, and the remaining foot plate of the stapes is given by otic capsule. तो ये इंपॉर्टेंट चीज है. Foot plate of stapes is going to be the only option जिसमें पूछेंगे which is not formed from this particular arch. So it will be the otic capsule. So the foot plate of stapes is derived from otic capsule. This is about the embryology related questions. ठीक है? अब malleus incus stapes के बीच में दो joint दिख रहे हैं. One joint is between the malleus and incus, one joint is between the stapes and incus. The joint between the malleus and incus is called as 𝐒𝐄𝐝 joint. Joint between the incus and stapes is called as 𝐒𝐒𝐿 joint. 𝐒𝐒𝐿 joint is a type of what joint? It is a type of saddle variety of synovial joint. 𝐒𝐒𝐿 joint is what variety of joint? It is a type of ball and socket variety of synovial joint. दोनों important questions. ठीक है, फाइन. सो दिस फिनिशेस अबाउट इन जनरल कि एम्ब्रियोलॉजिकली कैसे निकलती हैं ऑसिकल्स, एंड एट द सेम टाइम व्हाट आर दीज जॉइंट्स एंड हाउ डू यू गेट दीज जॉइंट्स. ठीक है, चलो आगे बढ़े. वेरी इंपॉर्टेंट क्वेश्चन एंड ऑल्सो अ वेरी इंपॉर्टेंट क्लिनिकल सिनेरियो. व्हाट इज दिस? व्हाट इज दिस डायग्राम? व्हाट इज दिस स्पेस? दिस टाइनी little space is what? This is the favorite for them to ask in middle year. This space that we have marked over here, this is called as Prusac space. This is called as Prusac space. ये छोटी सी space. What are the boundaries of Prusac space? Now we can see over here. ये हमारी pars tensa है, तो ऊपर की portion, this is our pars flaccida, right? This is our malleus. This is the head of the malleus. This is the lateral process of malleus, and this is the handle of malleus, which is attaching to the pars tensa. So what are the boundaries that we can see? We can see anteriorly, this space is bounded by the pars flaccida. So Prusac space anteriorly is bounded by pars flaccida, right? Posteriorly, this space is bounded by the neck of malleus. Posteriorly, Prusac space is bounded by neck of malleus. Superiorly, you can see this important ligament is attaching to the malleus, to the outer attic wall. This ligament of the malleus is called as lateral malleal ligament. इसे कहते हैं lateral malleal ligament. So even if you don't remember any ligament, ये space के ligament को याद रखना है. The superior boundary of the Prusac space is lateral malleal ligament. And what is the inferior limit of Prusac space? अब नीचे देखो, नीचे क्या है? नीचे is this lateral process of malleus. So inferiorly, Prusac space has got lateral process of malleus. What is the clinical importance of this particular space? इसमें क्या है? This particular space is very important for the formation of primary acquired cholesteatoma. One important question. Primary acquired cholesteatoma कौन सी space से निकलता है? The most important space where primary acquired cholesteatoma arises from, that is Prusac space. ये सबसे common site है primary acquired cholesteatoma की. ठीक है, fine. So this is associated to Prusac space question और इसकी boundaries. चलो आगे बढ़ते हैं. अब आता है important pointers that you need to know inside the mastoid because they have started showing mastoid pictures nowadays. तो अगर what is this? This is your mastoid cavity after we have drilled. So if you see this is my mastoid from behind, ये इस तरीके से मेरा mastoid है. If I lie down, you're going to see this लेटा हुआ mastoid. So this is a mastoid when a patient is lying down. Okay. Now what you see over here, you can see this is the tympanic cavity. You can see this is your tympanic cavity through the external auditory canal. So you're seeing through the external auditory canal where you can see the tympanic cavity, right? Now this patient is lying down. That means this is posterior, this is superior, this is inferior, and this is anterior when the patient is lying down. Correct? Very important questions that are related to mastoidectomy. जब भी हम mastoidectomy करते हैं या mastoid में कभी भी ड्रिलिंग करते हैं तो what are the limits of mastoidectomy? Mastoidectomy में क्या क्या critical structures आते हैं that we need to see and identify. तो अगर mastoid में posteriorly कुछ भी blue दिखता है, what is this structure here? This is your sigmoid sinus. In mastoidectomy, the most posterior thing which can accidentally get injured is your sigmoid sinus. Okay, fine. What is this superior end? अब सोचो mastoid के superior क्या है? Superior is a plate which demarcates it with the dura of the middle cranial fossa. इसके ऊपर middle cranial fossa है. So this plate is called as dural plate. There is a triangle or there is an angle present between the sigmoid and the dura. This angle which is formed over here, this is called as sinodural angle. Question इस पे आया है, what is it called? It is called as Sitteley's angle. So Sitteley's angle is called as sinodural angle. ठीक है? Now, I want you all to identify two important structures over here. जब हम mastoid की drilling करते हैं, तो what do we find over here? We find two important bulges. एक लेटा हुआ, एक सीधा. तो जो सीधा bulge है, which is coming down vertically, this is our lateral semicircular canal. And जो टेढ़ा है, which is perpendicular to the lateral canal, this is posterior semicircular canal. So try identifying these two semicircular canals. One is lateral, one is posterior. The angle formed between the semicircular canals, this angle is called as solid angle. So what is solid angle? The angle formed between the three semicircular canals, that is called as solid angle. अब एक important point that is very very important for a surgery that we do, and that is very important IBQ for INICET as well. अगर हम एक imaginary line इस lateral canal के बनाते हैं which bisects the posterior canal perpendicularly, अगर इसके along एक line बनाई which is bisecting this posterior canal perpendicularly, what is this line called as? This line is called as Donaldson line. This is called as Donaldson line. What is the importance of Donaldson line? Donaldson line का मतलब है इसी line के inferior, if we drill over here, we will find something called as endolymphatic sac. And endolymphatic sac surgery is the surgery which we do for Meniere's disease. तो सबसे पहली important चीज क्या है? I want you all to identify this line. If we draw an imaginary line along the lateral semicircular canal which bisects the posterior canal perpendicularly, that line ke inferior, if we drill somewhere here, this is the point where we will get the endolymphatic sac. And endolymphatic sac surgery is the surgery done for Meniere's disease. ठीक है? Fine? चलो. अब जैसे जैसे एक क्वेश्चन आया है, persistent petrosquamous suture is called as. So when your whole mastoid and ear is developing, petrous bone and the outer squamous bone, they both join together. और इनका जो suture होता है वो बहुत छोटा सा हो जाता है. अगर ये suture मोटा रह गया या if the suture is persistent, then during mastoid drilling you can accidentally injure critical structures. Very nice, Javed has already answered. Persistent petrosquamous suture is called as corner septum. So this is a very important question for your one word too. What is corner septum? It is persistent petrosquamous suture. इससे क्या होता है mastoid की cavity के अंदर all the areas, you know, they become haphazard. ये सारी canals, facial nerve, they all go here and there, and that is the reason accidentally we can injure those things. Okay, चलो आगे बढ़ते हैं. Very important question is what is McEwen's triangle? Okay, so there is another triangle which is present inside in your ear, that is McEwen's triangle. Now what is McEwen's triangle? Now see this is your external auditory canal, this is your whole bone or the temporal bone. what we have taken out, and this is your mastoid. अब 3 लाइन हमें बनानी है. One line of this has to be along the posterior canal wall. देखो ये मेरी canal है, so this is my posterior canal wall. So imagine this is my external auditory canal, ये इसकी anterior wall है, इसके पीछे ये इसकी posterior wall है. So if we draw an imaginary line, one along the posterior canal wall, that is going to be the anterior limit of this triangle. Another imaginary line drawn along the supramastoid crest. Mastoid के ऊपर एक छोटा सा crest होता है, which is called as supramastoid crest. This is the superior line, and then again a tangent joining the two. So if we draw 3 important lines, one along the supramastoid crest, one along the posterior canal wall, and a tangent joining the two, this will form a triangle, and this triangle is given the name as McEwan's triangle. अब आपसे ये पूछा जाता है मैकइवन्स ट्रायंगल की क्या इंपॉर्टेंस है. द इंपॉर्टेंस ऑफ मैकइवन्स ट्रायंगल इज कि अगर मैंने इस ट्रायंगल के अंदर 1.5 सेंटीमीटर डीप ड्रिल किया, I will find the largest air cell of mastoid. So if I drill 1.5 centimeters deep in this triangle, then I will find the largest air cell of mastoid, which is called as mastoid antrum. So largest air cell of mastoid को क्या बोलते हैं? It is called as mastoid antrum. Which is the surgical landmark for finding the mastoid antrum? It is McEwan's triangle. कितना centimeter it lies deep? 1.5 centimeters. So remember this, okay? This is a very important surgical landmark, which is important for our clinical scenario-based perspective during mastoidectomy. ठीक, चलो आते आगे. Now let's come to important tuning fork test, क्योंकि ये बड़ी important चीज है जिसमें बहुत सारे questions को वो here and there frame करेंगे. तो सबसे पहली चीज है, whenever you get tuning fork test, 2 टेस्ट आपको दिए जाएंगे. One is Rennie's and one is Weber's. Still I've given you 2 more, but the most important are the first 2, Rennie and Weber's test. First, always see the Weber's test, because that will make you very confident कि इसके Rennie's में क्या होगा. तो सबसे पहले whenever you're given a question of tuning fork, watch on Weber's test first. अब एक चीज है, whenever you do Weber's test, you do it with a 512 Hz tuning fork. Let's say my pen is a tuning fork, इसको मैंने strike किया and I place it over the vertex. Now when I place it over the vertex, my bone conduction will stimulate both my cochlea equally. दोनों में मेरे bone conduction जाएगा. So in normal people, my Weber's will be equally perceived on both the sides. जैसे हम कहते हैं सेंट्रलाइज्ड वेबर्स, ये नॉर्मल लोगों में होता है. अगर वेबर एक तरफ जा रहा है, नाउ लेट्स से दिस इज द पर्सन, राइट, एंड दिस इज द कॉक्लिया इनसाइड, you have put a Weber's. So if it is centralized, the bone conduction will happen equally on both the sides. Let's say now this particular person has got a malformed cochlea on the right side. इसके right side का cochlea काम नहीं कर रहा, या इसकी vestibulocochlear nerve damaged है. That means this patient has sensory neural hearing loss on the right side. Sensory मतलब hair cells which is in the cochlea, neural मतलब vestibulocochlear nerve. तो अगर किसी के sensory neural hearing loss होगा, so the Weber's will get lateralized obviously to the better side, to the better cochlea. So in always sensory neural hearing loss, Weber's gets lateralized to the better ear. We need to remember this. ठीक है? And अगर let's say this particular person has got wax out in, or wax is present in his external ear, that means इसका air conduction is already low. तो होगा क्या? This, when we do Weber's test in conductive hearing loss, जिसमें कोई external ear या middle ear disease है, उसमें Weber's always gets lateralized to the worst side. And why does that happen? It happens because of the phenomena of masking. अब मैं चाहता हूं आप लोग अपना एक कान बंद करो, अपने आप से बोलो. अगर आप अपना एक कान बंद करते हो, अपने आप से बोलते हो, you will automatically hear more on the side you have blocked your ear. Why? क्योंकि आपने बाहर की ambient noise को बंद कर दिया. So what has happened when you stop the ambient noise which is coming from the outside, that's called as masking. So your inner voice or your bone conduction becomes hyper amplified. That is the reason Weber's gets lateralized to the worst side in conductive hearing loss. So जहां पे भी Weber's जा रहा है, you can at least come to know that at least they are talking about sensory neural or they are talking about conductive hearing loss. And they will always mention कि ये middle ear disease है, कि ये inner ear disease है. Now comes what is Rennie's test. Rennie's test is done by all 3 tuning forks. Rennie's test में 2 interpretation होते हैं. Air conduction is more than bone conduction, या bone conduction is more than air conduction. If in your particular question they say air conduction is more than bone conduction, they are talking about normal people or they are talking about sensory neural hearing loss patients. Why? क्योंकि उनका bone conduction already कम होता है. If they are talking about bone conduction is more than air conduction, मतलब इसमें air conduction pathway कम हो गया, that means the patient has got conductive hearing loss or the patient has got some external या middle ear disease. That means here the diagnosis will become conductive hearing loss. So always remember bone conduction गिरता है in sensory neural hearing loss, that is why air conduction is more than bone conduction. तो अगर आपके पेशेंट जो दिया गया सिनेरियो उसका वेबर सेंट्रलाइज्ड है यानी इक्वल है and their air conduction is more than bone conduction in knees, that means they are talking about normal people. But if they are showing that the air conduction is more than bone conduction in knees and the Weber's is lateralized to the better ear, so obviously they are talking about sensory neural hearing loss. Please be confident on these questions क्योंकि यही दो important test आपको दिए जाएंगे where they will tell you to diagnose this particular problem. ठीक है? अब there are two more tests which are important historically, that is ABC, that is absolute bone conduction test, and the next is Shawback test. दोनों में कोई फर्क नहीं होता, दोनों इंपॉर्टेंट टेस्ट है बोन कंडक्शन के लिए. क्या करते हैं, लेट्स से दिस इज माय ट्यूनिंग फोक. अगर मैंने अपने कान को बिल्कुल बंद कर दिया बाहर से and I put a tuning fork over the person whom I am testing and I compare the bone conduction of the examiner with respect to the patient with the tragus closed, that means I am absolutely testing my bone conduction. Agar bone conduction of the examiner is same as that of the patient, then that means that person is normal. If the examiner's bone conduction is more than the patient, that means obviously the bone conduction of the patient is low. So obviously we will say it is shortened and the patient has sensory neural hearing loss, right? और अगर उसका same as examiner है, then also the patient might be having conductive hearing loss क्योंकि this is a pure test for testing bone conduction for sensory neural hearing loss. Conductive hearing loss हम नहीं बता सकते ABC से, ये important point है. अब जैसे मैंने आपको बताया कि इसमें एग्जामिनर वर्सेस पेशेंट की टेस्टिंग हो रही है. अगर आपने ट्रेगस को क्लोज कर दिया और टेस्ट किया, दैट इज एब्सोल्यूट बोन कंडक्शन टेस्ट. अगर आपने ट्रेगस को ओपन रखा, देन दैट इज शॉबैक टेस्ट. दैट्स द ओनली डिफरेंस बिटवीन द टू. But the one thing that you need to notice is that in conductive hearing loss patients, Shawback test becomes lengthened. ABC में conductive hearing loss का कोई पता नहीं होता. But in cases of Shawback test, क्योंकि आपका tragus open है, here in conductive hearing loss patients, they will have lengthened Shawbacks. मतलब examiner से ज़्यादा patient का lengthened होगा bone conduction. That is what you need to understand among all tuning fork tests and the examination question that are asked to you. ठीक है, चलो आगे बढ़ते हैं. ओके, अब आते हैं इंपॉर्टेंट ऑडियोग्राम्स पे. वन इंपॉर्टेंट क्वेश्चन आई वांट यू ऑल टू आंसर दिस जस्ट बाय सीइंग. सबसे इंपॉर्टेंट चीज याद रखना, जब भी कोई दिखे डॉटेड लाइन, कभी भी आपको डॉट 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 दिखे, दे आर टॉकिंग अबाउट बोन कंडक्शन. जब भी लिखी सॉलिड लाइन, दे आर टॉकिंग अबाउट एयर कंडक्शन. तो कभी भी ऑडियोग्राम में डॉट 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 वाली लाइन दिखी, दैट इज बोन कंडक्शन लाइन. कभी भी स्ट्रेट सॉलिड लाइन दिखी, दैट इज एयर कंडक्शन लाइन. कुछ भी याद नहीं है तो ये याद रखना. If they give you a red color in audiogram, that is R for right, R for red. If they ask you anything which is blue, blue में L आता है, that is for left ear. तो left ear वाले blue होंगे, right ear वाले red होंगे, dot वाली होगी bone conduction line, solid line will be air conduction line. ठीक है? अब what is this? Here what they are showing is that here there is a dip that is present at 4000 hertz. If there is a 4000 hertz dip, याद रखना 4000 पे अगर डिप किया तो 4000 हर्ट्ज पे अगर एयर कंडक्शन एंड बोन कंडक्शन दोनों डिप कर गए, दैट इज नॉइज इंड्यूस्ड हियरिंग लॉस. आंसर इज नॉइज इंड्यूस्ड हियरिंग लॉस. ठीक है, मीनियस का दूसरी चीज होती है. सो नॉइज इंड्यूस्ड हियरिंग लॉस में 4000 हर्ट्ज पे डिप दिखती है एंड दिस इज बेसिकली कॉल्ड एज बॉयलर मेकर नॉच. This is called as boiler maker notch, या इसे हम सिंपली बॉयलर नॉच कहते हैं. ठीक है, अब आ जाते हैं सेकंड इंपॉर्टेंट ऑडियोग्राम पे. इन दिस ऑडियोग्राम व्हाट यू आर सीइंग की जो डॉट 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 है, दैट इज द बोन कंडक्शन लाइन. ये मेरी बोन कंडक्शन की लाइन है, ये मेरी एयर कंडक्शन की लाइन है, बिकॉज इट इज सॉलिड. एंड व्हाट यू आर सीइंग, दिस इज रेड इन कलर, सो ऑब्वियसली दे आर टॉकिंग अबाउट द राइट. नाउ वन इंपॉर्टेंट थिंग इज कि दैट दिस पर्टिकुलर थिंग इज दिस बोन कंडक्शन इज डिपिंग एट 2000 हर्ट्ज. If bone conduction alone is dipping at 2000 hertz, bone conduction alone is dipping at 2000 hertz, then this is given the name as Carhart's notch. And Carhart's notch is a characteristic feature which is seen in cases of otosclerosis. Why is Carhart's notch seen only at 2000 hertz frequency? Because the vibration frequency of this tapees is 2000 hertz. That is why the bone conduction reduces at 2000 hertz. ठीक है, चलो आगे बढ़ते हैं. व्हाट इज दिस? जब भी हम एक चढ़ता हुआ ऑडियोग्राम देखेंगे, whenever we see a चढ़ता हुआ ऑडियोग्राम, a climbing audiogram, this is called as a rising curve. Rising curve audiogram is a characteristic feature of Meniere's disease. This is a characteristic feature of Meniere's disease. अब हमेशा एक चीज याद रखना, कभी भी सेंसोरी न्यूरल हियरिंग लॉस होता है किसी को भी, तो सेंसोरी न्यूरल हियरिंग लॉस में एयर कंडक्शन एंड बोन कंडक्शन हमेशा साथ साथ चलते हैं. एस फॉर साथ साथ, एस फॉर सेंसोरी न्यूरल. इसमें भी देखो जो डॉट डॉट वाली लाइन है, दैट इज फॉर बोन कंडक्शन. दिस सॉलिड लाइन इज फॉर एयर कंडक्शन. दिस इज ऑफ लेफ्ट ईयर, क्योंकि ये ब्लू इन कलर है. दे बोथ आर टुगेदर. So this is a type of sensory neural hearing loss which is seen in Meniere's disease, but in the earlier course of Meniere's disease, they present with a rising curve. So this is a rising curve pure tone audiogram seen classically in earlier stages of Meniere's disease. Remember this. Okay? The second feature of Meniere's disease is that they will show low frequency hearing loss. So you can see there is low frequency. नीचे के frequencies में there is sensory neural hearing loss क्योंकि साथ साथ है. ठीक है, so that is another point that you need to note about what is the audiogram seen in Meniere's disease. आगे बढ़ते हैं. Now let's come to another important thing. Now see, this is red in color, so obviously this is a right audiogram. ठीक है. Now you can see that the bone conduction, air conduction both are together. मैंने बताया था अगर bone conduction और air conduction की लाइन साथ साथ दिखें, S for साथ साथ, S for sensory neural. तो ये क्या है? This is a right-sided sensory neural hearing loss क्योंकि वो साथ साथ है. And this is opposite to what we saw. This is called as sloping SNHL. Sloping मतलब ये गिर रहा है. It is falling down. What is the differential diagnosis for a sloping SNHL? अगर आपको ये ग्राफ दिया जाता है in a 70-year-old patient, then the answer will become presbyacusis. Presbyacusis means age-related hearing loss. So always see the age over here with the sloping audiogram. If they give you this kind of an audiogram and they tell कि ये एक साइड पे हो रहा है, maybe in a middle-aged man, and that person has also developed tinnitus, answer is acoustic neuroma or vestibular schwannoma. So this audiogram is seen in cases of vestibular schwannoma as well. If they give you a unilateral disease, then it is vestibular schwannoma. If they give you bilateral progressive sensory neural hearing loss, then it is presbyacusis. Also, presbyacusis is age related, तो ये 70-80-year-old में दिखेगा. This is unilateral sloping type of SNHL that will be seen in cases of vestibular schwannoma. So remember this particular point. ठीक है? Third, this is also seen in cases of ototoxicity. Any person who has taken certain ototoxic drug, हम देखेंगे इसके आगे कौन से ototoxic drug होते हैं. ठीक है? And also this is seen in cases of late stages of Meniere's disease. So these are the four differential diagnoses of sloping audiograms or slope that is present over in sensory neural hearing loss. ठीक है? चले? चलो. So now we have done about what are the important pure tone audiograms. But audiometry बहुत पूछी जाती है, so one of the most important thing is impedance audiometry as well. ठीक है? तो impedance audiometry क्या होती है? Impedance का मतलब resistance. इसमें क्या होता है? वी कीप समथिंग कॉल्ड एज अ प्रोब. इंपेडेंस प्रोब होता है, उसे हम कान में लगाते हैं एंड वी चेक ओवर कि कितनी रेजिस्टेंस टिम्पैनिक मेम्ब्रेन में है. ठीक है, सो वी गेट समथिंग कॉल्ड एज अ ग्राफ ऑन इंपेडेंस ऑडियोमेट्री. एक साइड ऑफ ग्राफ में प्रेशर होता है जिसमें 0 सेंटर हो गया. दिस इज लेट्स से +200, दिस इज -200. दिस इज कॉल्ड एज द कंप्लायंस कर्व. कंप्लायंस का मतलब मोबिलिटी. मतलब इसमें क्या होता है? whenever we put the probe inside the ear, there is a sound that is going to come which is going to move the tympanic membrane and it is going to get reflected. तो ये रिफ्लेक्शन जितना भी हो रहा है साउंड का, दिस इज गोइंग टू बी कॉट बाय दैट प्रोब और दिखेगा कि कितना रेजिस्टेंस प्रेजेंट है. तो कितना मोबिलिटी है टिम्पैनिक मेम्ब्रेन की, दैट इज गिवन द नेम एज कंप्लायंस. इफ द पेशेंट हैज गॉट अ नॉर्मल प्रेशर एंड नॉर्मल कंप्लायंस, मतलब प्रेशर भी ठीक, कंप्लायंस भी ठीक, दिस इज कॉल्ड एज ए कर्व. ए कर्व ऑन प्योर टोन ऑडियोमेट्री. ये नॉर्मल कर्व होती है प्योर टोन ऑडियोग्राम्स की. ठीक है, अब लेट्स से एक पर्टिकुलर इंसान के ओटोस्क्लेरोसिस हो गई. ओटोस्क्लेरोसिस में क्या होता है? स्टेपीज बिकम्स फिक्स्ड. अब अगर स्टेपीज में फिक्सेशन हो गया या स्टेपीज फिक्स हो गई तो क्या टिम्पैनिक मेम्ब्रेन अंदर अच्छे से मूव करेगी? नहीं. दैट मींस द कंप्लायंस विल गेट रिड्यूस्ड. उसकी मोबिलिटी रिड्यूस हो जाएगी क्योंकि पीछे स्टेपीज इज फिक्स्ड. सो व्हाट विल हैपन? Otosclerosis is not a problem with pressure. It is a problem in compliance. उसमें mobility नहीं हो रही है tympanic membrane की. It has become stiffer because of an underlying sclerosis in the stapes. So here, the pressure will become the normal and the compliance will reduce. So AS curve is normal pressure and decreased compliance. तो इसका आंसर ऐसे याद रखना है कि एस फॉर स्क्लेरोसिस. तो कोई भी स्क्लेरोसिस आपके ऑप्शन में है, ओटोस्क्लेरोसिस या टिम्पैनोस्क्लेरोसिस, दे बोथ विल प्रोड्यूस एएस कर्व. सिंपल एज दैट. ठीक है, चलो अब आते हैं दूसरी कर्व पे. दूसरी कर्व ये कि आपने साउंड दिया और बहुत ज्यादा मोबाइल हो गई है टिम्पैनिक मेम्ब्रेन. बहुत ज्यादा मोबिलिटी ऑफ टिम्पैनिक मेम्ब्रेन कब दिखेगी? जब ऑसिकल्स एक दूसरे से जुड़े नहीं हुए. When the ossicles are discontinued, malleus incus से नहीं जुड़ा है, incus stapes से नहीं जुड़ा है, तभी वो बहुत ज्यादा अंदर जा रही है. And hyper compliant tympanic membrane at normal pressure, और ये कर्व कभी बंद नहीं होती. It is so much that you cannot measure it. This is called as an AD curve. D is seen in discontinuity of ossicles. You can simply remember this mnemonic. Discontinued ossicles, malleus incus stapes discontinue हो गई, road traffic accident हो गया, you will say that the patient has AD curve. ठीक है, अब आते हैं next curve पे. Next curve means let's say the patient has a closed eustachian tube. Eustachian tube किसी का बंद हो गया. Eustachian tube क्या करता है? It equilibrates the pressure between the external environment and the ear. तो होगा क्या? अगर किसी का eustachian tube बंद हो गया, closed tube will produce negative pressure inside the ear. That negative pressure will be there, but still the tympanic membrane will have normal mobility. So in those people where negative pressure curve is there, that curve is called as C curve. और ये curve में there is no problem with the compliance. It is as good as A, but this is a negative pressure curve. So negative pressure but normal compliance curve is called as C curve. C for closed tube. So closed eustachian tube will present with C curve. आपके पास एक एडेनोइड हाइपरट्रॉफी का चाइल्ड आया. एडेनोइड हाइपरट्रॉफी के चाइल्ड में देयर इज वेरी कॉमन प्रॉब्लम दैट कॉजेज यूस्टेशियन ट्यूब ब्लॉकेज. उसमें कौन सी कर्व दिखेगी? क्वेश्चन आया, आप बोलेंगे सी कर्व. ठीक है, अब नाउ व्हाट विल हैपन आफ्टर द यूस्टेशियन ट्यूब हैज ब्लॉक्ड एंड द नेगेटिव प्रेशर हैज डेवलप्ड इन द मिडिल ईयर. नाउ द नेक्स्ट थिंग दैट विल हैपन इन द मिडिल ईयर इज फ्लूइड कलेक्शन. पहले नेगेटिव प्रेशर होता है, फिर धीरे धीरे उसमें फ्लूइड भरने लगता है. दैट फ्लूइड कलेक्शन इन द मिडिल ईयर इज कॉल्ड एज सीरस ओटाइटिस मीडिया. अब अगर मिडिल ईयर में फ्लूइड भर गया एंड देयर इज सीरस ओटाइटिस मीडिया, क्या आपकी टिम्पैनिक मेम्ब्रेन बिल्कुल भी चलेगी? नहीं, बिकॉज देयर इज सो मच ऑफ फ्लूइड बिहाइंड इट. सो दैट मींस यू विल नॉट बी एबल टू मेजर नाइदर द प्रेशर नाइदर द कंप्लायंस. सो इफ यू कैन नॉट मेजर कंप्लायंस एंड प्रेशर टुगेदर, दैट कर्व विल बिकम फ्लैट एंड दिस इज कॉल्ड एज बी कर्व. तो बी कर्व इज अ फ्लैट कर्व. फ्लैट मतलब दिखता है फ्लूइड, एफ फॉर एफ. फ्लूइड मतलब सीरस ओटाइटिस मीडिया या फिर ओटाइटिस मीडिया विद एफ्यूजन. The other reason for a flat curve is कि आप compliance नाप ही नहीं पाए. That is when you have got a perforation. Perforation जब किसी के भी होगा, the tympanic membrane will not move. It will be non-compliant. So I always say F for फटा हुआ eardrum याद रखो. That means perforation. So if you have fluid or perforation, you will get a B curve. If you have got closed eustachian tube, then you will have a C curve. If you have got AS curve, then it is for otosclerosis. If you have got AD curve, that is for ossicular discontinuity. This is the most important thing from audiometry, what you need to know in your exams. ठीक है, फाइन. चलो, तो ये हमारी खत्म होती है व्हाट इज अबाउट द इंपॉर्टेंट इंपेडेंस ऑडियोग्राम. बट अभी कहानी खत्म नहीं हुई है. नाउ लेट्स कम टू फेवरेट ऑफ माइन, आई सेड दैट इज बेरा. तो बेरा मींस व्हाट? बेरा मींस ब्रेनस्टेम इवोक्ड रिस्पांस ऑडियोमेट्री. तो इसमें हम क्या करते हैं? We place certain electrodes over the child's head, right? We place certain electrodes over the child's head and we give a sound stimulus to the child. अब क्या होगा? जब भी हम किसी को साउंड स्टिमुलस देंगे, पहले उसके एक्सटर्नल ईयर में जाएगा, फिर मिडिल ईयर में जाएगा, फिर इनर ईयर में जाएगा और फिर पूरे ऑडिटरी पाथवे में जाएगा, राइट? Now, as the sound travels through the auditory pathway, various waveforms start to happen, which are labeled as 1 to 7. तो कितनी वेव बनती है बेरा में? There are 7 waves which form in bera, right? Now, what is the interpretation of these bera waves is the question. ठीक है? So, whenever a patient, let's say this is a cochlea, these are the hair cells. यहाँ से vestibulocochlear nerve निकली, and then it has gone into your brainstem, and brainstem say it has finally gone into the auditory cortex. तो इस पूरे खेल में what is the mnemonic? The mnemonic is 𝐒𝐿. ईकोलीमा is the auditory pathway, जो आप सबको पता है, पर बेरा का mnemonic है 𝐒𝐿. अब 𝐒𝐿 का मतलब क्या है? 𝐒𝐿 का मतलब यह है that first the sound will travel to the distal segment of the vestibulocochlear nerve. तो eighth nerve का distal part is going to form the first wave of Bera, जो यहाँ पे, ठीक है? Then as the wave travels, now it will go to the proximal segment of the vestibulocochlear nerve. Proximal का मतलब है जो brain stem के पास है, right? So now wave 2 will form from the proximal segment of vestibulocochlear nerve. ठीक है? अब आते हैं वेव 3 पर, ई को का मतलब कॉक्लियर न्यूक्लियस, दैट इज वेव 3. फोर्थ, olivary complex, superior olivary complex, या olivary complex will form wave 4. After olivary complex, then the wave will go into what? Now the next wave that will get formed is the largest wave on Bera. अगर आपको क्वेश्चन आता है which among the following is the most consistent wave of Bera, which among the following is the most highest peak wave of Bera, जो हमेशा प्रेजेंट होती है, that wave is of lateral lemniscus. This is going to form wave 5. सबसे कंसिस्टेंट वेव अगर बेरा की है, देखो ये सबसे ऊंची है, दिस इज गोइंग टू बी वेव 5. सबसे बड़ी वेव ऑफ बेरा यही है, वेव 5. ठीक है, कोई बने ना बने, ये जरूर बनती है. एंड देन फाइनली आई टोल्ड यू आई इज इंफीरियर कॉलिकुलस, सो वेव 6 एंड वेव 7 आर फॉर्म्ड बाय द कंट्रीब्यूशन ऑफ inferior colliculus. But always remember here medial geniculate body and higher auditory cortex do not contribute to the formation of Bera waves. That's the important point which is given a lot wrong in textbooks. Sirf 𝐒𝐂𝐈, this is the one which only forms Bera waves. Now let me come to two important questions related to vestibular schwannoma. अगर किसी के वेस्टिबुलोकॉक्लियर नर्व में ट्यूमर है, एर्थ नर्व में ट्यूमर है, लेट्स से यहां पे ट्यूमर है, तो बेरा की फाइंडिंग क्या निकलेगी? In Bera, you will always find delayed latency of fifth wave. अब खुद सोचो यहां पे ट्यूमर आ गया, so the wave that will form of in lateral lemniscus, that will be much delayed than the normal. We call that as delayed latency, जो आपका क्वेश्चन आया है. So in cases of vestibular schwannoma, delayed latency of fifth wave is seen. And the second important point that you need to notice is that there is another point in Bera that in cases of vestibular schwannoma, the interoral latency increases more than 0.2 milliseconds between both the ears. ये दो पॉइंट बस याद कर लो. अगर दोनों कानों के बीच में वेव 5 more than 0.2 milliseconds से ज्यादा के डिफरेंस पे आ रही है, that is a 100% feature or the most important feature of Bera that signifies कि उस तरफ या जो भी disease size है उसमें vestibulocochlear nerve में कोई ना कोई problem है. And this is a classical feature which is seen in cases of vestibular schwannoma. तो दो important Bera features कहीं भी क्वेश्चन में देखे, one is delayed latency of wave 5, one is interoral latency has increased. Answer vestibular schwannoma ही है. ठीक है, fine. So this finishes about a very important aspect about what you need to do and what you need to interpret as far as brainstem evoked response audiometry is concerned. Now this is the investigation of choice in neonatal hearing loss. This is also a very important point. इसमें से कौन सा सबसे अच्छा टेस्ट है for neonatal hearing screening? This is going to be the gold standard test for neonatal hearing loss. Another test which is done for neonatal hearing loss is otoacoustic emission testing. Otoacoustic emission is generated from what? It is generated from outer hair cells. Question. ठीक है, but इससे ज्यादा sensitive क्योंकि ये हमें बताता है at what level the hearing loss has happened. That is why Bera is above OE. ठीक है, चलो अब खत्म हुआ what is Bera. Now let's come into we have considerably done about what is the general thing about what are the audiograms of ear. You've done about what is the embryology of ear and anatomy related questions. अब आ जाते हैं इनटू व्हाट इज द पैथोलॉजी ऑफ ईयर. सबसे पहली पैथोलॉजी ऑफ एक्सटर्नल ईयर में जो फेवरेट इनका क्वेश्चन है दैट इज व्हाट इज मैलिग्नेंट ओटाइटिस एक्सटर्ना. पहला क्वेश्चन, व्हेनेवर इन योर केस यू फाइंड देयर इज अ ओल्ड मैन हु इज डायबिटिक and that particular person has come with severe otalgia, swelling over the ear and purulent otorrhea. Diabetic man with otalgia and purulent otorrhea, always think as this as the primary diagnosis because this is the usual diagnosis in diabetic or immunocompromised people. What is the most common organism for malignant otitis externa? There is a common organism जो प्यार करता है हमारे external ear से and that is Pseudomonas. So Pseudomonas is the organism of choice which is given for malignant otitis externa. It can also have a fungal etiology, but सबसे important इसमें pseudomonas है. It always occurs in immunocompromised people. Leading cause is diabetes. And this only happens in males. Mostly, it happens in males. The other name of this condition, don't confuse, it is also called as skull base osteomyelitis, or it is also called as necrotizing osteomyelitis या necrotizing otitis externa. इसका काम ही है एंजियो इन्वेसिव प्रॉपर्टी, ये वेसल्स को खाता जाता है. And that is the reason it is called malignant, because ये ट्यूमर नहीं है. It is having a very rapid progression and a very rapid spread. And that is why this particular disease is seen primarily in cases of immunocompromised people. Right? Now, malignant otitis externa is a bone erosive process. That is why it is osteomyelitis. क्योंकि ये बोन को इरोड करती है. तो जब भी कोई बोन को इरोड करेगा, so ear is very near our skull base. Base of skull के बहुत नीचे, बहुत पास है हमारा ear. So it will cause multiple cranial nerve palsy. What is the most common cranial nerve involved in cases of malignant otitis externa? Obviously, there is a nerve which is closely related to your ear, and that is facial nerve. So the most common nerve which gets involved is facial nerve. What is the characteristic clinical feature of this particular condition? It is nocturnal otalgia and purulent otorrhea in a diabetic man. So रात में बहुत दर्द होगा and there will be pus which will keep coming out of the ear. What is the hallmark sign of malignant otitis externa? अब मैंने symptom बताए, hallmark sign. कहीं भी bone erosion होता है तो body granulation tissue बनाती है. It's a simple rule of the body. कहीं भी bone erosion होगा तो उसको ढकने के लिए body उसके ऊपर granulation tissue बनाएगी. Right? So the hallmark sign for malignant otitis externa is that at the bone and cartilaginous junction of the external auditory canal, you will see visible granulation tissue. And this is seen at the junction of bony and cartilaginous external auditory canal. तो खूब सारे red color के granulations दिखेंगे. Always remember, इसमें tympanic membrane की problem नहीं है. Here tympanic membrane is normal. So in this case, they will give you that the TM is normal because this is an external ear condition, which is rapidly progressive. Now, bone erosion आप कैसे देखेंगे? Bone erosion देखने के लिए best scan is a radio tracer scan. So we give a radio tracer and the investigation of choice is technetium 99 bone scan. So they have got set questions that are ready for this particular scenario. अगर उन्होंने आपसे ये पूछा कि ये particular patient है, आप bone erosion कैसे देखेंगे? तो आंसर है technetium 99 bone scan करेंगे. अब उन्होंने ये पूछा कि ठीक है, आपने technetium 99 bone scan कर दिया, आपने ये देखा कि ये particular disease है, आपने उसे स्टेज किया, आपने ट्रीटमेंट स्टार्ट किया. What is the treatment of choice? जहां चला pseudomonas, वहां चला ciprofloxacin. Ciprofloxacin is a drug of choice for pseudomonal infections. Always remember that. ठीक है? Now, if not ciprofloxacin, then what you can give? You can give the second line, which is ceftazidime. So 2C, या तो ceftazidime या फिर ciprofloxacin. ठीक है? अब these are the drug of choice that we will give in this case. अब हमें कैसे पता चलेगा whether the patient is improving with our treatment or not? So there are investigations which are done on follow-up of the patient, whether the malignant otitis externa patient is improving or not. What are the investigations for follow-up? We will do a gallium citrate 67 scan. So gallium scan अगर हम करते हैं तो gallium is taken up by the side which is showing disease. It is not taken up by the side which is not showing disease. तो अगर gallium ज़्यादा uptake हो रहा है, we will come to know कि भाई अभी भी disease है, we need to keep continuing the treatment or we can do a surgery as well. ठीक है? Also, we will see ESR and CRP levels. These are acute phase reactants. तो अगर हम इनको देखते रहेंगे तो हमें पता चलता रहेगा कि whether the inflammation and infection has gone down or not. So what will you do in case of follow-up? Gallium 67, ESR and CRP. What will you do in order to see technetium 99 bone scan? Treat कैसे करेंगे? Ciprofloxacin से. Hallmark sign, granulations. ठीक? These are the questions that are related to malignant otitis externa. चलो आगे बढ़ते हैं. आपके पास एक particular image आई. एक particular patient है that is from the tropical area. बड़ी humid conditions हैं. And the patient has got a musty odor that is coming from the ear. Musty odor. And the patient has got otalgia. Patient has a tropical area habitants. So he lives in a tropical area and this particular patient has got otalgia and a musty odor. ये क्या दिख रहा है? This is black and white. जहां कान में देखा black and white, this looks like a newspaper. So this answer is otomycosis. मतलब कान में fungus. Most common cause of otomycosis is Aspergillus niger. and you can very well see these kind of black filamentous heads. ये black colored जो colonies दिख रही हैं, these are of aspergillus. The second important cause of this particular otomycosis is Candida albicans. Candida albicans produces a curd-like discharge. Curd मतलब बिल्कुल दही जैसा, right? White colored. So curd-like discharge, Candida. Most common Aspergillus niger, and it will produce this black white appearance because of the black filamentous heads. What do we call this appearance as? It is called as a wet newspaper appearance. ठीक है, चलो. आपने अभी हाल में देखा जस्टिन बीबर came online and he actually made a video call with all the fans. Fans were also having some kind of attention कि क्या हो गया हमारे सुपरस्टार को, ये हो गया हमारे सुपरस्टार को. So what did Justin Bieber have? Justin Bieber showed that he had got vesicles over the pinna. He was in horrible pain in the ear, and at the same time he had lower motor neuron facial palsy. Three things, right? What is this? Lower motor neuron facial palsy. If the patient has got vesicles which are painful over the pinna and the patient has got severe otalgia, without a doubt this falls into a syndrome called as Ramsay-Hunt syndrome. ठीक है, so this is something which is very very important. Ramsay-Hunt syndrome, अगर आपको ये triad मिला, these are the vesicles what are shown over here. Because of the vesicles there is extensive pain and there will be ipsilateral lower motor neuron type of facial palsy. Answer is Ramsay-Hunt syndrome without a doubt. ठीक, चलो आगे बढ़े. अब आ जाते हैं into middle ear diseases. Once we have finished about external ear diseases, middle ear diseases में सबसे important disease जो हर साल आती है, and that is a very important tympanic membrane question also, that is acute otitis media. What is the most, अब देखो जितने मैंने क्वेश्चन है सारे लिख रखे हैं. Most common route for acute otitis media is what? Most common route of infection is eustachian tube. मतलब सारे के सारे ऑर्गेनिज्म मिडिल ईयर में कहां से आते हैं? eustachian tube से आते हैं. ठीक है, from nearby sources they will enter through the eustachian tube. That is why in children the eustachian tube is much, you know, it is in line with the external aortic canal. This is something which is less horizontal, more horizontal. So in children they have a more horizontal tube, a more wider tube. Adults have a more angulated tube. That is why these particular infections happen more in children than in adults, क्योंकि उनका more tube horizontal है. और अगर ज्यादा tube horizontal होगा तो जब भी बच्चा feed करेगा या लेटेगा, that time the infection can travel very easily. Angulated tube में ये problem नहीं होगी. The second thing is, what is the most common organism producing ASOM? That is without a doubt Streptococcus pneumoniae. Most common organism. ठीक? What are the 4 stages of ASOM? Actually there are 5 stages, but I am telling you the 4 क्योंकि ये सबसे important 4th है. अब पहली stage is called as stage of tubal occlusion. जब भी कोई organism आएगा सबसे पहले it will cross edema over the eustachian tube and it will close the eustachian tube causing tubal obstruction. अगर eustachian tube बंद हो गया, so what will happen to the middle ear? Middle ear will generate negative pressure. So the tympanic membrane will become retracted. वो पीछे चली जाएगी. That is stage 1, stage of tubal occlusion. Now what is going to happen next? Second में क्या आएगा? That infection is going to start inflaming. So now there will be stage of congestion. Congestion मतलब अब inflammation start होगा middle ear के अंदर. अब जब inflammation start होगा middle ear के अंदर, so in the second stage or stage of congestion, इसे हम stage of pre-suppuration भी कहते हैं. पस बनने से पहले, there will be marked vessels. You'll see red colored vessels and angry tympanic membrane. बहुत angry red. This red congested tympanic membrane is seen in the stage of pre-suppuration or in stage of congestion, and this is a characteristic appearance called as cartwheel appearance. The question आता है cartwheel appearance is seen in which stage of ASOM? It is seen in the stage of pre-suppuration or in the stage of congestion. Simple. अब क्या होगा? अब organism inflammation कर चुका है तो अब organism pus बनाएगा. So the next stage of ASOM is stage of pus formation या stage of suppuration. This is the stage where the patient will develop severe otalgia. The patient will develop very high grade fever. The patient can also have convulsions and vomiting. So this is the child stage जहां सबसे child sick होगा. Now what will you see in the stage of suppuration? आप देखेंगे that all your tympanic membrane becomes characterless. इसमें कुछ भी नहीं दिख रहा है tympanic membrane में. All the areas of the tympanic membrane are gone. It has become characterless. So इसमें what are the signs that are seen in stage of suppuration? You will see tympanic membrane bulging. Bulged out tympanic membrane. Correct? And also you will see a kind of a yellowish color behind the tympanic membrane, which is thick pus which has collected. अब जिस point पे the the malleus is attaching to the tympanic membrane. So malleus attaches to the tympanic membrane at a point, and this point is called as umbo. तो ये जो पॉइंट होता है, दिस इज द पॉइंट वेयर द टिम्पैनिक मेम्ब्रेन इज एक्चुअली डिप्ड इनसाइड. ये अंदर की तरफ इट टेक्स द टिम्पैनिक मेम्ब्रेन अ लिटिल इनवर्ड्स, जहां पे मैलियस अटैच होती है. तो मैलियस लेट्स से पीछे अटैच हो रही है, तो इस तरीके से मेरी नॉर्मल टिम्पैनिक मेम्ब्रेन है. तो क्या होता है, हर तरफ पस भर जाएगा, बट दिस इज द पॉइंट विच विल स्टिल शो द डिप. So you can see over here, this is the only point which is not bulging out, क्योंकि यहां पे मैलियस अटैच होती है. And that is why this whole appearance, you can see a dip in the center. This is called as dimpling in the tympanic membrane. So you can see a center dimple which has formed over in the suppuration stage, जहां पे suddenly your tympanic membrane has gone inside at the area जहां पे वो join कर रही है at the umbo. ठीक है, with the malleus. So this is a dimple which is present in the past tense. This is a characteristic. बाकी सारी tympanic membrane is bulged out except for the center. ठीक है. अब now let's come to the next stage, which is the stage of resolution. Resolution का मतलब क्या है? अब अपने आप बस ठीक हो गया. That is called a stage of resolution. आपने एंटीबायोटिक दी, अपने आप सारी काम ठीक हो गए. But अगर आपने कुछ नहीं दिया, so what will happen? Suddenly, in the anteroinferior quadrant of the tympanic membrane, suddenly, there, because of the constant pressure, there will be necrosis, and this tympanic membrane will burst out. और क्या होगा, जब tympanic membrane अपने आप burst हो जाएगी, तो suddenly सारा discharge ऐसे निकलेगा, pulsatile manner में सारा discharge throw out होगा. So when you put an otoscope light and you see this discharge coming out, आप देखोगे discharge बस निकलते जा रहा है like a pulsation. So your light of the otoscope will shine and go away, shine and go away, shine and go away. What is that called as? That's called as a lighthouse effect, also called as a lighthouse sign. Okay, so that is basically, you know, a very important feature is seen whenever there is the tympanic membrane bursts out and there is a perforation which forms and there is a lighthouse effect where all the pulsatile otoria is coming out. That happens when you don't give any treatment. ठीक है, चलो. अब एक इंपॉर्टेंट कंडीशन होती है जिसमें सर्टेन इंफेक्शंस कैन कॉज कंप्लीट डिस्ट्रक्शन ऑफ द टिम्पैनिक मेम्ब्रेन. दैट इज कॉल्ड एज अक्यूट नेक्रोटाइजिंग ओटाइटिस मीडिया. ये इंपॉर्टेंट है आपके लिए. व्हाट इज अक्यूट नेक्रोटाइजिंग ओटाइटिस मीडिया? सर्टेन इंफेक्शंस में, जैसे कि स्कारलेट फीवर. Scarlet fever is a very common fever which happens because of beta hemolytic streptococci. It has got pharyngitis, it has got rash formation over the body. तो इसमें क्या होता है? When somebody develops beta hemolytic streptococcal infection, they can actually lead to complete destruction of the tympanic membrane. मतलब past tensa गया, past flaccida गया, सारे ossicle चले गए, and annulus चला गया, everything. It's a plain box which you will be able to see, nothing else. Complete destruction of the tympanic membrane. That is why it's called as acute necrotizing, क्योंकि सब necrosis हो जाता है. This is a fulminant middle ear infection. So in that case, secondary acquired cholesteatoma is very common in those cases where acute necrotizing otitis media happens. Secondary acquired cholesteatoma का क्या मतलब है? जब external auditory canal की skin migrates inside into the middle ear, that is called as secondary acquired cholesteatoma. तो होगा क्या, जब मेरी सारी की सारी tympanic membrane destroy हो गई, pars tensa, pars flaccida, annulus, सब कुछ, तो obviously it's like a blank space inside. So middle ear will be the area where all my stratified squamous epithelium of the external auditory canal will start going inwards. और जब ये migrate करेगा अंदर, तो क्या होगा? Secondary acquired cholesteatoma होगा. तो क्वेश्चन ये याद रखना that what is the most common cause for secondary acquired cholesteatoma? It is acute necrotizing otitis media caused by scarlet fever, organism beta hemolytic streptococci. ठीक है, चलो. सो ये खत्म होता है अबाउट इन बेसिक थिंग्स व्हाट इज अबाउट ASOM. ओके, अब आ जाते हैं व्हाट इज द क्वेश्चन दैट दे कैन आस्क यू अबाउट सीरस ओटाइटिस मीडिया. सीरस ओटाइटिस मीडिया को हम लोग कहते हैं ग्लू ईयर. ग्लू की तरह फ्लूइड इज डेवलप बिहाइंड द मिडल ईयर, राइट? Or you can also call it as otitis media with effusion. So this is something which is a sterile fluid which starts to develop inside the middle ear cavity, right? Now, what is the most common cause of reduced hearing in children? सबसे common cause of school going children में अगर deafness है, it is still otitis media with effusion. And why do people like children? Why do children develop otitis media with effusion? क्योंकि children have got maximum adenoid hypertrophy. तो children में होगी adenoid hypertrophy. तो जब एडिनोइड्स बड़े हो जाते हैं, सो लेट्स से दिस इज योर नेजोफैरिंक्स. नेजोफैरिंक्स के दोनों लैटरल एंड्स पे यूस्टेशियन ट्यूब ओपनिंग होती है. So if the adenoids become big inside the nasopharynx, they will block the eustachian tube opening. If they block the eustachian tube opening, there will be sudden negative pressure which will develop in the middle ear. एंड व्हेन देयर इज नेगेटिव प्रेशर इन द मिडिल ईयर तो होगा क्या, ये सारे के सारे जितना भी एपिथेलियम है, जितनी भी कैपिलरीज है मिडिल ईयर से, वो नेगेटिव प्रेशर पुल करने लगेगा. इट विल स्टार्ट पुलिंग आउट ऑल द फ्लूइड फ्रॉम ऑल द प्लेसेस. तो इट विल स्टार्ट पुलिंग आउट ऑल द फ्लूइड फ्रॉम ऑल द स्पेसेस. तो क्या होगा, फ्लूइड डेवलप होना शुरू होगा. एंड दिस इज कॉल्ड एज ओटाइटिस मीडिया विद एफ्यूजन. तो जब भी हम इसमें टिम्पैनिक मेम्ब्रेन देखेंगे, व्हाट विल वी सी? वी विल सी अ लॉट ऑफ बबल्स दैट आर प्रेजेंट बिहाइंड अ नॉर्मल टिम्पैनिक मेम्ब्रेन. So this bubble, these are the bubbles which you will be able to see in cases of otitis media with effusion, right? Now, अगर बच्चे होते हैं तो adenoid is the most important cause for causing tubal occlusion. But अगर बड़े हो जाते हैं, see adenoid is something which is a lymphoid tissue. ये 12 साल तक रहता है. It is given for protection. So please see this in your question. अगर आपको 12 साल का बच्चा या 7 साल 8 साल का बच्चे में दे रहे हैं that there is conductive hearing loss, answer is that this tubal occlusion has happened because of adenoid hypertrophy. But the most common cause of tubal occlusion that happens and causes OME in adults is not adenoid. If you have a nasopharyngeal mass in adult, the most common cause is nasopharyngeal carcinoma. So many of the times nasopharyngeal carcinoma is a very silent condition. The first sign of nasopharyngeal carcinoma in adult could be a serous otitis media. So always see the age group. अब अगर आपको serous otitis media एक 50 साल के इंसान में कोई पूछ रहा है, what is the cause likely? Then it is could be nasopharyngeal carcinoma. We have to see the other things also. But अगर 8 साल के बच्चे में they are showing that there is serous otitis media, then the answer is adenoid hypertrophy. Both are nasopharyngeal masses, but both are important at their own age groups. Okay, fine. So this is important as far as OME is concerned. ठीक है, चलो now अब आते हैं important theories of cholesteatoma पे. ये इनका favorite question आता है. Complications of chronic otitis media and theories of chronic otitis media is something they ask way in and way out, बहुत commonly asked. तो इसके लिए मैं आपको एक simple चीज बताऊंगा and I'll tell you about how to crack these questions. There are 3 type of cholesteatoma. Cholesteatoma का मतलब क्या होता है, पहले तो ये समझते हैं. Cholesteatoma means skin in the wrong place. हमारे मिडिल ईयर में कभी भी स्क्वामस एपिथेलियम नहीं होता. If squamous epithelium is present inside our middle ear, we will call it as a cholesteatoma, right? Johannes Muller was the first person who actually discovered this और उसने देखा कि epithelium middle ear में बना हुआ है. There are 3 principal types of cholesteatoma: congenital cholesteatoma, primary acquired cholesteatoma and secondary acquired cholesteatoma. आजकल एक और आ गया which is called as tertiary acquired cholesteatoma. वो होता है ड्यूरिंग सर्जरीज. अगर हम कोई सर्जरी करते हैं, लेट्स से लाइक टिम्पेनोप्लास्टी, और हमने एक्सीडेंटली इंप्लांट कर दिया स्क्वामस एपिथेलियम इनटू द मिडिल ईयर, दैट इज कॉल्ड एज टर्शियरी एक्वायर्ड. दैट मींस इट इज सर्जरी इंड्यूस्ड और iatrogenic. ओके, बट यू नीड टू फोकस अपॉन दीज टू. अब अगर आपके पास दे गिव यू दैट लेट्स से अ चाइल्ड हैज कम टू यू and that particular child has got a pearly white mass behind the tympanic membrane. तो देखो इसमें क्या दिख रहा है. You can see that there is a tympanic membrane, और tympanic membrane के एक क्वाड्रेंट में आपको दिख रहा है there is a pearly white mass. यानी कि आपको ये बताया गया that there is normal pars tensa, आपको ये बताया गया there is normal pars flaccida. Flaccida मतलब ये पिंक कलर का जो भी ऊपर का पार्ट है, this is pars flaccida. नीचे this is pars tensa. This is fairly normal. क्यों नॉर्मल है? क्योंकि आपको cone of light दिख रही है, right? So this is pars tensa, this is pars flaccida. They both are normal. Okay. Now what else they will show you? They will show you this kind of a pearly white mass. So there is a pearly white mass behind the tympanic membrane, behind normal tympanic membrane, right? And even if this child has got previous episodes of otitis media with effusion, that does not form the ground of exclusion. इसका मतलब क्या है? That previously अगर किसी को कितनी भी बार अगर otitis media with effusion हुआ है, that does not count. That does not count. अगर किसी के ये है, it is congenital cholesteatoma. So that does not form the ground of exclusion. What is this called as? This is given the name as Levinson's criteria. So what is Levinson's criteria? If a child has come to you with a normal tympanic membrane, normal pars tensa, normal pars flaccida, the child has got no prior history of any surgery, no prior history of discharge. So कोई भी discharge की history नहीं है, कोई भी surgery की history नहीं है, बिल्कुल ठीक है tympanic membrane, but you see a pearly white mass still behind the tympanic membrane. And even if the child has got 4 or 5 episodes of otitis media, it does not form the ground of exclusion. Your answer simply will become congenital cholesteatoma, without a doubt. ठीक है? अब इसमें बहुत केयरफुली ध्यान देना, this white mass is not tympanosclerosis. अगर tympanosclerosis आती है, tympanosclerosis will be seen as chalky white deposits. अगर chalk की तरह white deposits दिख रही हैं, that answer is tympanosclerosis. But here there is a pearly white mass. Now, the most common site for congenital cholesteatoma is the anterosuperior quadrant. So, if you see any pearly white mass, सबसे commonly in the anterosuperior quadrant, then this is classical congenital cholesteatoma, without a doubt. Okay? This finishes about what is congenital cholesteatoma, and I told you about the theory of basically the criteria for congenital cholesteatoma, that is Levinson's criteria. Okay? अब आ जाते हैं what is primary and what is secondary. ठीक है? अब ऐसे सोचो कि let's say this is your tympanic membrane. Let's say I'm drawing your tympanic membrane, and why am I doing this? This is something which is very important to make you understand about the questions of Prozac space. तो अब मैं आपको tympanic membrane side से दिखाऊंगा. So this is your external auditory canal. This is your external auditory canal. This is your middle ear. ये medial wall of middle ear है, and this is the end. So this is medial wall of middle ear, and this is your promontory. Behind this is your inner ear. Behind this is your inner ear. Okay, this is medial wall of middle ear, this is middle ear, this is external ear. Now, at the junction between your external ear and your middle ear, you have got something called as a tympanic membrane. You have got something called as a tympanic membrane, right? So let me just draw the tympanic membrane. Tympanic membrane has got an upper part which is called as pars flaccida and lower part which is called as pars tensa. ठीक है, ऊपर का पार्ट pars flaccida, नीचे का पार्ट pars tensa. What attaches to this tympanic membrane? The attachment of malleus is seen over the tympanic membrane. और malleus से अटैच होती है incus, incus अटैच होती है to stapes. ठीक है, अब सबसे इंपॉर्टेंट पॉइंट, एक ट्यूब ओपन करता है into this middle ear and this is called as the eustachian tube. Now, there are two important things that you need to remember. One is called as primary acquired cholesteatoma. One is called as secondary acquired cholesteatoma. क्वेश्चन ये आता है, इनमें से कौन सी थ्योरी प्राइमरी एक्वायर्ड कोलेस्टेटोमा की नहीं है, या इनमें से कौन सी थ्योरी सेकेंडरी एक्वायर्ड कोलेस्टेटोमा की नहीं है. तो दिस इज समथिंग दैट यू नीड टू आइडेंटिफाई. नाउ, प्राइमरी एक्वायर्ड कोलेस्टेटोमा की जो फर्स्ट थ्योरी होती है, दैट थ्योरी इज कॉल्ड एज विट-मैक्स थ्योरी, और इसका नाम होता है थ्योरी ऑफ इनवैजिनेशन. थ्योरी ऑफ इनवैजिनेशन या विट-मैक्स थ्योरी. ये थ्योरी ये कहती है कि अगर यूस्टेशियन ट्यूब ब्लॉक हो गया तो द पार्स फ्लैसिडा, देखो ये वाला एरिया इज द प्रोसैक स्पेस, तो द पार्स फ्लैसिडा विल रिट्रैक्ट इनवर्ड्स, ये अंदर चली जाएगी. एंड इफ द पार्स फ्लैसिडा रिट्रैक्ट्स इनवर्ड्स, squamous epithelium is going to start getting deposited within this invagination, and that will be a skin in the wrong place, and this will form a future cholesteatoma. So this is why this is called as a retraction pocket theory. इसे हम लोग retraction pocket theory भी कहते हैं, which happens because of eustachian tube blockage. That's the first theory of primary acquired cholesteatoma. The second theory of primary acquired cholesteatoma is given the name as Ruedi's basal cell hyperplasia theory. ये क्या कहती है? ये कहती है कि अगर किसी के कांस्टेंट एक्सटर्नल ईयर इंफेक्शन हो रहा है या कांस्टेंट मिडिल ईयर इंफेक्शन हो रहा है, तो होता क्या है, द लाइनिंग ऑफ दिस पार्स फ्लैसिडा व्हिच इज कंटेनिंग इट्स ओन सेल्स, इट स्टार्ट्स टू बिकम हाइपरप्लास्टिक. हाइपरप्लास्टिक का मतलब ये सेल नंबर इंक्रीज करने लगते हैं, यानी कि इस पार्स फ्लैसिडा जो भी सेल्स हैं, these cells are now going to start becoming more and more in number. और अगर सेल्स का नंबर बढ़ता है उसे हम हाइपरप्लेशिया कहते हैं, and this grows inwards. So that is why this is called as basal cell hyperplasia. जो basal cell layer है of the pars flaccida which is containing squamous epithelium, that starts to grow more and more and more because of the constant middle ear and external ear infections. That is called as Ruedi's basal cell hyperplasia theory. Third theory of primary acquired cholesteatoma, it's SAID's metaplasia theory. Metaplasia का मतलब one type of epithelium changes into another type of epithelium. So if somebody is getting chronic infections in the ear via the eustachian tube, then the epithelium which is present over in this area, the epithelium that is present over in the area of, or the roof of the middle ear, that starts to change into squamous. So normally squamous type hota nahi hai. Normally there is cuboidal type of epithelium over this area, but that changes into squamous type of epithelium because of constant infections which happen over time. और अगर constant infection हो रहे हैं तो that will change that one type of epithelium into another type of epithelium which is called as SAID's metaplasia theory. तो कौन सी थ्योरी इसमें आपको बोली जाएगी नहीं होती? आप बोलेंगे कि तीन थ्योरी होती हैं. That is Wick-Max theory, SAID's metaplasia theory and Rudy's basal hyperplasia theory. These are the three theories for primary acquired cholesteatoma. The most important point is what is this site? This site is Prusac space. तो कहां से ये प्राइमरी एक्वायर्ड कोलेस्टेटोमा निकल रहा है? इट इज अराइजिंग फ्रॉम विच स्पेस? इट इज अराइजिंग फ्रॉम द प्रूसैक स्पेस, व्हाटएवर बाउंड्रीज आई हैव डिस्कस्ड प्रीवियसली. द मोस्ट कॉमन साइट फॉर डेवलपिंग दिस पर्टिकुलर कोलेस्टेटोमा. ठीक है, अब हमेशा याद रखना, कभी भी प्राइमरी एक्वायर्ड कोलेस्टेटोमा का पेशेंट आएगा, दे विल हैव नो प्रायर हिस्ट्री ऑफ परफोरेशन, नो प्रायर हिस्ट्री ऑफ डिस्चार्ज. क्योंकि ये प्राइमरीली अगर हो रहा है तो दैट इज हैपनिंग बिकॉज ऑफ रिट्रैक्शन पॉकेट्स व्हिच आर गेटिंग फॉर्म्ड इन द एटिक. ये देखो मैंने एक पॉकेट बनाई है क्योंकि स्टेशन ट्यूब ब्लॉक हो रहा है. दैट इज द प्राइमरी वे इन विच दे आर फॉर्मिंग. तो प्राइमरी एक्वायर्ड कोलेस्टेटोमा, देयर इज नो हिस्ट्री ऑफ प्रायर परफोरेशन और डिस्चार्ज. दिस इज हाउ प्राइमरी एक्वायर्ड कोलेस्टेटोमा हैपेंस. नाउ कम्स सेकेंडरी एक्वायर्ड. सेकेंडरी मतलब किसी के सेकेंडरी हो रहा है. I told you a very common condition which is acute necrotizing otitis media, right? तो अगर in case if there is a perforation which forms over in this particular area, or if the perforation is on the margin of the tympanic membrane, what happens? In cases if the perforations are over on the margins of the tympanic membrane, then the epithelium of the external auditory canal starts to migrate inwards. If the epithelium starts to migrate inwards, that means the squamous cells will migrate inwards. And this squamous cell migration towards the middle ear, this is called as Haberman's theory. So Haberman's theory means that it is epithelial migration theory. And epithelial migration theory, या Haberman's theory, is the only theory which fits into secondary acquired cholesteatoma. So secondary acquired cholesteatoma happens because of a marginal perforation. Marginal मतलब देखो ये margin पे हो गया. It happens at the margin. And marginal perforation में annulus is also lost. Annulus भी चला जाता है. Annulus is a protector for not letting any epithelium migrate into the middle ear. If that epithelium starts to migrate into the middle ear, then that will form a later cholesteatoma, which is called as secondary acquired cholesteatoma, which is called as Haberman's theory. तो कभी भी कोई केस आएगा सेकेंडरी एक्वायर्ड कोलेस्टेटोमा में, उसमें देंगे देयर इज अ प्रायर हिस्ट्री ऑफ परफोरेशन एंड देयर इज प्रायर हिस्ट्री ऑफ डिस्चार्ज. तो आप अपने क्वेश्चंस में ध्यान रखिएगा. इफ दे टेल यू दैट द पेशेंट हैज गॉट हिस्ट्री ऑफ डिस्चार्ज, हिस्ट्री ऑफ परफोरेशन, नाउ डेवलप्स अ कोलेस्टेटोमा इनसाइड, आंसर इज सेकेंडरी एक्वायर्ड, क्योंकि द एपिथेलियम हैज माइग्रेटेड इनवर्ड्स थ्रू द प्री एक्जिस्टिंग परफोरेशन. इफ दे टेल यू दैट द पेशेंट हैज गॉट नो प्रायर हिस्ट्री ऑफ डिस्चार्ज, no history of perforation, still the patient has got an attic cholesteatoma, then the answer would be primary acquired cholesteatoma, which has happened because of a retraction pocket. Simple. ठीक है, तो ये हो गया हमारा what are the important theories of cholesteatoma and the importance of all of them. ठीक है, चले. So ये देखो, this is how, see this. Can you see this? This is your normal tympanic membrane and this is your attic. Attic में ये छेद बन गया. So this has happened after primary acquired cholesteatoma has happened. Primary acquired cholesteatoma में इतने सारा cholesteatoma flakes बन गए inside the invagination, inside the retraction pocket, कि बाद में it has burst out and it has created an attic perforation. So this is a case of primary acquired cholesteatoma. This I have already told you how to identify a congenital cholesteatoma and how it is different from tympanosclerosis. ठीक है, fine. चलो आगे बढ़े. अब आता है tuberculous otitis media. अगर आपके क्वेश्चन में कहीं पे भी देयर आर दी 6 P's दैट आर मेंशन्ड. 6 P का मतलब कोई भी अगर आपके पास इंडिविजुअल आया है हु हैव गॉट पेनलेस ओटोरिया, कोई पेन नहीं हो रहा, दे हैव गॉट मल्टीपल परफोरेशंस, मतलब एक नहीं बहुत सारे परफोरेशंस. तो परफोरेशंस आर मल्टीपल. The patient has pale granulation tissue. Tuberculosis is a granulomatous disease. So under you will see that यहाँ पे there will be pale granulations which are filled inside the middle ear compartment. The patient will have persistent discharge even antibiotics are given क्योंकि ये एक tuberculous etiology है. So the patient will not get better even after giving ciprofloxacin or any kind of ear drop. Still it is persisting. Tuberculosis is a granulomatous disease which will cause facial nerve paralysis also क्योंकि ये खाती है different areas. It will eat up the different areas, so there will be palsy of the face. And there will be progressive mixed hearing loss. They will also develop sensory neural hearing loss. 6P of tuberculous otitis media. Painless otorrhea, multiple perforations, pale granulations, persistent otorrhea. Painless persistent otorrhea even after giving antibiotics. Facial paralysis and progressive mixed hearing loss. ये 6P आए तो answer is tuberculous otitis media. What is the treatment for tuberculous otitis media? It is ATT, एंटी-ट्यूबरकुलर थेरेपी. ठीक है, चलो आगे बढ़े. अगर ईयर में कुछ भी सबसे ज्यादा पूछा जाता है तो वो है कॉम्प्लिकेशंस ऑफ CSOM एंड कॉक्लियर इम्प्लांट. इनमें सबसे ज्यादा क्वेश्चंस आते हैं. So now we are going to deal with the important complications of CSOM. Mark it as a 5-star question. If I ask you what is the most common complication of CSOM, answer is mastoiditis. Mastoiditis सबसे common inflammation and infection of the mastoid bone है, that is secondary to chronic otitis media. ठीक है? Now, what is the most common cause of mastoiditis? The most common cause or organism is Streptococcus pneumoniae. ठीक है? Now, how exactly are the signs of mastoiditis? और इसकी फोटो देख लेते हैं. तो अगर किसी के भी mastoiditis होती है तो देखो ये क्या है? This is a mastoid which is inflamed. ठीक है? So what are the signs of mastoiditis? Signs of mastoiditis are that you will see ironed out appearance. Ironed out मतलब ये red erythematous mastoid दिखेगा. ऐसे लग रहा है red and angry mastoid है, जैसे एक red hot iron होती है वैसा. ठीक है? Now, when this swelling will appear over the mastoid area, it will push the pinna downward and forward. देखो इसने नीचे कर दिया है पिन्ना को. So the pinna is pushed downward and forward. Downward and forward. That is the second point that we will notice. Third feature क्या है? अगर ये mastoid में इतनी swelling हो गई, so it will obliterate the retroauricular groove. ये जो groove है, it will become obliterated. So there is obliteration of retroauricular groove. That is the third feature. Right? Okay. Now, what else will you see over on mastoid? So next thing that you will see over on mastoid is that when you actually do otoscopy, जब आप otoscopy करेंगे, तो you will see a lighthouse sign. Lighthouse sign का क्या मतलब है? कि जब भी आप otoscopy करेंगे, through the perforation, pulsatile otorrhea will come out. Pulsatile मतलब आएगा जाएगा, आएगा जाएगा. So pulsatile otorrhea with ironed out appearance is a feature of what disease? It is a feature of mastoiditis. ठीक है? So there will be lighthouse sign, there will be ironed out appearance, there will be obliteration of retroauricular groove, and also you will notice that there is something called as reservoir sign. Reservoir sign का क्या मतलब है? That whenever you suction the discharge out, फिर से भर जाएगा. फिर आप सक्शन करेंगे वो फिर से भर जाएगा. फिर आप सक्शन करेंगे वो फिर से भर जाएगा. क्योंकि mastoid is a reservoir of pus. बस बहुत सारा mastoid में भरा हुआ है. So what will happen the moment you suction out the discharge, again it will start filling in. This is called as reservoir sign, which is also seen in cases of mastoiditis. ठीक है? अब एक और इंपॉर्टेंट चीज है which is sagging of posterior canal wall. ये आपका mastoid है, ये आपकी external auditory canal है. अगर इसमें बहुत सारा पस भर जाएगा तो what will happen? It will push the posterior canal wall anteriorly. This is called as sagging of the posterior canal wall. जब हम अंदर otoscopy करेंगे हमें दिखेगा कि external auditory canal bulged out है, अंदर की तरफ bulged है. And this is called as sagging of the posterior canal wall. So all of these signs are seen classically in cases of mastoiditis, which is the most common intratemporal complication of CS1. ठीक है? चलो आगे बढ़े. Now, second important thing that they ask is 3D. अगर कहीं पे भी 3D दिखे, 3D का मतलब discharge, diplopia and deep-seated retroorbital pain. This is a classical feature for Gradinego syndrome. Gradinego syndrome को हम लोग petrositis भी बोलते हैं. This lateral rectus palsy will be the reason for diplopia, which happens because of abducent nerve. So when the abducent nerve gets paralyzed, there is lateral rectus palsy in Gradinego syndrome, which is causing diplopia to happen. And deep-seated retroorbital pain is seen in cases of trigeminal involvement. So when the trigeminal nerve gets involved, then there will be deep-seated retroorbital pain as well. ठीक है, ये तीनों दिखे, D, 3D. Answer is Gradinego syndrome. ठीक है. अगर आपसे पूछा जाए what is the most common intracranial complication of CSOM, without a doubt it is meningitis. ठीक है. अब एक और बड़ा इंपॉर्टेंट क्वेश्चन, एक और बड़ी इंपॉर्टेंट कॉम्प्लिकेशन, लैटरल साइनस थ्रोम्बोसिस. ठीक है, तो ये हमारा हो गया मैस्टॉइड. दिस इज आवर मैस्टॉइड. इट इज कनेक्टेड टू आवर मिडल ईयर. In the posterior part of your mastoid is a very important sinus which is called as sigmoid sinus. Now in long-standing chronic inflammation of the middle ear या फिर long-standing middle ear diseases, होता क्या है that disease can erode this sigmoid sinus and it can form a thrombus inside the sigmoid sinus. If a thrombus is formed inside the sigmoid sinus, that is called as lateral sinus thrombosis या lateral sinus thrombophlebitis. अब इसका क्लासिकल फीचर क्या होता है? अगर आपको पेशेंट दिया गया that the patient has got ear discharge and इस पेशेंट के एक टाइप का फीवर आता है which is hectic picket fence. Hectic picket fence का क्या मतलब है? मतलब आता है जाता है, आता है जाता है, आता है जाता है. और ये क्यों होता है? Because if you see this particular thrombus which forms inside the sigmoid sinus, it is a septic thrombus. Septic मतलब इसके अंदर organisms multiply कर रहे हैं. ये थ्रोम्बस है बट इट कंटेन्स अ लॉट ऑफ ऑर्गेनिजम्स. तो क्या होता है, समटाइम्स दिस थ्रोम्बस ब्रेक्स अवे और ये सेप्टिक एम्बोलाई हमारी ब्लड स्ट्रीम में आ जाते हैं. तो जब भी ये सेप्टिक एम्बोलाई हमारी ब्लड स्ट्रीम में आएंगे, सडनली देयर विल बी अ स्पाइक ऑफ फीवर. जब ये चले जाएंगे द स्पाइक विल कम डाउन. फिर ये आएंगे, फिर देयर विल बी अ स्पाइक ऑफ फीवर. फिर चले जाएंगे, अगेन इट विल फॉल डाउन. सो व्हाट विल हैपन इन दिस पर्टिकुलर केस, इन केसेस ऑफ लैटरल साइनस थ्रोम्बोसिस, देयर विल बी हेक्टिक पिकेट फेंस फीवर. मतलब एक पिकेट फेंस की तरह आएगा जाएगा आएगा जाएगा आएगा जाएगा. Okay, now there is an important vein which connects your sigmoid sinus to the veins of the scalp. This vein is called as emissary vein. Emissary vein का मतलब क्या होता है? It is a one which connects our intracranial to extracranial compartment. तो scalp की veins को और sigmoid sinus के बीच में एक vein होती है that connects, is called as emissary vein. अगर ये septic thrombus जो अंदर बना हुआ है, it travels down into the emissary vein and blocks it. अगर इसको ब्लॉक कर दिया, then what will happen? There will be a lot of edema that will start developing over the post-oral area and over the occipital area. यहाँ पे खूब बड़ा सा एक edema हो जाएगा क्योंकि now the drainage is not happening through the emissary vein. And this is called as Grisinger's sign. Very, very important sign. Grisinger's sign. तो अगर आपको कभी भी ये साइन दिखा, इतना बड़ा सा एडिमा हो गया है किसी के भी, that is called as Grisinger's sign. And Grisinger's sign is a classical feature of lateral sinus thrombosis, which is nothing but it is edema over the post-oral area. That happens because of the blockage of emissary vein. Now, don't confuse this edema with ecchymosis. अगर आपको बाहर blue color की ecchymosis दिख रही है in the post-oral area, this ecchymosis is given the name as battle sign. And battle sign is a feature of basilar skull fractures. This is not a feature of lateral sinus thrombosis. Remember this. Okay? Fine. So this is something that is seen in basilar skull fractures, but this is a sign that is seen in cases of lateral sinus thrombosis. Okay? What are the next signs that is seen in lateral sinus thrombosis? So there is also something called as two important tests. एक होता है Tobey-Ayer test और एक होता है क्रॉई-बेक साइन. Tobey-Ayer test and क्रॉई-बेक साइन. अब इनके बारे में इंपॉर्टेंट है, ये आप लोग देख लो क्या होता है. तो as you know, our sigmoid sinus comes down and it forms the internal jugular vein. मतलब अगर कभी भी कोई थ्रोम्बस बन जाएगा सिग्मोइड में, it can travel down and block our internal jugular vein also. तो इन केसेस ऑफ लैटरल साइनस थ्रोम्बोसिस कभी कभी हमारी सिर्फ एक जुगुलर काम कर रही होती है, एक नहीं काम कर रही होती है. तो व्हाट हैपेंस इन केसेस ऑफ क्रॉई-बेक साइन? पहले मैं ये बताता हूं व्हाट इज क्रॉई-बेक साइन. क्रॉई-बेक साइन ये होता है कि एक तरफ अगर जुगुलर वेन ब्लॉक हो गई बिकॉज ऑफ द डिसेंडिंग थ्रोम्बस व्हिच हैज नाउ ब्लॉक्ड द इंटरनल जुगुलर वेन, इफ वी प्रेस ओवर द नॉर्मल साइड, अगर मैंने नॉर्मल इंटरनल जुगुलर को भी प्रेस कर दिया तो मेरी रेटिनल कंजेशन हो जाएगी. So suddenly when you do fundoscopy, you will see retinal congestion if you palpate or if you press over the normal internal jugular vein, क्योंकि opposite side की already blocked है. So it will cause venous congestion and that will lead to retinal congestion and you will see over on fundoscopy. So retinal congestion which is present over when you press the normal IJV, that is seen on fundoscopy and that is called as 𝐒𝐿-Beck sign to be positive. That is one feature, one sign which you see in lateral sinus thrombosis. दूसरा है टोबी आयर टेस्ट. टोबी आयर टेस्ट का मतलब क्या है? अगर मैं अपनी नॉर्मल जुगुलर वेन को दबाऊं तो मेरा सीएसएफ प्रेशर रेस करेगा और अगर मैं इसे छोड़ दूं तो मेरा सीएसएफ प्रेशर गिरेगा. In cases of this particular thrombosis, there is going, because it's already thrombosed, there is going to be a slow rise and a very slow fall. So इसमें क्या होता है? We press over the jugular and we check over the CSF pressures. In normal people, any person who has got a normal IJV, there could be a rapid rise and a rapid fall. But in cases of Toby IR test, that is found to be positive in cases of lateral sinus thrombosis क्योंकि इनकी IJV blocked है. So there is a very slow rise and slow fall of CSF when we press over the IJV. That are the important tests or important significant findings that you see in cases of lateral sinus thrombosis या फिर lateral sinus thrombophlebitis. ठीक, तो ये खत्म होता है about what is lateral sinus thrombosis और इसमें क्या क्या क्वेश्चन बनते हैं. चलो अब आ जाते हैं into very important outside abscess that are present over with CSOM. तो CSOM सिर्फ अंदर नहीं रहता, right? So let's say this is your middle ear. This is connected to your mastoid air cell system. And mastoid से जुड़ी होती हैं बहुत important muscles. One muscle is called as sternocleidomastoid. One muscle is our posterior belly of digastric. And इसके ऊपर एक muscle attach हो रही है which is our temporalis muscle. This is our temporalis muscle. Okay, now जब भी कोई भी मिडिल ईयर डिजीज होती है लाइक CSOM, that disease can spread over into the mastoid very easily. मतलब mastoid में खूब सारी ये डिजीज आएगी. Now which is the likable area in the mastoid to actually give away? सबसे पहले कौन सा एरिया टूटेगा? Which is under gravity. That means this area, the tip of the mastoid is very very weak. So in long standing cases of mastoiditis, this tip can break away and all the pus can travel down into the sternocleidomastoid sheath. यहाँ पे एक बड़ी सी एक abscess बन जाएगी. If there is an abscess which forms over the sternocleidomastoid sheath, what is that abscess called as? That is called as Bizold abscess. Simple. ठीक है? अब अगर ये mastoid से निकल के पस आ गया towards the posterior belly of digastric, then what will be? This digastric triangle will form an abscess. What is that called as? That is called as Sittel's abscess. अगर ये mastoid से पस ऊपर चला गया and it forms deep to the temporal muscle, that is called as a deep temporal abscess, also called as Lux abscess. And in some cases, अगर ये पस आके सामने आ गया towards the zygoma, here is your zygoma. If it comes in front of the zygoma, this was recently asked in your FMGE paper कि उन्होंने क्या दिखाया था? There is a long-standing case of CSOM and there is a huge bulge over in the zygomatic area. So zygomatic area में bulge मतलब zygomatic abscess है. So that is zygomatic abscess. Okay, that is zygomatic abscess. These are the four most important extratemporal, extracranial complications of CSOM जिसमें पस बाहर आ जाता है अपने कैविटी से and it starts spreading into other areas. ठीक है, तो याद रखना Bizold, SCM, Lux, deep temporal abscess, Sittel's, digastric triangle and zygoma के पास आई तो zygomatic abscess. ठीक है, चलो आगे बढ़े. अब फेशियल नर्व से रिलेटेड सारे क्वेश्चन इस बॉक्स में मैंने लगा दिए. इससे पहले मैं आपको एक छोटी सी एक आइडिया दे देता हूं अबाउट फेशियल नर्व कोर्स क्योंकि ये इंपॉर्टेंट क्वेश्चन है. लेट्स से ये हमारा मिड ब्रेन है, ये पॉन्स है एंड दिस इज योर मेडुला, राइट? दिस इज योर इंटरनल अकूस्टिक मियाटस. लेट्स से दिस इज इंटरनल अकूस्टिक मियाटस एंड दिस इज आवर मिडिल ईयर. दिस इज आवर मिडिल ईयर का डब्बा, द बॉक्स ऑफ द मिडिल ईयर. ओके, now this is the roof of middle ear, this is floor of middle ear, ये side anterior है, so this is anterior wall and this is posterior wall of middle ear. ठीक है, अब इसको हम लोग एक बार समझ लेते हैं. What you are seeing in this area, this is the medial wall of middle ear क्योंकि lateral wall आपकी तरफ है and I have taken it out. Lateral wall of the middle ear is our tympanic membrane, मैंने उसे खोल दिया है. I am seeing the medial wall of the middle ear over here. That means over the medial wall of the middle ear there is a projection which is called as promontory. Posterior superior to the promontory is oval window, posterior inferiorly is round window. This is over in our medial wall of middle ear. ठीक है? Facial nerve has got 4 important nucleus. 4 न्यूक्लियस होते हैं फेशियल नर्व के, 2 मोटर 2 सेंसरी. Facial nerve comes out of the brain stem and then it enters into the internal acoustic canal. After it goes into the internal acoustic canal, from here now it goes to the roof of the middle ear. When it reaches the roof of the middle ear, it forms a ganglion over here और इसको हम लोग कहते हैं geniculate ganglion. Geniculate ganglion, which is formed over at the roof of the middle ear. Now from here, from this geniculate ganglion, this facial nerve takes a turn. अब ये turn लेगी and now it will come at the junction of the posterior and medial wall of the middle ear. देखो, ठीक है? Now, here, at this point, there is also another thing which is present over here, and this particular structure that is present over in the medial wall, यहीं पे ही, this is lateral semicircular canal. यहीं पे ही medial wall में एक और important structure होता है which is lateral semicircular canal. Now what happens is when this particular facial nerve takes its first turn, इस particular part को कहते हैं first genu. Genu का मतलब होता है bent knee. जैसे कोई ऐसे knee को bend कर देगा, right? So that is called as genum. Genum का मतलब bent knee या genu. So first genu is formed just when the geniculate ganglion finishes. Now the facial nerve will come and it will come between the lateral semicircular canal and oval window. This place where it is taking its second turn, yes, second turn is happening between the lateral canal and oval window. This second turn is called as second genu. Now it will come down and it will come down till the level of a very important structure which is present up till the pyramid. और ये एक triangular projection है जो present है over in our posterior wall of middle ear. We call this triangular projection as pyramid. ठीक है? तो पिरामिड तक ये आई एंड पिरामिड के बाद फाइनली अब ये बाहर निकल गई थ्रू द स्टाइलोमास्टोइड फोरामेन इनटू द फेस. तो मैंने आपको क्या बताया? मैंने आपको ये बताया कि आपकी पूरी की पूरी फेशियल नर्व डिवाइडेड है डिफरेंट सेगमेंट्स में. द फर्स्ट कोर्स ऑफ द फेशियल नर्व इज फ्रॉम द पॉन्स अप टिल इंटरनल अकूस्टिक कैनल. इस पर्टिकुलर पार्ट को वी कॉल इट एज इंट्राक्रेनियल सेगमेंट. Intracranial part of this particular nerve is round about 17 millimeters. Okay. Now let's come to the other segment. अब क्या हो गई? Now this facial nerve will come inside the internal acoustic meatus. When the facial nerve enters inside the internal acoustic meatus, we call it as meatal segment. तो ये हो गया हमारा meatal segment. Meatal segment is 8 millimeters long. तो ये 8 millimeters का है. Then the facial nerve exits the internal acoustic meatus and goes up till the geniculate ganglion. इस particular segment को हम कहते हैं labyrinthine segment and this is half of 8. मतलब ये हो गया 4 millimeters का. This is also the narrowest segment of the facial nerve, only 0.64 to 0.68 millimeters in diameter. ठीक है? So ये हो गया 0.64 to 68 millimeters in diameter. मतलब ये मेरा narrowest segment of facial nerve है. ठीक है? और ये 4 millimeter का है, just half of the meatal segment. That is the third segment what I have told you. Now from the geniculate ganglion up till the pyramid, ये एक type का horizontal है. It's forming like a horizontal. ये horizontal लग रही है. That is why this segment is called as horizontal segment या tympanic segment of facial nerve. What is one important landmark or intraoperative landmark to identify horizontal segment of facial nerve? Horizontal segment of facial nerve के just नीचे एक C-shaped projection होता है. C-shaped projection. And this C-shaped projection से C for cochleariformis याद रख सकते हैं. So there is something called as processus cochleariformis, which is present in the medial wall of middle ear, जिसके just ऊपर horizontal या tympanic segment of facial nerve मिलता है. This is a very important classifying feature कि ये यहाँ पे present है. ठीक है? Now, second genu किसके बीच में है? Second genu is between the lateral semicircular canal and the oval window. So the surgical landmark for finding out the second genu is lateral semicircular canal. उसी के just आगे होगा. Just in front of the lateral canal is our facial nerve, second genu, जहाँ पे bend हो रहा है. Right? Then comes the pyramid. Pyramid के बाद, जब pyramid खत्म हो गया, pyramid के बाद this particular facial nerve is called as vertical segment of facial nerve. Okay, then that is called as vertical segment of the facial nerve. The horizontal segment of the facial nerve is 11 millimeters This is roughly around 13 millimeters. This is the whole story behind the course. ठीक है, अब अगर आपसे ये पूछा जाए, ये हो गए हमारे सारे के सारे इंपॉर्टेंट सेगमेंट्स और उनसे रिलेटेड क्वेश्चंस। अगर मैं आपसे ये पूछूं कि मोस्ट कॉमन साइट ऑफ कंजेनाइटल डेहिसेंस ऑफ फेशियल नर्व कौन सी है, मतलब कंजेनाइटली फेशियल नर्व सबसे ज्यादा डेहिसेंट कहां होगी, क्योंकि पूरी फेशियल नर्व इज इनसाइड अ बोन, ये पूरी फेशियल नर्व एक बोन कवर कर रही है इस पूरी फेशियल नर्व को, and the bone which is covering this whole facial nerve is called as fallopian canal. So in some cases of children, this fallopian canal might be absent over the facial nerve, which is called as congenital dehiscence. Most common area for congenital dehiscence of facial nerve is in the horizontal या tympanic segment. यहां पे सबसे ज्यादा dehiscence दिखती है। ये आ गया straight A question. अब आते हैं दूसरे क्वेश्चन पे। Most common area to get involved in Bell's palsy and Ramsay-Hunt syndrome is what? Is the narrowest segment of the facial nerve, which is labyrinthine segment. तो सबसे जल्दी कंप्रेस कौन सा सेगमेंट होगा किसी भी डिजीज में? लैब्रिंथाइन सेगमेंट, क्योंकि ये नैरोएस्ट होता है, इसका डायमीटर 0.64 to 0.68 मिलीमीटर ही है। तो दिस इज गोइंग टू बी इन्वॉल्व्ड मोस्ट कॉमनली इन बेल्स पैल्सी एंड रामसे-हंट सिंड्रोम। अब आ जाते हैं थर्ड इंपॉर्टेंट क्वेश्चन पे। मोस्ट कॉमन एरिया टू गेट इंजर्ड इन मैस्टोइडेक्टमी इज, तो जब भी हम मैस्टोइडेक्टमी करते हैं, अब देखो मैस्टोइड पीछे, यहां पे है मैस्टोइड पोस्टीरियर वॉल के पीछे, जब भी हम यहां से मैस्टोइडेक्टमी करते हैं, द लाइकेबल एरिया वेयर इट कैन गेट इंजर्ड इज द सेकंड जेनु, और द सेकंड एरिया व्हिच कैन एक्चुअली गेट इंजर्ड इज दिस वर्टिकल सेगमेंट ऑफ फेशियल नर्व, क्योंकि इसी के अंदर रन कर रही है, इट्स रनिंग लाइक दिस, राइट? सो द मोस्ट कॉमन साइट ऑफ इंजरी, अगर मैं आपसे पूछूं, इट इज सेकंड जेनु, इट इज सेकंड जेनु, सेकंड जेनु इज द फर्स्ट मोस्ट कॉमन एरिया, second most common area is the vertical segment of facial nerve for iatrogenic palsy. It is vertical segment for facial nerve. ठीक है, तो ये क्वेश्चन बन गए हमारे सारे के सारे फ्रॉम द फेशियल नर्व, राइट, अबाउट व्हाटएवर यू नीड टू नो। नाउ मियाटल सेगमेंट और लैब्रिंथाइन सेगमेंट, ये दोनों सेगमेंट्स को सप्लाई करती है एक आर्टरी विच इज कॉल्ड एज लैब्रिंथाइन आर्टरी। दिस इज कॉल्ड एज लैब्रिंथाइन आर्टरी। दिस इज सप्लाइड फ्रॉम, this is a supply for the first two segments. The third segment, or this segment, the horizontal segment, is the one which is supplied by superior petrosal artery. And finally, जब ये stylomastoid foramen से निकल जाती है, तो stylomastoid मतलब stylomastoid artery. So stylomastoid artery is going to supply the stylomastoid foramen जब ये exit करेगी. So this is about what is the importance of, you know, what are the questions that come in facial nerve and how you identify the course of the facial nerve. ठीक है, चलो अब आते हैं इंपॉर्टेंट सिंड्रोम्स पे। ये बहुत इंपॉर्टेंट है। अगर मैं आपसे पूछूं मोस्ट कॉमन कॉज ऑफ फेशियल पैल्सी इज बेल्स पैल्सी, आंसर है। एक क्वेश्चन आता है व्हाट इज मिलर्ड गुबलर सिंड्रोम। मिलर्ड गुबलर, मिलर्ड में LA आ रहा है, LAR आ रहा है, तो आई कैन से लैटरल रेक्टस, इसी के नेम में ही देयर इज लैटरल रेक्टस। तो इफ द पेशेंट डेवलप्स फेशियल पैल्सी with ipsilateral lateral rectus palsy and contralateral hemiplegia, then that is called as Millard-Gubler syndrome. अब एक और इंपॉर्टेंट पॉइंट, अगर आपने किसी पेशेंट के देखा कि उसकी टंग में बहुत सारे फिशर्स हैं, बड़े बड़े फिशर्स हैं टंग में, उसकी लिप्स बहुत बड़ी एडिमा हो गई है, बड़ी सी एडिमाटस उसकी लिप्स हैं, बहुत सारे फिशर्स हैं टंग पे, एंड उसके फेशियल पैल्सी है, तो फेशियल पैल्सी, एडिमा ऑफ लिप्स एंड फिशर टंग इज कॉल्ड एज मेलकर्सन-रोजेंथल सिंड्रोम। आइनाइसेट में सिंड्रोम आते हैं, तभी आई एम कवरिंग अप सिंड्रोम्स अ लिटिल बिट मोर। नाउ कम्स द नेक्स्ट इंपॉर्टेंट थिंग इज हीरफोर्ड सिंड्रोम। हीरफोर्ड सिंड्रोम में ये दिखता है मोस्टली इन केसेस ऑफ सार्कोइडोसिस। इसमें क्या दिखता है? देयर इज बायलैटरल पेरोटिड एनलार्जमेंट, दोनों तरफ के पेरोटिड बड़े बड़े हो जाते हैं, देयर इज फेशियल पैरालिसिस एंड एट द सेम टाइम देयर इज यूवीआइटिस। So if you see bilateral parotid enlargement, facial palsy and uveitis, then it's called as Hereford syndrome. अब एक इंपॉर्टेंट और सिंड्रोम आता है, किसी इंसान के पेरोटिडेक्टमी हुई, वो घर गया, कुछ महीने के बाद आया और वो ये कहता है कि जब भी मैं खाना खाता हूं मेरे इसी साइड से स्वेटिंग होती है। That means the patient is having gustatory sweating. If the patient has gustatory sweating, the answer is Fraze syndrome. तो ऑलवेज रिमेंबर दीज इंपॉर्टेंट सिंड्रोम, ये बहुत इंपॉर्टेंट है, ये सर्जरी में भी पूछा जाता है कि अगर किसी की पेरोटिडेक्टमी हो गई तो क्या हो रहा है। नाउ व्हाट हैपेंस इज देयर आर सर्टेन फाइबर्स ऑफ द ऑरिकुलोटेम्पोरल नर्व्स व्हिच बिकम एबरेंट, ये इधर उधर कूदने लगते हैं एंड दे गो एंड स्टार्ट सप्लाइंग द स्वेट ग्लैंड्स। So parasympathetic supply is diverted towards the sweat glands, and what happens whenever the patient starts eating, there is sweating that starts over on the ipsilateral half of the face. That is called as Fraze syndrome. ठीक है, अब आपसे एक क्वेश्चन और पूछा गया था इन सर्जरी विच इज कॉमन टू ईएनटी, इस फ्रेज सिंड्रोम आप कैसे ठीक करेंगे? तो फ्रेज सिंड्रोम जनरली वी डू समथिंग कॉल्ड एज बोटॉक्स इंजेक्शन या फिर सिंपली बॉटुलिनम टॉक्सिन इंजेक्शन. सो यहीं पे हम बॉटुलिनम टॉक्सिन लगा देते हैं. दैट विल डिक्रीज द स्वेटिंग और दैट विल डिक्रीज द एरिया एंड दैट विल नंब द एरिया एंड द पेशेंट विल बिकम बेटर विद दैट. ठीक है, फाइन. तो दिस इज समथिंग दैट इज रिक्वायर्ड फॉर फेशियल नर्व. चलो आगे बढ़ते हैं. Now let's come to another hi-fi topic जो बड़ा commonly इनसे पूछा जाता है, that is about otosclerosis. Otosclerosis से straight forward 2-3 क्वेश्चन जो पूछे जाएंगे वो मैं आप लोगों को बता देता हूं. Otosclerosis पहली चीज तो क्या है? Otosclerosis means कि there is an extra bone which is getting formed over the stapes which is fixing the stapes. ठीक है? तो otosclerosis is a disease of the otic capsule. क्योंकि otic capsule is the one which is forming the stapes foot plate. Right? Okay? So, now, whenever there is otosclerosis, whenever otosclerosis forms, there are two stages of otosclerosis. The first stage of otosclerosis is called as active stage, and the second stage is called as inactive stage. Active stage of otosclerosis का मतलब है here the bone resorption is more. इसमें bone resorb होती जा रही है stapes के ऊपर से. There is proliferation of cartilaginous islands which is taking place. So what is going to happen in the first stage? In the first stage, when the bone resorption is more, the bone resorption जब ज्यादा होता है, there are new vessels which are getting formed. Now new vessel formation जब भी होता है, it will shine through the normal tympanic membrane. So जब भी in the earlier stages or in the active stages of otosclerosis, when there is higher chances of bone resorption, new vessels are getting formed, they shine through the posterior superior quadrant. So देखो, this is our posterior superior quadrant and it is shining. It is a reddish hue which is coming through the posterior superior quadrant. If you see that there is in the posterior superior quadrant is reddish, this is called as a flamingo pink sign, also called as Schwartz sign. So either you call it as a Schwartz sign or you call it as flamingo pink sign. This is seen in the cases of active otosclerosis. ठीक है, अब active otosclerosis में जिसमें short sign दिखेगा या flamingo pink sign दिखेगा, this short sign or flamingo pink sign will become absent in inactive stage. Inactive stage में क्या होता है? Sclerosis happens. तो पहले there is bone resorption, जब bone टूटती है around the otic capsule, तो let's say this is your stapes, तो पहले क्या होगा? There will be bone resorption. इस एरिया की bone टूटेगी. जब इसकी बोन टूट जाएगी, there will be resorption. तब क्या होगा? There will be new bone which will start forming in this area. If a new bone will form in this area, it will make the stapes fixed. ठीक है? So that is the reason why active stage में resorption ज्यादा है, vessels ज्यादा बनती हैं. That is why you see Schwartz sign only in the active stage. जब new bone formation हो जाता है, तब ये चीज absent हो जाती है. Then that resorption, then vascularity also decreases. That is why Schwartz sign is only seen in cases of active otosclerosis. मेरा क्वेश्चन ये है कि अगर आपको शॉर्ट साइन पॉजिटिव दिया गया और आपसे पूछा गया व्हाट इज द ट्रीटमेंट यू आर गोइंग टू गिव इन द पेशेंट, तो इन शॉर्ट साइन पॉजिटिव ओटोस्क्लेरोसिस, दैट मींस इन द एक्टिव स्टेज ऑफ ओटोस्क्लेरोसिस, हम स्टेपिडोटमी नहीं करते. दैट टाइम वी गिव द ड्रग ऑफ चॉइस इज सोडियम फ्लोराइड. द ड्रग ऑफ चॉइस इज सोडियम फ्लोराइड व्हिच इज गिवन एज अ ड्रग ऑफ चॉइस इन केसेस ऑफ एक्टिव स्टेजेस. जब इनएक्टिव हो जाती है ओटोस्क्लेरोसिस, व्हेन इट बिकम्स इनएक्टिव, दैट मींस नाउ द मैच्योर्ड फोकस हैज फॉर्म्ड. अब स्टेपीज फिक्स हो चुकी है, अब हमें इसको हटाना है एंड वी हैव टू मेक अ होल इनसाइड द स्टेपीज फुट प्लेट सो दैट इट कैन मूव. दैट केस इन इनएक्टिव स्टेज वी डू अ प्रोसीजर व्हिच इज कॉल्ड एज स्टेपिडोटोमी. स्टेपिडोटमी. अब ये इंपॉर्टेंट एक इमेज देख लो, ये इंपॉर्टेंट इमेज बेस्ड क्वेश्चन है, राइट? व्हाट आर यू सीइंग ओवर हियर? This, what you see over here, this thing, what is going inside, what the surgeon is placing, this thing looks like actually this. This is called as a stapes piston. This is called as stapes piston. So whenever you see someone putting something white like a hook, तो वो क्या है? This is the stapes piston and the person is performing a stepidotomy. Very, very important question. ठीक है? Fine? चलो, अब आगे बढ़ते हैं. Now, one important more question is, what is the most common site of stepidotomy? most common site for otosclerosis. Most common site for otosclerosis is called fistula antifenestrum. या फिर we also call it as anterior focus. So you know there are two crura of the stapes. दो crura होते हैं, anterior crus, posterior crus. If there is any foci which forms at the anterior crus, तब हम उसे बोलेंगे fistula antifenestrum. तो या तो इसको fistula antifenestrum बोल दो या फिर इसे anterior crus बोल दो. It's the same thing. But the most common site for otosclerosis is this site, anterior crus या fistula antifenestrum. So Vinay Prakash is saying, okay, thank you. Great. चलो अभी बहुत आगे जाना है. So we have to keep finishing about a lot of things inside this. Right now, this is the classification for otosclerosis, right? So otosclerosis can be of two types. One is called as stapedial otosclerosis. One is called as cochlear otosclerosis. So stapedial का मतलब the most common otosclerosis which happens is at the stapes foot plate. अगर वो चली गई advance हो गई into the cochlea, we will call it as far advanced otosclerosis. So if there is involvement of the stapes foot plate only, then we call it as stapedial otosclerosis. If it involves the cochlea, we call it far advanced otosclerosis. What are the types of stapedial otosclerosis? The first type is the anterior focus. मैंने बताया था, this is anterior crus, this is posterior crus, this is neck of stapes, this is foot plate of stapes. अगर सिर्फ anterior crus के पास बनी, this is called as anterior crus, this is the area which is called as anterior focus. Most common, इसे हम fistula antifenestrum भी कहते हैं. If there is a otosclerotic foci which forms on the posterior side, we call it as posterior focus. If we see that now the whole otosclerotic foci is around the stapes foot plate. Around का मतलब ये समझो that now see this is your anterior crus, this is posterior crus, this is the foot plate. Now there is a ligament which is present around the foot plate of stapes, and this ligament of the foot plate of stapes, this is called as annular ligament. This is called as annular ligament. If the stapedial otosclerosis involves only the annular ligament and not the base of the foot plate, देखो ये सिर्फ annulus के around है, सिर्फ annular ligament के around है, it is not over the foot plate of the stapes. That means it is around the circumference. The foot plate of the stapes is spared. ये सिर्फ circumference पे है, that is why we call it as circumferential. ठीक है? Next type. अगर next type में ये हुआ कि आपका annular ligament is spared, but the stapedial otosclerosis is only in the center of the foot plate. देखो सिर्फ center of foot plate पे है, annular ligament that is present around the foot plate is spared. We will call this as biscuit type. ये ऐसे लग रहा है biscuit की तरह. और अगर सब कुछ चला गया, you cannot see the foot plate at all, which is the worst type, we call this as obliterative otosclerosis. ठीक है? So this finishes about what are the different types of stapedial otosclerosis. I told you, अगर ये stapedial otosclerosis goes into the cochlea, we call it far advanced otosclerosis. ठीक है? चलो आगे बढ़ते हैं. Now let's come to the next. Ototoxicity. Ototoxicity में आपसे क्या पूछा जाएगा? What are the drugs that cause ototoxicity? Drugs of ototoxicity के लिए सबसे important drugs मैंने आपको mention कर दिए हैं. Mnemonic है A, C, D. You can write down A, B, C, D. मैं आपको B भी बता देता हूँ. The first and foremost and the most important drug which is causing ototoxicity are aminoglycosides. Aminoglycosides can be cochleotoxic and vestibulotoxic drugs. अब ये important question आता है, which among the following are cochleotoxic? Which among the following is a vestibulotoxic drug? या all of the following are cochleotoxic except. So remember the mnemonic कान. कान पढ़ रहे हैं तो कान हो गया हमारा mnemonic. Cochleotoxic का मतलब सिर्फ कॉक्लिया जो डैमेज करे. तो कान में K is kanamycin, amikacin, neomycin. ये हो गया हमारे cochleotoxic drug. When it comes to vestibulo, मतलब vestibule and semicircular canal, जो भी हमारा balance है उसको बिगाड़ रहे हैं. In that case, the mnemonic is no GST. N for nettlemycin, gentamicin, streptomycin and tobramycin. सारे mycin. तो ये हो गया हमारा no GST. That are vestibulotoxic drugs. ठीक है? अब Second A is analgesic. Analgesics में सबसे common analgesic is aspirin. Everybody uses Disprin tablets. Third A is antimalarial. Most common antimalarial to cause sensorineural hearing loss is quinine. ठीक है? अब इसमें B भी ऐड कर लो, एक B ऐड कर लो. B is for beta blocker. So ABCD you can remember. Beta blocker में सबसे common is practolol, labetalol. So labetalol, practalol, propranolol, they are very common beta blockers which cause sensorineural hearing loss. Next, C, दो C important, cytotoxic drugs. Cytotoxic का मतलब chemotherapy drugs. Most common chemotherapy drug, cisplatin. Second, chelating drugs. Chelating मतलब these are iron chelators. These are very commonly given in cases of iron toxicity. तो आयरन जो किलेट कर दे, मतलब आयरन को जो डिक्रीज करे बॉडी में, दे आर आयरन किलेटिंग ड्रग्स. ड्रग ऑफ चॉइस फॉर आयरन पॉइजनिंग इज डेस्फेरिऑक्सिमीन. और फाइनली डी फॉर डायूरेटिक. सबसे कॉमन डायूरेटिक टू कॉज ओटोटॉक्सिसिटी, फ्यूरोसमाइड. तो ये याद करने वाली चीज है, राइट, अबाउट व्हाट आर दी ओटोटॉक्सिक एजेंट्स. बट ये सबसे इंपॉर्टेंट ड्रग्स हैं विच कैन कम इन योर वाइवर्स. एंड व्हाट डू दे डू, अगर ये आपके लॉन्ग टर्म के लिए देते हैं, दे विल लीड टू हाई फ्रीक्वेंसी सेंसोरी न्यूरल हियरिंग लॉस. मतलब हायर फ्रीक्वेंसीज पे हमारा सेंसरी न्यूरल हियरिंग लॉस दिखेगा इफ यू गिव एनी काइंड ऑफ ओटोटॉक्सिक ड्रग. ठीक है, चलो आगे बढ़े. अब आ जाता है ये प्रीवियस INICET का क्वेश्चन था. अगर आपको कहीं पे भी आपके क्वेश्चन में ये दिखता है that there is a person and usually a young person who develops sudden change or sudden rotatory vertigo. देखना, rotatory vertigo मतलब सब कुछ घूमेगा. So if a person develops rotatory vertigo with nausea, with vomiting, and the vertigo lasts only for a few seconds to 1 or 2 minutes, that vertigo is seen mostly on positional change. Answer is BPPV. BPPV का vertigo 2-3 मिनट से ज्यादा का नहीं होता. So remember the question. जब भी rotatory vertigo देंगे, they will tell you that it is on certain positional change, जैसे right की तरफ मुड़ा, left की तरफ मुड़ा. They will tell you about कि इससे associated nausea vomiting है, and there is no hearing loss, there is no oral complaint, कुछ नहीं, सिर्फ rotation हो रहा है and on positional change. Answer is BPPV. Now, benign paroxysmal positional vertigo happens because of the otoconial debris. Now, there are certain debris which are present over in the otolithic organs like utricle and saccule. हमारी utricle and saccule के अंदर there are certain otolithic or otoconia, कुछ टाइप के stone like things होती हैं which are called as otoconia. अब ये ओटोकोनिया वेस्टिब्यूल में रहने चाहिए, बट अगर ये बाहर निकल गए एंड दे फ्रीली स्टार्ट फ्लोटिंग इन आवर सेमीसर्कुलर कैनाल्स, तो होता क्या है, दैट चेंज द फ्लूइड डायनेमिक्स इनसाइड आवर सेमीसर्कुलर कैनाल्स एंड दैट लीड्स टू रोटेशन. So the most common canal to get affected in BPPV is what canal? It is posterior semicircular canal. Posterior semicircular canal is the one which is most commonly affected due to gravity. सबसे commonly यही effect होती है. अब दो important question. BPPV को डायग्नोज करने के लिए कौन सा मैनूवर करते हैं? डिक्स-हॉल-पाइक मैनूवर. BPPV को ट्रीट किस मैनूवर से करते हैं? एप्लीज मैनूवर. इसे हम लोग कैनाल रिपोजिशनिंग मैनूवर भी कहते हैं. तो या तो कैनाल रिपोजिशनिंग मैनूवर बोलेंगे या एप्लीज बोलेंगे. दैट इज द ट्रीटमेंट. डायग्नोसिस इज बाय डिक्स-हॉल-पाइक मैनूवर. बस दीज आर द इंपॉर्टेंट क्वेश्चंस रिलेटेड टू BPPV. ठीक है, चलो अब आया एक और इंपॉर्टेंट पॉइंट, सडन सेंसोरी न्यूरल हियरिंग लॉस. रूल ऑफ 3. अगर आपके क्वेश्चन में यह लिखा हुआ है that there is a young person who has come to your clinic and that particular person has got sudden hearing loss which has happened within 3 days, you do a pure tone audiometry, you find more than 30 decibel loss at 3 frequencies, तो उसे हम क्या बोलेंगे? sudden sensory neural hearing loss. यानी कि this is a loss in which occurs within 72 hours, यानी 3 दिन के अंदर. पहला 3. दूसरा, this occurs for more than 30 decibels and at least in 3 continuous frequencies. Continuous का मतलब 500, 1000, 2000, 1000, 2000, 4000. तो मतलब 3 continuous frequency पे अगर 30 decibel से ज्यादा का आपको लॉस दिख रहा है and that is within 3 days of time, so obviously that answer will become sudden sensory neural hearing loss. What are the causes of sudden sensory neural hearing loss? ITQ. मतलब तीन इंपॉर्टेंट T है और एक इंपॉर्टेंट I है. If I ask you what is the most common cause of sudden sensory neural hearing loss, most common cause is idiopathic. अभी भी हमें नहीं पता चला है, but it has found to be associated by post viral infections जैसे कि mumps, herpes simplex virus, cytomegalovirus, influenza. These are the viral infections where this particular thing has been proposed or seen. The other 3 T are trauma, जैसे कोई टेम्पोरल बोन में फ्रैक्चर हो गया, टेम्पोरल बोन टूट गई, या फिर किसी के ट्यूमर हो गया जैसे कि वेस्टिबुलर शोनोमा which is occurring over the vestibulocochlear nerve. Suddenly somebody has taken some ototoxic drugs जो हमने देखे थे, that is toxin, right? क्वेश्चन ये आता है कि अगर आपके पास कोई भी सेंसोरी न्यूरल हियरिंग लॉस का पेशेंट आया है विच इज सडन, तो आप उसमें क्या करेंगे? द मैनेजमेंट ऑफ चॉइस इज ऑलवेज एंटीवायरल एंड स्टेरॉइड। तो ड्रग ऑफ चॉइस हमेशा स्टेरॉइड होता है। स्टेरॉइड क्यों? क्योंकि स्टेरॉइड रिड्यूसेस इन्फ्लेमेशन। तो स्टेरॉइड इज नर्व सेविंग, ये सडनली वेस्टिबुलोकॉक्लियर नर्व के ऊपर से इन्फ्लेमेशन हटाएगा, एंड दैट स्टेरॉइड कैन बी गिवन ओरल, इट कैन बी गिवन इंट्रावीनस, इट कैन बी गिवन इंट्राटिम्पैनिक, किसी भी तरीके से हम दे सकते हैं, बट द ड्रग ऑफ चॉइस फॉर दीज इन्फेक्शन फॉर दिस पर्टिकुलर कंडीशन इज स्टेरॉइड। ठीक, अब next thing that we can give is an antiviral drug which is also acyclovir. Why? Because most of the infections are viral, जिसकी वजह से यह हो रहा है। एक और नई चीज आई है जिसको हम लोगों ने देना शुरू किया है, विच इज हाइपरबारिक ऑक्सीजन थेरेपी। हाइपरबारिक ऑक्सीजन का मतलब क्या है? हाइपरबारिक मतलब प्रेशर के अंदर ऑक्सीजन देना। तो इसमें क्या करते हैं हम लोग? पेशेंट को लिटा देते हैं इन अ चेंबर, एंड इन दैट चेंबर वी गिव 100% ऑक्सीजन एट 2.4 एटमॉस्फेरिक प्रेशर। मतलब 2.4 एटमॉस्फेरिक प्रेशर, काफी सारे प्रेशर पे हम 100% ऑक्सीजन पंप करते हैं बॉडी में, एंड वी यूजुअली गिव अ साइकिल ऑफ 90 मिनट्स। तो दिस वी डू अंडर प्रेशर, जिसमें एक चेंबर के अंदर पेशेंट के बहुत सारा ऑक्सीजन जा रहा है। सो इफ द ऑक्सीजन गेट्स सप्लाइड टू द वेस्टिबुलोकॉक्लियर नर्व, देन द इन्फ्लेमेशन आल्सो स्टार्ट्स टू रिड्यूस, राइट? सो दिस इज समथिंग व्हिच इज कॉल्ड एज हाइपरबारिक ऑक्सीजन थेरेपी। ठीक है, चलो उसके अलावा एक और चीज दे सकते हैं विच इज कॉल्ड एज कार्बोजेन। कार्बोजेन का क्या मतलब होता है कि हम पेशेंट को बिठा देते हैं और उसको हम लोग 95% ऑक्सीजन और 5% कार्बन डाइऑक्साइड भी सुंघाते हैं। तो वी गिव 5% कार्बन डाइऑक्साइड ऑल्सो। अब आपका क्वेश्चन है हम कार्बन डाइऑक्साइड क्यों देंगे? तो कार्बन डाइऑक्साइड एक्ट्स एज अ वेजोडाइलेटर। जब भी हमारे अंदर कार्बन डाइऑक्साइड जाता है, हमारी वेसल्स नॉर्मली एक्सपैंड करती हैं ताकि हम ज्यादा से ज्यादा ऑक्सीजन डिलीवरी कर सकें। तो कार्बन डाइऑक्साइड इज अ वेजोडाइलेटर and oxygen reverses hypoxia. So these are the two ways in which we decrease nerve injury. ठीक है? So this is something which is commonly done as far as sudden sensory neural hearing loss is concerned. चलो अब आ जाते हैं into a recent ad. Recent addition अभी जो हुआ है in INICET is ये important question आया है, which is superior semicircular canal syndrome. मैं आपको इसके बारे में ज्यादा नहीं बताऊंगा, मैं आपको इसका एक CT बताऊंगा क्योंकि CT पूछा गया। अब इसको सीधी तरीके से समझो कि यह है क्या। अगर आपको कभी भी किसी भी सीटी स्कैन में आपको एक सी बना दिख गया, अगर आपको ये सी दिख रहा है, ये एक सी है, लेकिन ये सी ऊपर से टूटा हुआ है। इसमें देखो ये सी जो है ये ऊपर से टूटा हुआ है, दैट मींस दिस इज द सेमी सर्कुलर कैनाल, क्योंकि सेमी सर्कुलर कैनाल सी शेप्ड होती है, एंड दिस सेमी सर्कुलर कैनाल हैज लॉस्ट इट्स बोन अबव, दैट मींस इट इज डेहिसेंट। तो दिस इज सुपीरियर सेमीसर्कुलर कैनाल डेहिसेंस। तो होता क्या है इन सुपीरियर सेमीसर्कुलर डेहिसेंस? दैट व्हेनेवर अ पेशेंट इज हियरिंग, so the patient will develop hearing and now suddenly the sound will also go through this window and it will disappear. ये एक एक्स्ट्रा विंडो बन गई है जिसके थ्रू साउंड जो है पूरी तरीके से कॉक्लिया में चल नहीं पाता, इट डिसअपियर्स, क्योंकि ऑब्वियसली ये एक नई विंडो बनी है। दिस इज कॉल्ड एज अ थर्ड विंडो फिनोमिनन। थर्ड विंडो फिनोमिनन। तो अगर किसी के भी सुपीरियर सेमी सर्कुलर कैनाल डेहिसेंस होती है तो उसकी एक नई विंडो बन जाती है विच इज कॉल्ड एज अ थर्ड विंडो इफेक्ट। ये देखो यहां पे थर्ड विंडो बन चुकी है। तो कोई भी साउंड आएगा, इट विल गो इनटू द मिडल ईयर, देन इट विल गो टू द इनर ईयर एंड इट विल एक्सीडेंटली शटल थ्रू दिस थर्ड विंडो एंड डिसअपियर। एंड दैट इज द रीजन ऑल दीज पेशेंट्स डेवलप अ ट्रायड ऑफ सिम्टम्स। और ट्रायड क्या होता है? दे डेवलप कंडक्टिव हियरिंग लॉस, एपिसोडिक वर्टिगो एंड ऑटोफोनी। तो अगर कोई भी इंसान में आपको यह क्वेश्चन दिखता है कि उस इंसान को हियरिंग लॉस हो रही है, चक्कर आ रहे हैं, क्योंकि ऑब्वियसली दिस इज सेमी सर्कुलर कैनाल, इट इज इंपॉर्टेंट फॉर योर बैलेंस, एंड द पेशेंट हैज गॉट ऑटोफोनी, मतलब वो अपनी आवाज खुद ज्यादा सुन रहा है। एंड क्यों सुन रहा है? बिकॉज ऑफ दिस थर्ड विंडो फिनोमिनन। दिस इज द ट्रायड, और दीज थ्री थिंग्स सिंपली टेल यू कि ये इंपॉर्टेंट डायग्नोसिस है, और इसमें सीटी स्कैन देंगे। तो अगर सी टूटा हुआ मिला तो टूटा सी मतलब सेमी सर्कुलर कैनाल की बात हो रही है, एंड दैट इज सुपीरियर सेमी सर्कुलर कैनाल डेहिसेंस विदाउट अ डाउट। ठीक, चलो आगे बढ़े। एक और इंपॉर्टेंट एस्पेक्ट, एक और इंपॉर्टेंट फीचर। ठीक, अब अगर हम वेस्टिबुलर शोनोमा और उसके क्वेश्चंस की बात करते हैं तो सबसे पहले हम ये देख लेते हैं वेस्टिबुलर शोनोमा का क्या इंपॉर्टेंट क्वेश्चन है। आर इंटरनल अकूस्टिक कैनाल, इंटरनल अकूस्टिक कैनाल के अंदर क्या क्या होता है? फर्स्ट लेट्स सी दैट। Our internal acoustic canal is divided into 4 quadrants. Let's say this is anterior, this is posterior. Internal acoustic canal को या internal auditory meatus को divide करते हैं horizontally by a bar, and this bar which horizontally divides the internal acoustic meatus, this is called as horizontal falciform crest. So what I'm telling you, this is the internal acoustic meatus anatomy. बड़ा important question. तो इंटरनल अकूस्टिक मियाटस के अंदर अगर हम इसको ऊपर और नीचे एक डिवाइड कर दें, we can give a bar or a bony ridge. This is called as horizontal या फिर falciform crest. Now, the superior part of the internal acoustic meatus is divided by a vertical ridge, and this vertical ridge is called as Bill's bar. इसे हम क्या कहते हैं? इसे कहते हैं Bill's bar. So now, this Bill's bar is an incomplete vertical partition. It only happens in the superior part. It does not happen in the inferior part. That means now you have got 4 quadrants in your internal acoustic meatus. 2 anterior की तरफ, 2 posterior की तरफ. अब एक कोल्ड ड्रिंक आती है जिसका नाम होता है 7 अप. तो 7 हमेशा अप होगी, और एक कोल्ड ड्रिंक आती है जिसका नाम है कोका कोला, तो कोक हमेशा डाउन होगी. तो अगर मैं आपसे पूछूं एंटेरो सुपीरियर पार्ट ऑफ इंटरनल अकूस्टिक मियाटस में क्या ट्रैवल करता है, आंसर है 7th क्रेनियल नर्व या फेशियल नर्व, जो हमने अभी देखी भी थी मियाटल सेगमेंट में. अगर मैं आपसे पूछूं कोक क्या है, कोक इज द कॉक्लियर डिवीजन ऑफ द वेस्टिबुलो कॉक्लियर नर्व व्हिच ट्रैवल्स इन द एंटेरो इंफीरियर पार्ट ऑफ द इंटरनल अकूस्टिक मियाटस. अब वेस्टिबुलो कॉक्लियर नर्व में 2 नाम है, वेस्टिबुलर एंड कॉक्लियर. तो कॉक्लियर डिवीजन इज ट्रैवलिंग इन द एंटेरो इंफीरियर क्वाड्रेंट. So superiorly, posteriorly, there will be superior vestibular nerve, and here there will be inferior vestibular nerve. The inferior vestibular nerve travels in the posterior-inferior quadrant. Posterior-superiorly is superior vestibular nerve. Cochlear division of vestibulocochlear nerve is antero-inferior, and antero-superior is always 7 up, yeah, 7th cranial nerve. These are the things which travel inside your internal acoustic canal या internal acoustic meatus. अब होता क्या है? Inferior vestibular nerve is the most common nerve which can form this tumor which is called as vestibular schwannoma. मतलब इस inferior vestibular nerve bundle की जो covering है, the lining or the covering of this inferior vestibular nerve is the one which can actually start, proliferating. और कोई भी nerve की जो covering होती है वो किससे बनती है? वो बनती है by Schwann cells. So this particular inferior vestibular nerve के जो Schwann cells हैं, they can start multiplying, and that multiplication of Schwann cells will form a tumor over this inferior vestibular nerve, most commonly in 80% of the cases, which is called as vestibular schwannoma. अब अगर vestibular schwannoma हो गया तो ये क्या करेगा? सबसे पहले किसको ले डूबेगा? This will go into this cochlear division of the 8th cranial nerve. So the first feature of vestibular schwannoma is what? It is sensory neural hearing loss. सबसे पहला फीचर है सेंसोरी न्यूरल हियरिंग लॉस. अब मैंने आपको बताया था कि अगर किसी के भी सेंसोरी न्यूरल हियरिंग लॉस होगा और अगर आप इसका पीटीए कराएंगे, प्यूटोन ऑडियोमेट्री कराएंगे, तो मैंने आपको सबसे पहले बताया था दैट इन पीटीए ऑफ वेस्टिबुलर schwannoma you will see a sloping audiogram. There will be a sloping sensory neural hearing loss. So because this is the one division which is very near the inferior vestibular nerve, that is the first sign that you need to remember in vestibular schwannoma. अब आता है दूसरा इंपॉर्टेंट थिंग. जब ये कॉक्लियर डिवीजन इन्वॉल्व होता है, देयर इज अनदर सिम्टम दैट इज प्रोड्यूस्ड बाय वेस्टिबुलर schwannoma, एंड द सेकंड सिम्टम इज रोरिंग टिनिटस. ऑब्वियसली अगर कोई भी नर्व किसी को कंप्रेस करेगी, लाइक द कॉक्लियर नर्व इज फॉर हियरिंग, तो ये चिल्लाएगी, चीखेगी, टी आवाज बजेगी, तो दैट इज टिनिटस, बहुत जोर से आएगा. तो माय क्वेश्चन इज व्हाट इज द फर्स्ट फीचर seen in cases of vestibular schwannoma? It is sloping audiogram or sloping SNHL as well as roaring tinnitus, and it is usually unilateral. Vestibular schwannoma is a unilateral tumor. The only variety where you can see bilateral vestibular schwannomas is bilateral vestibular schwannoma can be seen in neurofibromatosis type 2, 2 for 2. ठीक है, चलो अब what is going to be the next? अब ये इंपॉर्टेंट क्वेश्चन अगेन. अगर ये वेस्टिबुलर schwannoma और बड़ा हो गया, then it will go and it will also involve the facial nerve. अगर फेशियल नर्व को वेस्टिबुलर schwannoma ने इन्वॉल्व किया, तो व्हाट इज द साइन दैट यू विल सी ओवर हियर? तो हमेशा याद रखना, फेशियल नर्व के मोटर फाइबर्स आर वेरी रेजिलिएंट, द सेंसरी फाइबर्स आर वेरी वीक. तो अगर वेस्टिबुलर schwannoma फेशियल नर्व को इन्वॉल्व करता है, मोटर फाइबर्स आर गोइंग टू बी स्पेयर्ड. सेंसरी फाइबर्स आर गोइंग टू बी अफेक्टेड, सेंसेशन चली जाएगी, और सेंसेशन फेशियल नर्व कहां पे देती है? पोस्टीरियर कैनाल वॉल में. So there will be hypoesthesia of the posterior canal wall, which is called as Hitzelberger sign. Very, very important question. What is Hitzelberger sign? What is Hitzelberger sign? So Hitzelberger sign is the hypoesthesia of the posterior canal wall, which is seen during facial nerve involvement, and this is because of the sensory fibers of the facial nerve, क्योंकि motor fibers are resilient and they get spared. ठीक है, फाइन. तो ये हो गया हमारा एक और इंपॉर्टेंट क्वेश्चन. ठीक है, नाउ एक और इंपॉर्टेंट क्वेश्चन है, अगर ये ट्यूमर इससे बाहर निकल आया, अपने अपने एरिया से बाहर निकल आया, एंड इट गोज इनटू द ट्राइजेमाइनल नर्व, अगर इस ट्यूमर ये बाहर आ गया एंड इट हैज इन्वॉल्व्ड द फिफ्थ क्रेनियल नर्व या ट्राइजेमाइनल नर्व, व्हाट इज द अर्लीस्ट साइन फॉर ट्राइजेमाइनल नर्व इन्वॉल्वमेंट इन वेस्टिबुलर schwannoma? The earliest sign for trigeminal involvement in vestibular schwannoma is absence of corneal reflex. तो मैं आपको सारे एमसीक्यू बेस्ड रीडिंग करा रहा हूं. दिस इज समथिंग, ऑल ऑफ देम आर पोटेंशियल क्वेश्चंस. ये सब एक दूसरे के साथ लिंक्ड है. बस इसमें और हमें ज्यादा कुछ नहीं करना है. ये इंपॉर्टेंट क्वेश्चन है एज फार एज सिम्टम्स आर रिलेटेड. नाउ अगर हम वेस्टिबुलर schwannoma का व्हाट इज द इन्वेस्टिगेशन ऑफ चॉइस अगर हमें मिल गया, if there is someone who we are thinking has vestibular schwannoma, what you are going to do with this patient? The investigation of choice for vestibular schwannoma is do an MRI with gadolinium contrast. Do an MRI with GAD contrast. क्यों? क्योंकि हमेशा MRI में हम ये देखते हैं कि जब भी हम MRI करते हैं या कभी भी कॉन्ट्रास्ट देते हैं तो ट्यूमर कॉन्ट्रास्ट खाता है और चमकता है. तो आप क्या देखेंगे? जब भी आप देखेंगे वेस्टिबुलर schwannoma, ये देखो ये वेस्टिबुलर schwannoma निकल रहा है and it is growing towards the cerebellum. देखो ये पूरा मेरा cerebellum है. So it is growing towards the brainstem and now this tumor is shining because it has taken up the contrast, because it is containing blood vessels. तो ये किसकी तरह दिख रहा है? It looks like an ice cream. तो अगर MRI में आपको ice cream दिखी, this is called as an ice cream cone appearance. An ice cream cone appearance is a classical feature for which tumor? It is a classical feature for vestibular schwannoma. ठीक है, फाइन. सो दिस इज द इंपॉर्टेंट पोटेंशियल क्वेश्चन फॉर वेस्टिबुलर schwannomas दैट कैन कम इन योर पेपर एज वेल. चलो आगे बढ़ते हैं. अब आ जाते हैं इनटू द नेक्स्ट. अब ये क्वेश्चन आपका आया था अभी प्रीवियसली नीट पीजी में कि आपने वेस्टिबुलर schwannoma का ऑपरेशन किया, उसके बाद आपने उस ऑपरेशन के बाद उसको हिस्टोपैथोलॉजी के लिए भेज दिया. नाउ देयर इज समथिंग दैट द सर्जन नोटिस, दैट द पैथोलॉजिस्ट नोटिस्ड, और फिर सर्जन को कॉल किया कि भाई देखो हमें ये दिख रहा है. So what is the arrangement that is seen in a vestibular schwannoma? The arrangement that you see in vestibular schwannoma is Antony A and Antony B cell arrangement. So there is something called as Antony A cells and Antony B cells. तो अब ये होते क्या है? ठीक है, ये इंपॉर्टेंट पैथोलॉजी के लिए भी है. So I told you vestibular schwannomas are arising from what? They are arising from Schwann cells. तो आप ये जो देख रहे हैं बहुत सारे ब्लू कलर के, these are all Schwann cells. And what is exactly a Schwann cell? Schwann cells कैसे होते हैं? Schwann cells are like this and they have got a palisading nucleus. उनके लंबे लंबे न्यूक्लियस होते हैं, लंबे लंबे न्यूक्लियस. तो देखो इनका palisading पैटर्न है, palisading पैटर्न. और अगर ये डेंसली पैक्ड होते हैं तो ये एंटोनी ए है, अगर ये लूजली पैक्ड होते हैं तो ये एंटोनी बी है. तो एंटोनी ए इज मल्टी सेल्यूलर, एंटोनी बी इज पॉसी सेल्यूलर. राइट, so that is the difference between A and B. अब एक अरेंजमेंट, एक पर्टिकुलर अरेंजमेंट दिखता है in this particular vestibular schwannoma and this is called as a Verroque body. Verroque body का क्या मतलब होता है? Verroque body का मतलब होता है कि ये इसमें क्या होता है? You will see multiple Schwann cells, बहुत सारे आपको streaks of Schwann cells दिखेंगी, streaks of Schwann cells दिखेंगी, लेकिन बीच में there will be an area which will be empty and this area will be only pink. ये एरिया सिर्फ पिंक होगा. Now this pink area only contains cytoplasmic processes. तो देखो ये दिख रहा है, एक तरफ lot of palisading nuclei of spindle shaped Schwann cells, एक तरफ और बहुत सारे Schwann cell, but center area में pink. This central area which is pink contains the cytoplasmic processes and this empty area is given the name as Verroque body. So Verroque body is a classical feature of what tumor? Of vestibular schwannoma. ठीक है, तो ये indirect question pathology mixed with ENT भी आ सकता है. ठीक है, चलो आगे बढ़ते हैं. अब आते हैं कॉकलियर इंप्लांट पे. पिछले आईएनआई सेट में एक और इंपॉर्टेंट क्वेश्चन पूछा गया था, कॉकलियर इंप्लांट की गाइडलाइंस पूछी गई थी. तो दीज आर सम थिंग्स और व्हिच आर द इंडिकेशंस ऑफ कॉकलियर इंप्लांट एंड कॉन्ट्राइंडिकेशंस, ये आप लोग लिख लीजिए. ठीक है, तो इसमें क्या क्वेश्चन बनता है? इसमें ये क्वेश्चन बनता है कि दे विल टेल यू विच अमंग द फॉलोइंग इज द बेस्ट कैंडिडेट फॉर कॉक्लियर इंप्लांटेशन, विच अमंग द फॉलोइंग डज नॉट रिक्वायर अ कॉक्लियर इंप्लांट. The best candidate for doing a cochlear implant, no doubt, is bilateral severe profound sensorineural hearing loss. अब या तो ये लैंग्वेज डेवलपमेंट के पहले कर सकते हैं विच इज कॉल्ड एज प्रीलिंगुअल डेफनेस, या ये लैंग्वेज डेवलपमेंट के बाद कर सकते हैं विच इज कॉल्ड एज पोस्ट लिंगुअल डेफनेस. बट अमंग देम अगर किसी के भी बायलैटरल प्रोग्रेसिव सेंसोरिन्यूरल हियरिंग लॉस है विच इज प्रोफाउंड और आपने हियरिंग एड दे रखी है, वो हियरिंग एड काम नहीं करी है, दैट इज द क्लासिकल इंडिकेशन फॉर डूइंग अ कॉक्लियर इंप्लांट सर्जरी. ठीक है. सेकेंड इंडिकेशन इज टेम्पोरल बोन फ्रैक्चर. तो आप टेम्पोरल बोन में फ्रैक्चर हो गया, कॉक्लिया गॉट डिस्ट्रॉयड, सो ऑब्वियसली नाउ यू विल डू अ कॉक्लियर इंप्लांट. थर्ड इज ऑब्वियसली अ पर्सन हु हैज नॉट बेनिफिटेड फ्रॉम एनी हियरिंग एड बिकॉज देयर इज प्रोफाउंड हियरिंग लॉस. तो कोई हियरिंग एड से बेनिफिट नहीं है. Next, ototoxicity. I told you there is going to be sensorineural hearing loss. Cochlea में loss होगा in cases of ototoxicity. Far advanced otosclerosis. मैंने आपको बताया था कि when the otosclerosis has crossed over from the stapes to the cochlea, तो मतलब cochlear involvement has happened. That means the cochlea is not working, and that is also an indication for doing a cochlear implant. And in some people, the neurosynaptic junction becomes impaired. मतलब जो hair cells हैं cochlea में और उनके जो vestibulocochlear nerve के neurons के साथ synapse है वो काम नहीं कर रही. So if the synapse is not working, that is called as auditory neuropathy. Auditory neuropathy. Neuro मतलब nerves, pathy मतलब pathology at the junction between the hair cells and the neuronal synapse. That is where auditory neuropathy happens. In सारे cases में हम cochlear implant करते हैं. The only thing what I am telling you is कि अगर हम कभी भी cochlear implant कर रहे हैं तो cochlear implant में कुछ भी हो, सब कुछ ठीक है. कॉक्लिया काम नहीं कर रहा, वी कैन डू एनीथिंग, वी कैन डू अ कॉक्लियर इंप्लांट. बट द ओनली थिंग दैट शुड बी फंक्शनल ड्यूरिंग अ कॉक्लियर इंप्लांट सर्जरी इज द वेस्टिबुलोकॉक्लियर नर्व. इसमें कोई प्रॉब्लम नहीं होनी चाहिए. अगर वेस्टिबुलोकॉक्लियर नर्व इज नॉट इट्स समथिंग व्हिच इज नॉट वर्किंग, then we cannot do a cochlear implant. Why? Because even if we place an implant in the or we place an electrode inside the cochlea, ये impulses कैसे travel करेंगी जब तक हमारे पास vestibulocochlear nerve ही नहीं है. So vestibular cochlear nerve is very important for anything and everything whatever we are going to do. ठीक है. So now contraindications are what? Obviously अगर किसी के cochlea absent है तो आप electrode उसके लगा नहीं सकते. That is the first contraindication. Indication से question आया है, contraindication से नहीं आया है. That's why I'm doing the contraindications. कहीं भी आपको दिखा something is wrong with the vestibular cochlear nerve, you will not do a cochlear implant. That means cochlear nerve aplasia, कोई बनी नहीं vestibular cochlear nerve, or if there is transected vestibular cochlear nerve, मतलब ये टूट गई, obviously you won't be able to do anything, or there are central disorders या brain disorders जिसमें the auditory system is not working. So in any of these cases you will not do a cochlear implant. Now this is how your cochlear implant looks like. ये cochlear implant की total assembly है. ठीक है. What does it contain? This is the external component of cochlear implant. ये जो आपको दिख रहा है. This contains 3 parts. एक part is called as microphone, जो यहां पे दिख रहा है. This part is called as speech processor, and this part is called as external transmitter. Okay? तो हमेशा बाहर के जो स्ट्रक्चर्स होते हैं दैट इज एन एक्सटर्नल ट्रांसमीटर, देयर इज अ स्पीच प्रोसेसर एंड देयर इज अ माइक्रोफोन. तो होता क्या है, व्हेनेवर अ साउंड कम्स इनटू द ईयर, सबसे पहले ये माइक्रोफोन लेगा. साउंड इज अ फॉर्म ऑफ मैकेनिकल एनर्जी, तो सबसे पहले ये सारा का सारा साउंड माइक्रोफोन पकड़ लेगा. अब क्या करेगा, दिस माइक्रोफोन विल सेंड दिस साउंड टू द स्पीच प्रोसेसर एंड द स्पीच प्रोसेसर विल कन्वर्ट दिस मैकेनिकल एनर्जी इनटू अ डिजिटल एनालॉग सिग्नल. मतलब ये एक डिजिटल सिग्नल में बना, ये कन्वर्ट कर देगा दिस स्पीच प्रोसेसर, क्योंकि हम लोग का जो ब्रेन है वो स्पीच नहीं अंडरस्टैंड करता, इट अंडरस्टैंड्स इंपल्सेस. So this will convert this sound, the speech processor will convert this sound into a digital analog signal. Now this digital analog signal now will go into this external transmitter which is attached over the scalp. ठीक है, अब तक ये कहानी रही. अब देखो क्या होता है. Now ये एक्सटर्नल ट्रांसमीटर जो है ये तो बाहर है, इसी के कॉरेस्पॉन्डिंग स्कैल्प के अंदर, मतलब यहां पे स्कल के अंदर हम लोग एक छोटा सा वेल बनाते हैं, एक छोटा सा छेद बनाते हैं, वेल जिसे हम कहते हैं वेल. और इस स्कल के अंदर कॉरेस्पॉन्डिंग टू द एक्सटर्नल ट्रांसमीटर, मतलब जस्ट इस एक्सटर्नल ट्रांसमीटर को हटाएंगे तो स्कैल्प के नीचे जस्ट कॉरेस्पॉन्डिंग टू इट वी प्लेस समथिंग कॉल्ड एज अ रिसीवर स्टिम्युलेटर। रिसीवर स्टिम्युलेटर तो होता क्या है, ये दोनों एक्सटर्नल ट्रांसमीटर और रिसीवर स्टिम्युलेटर के बीच में होता है एक मैग्नेट। तो दिस आउटर असेंबली गोज एंड अटैचेस टू द इनर असेंबली लाइक अ मैग्नेट। ये दोनों चिपक जाते हैं, वन इज बीनीथ द स्कैल्प, वन इज अबव द स्कैल्प। नाउ वंस द साउंड रीचेस द ट्रांसमीटर, मैंने बताया था ट्रांसमीटर में साउंड आ चुकी है, अब क्या होगा, नाउ द साउंड फ्रॉम द ट्रांसमीटर विल रीच इनटू द रिसीवर स्टिम्युलेटर इन द फॉर्म ऑफ रेडियो फ्रीक्वेंसी वेव्स। ठीक है, एंड अब क्या होता है, ये जो अंदर का रिसीवर स्टिम्युलेटर है ये अटैच्ड है मेन इलेक्ट्रोड से, ये जो मेन इलेक्ट्रोड है which we are going to place inside the cochlea. So this receiver stimulator, once it gets the radio frequency waves, this will convert these radio frequency waves into an electrical signal, and this electrical signal is going to be transferred into the cochlea and you will hear. इस तरीके से हम लोग कॉक्लिया में, this is what is the whole cochlear assembly. So external microphone, speech processor, external transmitter, then receiver stimulator attached to the electrode. अब क्वेश्चन क्या आते हैं कॉक्लियर इंप्लांट सर्जरी में, ये तो हो गए अबाउट कंपोनेंट रिलेटेड क्वेश्चन एंड कैंडिडेसी क्राइटेरिया। सबसे इंपॉर्टेंट जो क्वेश्चंस आएंगे कॉक्लियर इंप्लांटोलॉजी में और सबसे इंपॉर्टेंट जो क्वेश्चंस बनते हैं कॉक्लियर इंप्लांट में इज अबाउट तीन इंपॉर्टेंट चीजें जो मैं आपको बताऊंगा। कॉक्लियर इंप्लांट की अप्रोच क्या होती है, तो ये सर्जरी की ये इंपॉर्टेंट सर्जिकल इमेज है विच इज वेरी इंपॉर्टेंट फॉर योर एग्जाम पॉइंट ऑफ व्यू। तो कॉक्लियर इंप्लांट की जो सर्जरी होती है दैट इज कॉल्ड एज फेशियल रीसेस अप्रोच, या फिर इसे हम कहते हैं पोस्टीरियर टिम्पेनोटमी, या तो इसे बोलो पोस्टीरियर टिम्पेनोटमी या फिर इसे बोलो फेशियल रीसेस अप्रोच। ठीक है, अब व्हाट इज फेशियल रीसेस, दिस इज योर फेशियल नर्व, व्हाट यू सी हियर दिस इज अ ड्रिल्ड मैस्टोइड, ये मैस्टोइड की हमने ड्रिलिंग कर रखी है। दिस इज द पोस्टीरियर कैनाल वॉल, दिस इज पोस्टीरियर कैनाल वॉल, पोस्टीरियर कैनाल वॉल के जस्ट पीछे फेशियल नर्व रन करती है। दिस इज द वर्टिकल सेगमेंट ऑफ द फेशियल नर्व, यू कैन सी दैट दिस इज योर वर्टिकल सेगमेंट ऑफ द फेशियल नर्व। One important branch from the vertical segment of the facial nerve which goes into the ear is called as chorda tympani. इसे हम बोलते हैं chorda tympani. This is the nerve of taste. This is main facial trunk. This is the main facial nerve. Facial nerve और chorda tympani के बीच की जो स्पेस होती है इसको कहते हैं facial recess. मतलब हम एक ड्रिल लेंगे और इन दोनों के बीच में ड्रिल करेंगे। अगर हम इन दोनों के बीच में ड्रिल करते हैं दैट अप्रोच इज कॉल्ड एज पोस्टीरियर टिम्पेनोटमी या फेशियल रिसेस अप्रोच। अब जब भी हम इनके अंदर ड्रिल करेंगे सबसे पहले हमें क्या दिखेगा, वी विल सी द स्टार। तो स्टार क्या है, स्टार इज द राउंड विंडो। तो जब हम ड्रिल करके अंदर चले जाएंगे वी विल एंटर द मिडिल ईयर एंड वी विल सी द राउंड विंडो। तो अगर मैंने आपका क्वेश्चन पूछा कि अप्रोच ऑफ कॉक्लियर इंप्लांट क्या है, सर्जरी का नाम क्या है, दैट इज पोस्टीरियर टिम्पेनोटमी या फेशियल रिसेस अप्रोच। अगर मैंने आपसे पूछा कि अब आप क्या करेंगे, यू विल प्लेस द इलेक्ट्रोड ऑफ द कॉक्लियर इंप्लांट थ्रू व्हाट, तो यू विल प्लेस द इलेक्ट्रोड ऑफ कॉक्लियर इंप्लांट थ्रू द राउंड विंडो। थ्रू द राउंड विंडो मतलब राउंड विंडो के थ्रू जाएगा, ये वर्ड इंपॉर्टेंट है। और राउंड विंडो के थ्रू जब जाएगा इलेक्ट्रोड तो किसमें जाएगा, आंसर इज स्केला टिम्पेनी। तो इलेक्ट्रोड ऑफ कॉक्लियर इंप्लांट इज प्लेस्ड थ्रू वर्ड round window and placed inside what, inside scala tympani, क्योंकि ये राउंड विंडो के पीछे होती है, inside scala tympani। ओके फाइन, चलो जी, 5 इंपॉर्टेंट क्वेश्चंस, 5 इंपॉर्टेंट टेढ़े क्वेश्चंस ऑफ आईएनआई सेट अबाउट व्हाट आर कॉक्लियर एनोमलीज। ठीक है, अगर किसी भी इंसान का कॉक्लिया कंप्लीटली एब्सेंट है उस पर्टिकुलर कंडीशन को हम कहते हैं माइकल एप्लेजिया। माइकल का कॉक्लिया नहीं है, तो माइकल का कॉक्लिया नहीं है तो उसे कहेंगे माइकल एप्लेजिया। ठीक है, सेकेंड इंपॉर्टेंट थिंग इज कॉल्ड एज शाइबीज डिस्प्लेजिया। अब ये सबसे कंफ्यूजिंग पार्ट होता है यहां का। शाइबी का मतलब क्या है, शाइबी का याद रखो एस और सी से स्टार्ट हो रहा है, मतलब इसमें सैक्यूल और कॉक्लिया दोनों नहीं बने। तो एस और सी से कुछ भी चीज स्टार्ट हुई दैट इज कॉक्लियोसैक्युलर डिस्प्लेजिया, यानी एस और सी इसमें दोनों लगे हुए हैं, दैट मींस इसमें सैक्यूल नहीं बना और कॉक्लिया नहीं बना, तो उन दोनों नहीं बने तो उसे हमने बोला शाइबी। बड़ा सिंपल तरीका है। तीसरा हो गया अलेक्जेंडर डिस्प्लेजिया। इसको याद करने का तरीका, अलेक्जेंडर में क्या आ रहा है, इसको याद करो, ABCD। A फॉर अलेक्जेंडर, D फॉर डिस्प्लेजिया और BC से हो गया बेजल टर्न ऑफ कॉक्लिया। तो अगर किसी का बेजल टर्न ऑफ कॉक्लिया एब्सेंट है तो ABCD अलेक्जेंडर डिस्प्लेजिया है। अगर किसी के मेम्ब्रेनस कॉक्लिया एब्सेंट है, मेम्ब्रेनस लैबिरिंथ एब्सेंट है, तो मेम्ब्रेनस कॉक्लिया एब्सेंट है तो मेम्ब्रेनस मेन से मैन, तो मेन से मैन, सो साइबन मैन में मेम्ब्रेनस पार्ट ऑफ द कॉक्लिया विल बी एब्सेंट। एंड फाइनली जो क्वेश्चन एक आया है, व्हाट इज मॉन्डिनी डिस्प्लेजिया। मॉन्डिनी डिस्प्लेजिया में कॉक्लिया सिर्फ 1.5 टर्न का होता है, 2/3/4 टर्न का नहीं, छोटा होता है, 1.5 टर्न का होता है। तो मैंने आपको तरीके बताए, कहीं पे भी एस और सी लगा हो, कॉक्लियोसैक्युलर शाइबी, ABCD अलेक्जेंडर बेजल टर्न ऑफ कॉक्लिया डिस्प्लेजिया, साइबिन मैन मेम्ब्रेन कुछ मैच कर रहा है तो इसमें मेम्ब्रेनस कॉक्लिया एब्सेंट है। और अगर आधा कॉक्लिया है, 1.5, दैट मीन्स मॉन्डिनी। ये हो गए हमारे कॉक्लियर एनोमलीज एंड द रिलेटेड क्वेश्चंस दैट कम अबाउट कॉक्लियर डिसऑर्डर्स। ठीक है, सारे के सारे में हम लोग कॉक्लियर इंप्लांट कर सकते हैं, सिर्फ एक कॉक्लियर एनोमली में नहीं कर सकते। क्वेश्चन ये आया है, तो किस में नहीं कर सकते? ऑब्वियसली जिसमें कॉक्लिया नहीं है। मैंने बताया भी था कॉन्ट्राइंडिकेटेड एंड एब्सेंट कॉक्लिया, तो एब्सेंट कॉक्लिया किस में दिखेगा? माइकल एप्लेजिया में। तो द ओनली रीजन और द ओनली प्लेस वेयर वी विल नॉट डू अ कॉक्लियर इंप्लांट इज माइकल एप्लेजिया, बाकी सब में कॉक्लियर इंप्लांट करा जा सकता है आजकल। ठीक है, चलो आगे आते हैं। ये क्या है? व्हाट डू यू सी ओवर हियर? तो जिन लोगों के हम एयर कंडक्शन हियरिंग एड नहीं लगा पाते, उनके हम बोन में ड्रिल करके हियरिंग एड लगा देते हैं। दिस इज कॉल्ड एज बाहा, या फिर इसे हम बोलते हैं बोन एंकर्ड हियरिंग एड, राइट? या इसे हम बाहा भी बोलते हैं। तो बाहा जनरली किस में लगाते हैं? कोई भी अगर आपको मिलेगा जिसमें हम एयर कंडक्शन से हियरिंग एड नहीं दे सकते, बाहर से नहीं दे सकते, जैसे कि एक्सटर्नल ऑर्टरी कैनाल एट्रीजिया, एक्सटर्नल ऑर्टरी कैनाल इंफेक्शंस या इन्फ्लेमेशन, क्रॉनिक डिस्चार्जिंग ईयर, एनोशिया या माइक्रोशिया, तो कान नहीं है या फिर बहुत छोटा है, इन सारे केसेस में एयर कंडक्शन हियरिंग एड नहीं दे सकते। तो उसके केस में क्या देंगे? वील गिव बोन एंकर्ड हियरिंग एड। बोन एंकर्ड हियरिंग एड के आप देख रहे हो इनमें 3 पार्ट है। ये आइडेंटिफिकेशन फीचर इसका क्या है? सबसे पहला पार्ट जो होता है, दिस इज कॉल्ड एज अ टाइटेनियम फिक्सचर, इसे बोलते हैं टाइटेनियम फिक्सचर। टाइटेनियम फिक्सचर क्या होता है कि सबसे पहले हम क्या करते हैं, छोटी सी यहाँ पे मैस्टोइड बॉडी के ऊपर हम यहाँ पे एक निक लगाते हैं एंड वी ड्रिल अ होल इनसाइड द स्कल। सबसे पहले होल बनाते हैं स्कल के अंदर, और स्कल के अंदर एक ये पेच लगा देते हैं छोटा सा, विच इज कॉल्ड एज अ टाइटेनियम फिक्सचर। देखो ये अंदर हमने एक ये स्क्रू लगा दिया इनसाइड द स्कल, फिर हम लोग छोड़ देते हैं। आफ्टर फॉर 3 months वी लीव दिस स्क्रू फॉर ऑसियो इंटीग्रेशन। तो सबसे पहले हम जब स्क्रू लगाएंगे उसके बाद वी विल लीव दिस स्क्रू फॉर अ प्रोसेस कॉल्ड एज ऑसियो इंटीग्रेशन। ऑसियो इंटीग्रेशन मतलब जब तक ये स्क्रू एक्सेप्ट हो जाए एंड इट गेट्स बरिड इनसाइड द बोन। नाउ आफ्टर 3 months व्हाट वी विल डू, ओवर दिस स्क्रू एंड ओवर द स्कैल्प हम लोग इसके ऊपर द सेकंड पार्ट ऑफ बाहा लगाएंगे एंड दिस इज कॉल्ड एज एन अबटमेंट। अबटमेंट के ऊपर जुड़ता है द मेन इंपॉर्टेंट प्रोसेसर विच इज कॉल्ड एज स्पीच प्रोसेसर। तो 3 असेंबली ऑफ बाहा क्या होती है? टाइटेनियम फिक्सचर जो ड्रिल करके लगाते हैं, उसके ऊपर भी फिक्स दिस टाइटेनियम अबटमेंट, और उसके ऊपर लगा देते हैं स्पीच प्रोसेसर। तो कोई भी अब साउंड जो भी आएगा, इट विल गेट कॉट बाय दिस स्पीच प्रोसेसर एंड इट विल डायरेक्टली ट्रांसमिटेड अप टिल द कॉक्लिया। अब एक्सटर्नल और मिडिल ईयर का कोई काम नहीं है। दिस इज व्हाई दिस इज कॉल्ड एज बोन एंकर्ड हियरिंग एड, क्योंकि बोन में एंकर्ड है ये हियरिंग एड। ठीक है, चलो आगे बढ़े। फाइनल पार्ट ऑफ ईयर, इसके बाद ईयर खत्म, क्योंकि ईयर सबसे बड़ा चंक है फॉर आईएनआई सेट। तो ईयर खत्म हो जाएगा, देन इट विल बी अ पीस ऑफ केक, तब हम बहुत जल्दी आगे बढ़ेंगे। ग्लोबस ट्यूमर और उससे रिलेटेड क्वेश्चंस क्या है, तो ये मैं आपको बता देता हूं। अगर आपको कभी भी टिम्पैनिक मेम्ब्रेन के पीछे एक पल्सेटाइल मास रेड कलर का दिखा, दैट मींस इफ यू फाइंड द पेशेंट्स हिस्ट्री टू हैव कंडक्टिव हियरिंग लॉस, pulsatile tinnitus, this is what they will give you as a catchword. If they give these 2 terms and they show you a red colored mass behind a normal tympanic membrane, then the answer is glomus tympanicum या फिर glomus tumor. ठीक है, so what is this sign called as? There are certain signs which are important for glomus. ये कौन सा साइन है? ये ऐसे लग रहा है सूरज उग रहा है, तो दिस इज कॉल्ड एज अ राइजिंग सन साइन, राइजिंग सन साइन। दिस इज अ फीचर ऑफ ग्लोमस टिम्पैनिकम। ठीक है, तो पहला फीचर हो गया राइजिंग सन साइन, वो हमने पढ़ लिया, राइजिंग सन साइन क्या होता है। सेकेंड इज ब्राउन साइन। व्हाट इज ब्राउन साइन? इफ आई पुट अ सीगल स्पेculum and I put pressure over in the external auditory canal, this tumor will blanch. मतलब कि B for brown, B for blanching. If there is blanching of glomus tumor, of glomus on seagulization, सीगल स्पेकुलम लगाने के बाद अगर ब्लांचिंग दिखी, दिस इज कॉल्ड एज ब्राउन साइन। ठीक है, फाइन। नाउ अगर किसी ने भी यहां पे ओवर द कैरोटिड आर्टरी प्रेस किया एंड दे सी ब्लांचिंग अगेन, so all glomus tumors are supplied by the carotid artery. So if you see blanching by compression over the carotid artery, that particular sign is called as Aquino's sign. So what is Aquino's sign? Blanching produced on carotid pressure. That is called as Aquino's sign. And last sign जो आता है, fourth sign, right? That is basically called as Phelps sign, which is seen on a CT scan. अब मैं आपको बताता हूं what is Phelps sign. तो Phelps sign में आपको इस तरीके का CT स्कैन मिलेगा। This is your CT स्कैन। अब इसमें आइडेंटिफाई करो, ये एक एक्सियल सेक्शन है, जैसे कि ये है ना मेरा स्कल, मैंने ऐसे काट दिया अपने स्कल को और ऊपर से देख रहा हूं। तो अगर मैंने ऊपर से देख रहा हूं या एक्सियल सेक्शन में देख रहा हूं, देन व्हाट एग्जैक्टली विल यू सी? ये देखो, दीज आर योर पीट्रस पिरामिड्स। ये आपकी पीट्रस पार्ट ऑफ टेम्पोरल बोन है, राइट? पीट्रस पार्ट ऑफ टेम्पोरल बोन के जस्ट पीछे ये एक फोरामेन है, विच इज दिस फोरामेन ग्रीन कलर्ड? दिस इज आर जुगुलर फोरामेन। जुगुलर फोरामेन के थ्रू क्या निकलता है? प्रीवियस INICET क्वेश्चन, ऑल ऑफ द फॉलोइंग पासेस थ्रू द जुगुलर फोरामेन एक्सेप्ट, इसके थ्रू निकलती है 9, 10 और 11th क्रेनियल नर्व। ठीक है, सो 9, 10 एंड 11th क्रेनियल नर्व टुगेदर विद द इंटरनल जुगुलर वेन पासेस थ्रू द जुगुलर फोरामेन। ठीक है, तो अगर किसी के ग्लोमस जुगुलेर होता है, नॉट टिम्पैनिकम, जुगुलर बल्ब, मतलब जस्ट एट दिस जंक्शन देयर इज अ ट्यूमर व्हिच फॉर्म्स ओवर द जुगुलर वेन, दैट इज कॉल्ड एज ग्लोमस जुगुलेर। तो होगा क्या? दैट ग्लोमस जुगुलेर विल स्प्रेड एंड इट विल ब्रेक दिस बोन, एंड दिस बोन व्हेन इट गेट्स ब्रोकन, that bone will be called as an erosion of the caroticojugular spine. Caroticojugular spine. And if this tumor erodes the caroticojugular spine, देखो यहाँ पे कोई बोन नहीं दिख रही, this is just seen to be, gray in color. अब एक चीज इंपॉर्टेंट है, इसमें इंटरनल कैरोटिड आर्टरी कहाँ है? तो कभी भी कोई फिंगर की तरह दिखे ना, देखो ये फिंगर, देखो यहाँ पे एक फिंगर लगा लो, तो ये फिंगर की तरह दिख रही है, दिस इज द इंटरनल कैरोटिड आर्टरी. That means if you see, this tumor has actually broken that bone which is present between the jugular bulb as well as the carotid artery. So if this bone gets broken, this is called as erosion of the caroticojugular spine, which is a classical feature of glomus jugulaire, and this sign is given the name as Phelps sign. This is called as Phelps sign. This is seen on an HRCT temporal bone on an axial section. ठीक है, अगर आप ग्लोमस ट्यूमर का MRI करते हैं, अगर आप MRI करते हैं, तो MRI में आपको दिखेगी कुछ सफेद कुछ काली तस्वीर। दैट मीन समथिंग व्हाइट समथिंग ग्रे। तो आप समथिंग व्हाइट समथिंग ब्लैक का मतलब क्या होता है? सॉल्ट एंड पेपर। तो ऑन एन MRI यू विल सी अ सॉल्ट एंड पेपर अपीयरेंस। इसमें प्रॉपर्ली नहीं दिख रहा है, यू सी ब्लैक एंड यू विल सी व्हाइट स्पॉट्स विद इन देम। So the white areas are of the hemorrhage which happen within the glomus tumor. तो अगर white और black appearance दिख रही है, that is called as salt and pepper appearance, and salt and pepper appearance is a classical feature of MRI, which is seen on an MRI in glomus tumors, and this is seen in glomus jugulaire. ठीक है, fine. So these are the important signs that you see over in glomus tumor. ये हमेशा याद रखना, these are the things that you will see in type of glomus tumors. And now we proceed on to nose and paranasal sinus. तो अब हमारा खत्म हो गया पार्ट A. I hope you guys have gotten the important questions. जो भी ईयर से रिलेटेड आते हैं, हमने काफी सारी चीजें पढ़ी, हमने टाइप का एक रन थ्रू किया अबाउट ओटोलॉजी, और हमने बहुत सारी चीजें ओटोलॉजी में खत्म कर दी. अब आसान पार्ट आता है, इसको हम जल्दी जल्दी खत्म करेंगे, एंड दिस इज अबाउट व्हाट इज राइनोलॉजी एंड द क्वेश्चंस एसोसिएटेड विद पैरानेजल साइनस। इसमें बहुत सारे स्कैन्स हैं, बहुत सारी रेडियोलॉजी है, तो इसको हम लोग मोर डायग्रामेटिक पढ़ेंगे, लेसर ओवर ऑन टेक्स्ट पढ़ेंगे। ठीक है, चलो स्टार्ट करते हैं। तो सबसे पहले व्हाट इज द फर्स्ट थिंग, ये क्या है, व्हाट इज दिस? नाउ यू हैव गॉट अ न्यू बॉर्न चाइल्ड हु कैन नॉट ब्रीथ फ्रॉम द नोज, so the child has got inspiratory stridor. Always remember, जब भी बच्चे पैदा होते हैं, they are obligate nasal breathers, वो सिर्फ नाक से सांस लेते हैं। So in certain children who have got chromosome number 8 defect which affects CHD7 gene, this is called as CHD7 gene which is present over chromosome number 8, 8 के ऊपर 7. This is something which produces a condition called as choanal atresia. Posterior choana बंद हो गए, that's called as choanal atresia. Now this particular situation is associated with a very common syndrome which is called as charge syndrome, right? Charge syndrome मतलब coloboma of the iris, H for heart defects, A for atresia, R for R for retarded growth, G for genitourinary anomalies, and E for ear anomalies. So this is called as Charge syndrome, which is the most common thing which is associated with choanal atresia, जिसमें posterior choana of the child बंद हो जाता है। ठीक है, अब one drug has been associated with the formation of more of choanal atresia. तो अगर प्रेगनेंसी के टाइम में the mother consumes methimazole, तो methimazole has got a direct chance of producing choanal atresia more. ठीक है, What is this image that is seen? तो देखो, एक तरफ तो नॉस्ट्रिल पीछे से खुली हुई है पर एक तरफ बंद है। This is choanal atresia on examination on an endoscopy. ठीक है, so what exactly will this be? So choanal atresia can be unilateral or bilateral. So according to the types, it could be unilateral or bilateral. Bilateral मतलब complete choanal closure, एक ही तरफ है तो it is unilateral. अगर on the basis of what is present inside this choanal atresia, so it could be membranous, bony or mixed. मतलब या तो ये चीज मेम्ब्रेन हो सकती है, या ये बोनी हो सकती है, या ये दोनों हो सकती है, बोन प्लस मेम्ब्रेन. द मोस्ट कॉमन टाइप इज मेम्ब्रेनस. ठीक है, आई टोल्ड यू दैट बच्चे आर ऑब्लिगेट नेजल ब्रीदर्स. ये सिर्फ नाक से सांस ले पाते हैं, ये मुंह खोल के सांस नहीं ले पाते. और क्यों नहीं ले पाते? बिकॉज देयर लैरिंग्स इज वेरी हाई प्लेस्ड एट द लेवल ऑफ C1 एंड C2 सर्वाइकल वर्टेब्रा. तो ये मुंह खोलेंगे तो ऑब्वियसली देयर लैरिंग्स विल शट. So that is why babies do not breathe with an open mouth. Now, in order to make them breathe, हमें कुछ तो उन्हें करना पड़ेगा, right? So what do we do? In order to make them breathe through the mouth, we use this appliance. और ये जो बच्चे के appliance लगी हुई है क्या है? This is called as a McGovern's nipple. तो McGovern's nipple क्या होती है? ये एक नॉर्मल निपल है जो बॉटल फीडिंग निपल होती है, राइट? तो इसको हम क्या करते हैं? वी कट दिस निपल एट दिस एंड. हम इसमें यहां से काट देते हैं. एंड वी टाई 2 थ्रेड्स अराउंड दिस. तो हम क्या करते हैं? वी प्लेस दिस कट एंड ऑफ द निपल इनसाइड द माउथ ऑफ द चाइल्ड एंड वी अटैच इट टू द ऑक्सीपुट. तो होगा क्या? बच्चे का मुंह खुला रहेगा बिकॉज ऑटोमेटिकली द चाइल्ड कैन नॉट ओपन द माउथ. तो दिस इज गिवन फॉर अक्यूट मैनेजमेंट, ताकि हम इंपॉर्टेंटली स्ट्राइडर हटा सकें. Yeah, because the baby is not breathing from the nose, now the baby will have cyanosis. So the most common feature of this particular condition is cyclical cyanosis. Cyclical cyanosis का मतलब cyanosis जो आएगी और जाएगी. तभी हम कहते हैं बच्चा रोता है और बच्चा सोता है. मतलब जब भी बच्चा रुक जाएगा तो the nose is already blocked, they will become cyanos, फिर वो झटपट आएंगे, वो रोएंगे. That rona will suddenly get their air inside the lung and then they will sleep again. Then again they will get up, again they will breathe more. तो cyclical cyanosis का मतलब है रोना और सोना साथ में चलता रहेगा. But we want the mouth to be open and that is why we keep this appliance called as McGovern's nipple. ठीक है, यही क्वेश्चन आए हैं इसके अकॉर्डिंग, बस और कुछ नहीं आया है. बस एक चीज और पूछी गई है, व्हाट विल बी द मैनेजमेंट? तो मैनेजमेंट इज ऑलवेज सर्जिकल. तो सर्जिकली हम लोग एंडोस्कोपी करते हैं एंड वी एक्चुअली टेक दिस एट्रीजिया आउट. इसको हम लोग तोड़ देते हैं, राइट? एक इंपॉर्टेंट चीज है दैट व्हेनेवर वी ब्रेक दिस एट्रीजिया, तो द पॉइंट इज कि व्हेनेवर बॉडी में हम सर्जरी करते हैं, बॉडी हील्स विद फाइब्रोसिस, वो वापस से हील होकर फाइब्रोस हो जाएगा. तो उसको हम कैसे प्रेजेंट करेंगे? उसको प्रिवेंट करने के लिए वी यूज एन एंटी फाइब्रोब्लास्टिक ड्रग, दैट इज मिटोमाइसिन सी. तो जब भी हम लोग एट्रेटिक प्लेट को रिमूव करते हैं विद द हेल्प ऑफ एन एंडोस्कोप और एंडोस्कोपिक सर्जरी, वी अप्लाई ऑन द साइड्स मिटोमाइसिन सी. Mitomycin C is an antifibroblastic drug and that will not allow the refibrosis to happen. That is what is used in cases of corneal atresia babies. But again, surgical management is the choice. Okay, चलो आगे बढ़े. अब आ गए दूसरी congenital anomaly. एक तरफ है encephalocele, एक तरफ है glioma. So you have got two babies. One has an encephalocele. One has a glioma. दोनों के बीच में क्या डिफरेंस नजर आ रही है? ये दोनों बेबीज के बीच में एक तो ये दोनों कंजेनाइटल प्रॉब्लम्स हैं और दोनों मिडलाइन में इतने बड़े बड़े दे प्रोड्यूस स्वेलिंग्स ओवर द नोज. पर दोनों को आइडेंटिफाई कैसे करेंगे? ठीक है, तो तीन चीजें हमेशा याद रखना. तीन चीजें हैं PCT, पल्सेटाइल, कॉम्प्रेसिबल एंड ट्रांसइल्यूमिनेंट. ये तीनों चीजें एंसेफेलोसील में दिखती हैं, ग्लायोमा में नहीं दिखती. This is something which is our intracranial content which is coming out of the nose. So if there is a defect over on the anterior aspect of the skull, all our intracranial contents will come out and they will produce a transilluminant pulsatile compressible swelling. This is called as encephalocele. But glioma is not intracranial. Glioma में कोई भी midline intracranial defect नहीं है. Glioma में there are dysplastic cells or glial cells which have deposited here over the dorsum of the nose. That means encephalocele has got an intracranial connection, but glioma does not have an intracranial connection. That is why the child will have a pulsatile, compressible and illuminant swelling whenever they will have an encephalocele, not on a glioma. अब बच्चा जब भी रोएगा या खांसेगा, encephalocele बढ़ जाएगी साइज में, but glioma नहीं बढ़ेगी. And why is that? Because whenever the baby will cry, that time the CSF pressure will get raised. When the CSF pressure will get raised, this particular swelling will increase in size. This test is called as Furstenberg test. So Furstenberg test will only be positive in those swellings which are intracranial, right? वो positive होगा encephalocele के केस में, but वो negative होगा in cases of glioma. So pulsatile, transilluminant, compressible swelling, positive Furstenberg test, encephalocele. ये कुछ भी नहीं है glioma. ठीक है? This is how we differentiate them. चलो आगे बढ़े. ये हो गई, ये एक और बड़ी कॉमन सी बड़ी फेमस इमेज है. अगर व्हाट इज द डिफरेंस बिटवीन अ क्रूकेड नोज एंड अ डिविएटेड नोज? अगर आपका एक्सटर्नल डिविएशन ऑफ द नोज इज ऑन वन साइड ऑफ द मिड लाइन बट द सेंटर कम्स बैक टू वेयर इट वाज, दैट मींस नाउ इट हैज कम बैक टू द टिप. डिविएशन है इन द सेंटर बट नाउ इट हैज कम बैक एट द लोअर एंड एट द टिप बैक, दैट इज कॉल्ड एज अ क्रूकेड नोज. बट अगर डिविएशन मिडलाइन से अवे है, दैट मींस द टिप इज डिविएटेड अवे फ्रॉम द मिडलाइन, देन इट इज कॉल्ड एज अ डिविएटेड नोज. तो डिविएटेड मतलब कंप्लीटली डिविएटेड. अगर टेढ़ी होके वापस मिडलाइन में आ गई, दैट इज कॉल्ड एज अ क्रूकेड नोज. दीज आर द डिफरेंसेस बिटवीन व्हाट इज अ क्रूकेड नोज एंड व्हाट इज अ डिविएटेड नोज. ठीक, चलो आगे बढ़े. राइनोफाइमा, ऑल्सो कॉल्ड एज पोटैटो ट्यूमर. रिमेंबर, अगर क्वेश्चन आएगा राइनोफाइमा का या पोटैटो ट्यूमर का, यू नीड टू रिमेंबर द रूल ऑफ ए. रूल ऑफ ए क्या होता है? ए का मतलब एज. एज मतलब ये जनरली मोर देन 60 इयर्स के होंगे. सेकेंड, ए इज एंड्रोजन डिपेंडेंट ट्यूमर है. एंड्रोजन डिपेंडेंट का मतलब दिस इज अ मेल डोमिनेंट ट्यूमर. 7:1 के रेशियो में मेल्स में ज्यादा दिखता है बिकॉज इट इज एंड्रोजन डिपेंडेंट. थर्ड, ए इट इज सीन इन अल्कोहलिक मेल्स. फोर्थ, ए इज सीन इन अनट्रीटेड एक्ने रोजेशिया. तो कभी भी ये सारे ए होंगे. ओल्ड एज में एक आदमी जो अल्कोहलिक है और अनट्रीटेड एक्ने रोजेशिया है, तो उसके होगा क्या? देयर विल बी डायलेशन ऑफ द सेबेशियस ग्लैंड्स ओवर द नोज. देयर विल बी हाइपरट्रॉफी एंड देयर विल बी डायलेशन ऑफ द सेबेशियस ग्लैंड्स प्रेजेंट ओवर द टिप ऑफ नोज. And this dilation and hypertrophy which will be present over the tip of nose, that will produce a huge swelling. And this is a benign tumor of the nose. This is also called as a potato nose, also called as rhinophyma. ठीक है, चलो. डिविएटेड नेजल सेप्टम में सबसे कॉमन चीज जो पूछी गई है वो है ये दो क्वेश्चन. ठीक है, अगर हम नोज को उठाते हैं एंड वी सी अ डिविएशन ऑफ द सेप्टम, मतलब ये नोज का सेप्टम एक तरफ हो गया. दिस टाइप ऑफ सेप्टल डिविएशन इज व्हाट? This is called as caudal septal deviation. Caudal septal deviation का मतलब आगे से जो है डीएनएस दिखने लगा, टड़क से बाहर आ गया, टेढ़ा हो गई नाक. This is caudal septal deviation. एक तरफ डीएनएस दिख रहा है सीधा सीधा, the moment we lift the nose. That's called as caudal deviation of septum. अगर शेल्फ लाइक प्रोजेक्शन दिखा, शेल्फ लाइक का मतलब अगर ये शार्प टाइप का डीएनएस दिखा, शार्प, शेल्फ का मतलब ऐसे शेल्फ होती है ना, इसके ऊपर कॉफी रख देते हैं, तो अगर इस टाइप का डिविएशन है विच लुक्स लाइक अ शेल्फ लाइक प्रोजेक्शन, और वी कैन ऑल्सो से दिस इज अ शार्प प्रोजेक्शन इन डीएनएस, व्हाट इज दिस कॉल्ड एज? दिस इज कॉल्ड एज अ सेप्टल स्पर. इसे कहते हैं सेप्टल स्पर. अब दो इंपॉर्टेंट क्वेश्चन रिलेटेड टू डीएनएस एंड सेप्टल स्पर. Most common type of DNS which produces epistaxis is septal spur. क्यों? क्योंकि ये शार्प होता है. Most common type of DNS to produce hemifacial pain, septal spur. तो क्यों होता है पेन इन केसेस ऑफ सेप्टल स्पर? ये इंपॉर्टेंट है. लेट्स से ये हमारी नाक है, ये हमारा इंफीरियर टर्बिनेट है, ये हमारा मिडिल टर्बिनेट है. Middle turbinate is supplied by a very important nerve and that is called as anterior ethmoidal nerve. अगर किसी के भी septal spur होगा, that will irritate the anterior ethmoidal nerve. And irritation of anterior ethmoidal nerve will produce hemifacial pain. And hemifacial pain produced on irritation of anterior ethmoidal nerve is called as, it is called as Sludder's neuralgia. It is called as Sludder's neuralgia. ठीक है, फाइन. सो दिस इज समथिंग विच इज कॉल्ड एज स्लडर्स न्यूराल्जिया. ठीक है, चलो अब आगे बढ़ते हैं. अब नेक्स्ट आता है आपका कॉटल्स टेस्ट. अगर इन ऑर्डर टू फाइंड आउट द पेटेंसी ऑफ इंटरनल नेजल वाल्व, वी डू अ पर्टिकुलर प्रोसीजर विच इज कॉल्ड एज कॉटल्स मैनूवर. कॉटल्स मैनूवर में हम क्या करते हैं? हम दो उंगली लेते हैं एंड वी प्लेस इट लैटरल टू द नेजोलेबियल फोल्ड एंड वी स्ट्रेच इट आउट. इफ वी स्ट्रेच इट आउट और हम पूछते हैं पेशेंट को ब्रीदिंग बेटर हुई कि नहीं हुई, अगर पेशेंट बोलेगा मेरी ब्रीदिंग अच्छी हो गई, दैट मीन्स नाउ द नोज हैज बिकम बेटर. Whenever we are stretching it out, that means there is a blockage or there is DNS which is causing mechanical obstruction. अगर नहीं है तो that means Cottel's test is negative. So this maneuver, जो भी आपको ये दिख रहा है, this is called as Cottel's maneuver or Cottel's test. ठीक है, this is basically to test for our internal nasal valve patency. ओके, फाइन. चलो आगे बढ़ते हैं. ये क्या है? व्हाट इज दिस? फॉर सेप्टल करेक्शन या फॉर सेप्टोप्लास्टी वी डू टू टाइप्स ऑफ ऑपरेशंस. वन इज कॉल्ड एज सेप्टोप्लास्टी, वन इज कॉल्ड एज सब म्यूकस रिसेक्शन या सब म्यूकोजल रिसेक्शन. अब इसमें जो दिए गए हैं, दीज आर टू इंसिजंस व्हिच वी गिव इन सेप्टोप्लास्टी एंड एसएमआर. इफ वी गिव एन इंसिजन जस्ट एट द कॉर्डल एंड ऑफ द सेप्टल कार्टिलेज, देखो ये मेरी सेप्टल कार्टिलेज है पूरी क्वाड्रेंगुलर शेप्ड, इसके जस्ट स्टार्टिंग पॉइंट पे, दैट इज कॉल्ड एज द कॉर्डल एंड ऑफ द सेप्टल कार्टिलेज, इसके जस्ट स्टार्टिंग पे अगर हमने दिया, दिस टाइप ऑफ इंसिजन इज कॉल्ड एज अ हेमी ट्रांसफिक्सेशन इंसिजन, ऑल्सो कॉल्ड एज प्रियर्स इंसिजन. ये हो गया पहले टाइप का इंसिजन. सेकेंड टाइप ऑफ इंसिजन इज गिवन इन केसेस ऑफ एसएमआर या सब म्यूकस रिसेक्शन, where we give the incision 5 millimeters away from the caudal end of the septum. And this incision, which is given 5 mm away from the caudal end of the septum, this is called as Killian's incision. Killian's incision is given in SMR. Prier's incision is given in cases of septoplasty. ठीक है, तो ये दोनों इंसिजन्स को आपको देखकर याद रखना चाहिए कि कौन सा इंसिजन कौन सा है. किलियन पीछे होता है, प्रियर्स आगे होता है. चलो आगे बढ़े. आपने सेप्टोप्लास्टी करी, आपके पास एक पेशेंट आया who had undergone a septoplasty. आपने नेक्स्ट डे देखा कि now there are two visible boggy red swellings which appear bilaterally in bilateral nasal cavities. So what are these? इसका क्या डायग्नोसिस है? This is a septal hematoma. अगर आपको कोई भी क्वेश्चन आता है that now the patient has undergone a road traffic accident, they have developed bilateral nasal obstruction and you see boggy swellings, this is septal hematoma. What is septal hematoma? Septal hematoma is a collection of blood between the septal cartilage and the mucoperichondrium. तो एक चीज हमेशा याद रखनी है that every cartilage has got a covering over it which is called as a perichondrium. और perichondrium के ऊपर होता है म्यूकोजा. तो अगर ब्लड इकट्ठा हो जाता है between the mucosa and the perichondrium and the septal cartilage, that means now the mucoperichondrium is here and this is your septal cartilage. इनके बीच में ये ब्लड भर गया. So what is going to happen is कि perichondrium is the one which supplies your cartilage. अगर कार्टिलेज की नेक्रोज, अगर पेरिकॉन्ड्रियम को अगर इसको हमने नहीं हटाया, इफ यू डोंट टेक आउट दिस ब्लड, द पेरिकॉन्ड्रियम विल नॉट सप्लाई द कार्टिलेज एंड द कार्टिलेज विल अंडरगो avascular necrosis because all the blood vessels of cartilage lie in the perichondrium. Cartilage itself is an avascular structure. तभी what to do in cases of septal hematoma? You have to do emergency incision and drainage. आप क्या करोगे? आप लोगे एक ब्लेड और ब्लेड से आप एक इंसिजन यहां पे मारोगे, एक इंसिजन यहां पे मारोगे एंड यू विल ड्रेन इट आउट. So what you do incision and drainage. That is something which is the most important point that you do in cases of septal hematoma. Otherwise, avascular necrosis of the cartilage will happen और उससे हो जाएगा perforation. ठीक है, चलो अब आते हैं नेक्स्ट पे. नेक्स्ट क्या है? व्हाट इज दिस? आपके पास एक पेशेंट आया, उस पेशेंट के एक मिस्ड फॉरेन बॉडी है. बचपन में एक उसके गलती से नाक में फॉरेन बॉडी चली गई थी. अब वो पेशेंट आया है विद यूनिलैटरल नेजल ऑब्स्ट्रक्शन. So in patients who have got a missed foreign body मतलब वो खो गई थी कहीं, वो कभी मिली नहीं, किसी ने निकाली नहीं. तो होता क्या है, in patients who have got a missed foreign body, let's say this was a foreign body, our own body starts to make granulation tissue around it. Our own body starts to make granulation tissue around it. And over this granulation tissue, as a protective mechanism, there is laying down of मैग्नीशियम एंड सोडियम सॉल्ट्स. इसके ऊपर सोडियम और मैग्नीशियम सॉल्ट डिपॉजिट होने लगते हैं. एंड दिस सोडियम एंड मैग्नीशियम सॉल्ट्स व्हेन दे डिपॉजिट ओवर दिस मिस्ड फॉरेन बॉडी, दे विल प्रोड्यूस अ स्टोन लाइक स्ट्रक्चर. ये देखो, ये एक स्टोन की तरह ये स्ट्रक्चर बन गया है. मतलब सेंटर में कभी एक फॉरेन बॉडी रही होगी, उसके ऊपर देयर इज ग्रैनुलेशन टिश्यू एंड उसके ऊपर देयर इज डिपॉजिशन ऑफ सोडियम एंड मैग्नीशियम सॉल्ट्स. तो अब ये एक स्टोन लाइक स्ट्रक्चर बन गया है. लिथोस का मतलब होता है स्टोन. स्टोन इन द नोज इज कॉल्ड एज राइनोलिथ. तो इसको हम लोग बोलते हैं राइनोलिथ. तो राइनोलिथ हम कैसे करेंगे ट्रीट? राइनोलिथ का द ओनली ट्रीटमेंट इज रिमूवल. So if the rhinolith is small, we can take it out in one go, that is in toto. If the rhinolith is very big, then we have to break it down into multiple small pieces and that is called as piecemeal removal. ठीक है? That is the treatment for rhinolith. चलो आगे बढ़े. Now comes tumors of nose. ये मैंने एक टेबल जो बना के दी है आपको, ये सारे ट्यूमर्स को कन्वर्ट पूरी की पूरी कवर करती है और ये सारे के सारे क्वेश्चन कवर करती है अबाउट व्हाट आर द ट्यूमर्स ऑफ द नोज एंड पैरानेजल साइनसेस. ठीक है, अब मैं आपको एक एक करके बताता हूं. सबसे पहला, द मोस्ट कॉमन बिनाइन ट्यूमर ऑफ द नेजल कैविटी, आई एम टॉकिंग अबाउट बिनाइन ट्यूमर ऑफ नेजल कैविटी, इज इन्वर्टेड पैपिलोमा. उसका दूसरा नाम होता है रिंगर्ड्स ट्यूमर. इट इज द मोस्ट कॉमन बिनाइन ट्यूमर ऑफ द नेजल कैविटी. तो होता क्या है? नाउ सी दिस पर्टिकुलर इमेज. इफ यू आर गिवन एनी पर्टिकुलर केस ऑफ अ मिडिल एज मैन हु हैज कम टू यू विद यूनिलैटरल नेजल ऑब्स्ट्रक्शन एंड दैट ऑब्स्ट्रक्शन में आपको दिखता है एक मास विच इज रेडिश इन कलर. तो एक मिडिल एज मैन है जिसमें आपने देखा कि नेजल कैविटी के अंदर एक मास भरा हुआ है and this mass is basically the one which has got, इसको देखो ये इसके ऐसे उभरे हुए हैं, इसके छोटे छोटे चीजें निकली हुई हैं इससे. This is called as frond like appearance. फ्रॉन्ड लाइक मतलब जैसे ये मेरे नकल है ना, ऐसे निकले हुए हैं. तो अगर आपके पास एक मिडिल एज मैन की हिस्ट्री आई जिसमें नेजल ऑब्स्ट्रक्शन में आपको ये एक ट्यूमर टाइप का दिख रहा है नोज में, एंड दिस इज हैविंग अ फ्रॉन्ड लाइक अपीयरेंस, इसके मल्टीपल ऐसे छोटे छोटे नोड्यूल्स टाइप के निकले. दिस इज अ क्लासिकल फीचर ऑफ इन्वर्टेड पैपिलोमा एंड इट इज ऑल्सो कॉल्ड एज रिंगर्ड्स ट्यूमर. इसे इन्वर्टेड पैपिलोमा या रिंगर्ड्स ट्यूमर कहते हैं. What is the most common site from which this papilloma arises? Inverted papilloma is the most common benign tumor of the nasal cavity and it arises from the lateral nasal wall. Lateral nasal wall से सबसे commonly ये निकलता है. ठीक है? What is the epithelium from which inverted papilloma arises from? The name of the epithelium is also called as Schneiderian epithelium. अब इसमें कंफ्यूज होने की कोई बात नहीं है. जो हमारी नॉर्मल नेजल कैविटी की एपिथेलियम है, प्यूडो स्ट्रैटिफाइड सीलेटेड कॉलमनर एपिथेलियम, उसी को श्नाइडेरियन एपिथेलियम कहा जाता है. तो लैटरल नेजल वॉल का जो भी एपिथेलियम है उसको हम श्नाइडेरियन एपिथेलियम बोल रहे हैं. उससे जो भी निकल रहा है, व्हाटएवर ट्यूमर इज कमिंग आउट फ्रॉम द श्नाइडेरियन मेम्ब्रेन, that is called as a Schneiderian papilloma, also called as inverted papilloma, also given the name as Ringer's tumor. तो देखो, what you see over here, this is a CT scan. CT scan में आपको क्या इमेज दिखेगी? आपने कोरोनली एक पेशेंट को काटा, ऐसे काटा और आपने ऐसे दिखाया. जो भी CT स्कैन में ग्रे दिख रहा है दैट इज सॉफ्ट टिश्यू, जो भी CT स्कैन में व्हाइट दिख रहा है वो बोन है, और जो भी CT स्कैन में ब्लैक दिख रहा है वो एयर है. ये चीज हमें याद रखनी है. तो इससे पहले तो आइडेंटिफाई करते हैं क्या नॉर्मल दिख रहा है. देखो ये सेंटर में सेप्टम है, दिस इज इंफीरियर टर्बिनेट, ये इस साइड का मिडिल टर्बिनेट है. यू कैन सी दिस इज योर मैक्सिलरी साइनस, दिस इज ऑर्बिट. ठीक है, इधर के मैक्सिलरी साइनस में ब्लैक है क्योंकि मैक्सिलरी साइनस कंटेन्स एयर, बट इधर के मैक्सिलरी साइनस इज ग्रे. दैट मीन्स फ्रॉम द लैटरल नेजल वॉल दिस पर्टिकुलर pathology has come, and now this gray colored thing is occupying everything, even the right side of the maxillary sinus. अगर आपको ये टाइप का CT स्कैन मिला एंड आपको एक मिडिल एज आदमी मिला जिसमें नेजल ऑब्स्ट्रक्शन है, फ्रॉन्ड लाइक मास है, एंड दैट मास ब्लीड्स, आंसर इज इन्वर्टेड पैपिलोमा विदाउट अ डाउट. ठीक है, वन इंपॉर्टेंट फीचर ऑफ इन्वर्टेड पैपिलोमा इज दैट फ्रॉम whichever site this particular tumor arises from, it produces new bone. देखो इससे नई बोन बनाई है. This is the site of origin of inverted papilloma. So whenever you will see gray के पीछे एक site of origin भी दिखेगी which is white in color. This is the site of origin for this inverted papilloma. That means this is a benign etiology. अगर ये एक malignant tumor होता तो ये सारी की सारी बोन, ऑर्बिट की, नोज की, ये सब टूट चुकी होती. There would have been intense bony destruction. तो उससे में समझ में आ जाता है ये malignancy है. But this is something which is confined, ये एक space में है. That is why this is Ringer's tumor, because it is locally aggressive but it is not malignant. ठीक है, तो मैंने आपको क्या बताया इस चार्ट में, that it will arise from the Schneiderian membrane. ये benign है, locally aggressive है. इसमें unilateral nasal obstruction और epistaxis in a middle age man का एक criteria दिया जाएगा. ठीक है, now the question will be आप इसको कैसे ठीक करेंगे. तो this particular inverted papilloma has got a very high chance of recurrence. तो अगर आपने छोटा सा भी छोड़ दिया तो ये वापस आ जाएगा. तभी हम मीडियल वॉल ऑफ मैक्सिलरी साइनस, क्यों मीडियल वॉल ऑफ मैक्सिलरी साइनस, क्योंकि देखो दिस इज मीडियल वॉल ऑफ मैक्सिलरी साइनस, हम ये पूरी हटा देते हैं so that this does not have any chance to come back. If we remove the medial wall of the maxillary sinus completely, we call that particular thing as medial maxillectomy. ठीक है, तो I told you the key features are male with unilateral nasal obstruction with epistaxis 40 to 70 year old. ये याद रखना. ठीक है, दिस इज समथिंग विच इज द केस सिनारियो फॉर इन्वर्टेड पैपिलोमा. अब आ जाओ सेकेंड ट्यूमर ऑफ पैरानेजल साइनस पे. अगर मैंने कहा मोस्ट इंपॉर्टेंट और मोस्ट कॉमन कॉज फॉर नेजल कैविटी ट्यूमर, तो दैट इज इन्वर्टेड पैपिलोमा. मोस्ट कॉमन टाइप ऑफ ट्यूमर ऑफ बिनाइन एटियोलॉजी इन पैरानेजल साइनस इज ऑस्टियोमा. बिनाइन ट्यूमर ऑफ पैरानेजल साइनस सबसे कॉमन इज ऑस्टियोमा. अब ऑब्वियसली ऑस्टियोमा बिनाइन है. अब सबसे कॉमन ऑस्टियोमा कहां होता है? फ्रंटल. सबसे कॉमन, यहां पे एक हार्ड टाइप की स्वेलिंग आ जाएगी. तो फ्रंटल ऑस्टियोमास आर मोस्ट कॉमन. दे कैन इवन हैपन विद एथमोइड. अब अगर किसी भी साइनस में इतनी बड़ी बोन बन गई तो दे विल स्टार्ट कलेक्टिंग डिस्चार्ज इनसाइड इट, एंड दैट इज व्हाई दीस फ्रंटल ऑस्टियोमास आर वेरी कॉमनली एसोसिएटेड विद म्यूकोसील फॉर्मेशन. म्यूकोसील का मतलब म्यूकस कलेक्शन हो गया विद इन द साइनस, उससे वो फैल गया. दैट इज कॉल्ड एज म्यूकोसील. तो इसमें हम क्या करते हैं, व्हेनेवर वी हैव गॉट अ ह्यूज टाइप ऑफ अ फ्रंटल और एन एथमोइड टाइप ऑफ ऑस्टियोमा, उसमें हम क्या करते हैं, वी डू समथिंग कॉल्ड एज लिंच होवर्थ ऑपरेशन. लिंच होवर्थ ऑपरेशन का मतलब क्या होता है? लिंच होवर्थ ऑपरेशन का मतलब ये होता है कि इसमें लेट्स से इफ दिस इज द आई एंड दिस इज द नोज, दिस इज द नोज, राइट, वी विल गिव एन इंसिजन जस्ट फ्रॉम हियर अप टिल हियर, मीडियल कैंथस के जस्ट थोड़ी सी दूर टुवर्ड्स द डॉर्सम ऑफ द नोज, एंड वी एक्सटेंड इट अपवर्ड्स टुवर्ड्स द फ्रंटल बोन. यानी कि जब हम ये खोलेंगे तो टोटली हमारा एथमोइड एंड फ्रंटल एरिया खुल जाएगा. दिस इज कॉल्ड एज अ लिंच होवर्थ प्रोसीजर. ठीक है, राइट. दिस इज डन इन केसेस ऑफ ऑस्टियोमास. मोस्ट कॉमन टाइप ऑफ हिस्टोलॉजिकल सबटाइप ऑफ ऑस्टियोमा इज आइवरी टाइप. आइवरी ऑस्टियोमा इज द मोस्ट कॉमन टाइप ऑफ हिस्टोलॉजिकल सबटाइप व्हिच इज सीन इन पैरानेजल साइनस. आइवरी टाइप, बिल्कुल आइवरी हार्ड. अब आ जाओ नेक्स्ट पे. नेक्स्ट स्क्वामस सेल कार्सिनोमा. अगर किसी के भी मेलिग्नेंसी है तो स्क्वामस सेल कार्सिनोमा इज द मोस्ट कॉमन टाइप ऑफ हिस्टोलॉजिकल सबटाइप ऑफ पैरानेजल साइनस कार्सिनोमास. द मोस्ट कॉमन साइट फॉर पैरानेजल साइनस मेलिग्नेंसीज आर फ्रॉम विच साइनस? मैक्सिलरी साइनस. व्हाट विल बी द क्लिनिकल सिनेरियो दैट विल बी गिवन टू यू? अगर कभी भी आपको ये क्लिनिकल सिनेरियो मिला दैट देयर इज एन ओल्ड मेल और अ फीमेल विद सम nasal obstruction and that mass is profusely bleeding, and at the same time the person also shows nodal metastasis, मतलब nodes palpable हैं, जैसे 1A 1B 2। तो अगर नोड्स आ गए और एक मास आ गया और एपिस्टैक्सिस आ गया तो नोड्स विल बिकम द कैरेक्टरिस्टिक फीचर कि ये मेलिग्नेंट है, तो आंसर होगा मेलिग्नेंसी। ठीक है, अब एक इंपॉर्टेंट चीज है, स्क्वामस सेल कार्सिनोमा क्यों होता है? एस फॉर स्क्वामस सेल, एस फॉर सॉफ्ट वुड। तो जो वुड फैक्ट्री वर्कर्स होते हैं वो सबसे कॉमनली एसोसिएटेड होते हैं पैरानेजल साइनस मेलिग्नेंसी से। तो सॉफ्ट वुड वर्कर, सॉफ्ट वुड जो होती है सॉफ्ट, जैसे यूकलिप्टस, दैट इज अ सॉफ्ट वुड, पाइन इज अ हार्ड वुड। तो इसीलिए सॉफ्ट वुड causes squamous cell, S for S. Hardwood, HA, causes adenocarcinoma. So hardwood factory workers have adenocarcinoma more. Softwood factory workers have squamous cell carcinoma more. What is the treatment जो आप इसमें करेंगे? कोई भी malignancy हो पैरानेजल साइनस की तो उसमें हम क्या करते हैं? We do something called as removal of that malignancy by doing something called as surgery. तो इसमें अगर maxillary sinus है तो उसे हम करेंगे total maxillectomy. Total maxillectomy. And उसके बाद we will give the patient concurrent chemo RT. तो concurrent chemo RT, chemo और RT साथ साथ concurrent. So surgery with or without concurrent chemo RT is the treatment of choice for all paranasal sinus malignancies. अब मैं आपका एक क्वेश्चन एक और इंपॉर्टेंट आता हूं और इमेज पे आता हूं जो आपकी बड़ी कॉमनली पूछी गई है। ये क्या है? व्हाट इज दिस? तो इफ दिस इमेज इज गिवन टू यू एंड यू आर आस्क्ड कि ये कौन सा प्रोसीजर आपको दिखाया जा रहा है या इंसिजन का नाम क्या है? If we take an incision from the medial canthus of the eye, देखो ये medial canthus है, we get down along the nasolabial fold, medial canthus से nasolabial fold, we turn it around the ala, ala के around turn किया, and we get it down up till the level of upper lip, मतलब upper lip के just filtrum तक आए, medial canthus से नीचे आए, ala के around गए, and we get up till the upper lip, बिल्कुल upper lip के ऊपर हमने छोड़ दिया। अगर इंसिजन सिर्फ अपर लिप के ऊपर तक बना हुआ है, दिस इंसिजन इज कॉल्ड एज लैटरल राइनोटमी इंसिजन। अगर उन्होंने इंसिजन से लिप को थ्रू एंड थ्रू काट दिया है, देन दिस इंसिजन विल बी कॉल्ड एज वेबर फर्ग्यूसन इंसिजन। ठीक है, तो याद रखना लैटरल राइनोटमी में द लिप स्प्लिट इज नॉट देयर, वेबर फर्ग्यूसन में लिप गेट स्प्लिट। मीडियल कैंथस से एला, एला के अराउंड टर्न किया, आए अप टिल द अपर लिप, लैटरल राइनोटमी, लिप को स्प्लिट भी कर दिया, वेबर फर्ग्यूसन। बोथ दीज इंसिजन्स आर डन फॉर टोटल मैक्सिलेक्टमी। So this what I have shown here, this is done for total maxillectomy. Another important line. If somebody has got a maxillary tumor, let's say यहाँ पे एक maxillary tumor है, how will we tell what is the prognosis of this tumor? तो होता क्या है, if we draw an imaginary line from the medial canthus to the angle of mandible, ऐसे, this line is called as Orngren's line. Orngren line. Any tumor which is below this line will have good prognosis. अगर कोई ट्यूमर इस लाइन को क्रॉस करके ऊपर चला गया, that tumor will have bad prognosis. तो ऑनग्रेन लाइन के नीचे ट्यूमर की अच्छी प्रोग्नोसिस है, अगर इसके ऊपर हो गया तो इसकी प्रोग्नोसिस खराब है। Why? Because many critical structures like brain, orbit are above it. ठीक है, चलो ये खत्म होता है हमारा इंपॉर्टेंट ट्यूमर्स ऑफ नेजल कैविटी। अब आते हैं इनटू व्हाट आर द फ्रैक्चर्स ऑफ फेस। ये भी इंपॉर्टेंट क्वेश्चन है। फ्रैक्चर्स ऑफ फेस में दो तरीके के डायग्राम मैंने दे रखे। दीज आर द सेप्टल फ्रैक्चर्स व्हिच यू गेट। मोस्ट कॉमन फ्रैक्चर ऑफ फेस आर नेजल फ्रैक्चर्स। So nasal fractures are the most common fractures of the face. Two types of fractures are given over here. One is called as chevalet, one is called as jarjave. अगर किसी के भी कोई सामने से घूंसा मारेगा, सामने से यूं नाक पे ऐसे ऐसे पड़ी, तो फ्रैक्चर की लाइन कैसे जाएगी? The fracture line in cases of a frontal blow, सामने से कोई मारेगा, will start from the anterior end of the septal cartilage, go posteriorly, and it will move towards the perpendicular plate of ethmoid. So this fracture line will run parallel to the junction between the septal cartilage and the vomer. ये देखो, ये मेरी vomer है, ये septal cartilage है, ये इनका junction है। ये fracture line is parallel to the junction between the septal cartilage and the vomer, and it goes upwards towards the perpendicular plate of ethmoid bone. ये ऊपर तक जा रहा है। जार्ज अवे आएगा और ऊपर की तरफ जाएगा, जार्ज अवे फ्रैक्चर। अगर किसी को नीचे से किसी ने मारा यूं, तो ऑब्वियसली नीचे से अगर किसी का ब्लो है तो उसका सेप्टल फ्रैक्चर विल स्टार्ट फ्रॉम द एंटीरियर एंड ऑफ द सेप्टल कार्टिलेज, इट विल मूव अप perpendicularly and it will go up till the junction of the nasal bone and the upper lateral cartilage. ये मेरी नेजल बोन है और इसके नीचे अपर लैटरल कार्टिलेज है, तो ये नीचे सेप्टम ऐसे टूटेगा ऊपर तक, जस्ट एट द जंक्शन बिटवीन माय नेजल बोन एंड द अपर लैटरल कार्टिलेज, ये नीचे से ऊपर जाएगा। दिस इज कॉल्ड एज व्हाट? दिस इज कॉल्ड एज अ वर्टिकल फ्रैक्चर। तो अगर आपको वर्टिकल फ्रैक्चर देखना है तो नीचे से किसी को मारो, दैट इज शेवलेट। अगर आपको हॉरिजॉन्टल फ्रैक्चर देखना है या पैरेलल टू द सेप्टम एंड वोमर देखना है, देन इट इज जार्जवे, दैट इज फ्रॉम द फ्रंटल ब्लो, दिस इज फ्रॉम फ्रंटल ब्लो। ठीक है, दीज आर द टू इंपॉर्टेंट नेजल बोन फ्रैक्चर्स। ओके, चलो आगे बढ़े। अब आता है एक और इंपॉर्टेंट साइन, सीएसएफ राइनोरिया। बहुत इंपॉर्टेंट क्वेश्चन। अगर सीएसएफ नोज से लीक करने लगे, वी कॉल दैट एज सीएसएफ राइनोरिया। What are the signs of CSF rhinorrhea? Let's first discuss that. अगर किसी के भी CSF rhinorrhea है तो सबसे पहले क्या होगा कि जब भी उसको बोलेंगे कि भाई ऐसे झुक जाओ, तो टप 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 CSF गिरने लगेगा। इसका मतलब क्या है कि जैसे आप चाय गिराते हैं, like a teapot, CSF भी ऐसे ही गिरेगा, because when I bend down, my CSF pressure raises, and that is the reason my CSF will also start leaking out. This is called as teapot sign, first sign of CSF rhinorrhea. Now let's come to the second sign of CSF rhinorrhea. Second sign of CSF rhinorrhea ये है, which is called as reservoir sign. Reservoir का मतलब क्या है? अगर किसी के CSF rhinorrhea होता है या CSF लीक होती है नोज से, तो जब वो सोएगा तो वो पीछे अपना सारा CSF स्फीनोइड में कलेक्ट करेगा। All the CSF start getting collected in the sphenoid sinus जब आदमी सोता है। तो होता क्या है, जब वो उठेगा सडनली ग्रेविटी की वजह से सारा CSF बाहर आ जाएगा। That means sphenoid sinus acts as a reservoir of CSF during sleep. और जैसे ही आदमी उठेगा सुबह, वैसे ही सारा का सारा CSF will gush out. This is called as reservoir sign. Third, handkerchief sign. CSF में म्यूकस नहीं होता, CSF पानी है। म्यूकोइड डिस्चार्ज इज क्रिएटेड बाय द नोज एपिथेलियम। तो जब आपके नोज, जब भी आपकी एलर्जी होती है, जब आपकी नाक बहती है, तो क्या करते हैं, यू टेक अ हैंकी एंड यू पुट इट इन योर पॉकेट। आप देखते हो हैंकरशिफ स्टिफ हो जाता है। व्हाई डज इट स्टिफन? बिकॉज योर नेजल डिस्चार्ज कंटेन्स म्यूकस, बट CSF डज नॉट कंटेन एनी म्यूकस। तो जब भी CSF कोई भी पूछता है, द हैंकरशिफ डज नॉट स्टिफ, वो स्टिफ नहीं होगा। दैट इज व्हाई वी आस्क द पेशेंट्स की स्टिफ हुआ कि नहीं हैंकरशिफ, तो वो कहेगा नहीं, तो दैट इज हैंकरशिफ साइन। फोर्थ साइन ऑफ CSF इज कॉल्ड एज स्निफ साइन। जब भी आपकी नाक बहती है, नेजल डिस्चार्ज आता है, तो आप क्या करते हैं, आप ठीक हो जाते हैं। यू कैन स्निफ अ डिस्चार्ज बट यू कैन स्निफ बैक CSF। आप CSF को वापस नहीं ले पाएंगे बिकॉज इट इज कमिंग फ्रॉम द इंट्राक्रैनियल कंपार्टमेंट। दैट्स कॉल्ड अ स्निफ साइन। एंड फाइनली कम्स हैलो साइन, टारगेट साइन या बुलजाई साइन। दिस इज सीन इन केसेस ऑफ ट्रॉमेटिक CSF लीक्स। आप इमरजेंसी में, रोड ट्रैफिक एक्सीडेंट का पेशेंट आया है, he has fell down over the nose, he has fractured over his external nose, उसके ब्लीडिंग हो रही है। आपको कैसे पता चलेगा कि CSF ब्लड में मिक्सड है कि नहीं? तो व्हाट विल यू डू, यू विल जस्ट टेक अ स्मॉल ब्लॉटिंग पेपर, उस ब्लॉटिंग पेपर के ऊपर यू विल टेल द पेशेंट टू पुट अ ड्रॉप ऑफ CSF। अब अगर पेशेंट ने ड्रॉप ऑफ CSF गिराई, सो देयर इज अ प्रिंसिपल ऑफ डिफ्यूजन क्रोमैटोग्राफी। डिफ्यूजन क्रोमैटोग्राफी का मतलब कोई भी चीज भारी होती है वो सेंटर में रंग बनाती है, और कोई भी चीज जो हल्की होती है वो साइड साइड में चली जाएगी एंड इट विल क्रिएट अनदर कलर। So the CSF will get diffused away and it will produce a pale color and the center will be red in color, which is heavier, which is blood. तो ये ऐसे लग रहा है किसी ने बुलजाई लगा दिया है, किसी ने टारगेट लगा दिया है। This is called as target sign, bullseye sign, also seen in cases of traumatic CSF leak. ठीक है, fine. So this is something that finishes about another important topic, that is signs of CSF rhinorrhea. अब important CSF rhinorrhea के question, अगर मैं आपसे पूछूं what is the most significant या investigation of choice for CSF rhinorrhea, biochemical investigation, मतलब कौन सी ऐसी investigation आप भेजना चाहते हैं which will confirm CSF rhinorrhea, तो you will tell me, you will send beta-2 transferrin levels. Beta-2 transferrin is a protein which is created from the choroid plexus of the brain. choroid plexus से CSF भी बनता है, तो this is only seen in CSF. बट आजकल इससे ज्यादा सेंसिटिव, इससे ज्यादा स्पेसिफिक मार्कर आ गया है। तो इफ देयर इज समथिंग कॉल्ड एज बीटा ट्रेस प्रोटीन, बीटा ट्रेस प्रोटीन्स आर मोर सेंसिटिव एंड मोर स्पेसिफिक देन बीटा 2 ट्रांसफेरिन लेवल्स। एंड दैट इज वाई अगर दोनों के बीच में आपको ऑप्शन दिया जा रहा है, दिस इज अ बेटर ऑप्शन दैन बीटा 2 ट्रांसफेरिन. अगर दोनों में से सिर्फ एक दिया जा रहा है, दैट इज द आंसर. These are the investigation of choice for biochemical investigations. What is the radiological investigation of choice for this? There will be CT cysternography. This will, a patient will be given a dye and that dye will go into the side of the defect and it will leak down. उसके बाद हम उसको CT देंगे. तो जब CT करेंगे तो हमें दिखेगा वो dye चमकता हुआ when it is leaking out. This is the radiological investigation of choice, either CT or MR cysternography. Any of the two. ठीक है. अब जब भी आपके पास क्वेश्चन आएगा, सबसे पहले आपसे क्या पूछा जाएगा कि सीएसएफ राइनोरिया का आपके पास पेशेंट आया है, ट्रॉमेटिक सीएसएफ लीक है, व्हाट आर यू गोइंग टू डू नेक्स्ट? तो आप सर्जरी नहीं करेंगे, सबसे पहले सर्जरी नहीं होती. द फर्स्ट लाइन ऑफ चॉइस फॉर ट्रीटिंग सीएसएफ राइनोरिया इज वेट एंड वॉच. तो सबसे पहले आप क्या करेंगे? यू विल टेल द पेशेंट टू रेस्ट, यू विल इंक्लाइन द पेशेंट्स हेड अप टू 45 डिग्रीज, यू विल गिव द पेशेंट स्टूल सॉफ्टनर ताकि स्ट्रेन ना करे, you will tell the patient not to strain, you will give mucolytics so that cough na aaye, you will give antihistamines taki sneeze na aaye. This is how you treat CSF rhinorrhea. Drug of choice for CSF leak is acetazolamide. Acetazolamide की tablet आती है which is around 500 mg per day. This is a carbonic anhydrase inhibitor. So this will reduce the formation of CSF from the brain, so that will reduce down the pressures of CSF2. ठीक है. अब आ जाते हैं, if not, then after 14 days, अगर 14 days के बाद भी we do not get better with medical line of management, then we will do a surgical approach where we will seal that defect जहां से वो आ रहा है. ठीक है. So this is something that is very very important as far as CSF leaks and your questions are concerned. ठीक, चलो आगे बढ़े. ग्रैनुलोमैटस डिजीज ऑफ नोज, ये धीरे धीरे जैसे कि जैसे क्वेश्चन है ना वैसे के वैसे ही आएंगे. व्हाटएवर आई हैव शोन यू, दीज आर द इमेजेस फॉर ग्रैनुलोमैटस डिजीजेस ऑफ द नोज. ठीक, यू हैव गॉट अ पेशेंट हु इज अ यंग पेशेंट हु बिलोंग्स टू अ सदर्न स्टेट ऑफ इंडिया. दिस पर्टिकुलर पर्सन हैज गॉट अ हिस्ट्री ऑफ स्विमिंग इन अ डर्टी पॉन्ड. स्विमिंग इन अ डर्टी पॉन्ड मतलब क्या होगा? इफ अ पर्सन गोज एंड स्विम्स इनटू अ डर्टी पॉन्ड, then there is an organism which is called as Rhinosporidium seaberry. This is an aquatic protyston which belongs to the class Mesomycetozoa. पहले बोला जाता था ये फंगाई है, बट नहीं, ये एक aquatic protyston है. तो क्या करता है? ये गंदे गंदे पानी में तैरता रहता है. So the moment anybody bathes down into that dirty water, ये aquatic protyston अंदर चला जाता है into the nasal cavity. And what does it do? It starts to form something called as spores. ये spore बनाता है. And that spore is covered by an important thing which is called as a sporangium. तो देखो ये है इसका sporangium. What you are seeing over here, this is a covering which is called as a sporangium. And inside the sporangium, you will find these multiple basophilic spores. You can see these are multiple basophilic spores which are filled inside the sporangium. This is a classical histopathological picture of rhinosporidiosis, right? Now, if you see this particular person who has rhinosporidiosis, they will develop clinical features of what? They will have unilateral nasal obstruction. They will have unilateral nasal obstruction and they will have epistaxis. Epistaxis. So if the patient has got epistaxis and unilateral nasal obstruction, that particular patient definitely can be of rhinosporidiosis. अब what are the signs of rhinosporidiosis? आपको क्या दिख रहा है? तो आपको दिख रहा है एक बड़ा सा स्ट्रॉबेरी कलर का मास. बिल्कुल ठीक. तो आई थिंक अनिकेत has already answered. So this is a strawberry lesion in cases of rhinosporidiosis. स्ट्रॉबेरी क्यों? क्योंकि देखो ये रेड इन कलर है और जो ये स्पोरांजिया है ना, these sporangia appear to be like white dots. इसके ऊपर ये white कलर के डॉट्स दिखेंगे over this, and this is the classical feature for rhinosporidiosis. Now comes how will you treat it? The treatment of choice for rhinosporidiosis is always surgical. So we will surgically remove this rhinosporidiosis with the help of an endoscope and we will burn the base or we will cauterize the base जहां से ये निकल रहा है ताकि ये वापस ना आए. At the same time, this is very recurrent disease. तो ये recur ना करे, इसलिए recurrence के लिए we give the patient, the drug of choice is Dapsone. We give a tablet called Dapsone which is given 100 mg per day for roughly around 6 months. ठीक है, दिस इज द ड्रग ऑफ चॉइस. ओके, चलो आगे बढ़े. Now let's come to this. Okay, now you have got a particular person who has got firm nodules which are present in bilateral nasal cavity. तो अब आगे बात nodules की. So if you get any particular case where you have got these kind of dirty nodules which are present in bilateral nasal cavity, this case is of rhinoscleroma. Right? This case is of rhinoscleroma. Now, what is this rhinoscleroma? Rhinoscleroma is a chronic granulomatous disease. It is a chronic granulomatous disease which is caused by an organism called as Klebsiella rhinoscleromatis. इसे बनाता है Klebsiella rhinoscleromatis. अभी इसका नाम rhinoscleroma पड़ गया. Right? Now, rhinoscleroma जब होता है किसी को, तो rhinoscleroma की 3 स्टेजेस होती हैं. 3 स्टेजेस ऑफ rhinoscleroma कौन सी होती है? एट्रोफिक स्टेज, granulomatous stage एंड cicatricial स्टेज. ये 3 स्टेजेस हैं राइनोस्क्लेरोमा की. राइट? तो कौन सी इंपॉर्टेंट स्टेजेस हैं? राइट? एट्रोफिक स्टेज में देयर इज एट्रोफी दैट हैपेंस इन द यूनिलैटरल नेजल कैविटी एंड देयर इज गोइंग टू बी क्रस्टिंग. जैसे एट्रोफिक राइनाइटिस में होता है ना, ग्रीन कलर के क्रस्ट बन जाते हैं. तो देयर इज गोइंग टू बी एक्सटेंसिव क्रस्टिंग इनसाइड द नेजल कैविटी एंड फाउल स्मेलिंग नेजल डिस्चार्ज. तो एट्रोफिक स्टेज ऑफ राइनोस्क्लेरोमा हैज गॉट बहुत सारे गंदे गंदे क्रस्ट बनते हैं एंड देयर विल बी अ वेरी फाउल स्मेलिंग नेजल डिस्चार्ज इन द एट्रोफिक स्टेज. नाउ कम्स द सेकंड स्टेज. ये इंपॉर्टेंट है. सेकंड स्टेज इज ग्रैन्युलोमैटस स्टेज. ग्रैन्युलोमैटस स्टेज में क्या होगा? देयर विल बी फॉर्मेशन ऑफ मल्टीपल फर्म non-ulcerative, this is the word, non-ulcerative nodules at the mucocutaneous junction. तो नाक के जो mucocutaneous junction है उसमें खूब सारे nodules बनेंगे, but they will be non-ulcerative. This is the word. अगर आपको non-ulcerative nodule term मिल गया, answer is going to be rhinoscleroma. These nodules do not ulcerate, they heal with fibrosis. ये फाइब्रोस करते हैं. तो जब भी किसी के राइनोस्क्लेरोमा होता है, they will have these kind of nodules which will not be ulcerative, they will be firm, they will be woody hard. ये बिल्कुल लकड़ी की तरह हार्ड हो जाते हैं. अब किसी के भी नाक में अगर नोड्यूल दोनों साइड में बन गए, ये नाक ऐसे फैल जाएगी. तो सी द नोज हैज ब्रॉडेंड अ लॉट. दिस इज कॉल्ड एज अ हेब्रा नोज डिफॉर्मिटी. हेब्रा का मतलब जीब्रा और हॉर्स का क्रॉस कर दो तो वो हेब्रा होता है, जिसकी बड़ी सी नाक होती है. तो दिस इज कॉल्ड एज हेब्रा नोज डिफॉर्मिटी. हेब्रा नोज इज सीन इन विच स्टेज? ग्रैनुलोमैटस स्टेज. यहां पे क्या होता है? देयर आर firm woody hard nodules which are non-ulcerative, which are formed at both the sides of the nasal cavity at the mucocutaneous junction. ठीक? अब I told you that these nodules will not ulcerate. ये क्या करेंगे? ये फाइब्रोज हो जाएंगे. तो कुछ टाइम के बाद ये जब फाइब्रोज हो जाएंगे तो क्या होगा? नाक एकदम पतली हो जाएगी. You'll see the nose has become tapered. So when the nose will become fibrosed or tapered, वो बिल्कुल इस जानवर की तरह दिखेगी. This is a herbivore and this guy's name is a tapir. इसे हम लोग एक टापीर कहते हैं. इसकी छोटी सी एक स्नाउट होती है. दिस एक्चुअल स्नाउट एक्चुअली रिजेंबल्स अ राइनोस्क्लेरोमा नोज. तो जब भी सिकैट्रिशियल स्टेज आती है या फिर स्टेज आती है जिसमें फाइब्रोसिस हो जाती है, द नोज बिकम्स लाइक अ टापीर, ये एक एनिमल की तरह. तो दिस इज कॉल्ड एज अ टापीर नोज डिफॉर्मिटी. नाउ माय क्वेश्चन इज कि राइनोस्क्लेरोमा को ठीक कैसे करेंगे? राइनोस्क्लेरोमा का कोई सर्जिकल मैनेजमेंट नहीं है. जब भी किसी को राइनोस्क्लेरोमा होता है, वी गिव ड्रग्स अगेंस्ट क्लेब्सियला राइनोस्क्लेरोमैटिस. So the first and foremost feature is that whenever we give, the drug of choice is streptomycin. Drug of choice is streptomycin or rifampicin. एक और important चीज है which is called as local application of acreflavin solution. Acreflavin एक छोटा सा solution होता है जो इन nodules के ऊपर अगर हम लगा देते हैं, so they do not increase in size and they fibrose. So that is what is called as a medical line of management. अगर किसी को टापीर नोज डिफॉर्मिटी बाद में हो चुकी है, then we can do a surgery to correct the nose, which is called as a nose job, and that is called as rhinoplasty. तो अगर किसी की नाक पतली हो गई है, then we do rhinoplasty, but that is only done after the acute infection has subsided, otherwise not. ठीक है? So these are the whole sole things what you need to know about in rhinoscleroma. अब एक इंपॉर्टेंट पॉइंट, ये भी एक क्वेश्चन है. अगर मैंने उस नोड्यूल की बायोप्सी निकाल ली, तो what is the investigation of choice for rhinoscleroma to confirm it? Histopathology. What will you see in histopathology? So if we take a histopathology of rhinoscleroma, we will see foam-like macrophages. ये देखो, ये खूब सारे empty macrophages हैं. You can see that empty macrophages. These are foam-like macrophages. These foam-like macrophages or empty macrophages, which are seen as a characteristic feature of rhinoscleroma, are called as 𝐒𝐿𝐼C cells. इन्हें कहते हैं 𝐒𝐿𝐼C cells. In between these 𝐒𝐿𝐼C cells, can you see these kind of pink inclusion bodies? These pink inclusion bodies are actually plasma cells which are laden with immunoglobulins. तो जो भी immunoglobulin बन रहे हैं against rhinoscleroma, they get trapped inside plasma cells. और plasma cells immunoglobulin बनाते हैं, तो वो अंदर इसके रह जाते हैं. And that plasma cell together with that immunoglobulin stains eosinophilic. उसमें eosin चला जाता है ज़्यादा. So these eosinophilic inclusions, these are the ones which are given the name as Russell bodies. इन्हें हम बोलते हैं Russell body. तो Russell body और 𝐒𝐿𝐼C cell किसके इंपॉर्टेंट फीचर्स हैं राइनोस्क्लेरोमा के? विदाउट अ डाउट. ठीक है, चलो आगे बढ़े. ये क्या दिख रहा है? व्हाट डू यू सी ओवर हियर? तो अगर आपको कभी भी फ्रंटल साइनोसाइटिस होती है, तो फ्रंटल साइनोसाइटिस में समटाइम्स देयर कुड बी अ बॉगी एब्सेस दैट कैन फॉर्म ओवर द फोरहेड. हो सकता है ये फ्रंटल बोन टूट जाए, फ्रंटल बोन कैन बिकम ऑस्टियोमाइलाइटिक एंड एब्सेस और पस कैन कलेक्ट जस्ट बीनीथ द स्किन. So this particular abscess which forms underneath the skin over in the frontal region, this is called as a Pott's puffy tumor. So Pott's puffy tumor अगर दिखा तो it's not a tumor, it's a misnomer. This is something which is a boggy swelling, which is an abscess which is present underneath the skin. ठीक है? अब what is this? This is called as an X-ray Waters view. Waters view is done to identify which sinus. Best sinus to see on Waters view is maxillary sinus. Which X-ray view is used to visualize the frontal sinus? Caldwell's view is used to visualize the frontal sinus. तो ये दो व्यू होते हैं, एक होता है Waters view, एक होता है Caldwell's view. For frontal you want Caldwell, for maxillary there is Waters. अब water कैसे है? Water ऐसे है, पानी पीते हैं जैसे, बट ये पानी वाला वाटर नहीं है. दिस इज समथिंग व्हिच वाज डॉक्टर वाटर्स हु एक्चुअली गॉट दिस व्यू. तो अगर मैं 45 डिग्री बेंड कर लूं अपना हेड पोस्टीरियरली एंड आई ओपन माय माउथ एंड अ बीम इज कमिंग पोस्टेरो एंटीरियरली एंड इट इज मेकिंग एन एक्सरे, दैट इज कॉल्ड एज वाटर्स व्यू. नाउ वेरी इंपॉर्टेंट थिंग इज कि इस वाटर्स व्यू में अगर पेशेंट के अक्यूट साइनोसाइटिस है तो आपको क्या दिखेगा? वाटर्स व्यू में हमेशा ये चीज हमें याद रखनी है, एयर लाइट होती है और फ्लूइड डेंस होता है. तो किसी के भी अगर अक्यूट साइनोसाइटिस होती है तो अगर फ्लूइड नीचे है और एयर ऊपर है, दिस इज कॉल्ड एज एयर फ्लूइड लेवल. एयर फ्लूइड लेवल इज अ क्लासिकल फीचर फॉर अक्यूट साइनोसाइटिस. द क्लासिकल फीचर फॉर अक्यूट साइनोसाइटिस. ठीक है, चलो आगे बढ़े. ओके, नाउ वी कम टू पॉलिप्स. अब एक चीज जो बार बार पूछी जाती है, दैट्स व्हाई इन पॉलिप्स आई हैव नॉट गॉन इनटू मच ऑफ डिटेल. द ओनली थिंग दैट दे रिकरेंटली आस्क इन पॉलिप्स इज समथिंग व्हिच इज रिलेटेड टू सिंड्रोम वाले क्वेश्चन. तो हम वहीं पे फोकस करेंगे कि ये सिंड्रोम्स क्या होते हैं. तो पॉलिप दो तरीके के होते हैं, वन इज एंट्रोकोनल पॉलिप, वन इज एथमोइडल पॉलिप. एंट्रोकोनल पॉलिप यूजुअली हैपेंस इन यंगर पीपल व्हिच अराइज फ्रॉम द मैक्सिलरी साइनस एंड द कॉज इज इन्फेक्शन. अगर किसी के रिपीटेड अक्यूट साइनोसाइटिस हो रही है, इन्फेक्शियस एपिसोड्स हो रहे हैं साइनस में, यंग है, मेल है और यूनिलैटरल पॉलिप है, तो दैट इज समथिंग व्हिच इज एंट्रोकोनल. लेकिन अगर किसी के बायलैटरल पॉलिप्स हैं, मल्टीपल हैं, ग्रेप लाइक हैं, एलर्जी की वजह से हैं, देन दैट इज एथमोइडल. तो एथमोइडल हमेशा बायलैटरल होते हैं, एंट्रोकोनल यूनिलैटरल होता है. एंट्रोकोनल हमेशा इन्फेक्शियस एटियोलॉजी के हमेशा वजह से होता है. एथमोइडल इज हैपनिंग बिकॉज ऑफ एलर्जी, लॉन्ग स्टैंडिंग एलर्जी. तो नाउ व्हाट आर द इंपॉर्टेंट क्वेश्चंस दैट आर रिलेटेड विद पॉलिप्स. अगर किसी की आप एंडोस्कोपी करते हैं पॉलिप में एंड पॉलिप आपको खूब सारे दिखते हैं, देखो एक पॉलिप, दो पॉलिप, तीन पॉलिप, चार पॉलिप, तो बहुत सारे पॉलिप्स हैं. दिस इज कॉल्ड एज अ मल्टीपल ग्रेप लाइक अपीयरेंस ऑफ एथमोइडल पॉलिप्स. क्वेश्चन इसमें क्या आते हैं, व्हाट आर द कॉजेज ऑफ एथमोइडल पॉलिप, दे आस्क अ लॉट. तो यू कैन रिमेंबर द कॉजेज ऑफ एथमोइडल पॉलिप बाय 4C एंड 4A. ये हमारा निमोनिक है. तो 4C और 4A क्या है? First C is cystic fibrosis. If they give you a question in which they have told that the patient has got multiple polyps inside the nose and there is raised sweat chloride. If there is raised sweat chloride, why? Because this happens because of a mutation in the sodium and chloride co-transporter. Cystic fibrosis में there is a gene which is called as CFTR gene, cystic fibrosis transporter gene, and that is the one which regulates our co-transport between sodium and chloride. तो इसकी वजह से सोडियम एंड क्लोराइड का स्वेट क्लोराइड बढ़ जाता है. दैट इज वाई सिस्टिक फाइब्रोसिस में पॉलिप और स्वेट क्लोराइड एक के बाद एक उन्होंने मेंशन करेंगे. सेकंड, the second thing obviously that can lead to polyp is obviously long standing rhinosinusitis. That is obviously a question. Third is certain important disorders, certain important syndromes. So first syndrome that is associated is Churg-Strauss syndrome. Churg-Strauss syndrome में तीन चीजें होती हैं. The person who comes with Churg-Strauss syndrome has got vasculitis. So they present with rapidly progressive glomerulonephritis, eosinophilia and asthma. So they will always present polyps with RPGN, eosinophilia and asthma. तो इसको मैं रिमेंबर कैसे करता हूं? मैं हमेशा सोचता हूं कि रिया एक लड़की है जिसके चर्ग-स्ट्रॉस. तो चर्ग-स्ट्रॉस हैपेंड टू रिया. तो REA आपको याद रखना है. ठीक है? ओके. नाउ लेट्स कम टू द फोर्थ वन. ओके. द फोर्थ वन इज सीलियरी डिसऑर्डर्स. सीलियरी डिसऑर्डर्स का मतलब क्या हो गया कि जो सीलिया है वो मूव करना बंद हो गए. ओके. दैट इज व्हाट इज कॉल्ड एज सीलियरी डिसऑर्डर्स. राइट? नाउ व्हाट इज दिस सीलियरी डिसऑर्डर ऑल अबाउट? सीलिया जब मूव करना बंद कर गए, then that will be seen in two important syndromes. अब ये सबसे हिट क्वेश्चन है. What is the characteristic triad for cartilaginous syndrome and what is the characteristic triad for Young syndrome? अगर किसी भी इंसान के साइनोसाइटिस, ब्रोंकिएक्टासिस एंड साइटस इन्वर्सस है. साइनोसाइटिस मतलब पॉलिप्स है, ब्रोंकिएक्टासिस है एंड साइटस इन्वर्सस मतलब हार्ट उल्टा हो गया, डेक्स्ट्रोकार्डियक. That is called as cartilaginous. बस इसमें एक छोटी सी चेंज है. यंग लोगों में क्या होता है? यंग लोगों में एज़ोस्पर्मिया. तो अगर यंग है तो साइनोसाइटिस ब्रोंकिएक्टासिस इज स्टिल द सेम, बट इसमें एज़ोस्पर्मिया लगा दो. If they have put situs inversus as a triad, then that becomes cartilaginous. If they have put azoospermia, then they are talking about young. बस ये दो चीजें आपकी डिफरेंट है between the two syndromes, बाकी सेम. ठीक है? चलो बाकी के चार ए कौन से होते हैं? Allergy and asthma is obviously the leading cause of ethmoidal polyposis. ठीक? Allergic fungal sinusitis. So fungal sinusitis is the leading cause. So 80% of ethmoidal polyps are actually allergic fungal. और फाइनली आता है सैम्टर्स ट्रायड. सैम्टर्स ट्रायड को याद करने के लिए है आम आदमी पार्टी, AAP, अस्थमा, एस्पिरिन इंटॉलरेंस एंड पॉलिप. तो अस्थमा, एस्पिरिन इंटॉलरेंस एंड पॉलिप, these three are related with सैम्टर्स ट्रायड. ठीक है भी? ठीक है, चलो चलते रहो. ओके. एट्रोफिक राइनाइटिस का क्या क्वेश्चन आया है? एट्रोफिक राइनाइटिस में एट्रोफी मतलब सारे के सारे नेजल टर्मिनेट्स, नेजल म्यूकोजा एट्रोफी कर चुके हैं. दैट हैज बिकम श्रंकन, दैट हैज बिकम डिस्ट्रॉयड. व्हाट इज द कॉजेटिव ऑर्गेनिज्म फॉर एट्रोफिक राइनाइटिस? इट्स इज क्लिप्शिला ओजेनी. क्लिप्शिला ओजेनी इज द इंपॉर्टेंट ऑर्गेनिज्म विच कॉजेज इट. ठीक है? नाउ देयर इज अ ट्रायड विच यू सी इन केसेस ऑफ एट्रोफिक राइनाइटिस. तीन इंपॉर्टेंट चीजें जो एट्रोफिक राइनाइटिस में आपको दी जाएंगी. इफ यू सी एनी पेशेंट who has got foul smelling nasal discharge, greenish colored crust inside the nasal cavity and roomy nasal cavity. This triad is classical feature for atrophic rhinitis. मतलब जो भी ऑर्गेनिज्म है, this will produce green colored crust. ये देखो गंदे गंदे green colored crust बन गए. And there will be foul smell which will come out of the patient. Why? Because there is foul smelling nasal discharge. And at the same time उसकी जो नाक है वो बड़ी हो जाएगी because there is intense destruction inside the nasal cavity. So this will produce what? This will produce nasal obstruction, right? This patient is of atrophic rhinitis. अब एक चीज इन क्लासिकल इनमें दिखती है that because of the destruction of many things inside the nose, even the olfactory neurons get destroyed. Now because of the destruction of olfactory neurons in atrophic rhinitis, patient अपने खुद की स्मेल नहीं सूंघ पाता. Only the person who is next to them actually can smell them. And that is why it is a mercy on the patient that they cannot smell their own discharge, and that is what is called as merciful anosmia. तो कहीं पे भी ये सारे ट्रायड्स दिखते हैं या इंपॉर्टेंट ये दिखता है, then the answer is atrophic rhinitis without a doubt. अब इंपॉर्टेंट, एट्रोफिक राइनाइटिस का प्राइमरी मैनेजमेंट होता है मेडिकल. इट इज नॉट सर्जिकल, इट इज मेडिकल. प्राइमरी मैनेजमेंट. So the management of atrophic rhinitis is primarily medical. What are the treatments that are given in atrophic rhinitis? Mnemonic is डॉग्स क्या करते हैं? बार्क करते हैं इन द पार्क. डॉग्स बार्क इन द पार्क. ठीक है, दिस इज द प्राइमरी निमोनिक. ठीक है, तो स्नेहजीत इज ऑलरेडी आंसरिंग. ग्रेट. तो व्हाट इज डॉग्स? डी इज फॉर डूशिंग. डूशिंग का मतलब होता है सफाई. अल्कलाइन नेजल डूशिंग. तो व्हाट वी डू इन डूशिंग? तो अल्कलाइन नेजल डूशिंग में हम क्या करते हैं? वी टेक 28.4 grams ऑफ सोडियम बाइकार्बोनेट, 28.4 grams of sodium diborate and 56.7 grams of sodium chloride. ये तीन इंपॉर्टेंट सॉल्ट्स हैं विच वी यूज इन आवर अल्कलाइन नेजल डूश. क्यों करते हैं? बिकॉज सोडियम बाइकार्बोनेट डिसॉल्व्स दिस क्रस्ट. ये क्रस्ट को डिसॉल्व कर देगा. जब भी कहीं सोडियम बाइकार्बोनेट डालेंगे क्रस्ट टूट जाएंगे. सोडियम डाइबोरेट क्या होता है? इट्स एन एंटीसेप्टिक. और सोडियम क्लोराइड क्या करता है? दिस विल वॉश ऑल द डेब्रीज एंड इट विल डिक्रीज द एडिमा. तभी इन तीनों सॉल्ट्स को लेकर हम एक बनाते हैं सोल्यूशन इन 280 ml ऑफ वाटर एंड वी टेल द पेशेंट टू टेक अ सिरिंज एंड क्लीन द नेजल कैविटी. This will help in healing of the nasal cavity and regeneration. This is why the first thing is douching. That is the first point which you will give in atrophic rhinitis. अब आता है O. O is we will give the patient estradiol nasal spray. Estrogen या estradiol causes vasodilation, which will decrease crusting, which will decrease the destruction which is present over in the nasal cavity. Third, G. G is glucose plus glycerine drops. So what do? We take 25% of glucose with glycerine. इसकी हम एक सोल्यूशन बॉटल में बनाते हैं और इसको हम ऐड करते रहते हैं. तो इससे होता क्या है? जो ग्लूकोज है, when it goes into an anaerobic environment, glucose goes and forms lactic acid. जब भी किसी anaerobic environment में जाएगा तो क्या होगा? Whenever lactic acidosis happens or lactic acid starts to collect, there will be decrease in organism growth. ठीक है, बिल्कुल ठीक. तो लैक्टेट डिक्रीजेस ऑर्गेनिजम्स. नेक्स्ट इज ग्लिसरीन. ग्लिसरीन क्या है? एक लुब्रिकेंट है. सो इट विल लुब्रिकेट द इनसाइड ऑफ आवर नॉस्ट्रल. दैट इज ग्लिसरीन. दैट इज व्हाई वी कीप एडिंग दीस ड्रॉप्स 5 to 6 times a day. अब आता है फोर्थ एस. एस इज सब म्यूकोजल प्लासेंटल एक्सट्रैक्ट. प्लासेंटल एक्सट्रैक्ट हैज गॉट अ वेरी हाई अमाउंट ऑफ रीजेनरेशन कैपेसिटी. तो जो भी डिस्ट्रॉय हो गया है म्यूकोजा, दैट विल अंडरगो न्यू एंजियोजेनेसिस. वो नई वेसल बनाएगा इफ यू इंजेक्ट प्लासेंटल एक्सट्रैक्ट. अब डॉग्स बार्क. B12 विटामिन A, D, E, K इन सब के सप्लीमेंटेशन देंगे. राइट? व्हाई? बिकॉज दिस डेफिशिएंसी डायरेक्टली कॉजेज एट्रोफिक राइनाइटिस. तो इनके सप्लीमेंटेशन देने इंपॉर्टेंट है. ठीक है. नेक्स्ट इज डॉग्स बार्क. नाउ कम्स A. A stands for antibiotics. Antibiotics में the drug of choice again is streptomycin, which is given about 1 gram per day. So whatever we are doing, wherever Klebsiella comes, Klebsiella hates streptomycin. तो जहां पे भी Klebsiella नाम लग जाता है, जैसे राइनोस्क्लेरोमा में भी रिसेप्टर स्ट्रेप्टोमाइसिन दी थी, that was also Klebsiella. यहाँ पे Klebsiella uzeni है, that also hates streptomycin. So we give 1 gram a day in 4 divided doses. ठीक है. Now comes R. R is rich protein diet because malnourishment produces high chances of atrophic rhinitis. And then comes K. K is chemicetin solution. Chemicetin solution. अब chemicetin solution क्या होती है? Chemicetin solution एक रेडीमेड बॉटल आती है जिसके अंदर होती हैं 3 चीजें. That is C, D और E. C for chloramphenicol. It contains chloramphenicol. It contains vitamin D2 and it contains estradiol. तो ये तीनों चीजें मिला के बनाता है केमिसेटिन सॉल्यूशन. ये हम लोग डालते रहते हैं अंदर ताकि रीजेनरेशन हो सके. बिल्कुल ठीक. और फाइनली आता है हमारा पार्क. पार्क का बड़ा P. तो P is for potassium iodide. Potassium iodide has got a good healing property, so it has found to reverse atrophic rhinitis. तो डॉग्स बार्क इन द पार्क, ये हो गया आपका पूरा ट्रीटमेंट ऑफ एट्रोफिक राइनाइटिस. अब एक क्वेश्चन जो आपको पूछा गया, सर्जरी बहुत सारी होती है बट आपको जो इंपॉर्टेंट सर्जरी याद रखनी है फॉर INICET पर्सपेक्टिव इज दिस इज समथिंग, राइट? So I'm mixing Hindi and English so that people can get both the benefits of it, right? That's why I'm going into English as well as Hindi again. So what is this surgery that is given over here? If we do a surgery and close the nostril completely, That means we raise the flap from the lateral end, we raise the flap from the medial end, and we suture it both in the center. We raise the flaps from both the sides and we suture them in the center. This is called as Young's procedure. Young's procedure is the treatment of choice surgically for this particular disease. ठीक है, चलो आगे बढ़े. Now comes the next one. Now these are important CT scans that I will show you. Then we will finish nose and paranasal sinus, and then we will straight away plunge into our next domain, larynx. Okay. Now what are the anatomical aspects for nose and paranasal sinus? What are these X-rays? What are these CT scans? If they have shown you a coronal section, coronal means that they have cut open the skull like this. And if you see a cell which is present at the floor of orbit, see this is the orbit. This is the floor of orbit. If you see an extra cell at the floor of orbit, see this cell is absent over here. ये यहाँ नहीं है. This cell is present at the floor of orbit. This cell is an anterior ethmoidal cell which has pneumatized the floor of the orbit. And which cell is an anterior ethmoidal cell which pneumatizes the floor of orbit? That cell is called as Haller cell. So if you in your CT scan see an extra cell at the floor of orbit, then that cell is Haller cell. It's an anterior ethmoidal cell which pneumatizes the floor of the orbit. Now let's come to this particular image. This is sphenoid sinus. ये जो ऐसे दिखता है ना, like a tree. What you think over here like this? This is a sphenoid sinus. So the identification feature of sphenoid is like this, like me. So this is sphenoid. Now sphenoid are 2 in number. ये दो होते हैं. One on the right side, one on the left side. This is sphenoid, this is sphenoid. But this appears to be 3. इसमें 3 लग रहा है. What is there? So if a posterior ethmoidal air cell accidentally pneumatizes the sphenoid sinus, मतलब एक extra cell which is the posterior ethmoidal air cell has gone into the sphenoid sinus and it has pneumatized it. What is that called as? That cell is given the name as Onodi cell. Onodi cell always goes and pneumatizes posterolaterally. See, it has gone posterolaterally to the sphenoid sinus. So whenever they will ask this cell, this is Onodi cell. अब ओनोडी सेल में सबसे इंपॉर्टेंट बात क्या है कि ओनोडी सेल इज रिलेटेड टू व्हाट? ओनोडी सेल इज very closely related to one important nerve over here, and this nerve is basically nothing but our optic nerve. This is our optic nerve. So whenever you have any disease of sphenoid sinus, अगर आप ओनोडी सेल को निकाल रहे हैं, it can accidentally injure the optic nerve and that can lead to sudden blindness. That's the importance of onodi cell. Okay, now let me come to the third scan. Third, if they show you a sagittal section, ऐसे काटा, साइड से दिखाया. If they show you a sagittal section, and sagittal section में उन्होंने सबसे आगे का सेल बनाया है, the anterior most air cell, they are pointing out. The anterior most ethmoidal air cell, which is pneumatizing the frontonasal process of maxilla. See, this is the nasal process which is coming down. This is the nasal process of the frontal bone which is coming down. If there is any cell which is present below the nasal process of the frontal bone, that means that if an ethmoidal air cell goes and pneumatizes the nasal process of the frontal bone, and if you see any air cell just beneath that, इसके just नीचे देखा आपने एक air cell. This air cell is the anterior most cell and this is 𝐒𝐻. So remember one thing, simple, I'll tell you a simple way to deal with it. Anterior most air cell, if they are pointing, that is simple and straightforward 𝐒𝐻. That means देखो इस पूरे के पूरे line में the anterior most air cell is this. And this is just beneath the bone. So if this is just beneath the bone, it has to be 𝐒𝐻. This is the anterior most anterior ethmoidal air cell. Now let me come to the fourth scan. Fourth scan is again coronal. किसी ने ऐसे काट दिया सर को and they are showing in front. See this. What do you see wrong here? Here I told you everything what is white on a CT scan is bone. Anything which is grey is soft tissue. Anything which is black is air. So if you see over here, this is your inferior turbinate. This is your middle turbinate. But here middle turbinate appears to be black. It shouldn't be. So if you see black colored middle turbinate and huge middle turbinate, that means air is present inside the middle turbinate. And if air is present inside the middle turbinate, we call this particular condition as concabulosa. So concabulosa means air within the middle turbinate. Correct? So this is also one of the important CT scans that are important for your INICET exams. Chalo. Finished off 2 important segments. We have done ear, we have done nose. Now let's move on to the third important domain, larynx. So again, this will be more pictorial. This will be more related to showing you laryngoscopy pictures. This will be more related to showing you the direct questions which come in from larynx. Okay, chalo, let's go one by one. Now the first thing, let's come to the infections and inflammatory conditions of larynx first. Sabse pehle, if they tell you a particular child who's coming between the age group of 2 to 6 years of age, the child has got inspiratory stridor. Inspiratory matlab? Only on inspiration. Inspiratory stridor. The child is having severe odynophagia. That means the child is not able to eat properly. There is severe throat pain. Okay? Or the child is also having tripod position. Tripod position का मतलब whenever the epiglottis will become enlarged, right? तो epiglottis जब बड़े size में हो जाएगी तो बच्चा हमेशा ऐसे बैठेगा. They will always sit like this. Why? Because they want their epiglottis to fall forward, not backward. अगर बच्चा सोएगा, they will develop more of problems. If the case scenario has got a 2 to 6 year old child with inspiratory stridor, odynophagia, tripod position and drooling of saliva. This is a classical case. What they are asking about is of epiglottitis. This is the first feature, which is epiglottitis or acute epiglottitis. The most common organism for epiglottitis in children is Haemophilus influenza. The most common organism for epiglottitis in adults is Streptococcus pneumoniae. Remember this line. Agar children पूछे Haemophilus influenza, adult पूछे Streptococcus pneumoniae. Nowadays, we have gotten a fall in this particular H influenza. Why? Because the vaccines have come into play. The vaccines have come, so obviously H influenza is falling down and Streptococcus pneumoniae is in a surge. Okay? School going children, please see the age. Okay? Now let me come to another important point. Now, what is the next point is that whenever you get epiglottitis, the epiglottis gets enlarged and it becomes like a red cherry. So, अगर आपको ऐसे दिखा कुछ भी, this is like a cherry red epiglottis. So, this is called as cherry red epiglottis. This is a classical sign of epiglottitis. Okay, that is why the airway will become very, very small, and that is the reason why the child will actually sit in a tripod position. What is going to be the X-ray finding? If you do an X-ray of epiglottitis and you do it from the side, ये एक lateral view X-ray है, so you will see that your epiglottis is actually shaped like a thumb. ऐसे लगेगा यहाँ पे एक thumb लगा दिया है. So this particular thing will be looking like a thumb, and this sign is called as thumb sign. This is called as thumb sign. Now there is a small space which is present anterior to the epiglottis, which is called as vallicula. अब क्योंकि epiglottis becomes big, vallicula becomes obliterated. So the second sign what you see over here is called as absent vallicula sign. Absent vallicular sign or thumb sign. These are the things that you should know about in epiglottitis. ठीक है, चलो आगे बढ़ते हैं. Now coming to the next scenario. If you get a child and that particular child has got the age group between 6 months to 2 years. Again, this is not a school going child. This is much younger, 6 months to 2 years of age. And your case scenario has got 3S. 3S means seal-like cough, seal-like barking cough, severe chest retractions, and the patient is in stridor, and the stridor they are telling is biphasic. So 3S fall into one important thing which is called as croup, also called as laryngotracheobronchitis. So if there is inflammation of the subglottis means the area which lies within the cricoid cartilage and the cervical trachea. These are all surrounded all around. ये सारे बंद areas हैं. अगर ये inflame हो जाते हैं, they will cause significant narrowing of the upper airway, and this 3S is seen in that particular patient. These children are very, very small, 6 months to 2 years of age. Okay. Now, what will you see if you do an X-ray in croup? So this particular infection is not a bacterial infection. It is caused by para-influenza virus. The most common cause of croup is Para-influenza virus. It's a viral infection, like epiglottitis for the bacterial infection. Okay. If you do an X-ray in cases of croup, what will you see? You will see that there is significant narrowing of the tracheal column superiorly. Now, this narrowing of the tracheal column superiorly, this looks like a church top. So, अगर church का कोई top देखेगा, तो this is called as church steeple sign. This is called as church steeple sign, also called as a wine bottle sign, also called as a pencil tip sign. Any of the tip, any of these. So wine bottle sign, church steeple sign, pencil tip sign, kuch bhi ho. This is what exactly is the classical finding in croup. Now, very important point. How will you treat epiglottitis and croup babies? आपको ये पूछा जाएगा. What will you do in airway management? ये question है INICET का. So what will you do in this or in epiglottitis? What will you do? So the first thing, I'll tell you a very simple mnemonic of how I follow these two children. दोनों अगर बच्चे हैं, दोनों में same treatment है. So there is something called as the formula of H. I'll tell you that mnemonic now. Whenever you have any child of croup, be it epiglottitis, the first thing is hospitalization. Hospitalize the child and then start your treatment. Second, hydration. Because these children are eating very less, start the child on IV fluid straight away. That is called as hydration. Okay. Now comes the third H. Third H is head up nursing. Head up nursing means because their epiglottis is inflamed or their airway is very narrow because of croup, when you make them lying down, then what will happen? They will choke more. So if you prop up the patient, then there will be better airway, there will be better breathing. That is why head up position or head up nursing is very, very important. Now comes the fourth H. Fourth H is humidified oxygen support. Start the patient on high flow humidified oxygen, 3 to 4 liters per minute. Fifth H. Fifth H is high dose antibiotics. Now these high dose antibiotics are usually broad spectrum. You can start the patient on penicillins, cephalosporins, piperacillin, tazobactam, meropenem, anything. But it has to be broad spectrum with aerobic and anaerobic cover both. Now in cases of croup, usually it's a viral infection. Still we give supportive antibiotics because the child will be admitted in the hospital. So they can acquire secondary infection over it. That's why we give it. So that is high grade antibiotics. अब आ जाते हैं 6th H पे. 6th H is give all these babies hydrocortisone stat. This is a life-saving drug. See, whenever there is airway में the सबसे बड़ा airway drug is hydrocortisone. So if a child is there choking, right, and they cannot breathe, then obviously that person has to be given hydrocortisone. It decreases edema. If it decreases edema, there will be more space to breathe. 7th H is high dose nebulized racemic epinephrine. Now, if you remember my 𝐒𝐿 lecture last, I told you one of the questions that came from airway management was on this. What will you extra do in airway management of a croup child? So here, इसमें ये चीज है कि that there is narrowing of the cervical trachea and the subglottic lumen. I want to open it up for the child to breathe. So I will give him high dose nebulized racemic epinephrine. What is that? Epinephrine is a sympathomimetic drug. It increases sympathetic activity. So this is a non-selective. It's a non-selective sympathomimetic drug. It increases the activity of the sympathetic nervous system and it's non-selective. So it will act on the alpha receptors which are present over on blood vessels. It will act on beta 1 receptors which are present in the heart and it will act on the beta 2 receptors which are present in the airway. When this epinephrine will act on the alpha 1 receptor which is present over in the blood vessels of the airway, it will cause vasoconstriction. कहीं पे भी vasoconstriction होगा, better breathing होगी, right? Because everything will shrink. Beta 1 receptors are in the heart, so it will increase the cardiac output. That is a good ionotrope. And the third is it will act on the beta 2 receptors in the airway, which will cause smooth muscle relaxation. So that is why you give this nebulized form in order to cause a sudden relief in the airway and breathing. Okay, so this is my 7H mnemonic for airway emergencies wherever you get it. Be it croup, be it epiglottitis. ठीक है, चलो चलते हैं, आगे चलते हैं. Now comes TB larynx. This is, I'm expecting this question from quite some time now, but expect it to come very soon. If a person develops TB laryngitis, what are the symptoms or features that you will see in cases of TB laryngitis? They are very specific features. सबसे पहले whenever you have TB, सब कुछ larynx में गंदा गंदा दिखेगा, ये चीज याद रखो. गंदा the larynx is TB larynx. ठीक है? So what are the features? First feature of tuberculosis of larynx is turban epiglottis. Turban epiglottis means epiglottis will actually look like a big edematous, बड़ी सी epiglottis दिखेगी. This occurs due to pseudoedema over the epiglottis. बहुत बड़ी हो जाती है epiglottis. This is called like a turban. जैसे turban पहनते हैं ना पगड़ी. This is called as turban epiglottis. So it's a pagadi of the larynx. That's why turban epiglottis. Now comes the second thing. Second thing you will see is a mouse nibbled appearance of vocal cord. This is a classical sign. अब देखो ये वोकल कॉर्ड दिख रहे हैं, इसमें ऐसे लग रहा है कोई किसी ने यहाँ पे खा लिया, 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 तो कोई खा के चला गया. That means some mouse has come and nibbled over the vocal cords. That's called as mouse nibbled appearance of vocal cord, classical feature of TB larynx. Now let's come to the third one. Third one is called as interarytenoid mammillations. Mammillation का मतलब छोटे छोटे nodules. So that means if this is your arytenoid and this is your arytenoid, in between them you will find small nodules which will appear in this area. This is called as interarytenoid mammillations. Okay? Fourth sign, monochorditis. So it's not seen over in this diagram, but in some people you will find that only one vocal cord is red in color, rest vocal cord is white in color. एक cord red है, एक cord white है. मतलब there is single cord inflammation. This is called as monochorditis. And last feature is multiple ulcers and granulations over in the supraglottic area. If you see here, see this ulcer, 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 ulcer. Everywhere in the supraglottis, there are these ulcerations which have been formed and they are very, very ugly. So all these features match into TB larynx. कोई भी पूछा जाएगा, they are all TB laryngitis features. Their treatment is obviously do ATT. Nothing else. No operations over here. Okay? चलो आगे बढ़ते हैं. Now comes this important part. If you are given any particular case of a child, and this particular child has been born, and now that particular child has got stridor, that means during inspiration there is a sound that is coming out. At the same time, this particular child shows multiple growths over the larynx. See this? There are multiple polypoidal growths over the larynx. तो अगर कभी भी multiple polypoidal growth larynx में दिख रही है, answer is it is laryngeal papillomatosis. Now laryngeal papillomatosis are of two types. First of all, क्यों होती है? Laryngeal papillomas occur because infection of HPV. Now HPV or human papilloma virus has got certain strains which are oncogenic, certain strains which are non-oncogenic. HPV 6 and 11 strain forms papillomas and genital warts. HPV 16, 18 are the ones which are highly malignant strains. So all malignancies are associated with 16 and 18 strain. Okay? चलो आगे बढ़े. There are two types of papillomas, adult and juvenile. Juvenile मतलब बच्चों में. These are the two cases I am telling you जो भी आपको दिया जाएगा. If they give you an adult papilloma are solitary. Juvenile papillomas are many. That means अगर ये adult papilloma होता, it would have been over the vocal cord and it would have been just a polypoidal growth over one vocal cord. That's it. But अगर ये बहुत बड़ा है, ये हर जगह जा रहा है, everywhere it is going, that means this is not adult. This is not solitary. This is multiple. And multiple papillomas are a feature of छोटे बच्चों में, juvenile papillomas. ठीक है? Second important part. Adult papillomas occur because of orogenital sexual contact. This occurs because of orogenital sexual contact where the HPV gets transmitted into the larynx. Juvenile papillomas occur due to vertical transmission from the mother. So हो सकता है that the child is undergoing normal delivery and the mother has got genital warts at that time which are active and the child contaminates it or the virus goes inside the larynx. So that will form juvenile papillomas. Now comes the third part. क्योंकि juvenile many होते हैं, recurrence is very high in cases of juvenile papillomas. They're very high recurrence rates. But adult papillomas में क्योंकि ये छोटे होते हैं तो recurrence rates are less. But the opposite happens with adult, that they are more in malignant potential and they have less malignant potential. They are more recurrent, but they have less malignant potential. The most common feature of presentation in adult papilloma is hoarseness of voice. इसमें आदमी hoarse voice के साथ आएगा. Hello, my name is this. This is what? This is a hoarse voice. क्योंकि vocal cord के बीच में एक मांस हो गया. But what will be the presenting feature in babies? In presenting feature in babies will be that they will have a weak cry and the child will have stridor. So stridor and weak cry are the most important thing which are seen in juvenile papillomas. Now, how do you treat them? Treatment of papillomatosis is by A, B, C. 3 drug hai, A, B, C. A for alpha interferon therapy has been found to be good. There is a recent drug which has been launched which is called as bevacizumab, which is a monoclonal antibody which is actually very good in for respiratory papillomatosis. Or C for an antiviral drug which is called as cidofovir. तो ये 3 इसके मेडिकल लाइन ऑफ मैनेजमेंट है, ठीक है. दिस इज a monoclonal antibody, bevacizumab, और cidofovir is an antiviral drug against HPV. But at the same time इसमें हमें ऑपरेट भी करना पड़ता है. We give these short term treatments, we regress the papillomas. If they still persist, then we do a laser excision. तो हम लेजर से इसको हटाते हैं, ठीक है. फाइन, चलो आगे बढ़ते हैं. What is this? Now let's go into congenital disorders of larynx. What is this? This is laryngomalacia. So what is the most common cause of inspiratory stridor? Question. Most common cause of inspiratory stridor in infants is laryngomalacia. Malacia मतलब soft larynx. मतलब क्या हो रहा है? In laryngomalacia children, there are 4 things which are happening. जब भी बच्चा पैदा होता है with laryngomalacia, 4 things happen. What are those 4 things? 4 things means the first thing that happen is flaccidity of cartilage. मतलब उसकी जो cartilage है वो बहुत soft हो जाती है. जितनी उसकी cartilages है larynx की, they are very very soft. That's the first thing. Second thing that you see in these children is redundant mucosa. Redundant mucosa means that let's say I am a cartilage of larynx and I am wearing a triple XL shirt. मेरा size large है but मैं triple XL पहन के खड़ा हूँ. So what will happen whenever wind will flow towards me, my kapda will do phad against the wind. That's what happens in laryngomalacia. The larynx is actually wearing an XL size shirt. Extra mucosa is present, which is flapping down whenever the child is breathing. Third is these children have got neuromuscular incoordination. Their muscles are poorly coordinated with the nerves. And fourth, they have got short mucosal folds. They have got short mucosal folds. The most common cause of inspiratory stridor in children, in infants, laryngomalacia. These are the 4 reasons why laryngomalacia happens. Now what happens? Whenever because of these 4 reasons, the patient will breathe inside, so because of the flaccidity of cartilages, the cartilage will curl. Cartilage घूम जाएगी. So see this. The cartilage has become curled. What is this? This is the epiglottis. Now if the epiglottis becomes curled, it forms an omega-shaped epiglottis. Omega-shaped epiglottis is a classical feature seen in cases of laryngomalacia babies. The second thing is redundant mucosa. So they see this arytenoid. Arytenoid has got so much of extra mucosa over it. So whenever the child will breathe, this extra mucosa will fall inwards and the child will say inspiratory stridor. The third feature is neuromuscular incoordination. So they don't have good nerves and coordinated with their muscles. Both is short mucosal fold. So if you see here, this is epiglottis, this is arytenoid. They have got a very short airy epiglottic fold. So because of this, their larynx is very small. And that is the reason why they cannot breathe well. Now remember one thing. Laryngeal maturity starts to happen by 18 to 24 months of age. So by 2 to 4 years of age, normally larynx gets matured. Ye sari flaccid cartilages will gain some rigidity. That is the reason the first line of management in laryngomalacia babies is wait and watch. Don't say surgery. They will ask you, patient is of laryngomalacia, what will you do next? Wait and watch. Conservative management. And we will tell the patient to nurse in prone position. We will tell the patient to nurse in prone position. So even if they are feeding, feed in a little prop up position, feed in this way. So that obviously because their larynx is very small, they don't develop stridor. And whenever the child is getting fed, uske baad prone the child. Ulta kar do child ko. So if the child is lying down on the belly, their epiglottis will fall forward. So they will have a better breathing. So prone position nursing is actually the best thing what is found for laryngomalacia babies. That's what wait and watch for the first 2 to 3 years. If laryngomalacia does not resolve in 2 to 3 years, then we do second line of treatment, that is surgery. Surgery is done only in cases where if the SpO2 or the saturation is falling less than 90%. Second, the child is developing failure to thrive, is not growing properly. Third, the child is having severe retractions with stridor. If the child has got severe retractions, stridor, failure to thrive, and SpO2 is less than 90%, they are not good feeders. In cases may we do a surgery. What is the name of surgery for laryngomalacia? 2 surgeries are there. One is epiglottopexy. Second is supraglottoplasty. What do you understand by this? Epiglottopexy. Matlab ye epiglottis is getting curled. So what do? We take a suture and we tie this epiglottis to the base of tongue. हम इसको tongue से suture कर देते हैं. So what will happen if we tie this epiglottis to the suture with a suture to the tongue? This will not curl. ये रुक जाएगी. That is what is called as epiglottopexy. Pexy matlab जोड़ना. And supraglottoplasty is what? Supraglottoplasty means we will just put a cut over these aryepiglottic folds. So if we put a cut over these short folds, automatically my whole larynx will expand. That is what is called as supraglottoplasty. Okay, so these are the 2 important surgeries what you do in laryngomalacia children. Aage badhe. Now let's come to the next important congenital disorder. Again, very important for you for larynx. What is this? If you see that in between this is your vocal cord, and below the vocal cord, which area is present? Below the vocal cord is our subglottic area. If you see a pinhole subglottis, see, narrowing of the subglottis is there. This is called as subglottic stenosis. Now, very important question. This can be congenital or this can be acquired. Both. If they are telling you that it is a congenital subglottic stenosis, this is usually related to certain syndromes. The most common syndrome which is producing congenital stenosis is Down syndrome, Pallister-Hall syndrome, Treacher-Collins syndrome, where the subglottis is formed very narrow. तो इनकी cricoid cartilage बहुत छोटी होती है. So that is why the subglottic diameter also reduces. This is what is called as subglottic stenosis में congenital stenosis. What is acquired stenosis? They will give you a question of acquired. They will say that there is a patient who has come with repeated intubation history. So if the patient is undergoing repeated endotracheal intubation, matlab ki, let's say if this is your subglottic area, this is your cricoid cartilage, this is your trachea. So if there is a patient who has got intubations which are happening again and again, they are going to damage this lumen. They are going to actually damage the mucosa which is present in the subglottic area. And anything in our body heals with fibrosis. So what will happen? There will be concentric narrowing of the subglottic area. So that will produce this subglottic stenosis to happen. So what is the most common cause for acquired subglottic stenosis is my question. The most common cause for acquired subglottic stenosis is still undoubtedly repeated intubations. Intubation related trauma, and if it is repeated again and again, then that is the most common cause for subglottic stenosis on an acquired side. Okay, fine, chalo. So ये हमारा खत्म हो गया. What is acquired stenosis and what is congenital stenosis mainly. Now comes the important part. How will you stage this subglottic stenosis? Staging of subglottic stenosis is done by a classification system called as Cotton-Meyer classification. Very important for subglottic stenosis. ये question सबसे important है. Cotton-Meyer classification system. So it has got 4 grades of stenosis. सबसे पहले आता है grade 1. If the subglottic diameter is between 0 to 50%, that is grade 1. That means 50% of the subglottis has gotten narrowed. 0 to 50% grade 1. उसके बाद आता है grade 2. Grade 2 means now the diameter is between 51 to 70%. That is grade 2. If the diameter is in grade 3, if it is between 71 to 99%, it is grade 3. That means it's pinhole, बिल्कुल छोटू सा present है, 71 to 99%. And grade 4 means that now there is no detectable lumen. No lumen at all. This is something which is called as grade 4. Okay, fine. So it can be for FMG preparation. Yes, बिल्कुल it can be for FMG preparation. Everything is the same. ठीक है, चलो अब आते हैं into the next disorder. Next disorder, what you see over here, this they will give you in the form of a CT scan. What you see over here, this is called as a laryngocele. Now, what is a laryngocele? Laryngo means larynx, seal means collection of air within the larynx. Okay. Now, what exactly you need to know in laryngocele? Laryngocele is a benign condition of the larynx which happens commonly in trumpet players and glass blowers. So glass blowers and trumpet players have this laryngocele, the most common. Okay. Now, इसका CT scan समझना और याद करने के लिए I'll draw the same section for you over here. If we cut the larynx in a coronal plane, हम ऐसे अगर larynx को काटे in a coronal plane तो क्या होगा? So if we cut the larynx in a coronal plane, first we will get the hyoid bone ऊपर, ये हो गई हमारी hyoid bone. This is hyoid. Hyoid के नीचे होती है thyroid cartilage. This is our thyroid cartilage. This is thyroid cartilage. Thyroid cartilage के नीचे होती है cricoid cartilage. This is cricoid और उसके नीचे छोटू छोटू tracheal rings. के नीचे हो गई हमारी tracheal rings. There is a membrane which is present between the hyoid and thyroid, which is called as thyrohyoid membrane. There is a membrane which is present between the cricoid and thyroid, and that is called as cricothyroid membrane. There is another membrane present between the cricoid and first tracheal ring called as cricotracheal membrane. And finally, there are these intertracheal membrane. Okay? Now, if we cut the larynx and draw a coronal section of larynx, the coronal section of larynx somewhat seems like this. Coronal section ऐसा होता है. So there is a bulge up, फिर एक पीछे जाती है चीज, then something comes down and like this. This is how we draw a coronal section of larynx. Now, what important parts are there? इसमें क्या important parts है? Let me, because in order to tell you the CT scan, I need to show you these parts. जब भी larynx हम पढ़ते हैं, it is divided into three important zones: supraglottis, glottis, and subglottis. That means if these are my true vocal cords, this area I can give the name as glottis. Anything above this area I can call this as supraglottis. Anything below this area I can call this as subglottis. Right? Now, if these are my true vocal cords, this is my false vocal cord above. Okay? A space present between the false vocal cord above and the true vocal cord below. This little space over here, this is called as laryngeal ventricle. So, laryngeal ventricle is a small slit-like space present between the false vocal cord above and the true vocal cord below. Okay? Now, this laryngeal ventricle goes and expands laterally and superiorly towards the thyroid cartilage. See, this ventricle is expanding laterally and superiorly towards the thyroid lamina, towards the thyroid cartilage. That means this ventricle is getting dilated into a space. This dilated space present lateral to the ventricle, this little space is called as laryngeal saccule. Laryngeal saccule contains a lot of mucus glands. इसके अंदर बहुत सारे mucus glands होते हैं. And this is because of these mucus glands, it lubricates our true and false vocal cord. That is why saccule is also given the name as oil can of larynx. If any particular person develops, or if he is a trumpet player or a glass blower, तो suddenly वो बहुत जोर लगा रहा है. So if they are actually pushing a lot of efforts, their pressure of air increases in all the three domains. यहाँ पे पूरा pressure ही pressure होगा. हवा का यहाँ पे बहुत ज़्यादा pressure होगा. And if there is an increase in pressure in all the three areas, it can accidentally enter inside this saccule and can get trapped. This saccule can actually trap the extra air that is present over in the larynx. Now, if this extra air gets trapped inside this saccule will undergo a dilation, and that dilation will come out of the thyrohyoid membrane. So, what is laryngocele? It is an abnormal dilation of the saccule which is coming out of the thyrohyoid membrane. And this saccule is actually filled with air. इसके अंदर air भरी हुई है. This has air. So that is why if you see this particular image, you will be able to make out here. इसमें देखो, this is your false vocal cord. This is your false vocal cord. This is your true vocal cord. And can you see this particular expansion that has happened? This is how a laryngocele looks like on a coronal CT. See, it is normal on the other side, but this is the abnormal dilation which has happened. So this is something which is very, very important for identification of laryngocele. Now, very important. What are the clinical features of laryngocele? The laryngocele mein there will be a visible swelling over on the outside, which will increase on Valsalva maneuver, which is very correctly told by Vishwa Chandan. So if somebody does Valsalva, तो उसमें भी pressure increase होगा और ये swelling और बढ़ जाएगी size में. ठीक है? That is something which is characteristic of laryngocele. Now, laryngocele में एक चीज होती है कि अगर यहाँ पे swelling बाहर present है और आप उसे दबाएंगे, तो वो swelling जो है that will reduce by producing a hissing sound. मतलब टाइप की साउंड आएगी. That means why? Because ये air से भरा हुआ एक balloon है. So whenever you try to reduce it, it will leak all the air within the laryngeal inlet, and that is something which is called as a sign, and this sign is called as Bryce sign. तो laryngo में भी RY आता है और Bryce में भी RY आता है. तो Bryce sign is a feature of laryngocele. Remember that, which is a hissing sound whenever you push a laryngocele inside. Now, how do you treat a laryngocele? Treatment of laryngocele is again excision. Simple. ठीक है, चले. तो ये हमने खत्म कर लिया अबाउट व्हाट इज laryngocele. अब आगे बढ़ते हैं. नाउ वी गोइंग टू इंपॉर्टेंट वॉइस एंड स्पीच डिसऑर्डर्स. तो यहां पे मैं आपको बहुत सिंपल और स्ट्रेट तरीके बताऊंगा अबाउट हाउ टू अप्रोच दीज पर्टिकुलर क्वेश्चंस. तो मैंने यहाँ पे आपको दो इंपॉर्टेंट वॉइस डिसऑर्डर्स दिखा रखे हैं. एक तरफ है वोकल नोड्यूल, एक तरफ है वोकल पॉलिप. अब इन दोनों के क्या क्या इंपॉर्टेंट मतलब है. सबसे पहले इसमें क्या देखना है आपको. सबसे पहले आपको देखना है कि अगर इन केस आपको कभी भी chronic voice abuser mila, that means if there is a teacher who's a singer, right, long standing voice abuse, these particular lesions will always occur at the anterior 1/3 and mid 1/3 of the cord. They are always bilateral. They are sessile. Sessile ka matlab anything which is coming out from a flat base, that is sessile. Third, they are going to be less than 3 millimeters in diameter. They are going to be whitish in color. These are nodules. So if there is chronic voice abuse, teacher, singer, politician, mother with laryngoscopy picture shows bilateral, sessile, whitish growths present at the anterior and mid 1/3 of the cord, answer straight away is a vocal nodule. ठीक है? What is the treatment of vocal nodule? It is always voice rest. So medical line of management with voice rest is the most important thing which we do for vocal nodules. Now medical line of management हम इसमें क्या करते हैं? इसमें सर्जरी नहीं करते, because the moment we take out a vocal nodule, it will scar more. So if the vocal scarring happens, there will be more worse type of speech. So what important thing that you will give medically? So medically we also give them proton pump inhibitors to control reflux, because reflux can produce repeated throat clearing. ये करते हो ना जब reflux आता है, जब GERD होती है, तो we don't want that. We give PPIs to control the cough. We give them antihistamines and we give them a short course of even mucolytic agents containing ambroxol. So all of these things with voice rest are the classical feature for vocal nodule. अगर आपके पास कोई important scenario आया जिसमें दे हैव मेंशन्ड सडन वॉइस अब्यूज, जैसे आदमी गया, आरसीबी जीत गई, उसने विराट कोहली के लिए चिल्लाया और 15 दिन के बाद दे हैव कम टू द ENT OPD saying they have hoarseness of voice. So sudden voice abuse is related to vocal polyp. Chronic voice abuse is related to vocal nodule. So sudden voice abuse में क्या होगा? There will be trauma in the vocal cord. If there is trauma in the vocal cord, they will produce a kind of a hemorrhagic polyp. Now the importance is, polyp will always be unilateral. They will be pedunculated. They will also be at the junction of anterior and mid 1/3 of the cord. Why? Because जब भी vocal cords close कर सकते हैं, this is the maximum friction zone. Yeah, this is the maximum striking zone. Third, they are red in color. They are reddish. Why? Because they are hemorrhagic. Fourth, they are more than 3 millimeters. So this is a vocal polyp whenever you see it. Now important part. Vocal polyp में what is the line of treatment? Vocal polyp में voice rest is not the line of treatment. That is for nodule. Vocal polyp में we do something called as removal. So microlaryngeal surgery plus excision. So we use something called as a microlaryngoscope. We go inside and we just get it out. That is what is called as microlaryngoscopy with excision. Okay, so this is the first line of treatment for polyp. This is the first line of treatment for nodule. चलो आगे बढ़ते हैं. Okay, ये क्या है? Now, if you are given any particular scenario where they are talking about a female who is a smoker, who has got deepening of voice, मतलब those females who are generally smokers, this is a female dominant disease, who are generally smokers, what happens? Smoking causes chronic irritation in the vocal cords, and that causes in return edema over the vocal cords. So if edema occurs over the vocal cords, we call that edema as Rinke's edema. It is also called as, that is why it is also called as smoker's larynx, or it is also called as pseudomyxomatous laryngitis, because this is a pseudomyxoma or an edema within the vocal cord. So when we read vocal cord की 5 layer होती हैं. There are 5 layers in the vocal cord. The outermost layer is given the name as epithelium. This is important. Below the epithelium, the second layer of the vocal cord is called as superficial lamina propria. The third layer of the vocal cord is called as intermediate lamina propria. The fourth layer of the vocal cord is called as deep lamina propria. And finally, inside the vocal cord, there is a muscle which is called as thyroarytenoid muscle, also called as vocalis muscle. These are the 5 layers of the vocal cord. Epithelium, superficial lamina propria, intermediate lamina propria, deep lamina propria, and finally thyroarytenoid muscle, which is vocalis muscle. Now, the importance of this diagram is, this superficial lamina propria, the second name of this superficial lamina propria is also called as Rinke's space. We also call this space as Rinke's space. Okay, so any edema, because of chronic smoking, let's say because of chronic smoking, there are many vessels which are present below this epithelium. बहुत सारी vessels हैं which are present below this epithelium. So because of chronic smoking, what happens is, it leads to breaking down or fragility of these vessels. Now, if vessels get broken down, they will start leaking. So these vessels start to leak, और leaking की वजह से यहाँ पे बहुत सारा edema इकट्ठा हो जाता है. So this is a bilateral chronic progressive swelling over the vocal cord, which happens because of fluid collection in the Rinke's space or the superficial lamina propria. Now, importantly, they will produce chronic swelling of the vocal cord. And this is called as a bag of water appearance. What will be the treatment for Rinke's edema? So always remember, they occur in females, so that is why they become male-like voice. अगर किसी का भी भारी हो जाता है ना vocal cord, तो उनकी आवाज हमेशा भारी हो जाती है. तो it will drop down. So suppose I'm talking to you. So if I get Rinke's edema, I'll drop down more. I'll get deepened voice, right? So this is something which is called as a gruffy voice. जैसे कोई नाराज है, gruffiness of voice. Now how will you treat it? Treatment के लिए सबसे पहले is avoid smoking. सबसे पहले avoid smoking. ठीक है? Second important thing is same as vocal nodule. जो भी हमने वहां पे दिया था, PPIs, antihistamine, mucolytics, same. कभी-कभी Rinke's edema is also seen with thyroid disorders like hypothyroidism. Hypothyroidism में there is generalized edema over the body, which is called as mixed edema. तो कभी-कभी thyroid disorders में भी ये दिखता है, and thyroid में हमें we have to correct by thyroxine. अब अगर इनके केस में by this also the patient does not become better, then what is the surgery that we do? Surgery is we put an incision over the vocal cords and we drain out the fluid. This particular surgery is called as reduction glottoplasty. It is called as reduction glottoplasty. Okay, this is a surgery where we reduce the edema which is present over the vocal cords. ठीक है, चलो आगे बढ़े. Okay, so now comes, okay, this is the wrong heading. This shouldn't be there. What is this? What is this over here? Okay, so don't go with the heading. What is this? If you find any particular patient where there is intubation trauma that has happened, and after intubation trauma, the patient has hoarseness of voice. And now what do you see? At the posterior 1/3 of the right vocal cord, there is a huge type of a growth, a globular growth at the posterior 1/3 of the vocal cord. So intubation trauma may, if you see anything on posterior 1/3 of the vocal cord, this is basically nothing but this is an intubation granuloma. Intubation granuloma always happens on the posterior 1/3 of the vocal cord during intubation injury. So wherever this intubation happens and this causes injury, तो यहाँ पे granulation tissue बन जाता है which heaps up to form a granuloma. ठीक है? So that is what is called as intubation granuloma. How will you treat it? Treatment is usually by giving a short steroid therapy. So treatment is by steroid therapy or it is by excision. That is microlaryngoscopy and excision. ठीक है? That is all. Now, अब आ जाते हैं into more important stuff. ये आ गई पैरालिसिस. वोकल पैल्सी ऐसा क्वेश्चन है जिसमें सब अटकते हैं. Again and again there are a lot of problems which happen every year in vocal palsy. तो मैं आपको थोड़े बहुत इंपॉर्टेंट कॉन्सेप्ट्स बता रहा हूं अबाउट वोकल पैल्सी, हाउ टू अप्रोच वोकल पैल्सी क्वेश्चंस सो दैट यू कैन अंडरस्टैंड ऑल दीज फोर कि यूनिलैटरल आरएलएन, बायलैटरल आरएलएन, यूनिलैटरल कंप्लीट और बायलैटरल कंप्लीट और इन सब में हमें कैसे आंसर करना है और क्या करना है. So let me first discuss about something about in detail कि what exactly happens in these particular questions. ठीक है? तो पहले मैं आपको एक सिंपल सी चीज बताता हूं. There are two nerves which supply the larynx. Both nerves are a part of vagus nerve. One is called as superior laryngeal nerve, other one is called as recurrent laryngeal nerve. Superior laryngeal nerve की एक होती है external branch, एक होती है internal branch. The external branch of superior laryngeal nerve supplies our important muscle, which is cricothyroid muscle. Cricothyroid is also called as Singer's muscle. तो अगर मैं आपसे बात कर रहा हूं, so I've raised my voice. That muscle which is raising my voice, raising my pitch, that is cricothyroid muscle. It is supplied by external branch of the superior laryngeal nerve, which is the only muscle not supplied by RLN. ये हमारी important point है. What is internal branch? Internal branch of the superior laryngeal nerve is sensory. This supplies sensations above the level of vocal cord. If there is any sensation above the level of vocal cord, that is from this internal branch of superior laryngeal nerve. Now comes what is RLN. Recurrent laryngeal nerve की भी दो function है. It provides motor supply to all muscles of larynx. That means all intrinsic muscles of larynx except cricothyroid muscle. क्योंकि cricothyroid is supplied by the external branch of superior laryngeal nerve. Okay. Also, recurrent laryngeal nerve supplies sensations below the vocal cords. So, अगर superior laryngeal nerve is supplying above the vocal cord sensations, this is supplying below the vocal cord sensations. Okay, so these are the 4 MCQs which come regularly. अब सबसे important चीज आपको दो चीजें याद रखनी है. Always remember one thing. If suppose any person develops recurrent laryngeal nerve injury, so I am saying that his recurrent laryngeal nerve is injured, but still his superior laryngeal is functional. What will be the position of the vocal cord if in case there is recurrent laryngeal nerve injury? My question is that. So if let's say this is your epiglottis. Let's say this is your epiglottis. This is your aryepiglottic fold and the arytenoids. Now normally our vocal cord has got certain positions. Normally हमारे vocal cord की कुछ positions होती हैं. What are the positions? Normal positions of vocal cord. तो जब हम बात करते हैं vocal cords adduct, तो हम breathe करते हैं vocal cords abduct. तो सबसे पहली position of vocal cord is called as median position. which means 0 mm, which means both my vocal cords are straight away in the midline. बिल्कुल center में हैं, चिपके हुए हैं whenever I am talking. This is the normal position of the vocal cord which happens when I talk. This is the normal position seen called as median position. दूसरी position is called as paramedian position. Paramedian means that now my vocal cords are 1.5 mm away from the midline. That means now they are 1.5 mm, a little away from the midline. That means a little away from the midline, but still together. That means whenever I whisper, तो एक तो गई मेरी बात, hello, hello, this is median. If I whisper, hello, hello, this is paramedian. That means they are 1.5 millimeters away from the midline. This is the second position that my vocal cord has. Okay? Now comes my third position. Third position is called as gentle abduction. Gentle abduction मतलब थोड़ा सा दूर चले गए. And fourth position is called as full abduction. मतलब बहुत दूर चले गए. तो एक पोजीशन हो गई जेंटल abduction, which occurs in normal inspiration. एक हो गई full abduction, which occurs in deep inspiration. इसका मतलब क्या हुआ? When I talk, median. When I whisper, paramedian. Hello. When I simply breathe, gentle abduction. When I deep breathe, full abduction. This is what we are seeing over here, right? This is around 7.5 mm away from the midline. This is 9 mm away from midline. Okay, fine. अब important चीज इसमें क्या फर्क आती है? Let's say a person has developed recurrent laryngeal nerve injury. Recurrent laryngeal nerve अगर इंजर हो जाती है तो still उसकी superior laryngeal nerve functional है. That means the cricothyroid is functional. तो एक चीज आपको हमेशा rule of thumb याद रखनी है vocal palsy में. That's the rule of thumb. If somebody develops recurrent laryngeal nerve injury, still the superior laryngeal nerve is functional, and this superior laryngeal nerve is supplying cricothyroid muscle. So the cricothyroid muscle will undergo constriction, but this will undergo contraction, and it will maintain the cord in paramedian position. इसका मतलब क्या है? इसका मतलब यह है कि whenever there is any patient with recurrent laryngeal nerve injury, still their superior laryngeal nerve is functional, and that nerve which is functional, that will maintain the paralyzed cord in the paramedian position. क्योंकि cricothyroid is also a potent tensor of the vocal cord. Not only is that pitch raiser, वो सिर्फ pitch नहीं ऊपर करती, it is also which causes it is also a tensor of the vocal cord. It is also an adductor of the vocal cord. So what will happen? If somebody has got any kind of recurrent laryngeal nerve injury, तो उसका एक cord तो normal होगा, one cord will be normal, but one cord will be paralyzed and it will attain a paramedian position. ये देखो ये वाला कॉर्ड पैरालाइज्ड है तो ये सेंटर में आ गया इन अ पैरामीडियन पोजीशन, द अदर कॉर्ड इज मूविंग. तो अगर मेरा हाथ है तो ये मेरा पैरालाइज कॉर्ड है, दूसरा जो है वो मूव करता रहेगा, बट दिस वोंट मूव. द फिंगर दैट आई एम होल्डिंग won't move, the other will move. Why? Because now this is only being acted by the cricothyroid muscle, which is just tensing this vocal cord and keeping it adducted, because that is the only thing that is working. This is called as unilateral recurrent laryngeal nerve injury. जिसमें एक कॉर्ड पैरामीडियन हो जाएगा, दूसरा कॉर्ड मूव करेगा नॉर्मली. नाउ डू यू नीड एनीथिंग इन दिस? नो. क्यों? क्योंकि अगर एक कॉर्ड में सिर्फ आरएलएन इंजर हुई है, उसकी क्रिकोथायरॉइड स्टिल फंक्शनल है, वो एडक्टेड है, तो होगा क्या? इन ऑर्डर एवरी टाइम व्हेनेवर वी डील विद वोकल पाल्सी पेशेंट्स, वी सी थ्री थिंग्स. वी सी स्पीच, वी सी एस्पिरेशन एंड वी सी रेस्पिरेशन. SAR, तीन चीजें हमें देखनी है. अब दूसरा वोकल कॉर्ड तो ऑलरेडी फंक्शनिंग है, तो दैट मीन्स अगर ये वोकल कॉर्ड कॉम्पनसेट करके पास जितना भी आ गया, एटलीस्ट कुछ ना कुछ स्पीच इसके आएगी. तो स्पीच इज ओके. क्या ये पेशेंट एस्पिरेट करेगा? नहीं, क्योंकि ऑपोजिट साइड का क्लोजर हो रहा है. एंड रेस्पिरेशन में कोई प्रॉब्लम आएगी? नहीं, क्योंकि ऑपोजिट साइड मूव कर रही है. So speech, aspiration and respiration, all three will be normal in unilateral RLN palsy. That is why in the table that I have given you, in unilateral RLN palsy, the position of the vocal cord is paramedian or median because of the action of the unopposed cricothyroid muscle, which is still active. And there will be normal speech, no aspiration, normal respiration, and we require conservative management. तो जब भी आपको unilateral RLN palsy का क्वेश्चन आएगा, आपको पूछा जाएगा कि आप क्या करेंगे? आप कुछ नहीं करेंगे. You will just wait and watch. Conservative treatment. अब खुद सोचो एक और इंपॉर्टेंट चीज. एक और इंपॉर्टेंट चीज यह है कि लेट्स से नाउ यू गेट अ पेशेंट जिसकी थायराइड सर्जरी हुई, लेट्स से एक पेशेंट है उसकी थायराइड सर्जरी हुई और थायराइड सर्जरी में दोनों आरएलएन उड़ गई। तो अब दोनों तरफ की अगर आरएलएन इंजर हो गई तो दोनों साइड की क्रिकोथायराइड इज स्टिल फंक्शनल। If दोनों साइड की क्रिकोथायराइड इज स्टिल फंक्शनल, दे विल बोथ अटेन द वोकल कॉर्ड ओनली इन द पैरामीडियन पोजीशन। मतलब ये ऐसे ही रहेगा। क्या ये एब्डक्ट करेगा? नहीं, बिकॉज द ओनली एब्डक्टर ऑफ योर वोकल कॉर्ड इज पोस्टीरियर क्रिकोएरिटिनोइड मसल। वो रिकरेंट लैरिंजियल नर्व सप्लाई करती है। दैट इज नॉट गोइंग टू वर्क। तो ये सिर्फ ऐसे ही रहेंगे। दे आर नॉट गोइंग टू एब्डक्ट एनीमोर, दे आर गोइंग टू स्ट्रेट अवे स्ट्रेन द मिड लाइन। So that means now your vocal cords, both your vocal cords will come straight in the midline, एक ऐसे और एक यूं। ये तो अब ये ऐसे ही रहेंगे, ना ये abduct करेंगे ना adduct करेंगे, बस ये यूं रहेंगे। Why? Because of the unopposed action of the cricothyroid muscle, which is an adductor and a tensor of your vocal cord. That's the rule of thumb. तो अगर दोनों vocal cord बिल्कुल सेंटर में आ गए, what is going to be the problem with speech, aspiration, respiration? स्पीच नॉर्मल रहेगी। क्यों? क्योंकि ये वोकल कॉर्ड दोनों पास पास है, तो कुछ कुछ तो आवाज आएगी। वोकल कॉर्ड पास होने से आवाज आती है। एस्पिरेशन करेंगे, एस्पिरेशन होने के लिए गैप चाहिए, यहां गैप ही नहीं है, तो पेशेंट विल नॉट एस्पिरेट। बट प्रॉब्लम कहां आएगी? प्रॉब्लम आएगी रेस्पिरेशन में, बिकॉज पेशेंट्स वोकल कॉर्ड आर नॉट एब्डक्टिंग, दे आर स्टिल स्टैंडिंग इन द सेंटर, सो दे विल डेवलप स्ट्राइडर। सो नाउ द पेशेंट विल हैव चोकिंग, दे विल नॉट बी एबल टू ब्रीथ। That is why I've told over here that now both the vocal cords will be in the center. There will be normal speech, no aspiration, but the patient will develop stridor. That is difficulty in breathing. तो इसके लिए हम कौन सी टाइप की थायरोप्लास्टी करेंगे? तो एक सर्जरी होती है जैसे कहते हैं थायरोप्लास्टी। थायरोप्लास्टी 4 टाइप की होती है। यू हैव टू रिमेंबर द निमोनिक 1 2 3 4 है। तो हम लैरिंग से कौन सी सर्जरी करते हैं? एमएलएस करते हैं, राइट? तो एमएलएस याद रखो 1 2 3 के हिसाब से। M is called as medialization thyroplasty. L is called as lateralization thyroplasty. S is called as shortening of vocal cord. And L again is lengthening of vocal cord. तो पहली याद रखनी है हमें MLS, उसके बाद एक L लगा देना है, ठीक है? सो इसमें कौन सी टाइप की थायरोप्लास्टी करेंगे? अगर दोनों वोकल कॉर्ड मेरे सेंटर में आ गए, मुझे इन दोनों को लैटरलाइज करना पड़ेगा ताकि मेरी कोई स्पेस हो, या फिर एक को मैं लैटरलाइज करूंगा ताकि स्पेस बने। That is why we will do type 2 thyroplasty. We will do type 2 thyroplasty, which is lateralization thyroplasty, ताकि we get some space. Now we get into another important procedure. अगर space बनानी है, so we also do another important thing. And what do? We take a laser, हम एक laser लेते हैं, and we create a wedge-shaped excision on the posterior 1/3 of the vocal cord. So we excise like a wedge. Posterior 1/3 of the vocal cord is excised like a wedge, and this is called as Kashima's procedure. So if we excise posterior 1/3 of the vocal cord like a wedge, it is called as Kashima's operation or Kashima's procedure. ठीक है, fine. चलो, now this also is important. Okay. So I've written here what is Kashima's operation, and finally, if you want to do, then you can even reduce the vocal cord. इस vocal cord को हटा भी सकते हैं आधा। We can reduce the bulk of the vocal cord, which is called as chordectomy. तो ये सब हमने कर रहे हैं। Why? We need to space it. We need to create some space. That's why we are doing it. ठीक है, चलो आगे आते हैं। Now let's come to if the person has got पूरी palsy, RLN भी चली गई, SLN भी चली गई, अब क्या होगा? So now this is important again. Now let me tell you the second rule of thumb. Second rule of thumb ये होता है कि अगर किसी की RLN plus SLN palsy हो गई, then the cord will attain an intermediate position, which is called as cadaveric position. This is never seen in normal people. This position is only seen whenever the patient has got complete palsy, या फिर patient is in postmortem or the patient is in general anesthesia. So that means इस position में क्या होता है? What do you see when both these nerves are getting injured? When both these nerves get injured, then the vocal cord will attain an intermediate position. Intermediate का मतलब क्या हुआ? It will be 3.5 mm from the midline. यहां पे आके ऐसे खड़ा हो जाएगा, बस ये ना इधर जाएगा ना इधर जाएगा. It will be 3.5 mm away from the midline. That's called as cadaveric position or intermediate position. अब खुद सोचो, अगर किसी के यूनिलैटरल RLN SLN दोनों पैल्सी होगी, मतलब कोई मसल काम नहीं कर रही, कोई सेंसेशन नहीं है, तो एक कॉर्ड ऐसे रहेगा, राइट? वन कॉर्ड विल बी लाइक दिस. The opposite cord is going to be the one which is going to come in the center. It is going to go away. It is going to come in the center. It is going to go away. But this cord is going to go straight. ऐसे ही रहेगा ये. Opposite cord बाहर जाएगा, फिर opposite cord अंदर आएगा, फिर opposite cord बाहर जाएगा, फिर अंदर आएगा. But ये cord इतनी दूर ही रहेगा. That means you are not able to close this gap at all. So if this gap will not close, what will happen to speech? Speech obviously होगी नहीं, क्योंकि vocal cords are not adducting together. That means the patient will develop aphonia. बात ही नहीं आएगी. You won't be able, because now the patient will get a very breathy voice. आवाज ही नहीं निकलेगी. Why? Because now the gap is too big. Obviously, if there is a gap, there will be patient aspirating. Aspirate करेगा, जो भी खाएगा नीचे चला जाएगा. Why? Because now the sensations which are present above and below the level of the vocal cord are also lost. Right? Okay? And finally comes respiration. Respiration में कोई issue नहीं होगा. Why? Because there is a big gap to respire. So the problem with these patients is respiration, is aspiration. अब what to do in cases of aspiration? अगर कोई aspirate कर रहा है, मैं एक चीज ये कर सकता हूं कि अगर मैं इस पैरालाइज वोकल कॉर्ड को धक्का देके सेंटर में ले आऊं, तो ऑपोजिट कॉर्ड विल स्टार्ट टू क्लोज दिस वेल, क्योंकि अभी तक एक कॉर्ड बहुत दूर है, एक ही कॉर्ड है जो चल रहा है. तो अगर मैं इसको धक्का देके सेंटर में ले आऊं, सो दिस पर्टिकुलर एक्शन ऑफ क्लोजिंग विल बी बेटर. दैट मीन्स इन केसेस ऑफ यूनिलैटरल प्लस आरएलएन पैल्सी, जिसमें कंप्लीट पैल्सी है, जिसमें कॉर्ड इज इन अ कैडेवरिक पोजीशन, आई नीड टू पुश द पैरालाइज कॉर्ड इन द मिड लाइन so that I can get a good closure, so that aspiration does not happen. That is why we do something called as type 1 thyroplasty. Medialize कर दो कॉर्ड को. That means medialization या type 1 thyroplasty is done in cases of complete palsy which is unilateral. और फाइनली आते हैं bilateral complete पे. Bilateral complete मतलब अब दोनों कॉर्ड कैडवरिक हैं, मतलब ऐसा ही है larynx, ना आगे आ रहा है ना पीछे जा रहा है, बस ऐसा खुला हुआ है. That means larynx is good for nothing. There is only air coming in and going out. Patient जो भी खा रहा है larynx के अंदर जा रहा है, complete aspiration है. There is complete aphonia. कोई बात नहीं कर पा रहा है because vocal cords are just like this. Both are in cadaveric position, both are in intermediate position. So now what to do? Larynx is non-functional. Larynx is completely gone. तो इसके केस में we do something called as tracheo-esophageal diversion. Larynx इसी काम का नहीं है, तो trachea और esophagus को हम divert कर देते हैं. How do we do that? कि आगे होता है trachea, like let's say this is the larynx, this is the larynx of the patient, this is the trachea, and behind is the esophagus of the patient. ये esophagus है patient के, और ये उसकी neck है. तो इसमें हम क्या करते हैं? We cut the trachea with the larynx, right? And what do we do? The upper part of the remaining larynx and trachea, we suture it to the esophagus, and the remaining lower trachea we open it through the skin. मतलब हम ट्रेकिया और ईसोफेगस को डाइवर्ट कर दिया है. मतलब अब जो भी खाना पेशेंट खा रहा है वो उसके स्ट्रेट अवे ईसोफेगस में जा रहा है. एंड व्हाटएवर द पेशेंट इज ब्रीदिंग थ्रू द स्टोमा. यहां पे एक स्टोमा बना दिया जिसके थ्रू वो ब्रीथ कर रहा है. दैट्स व्हाट इज एग्जैक्टली कॉल्ड एज ट्रेकियो-ईसोफेजियल डाइवर्जन. ये सारे क्वेश्चंस हैं, ये सारी की सारी चीजें आपके लिए इंपॉर्टेंट है एज फार एज दिस इज कंसर्न्ड. चलिए आगे बढ़ते हैं. ओके, फाइनल. नाउ लेट्स कम टू व्हाट इज लैरिंजियल मैलिग्नेंसी एंड लैरिंजियल मैलिग्नेंसी से रिलेटेड इंपॉर्टेंट क्वेश्चन बिफोर वी गो ऑन टू द फाइनल थिंग दैट इज फारिंग्स. ठीक है, तो लैरिंजियल मैलिग्नेंसी से एसोसिएटेड बड़े इंपॉर्टेंट क्वेश्चन है, दैट इज स्टेजिंग ऑफ लैरिंजियल कैंसर्स. एंड उससे एसोसिएटेड आपको ये पूछा जाता है दैट व्हाट एग्जैक्टली विल बी द मैनेजमेंट स्ट्रेटजीज जो आप इसमें देखेंगे. ठीक है, तो सबसे पहली चीज लैरिंजियल मैलिग्नेंसीज में जो टी स्टेजिंग है वो आपको आनी चाहिए. टी स्टेजिंग इज अगेन डिवाइडेड इनटू T0. T0 means laryngeal staging. I'm telling you about glottic carcinoma, क्योंकि इसी से आपके क्वेश्चन आएंगे. So I'm telling you about glottic carcinoma over here. What is the T staging of glottic cancers? सबसे पहले हो गया T0. T0 means no identifiable malignancy. Malignancy identifiable नहीं है, कोई malignancy नहीं है. That is called as T0. Okay. Now comes T1. T1 is again divided into T1A, T1B. ऑलवेज रिमेंबर T1 में द वोकल कॉर्ड मोबिलिटी इज नॉर्मल. तो अगर आपसे आपकी स्टेजिंग में बोला जाए मोबाइल कॉर्ड्स हैं, मतलब दोनों कॉर्ड मोबाइल हैं, दैट मींस इट इज स्टिल इन T1. T1A, A फॉर एक. एक का मतलब इफ देयर इज मैलिग्नेंसी ओवर वन वोकल कॉर्ड विद नॉर्मल मोबिलिटी ऑफ बोथ द कॉर्ड्स, दोनों कॉर्ड्स की मोबिलिटी अच्छी है एंड देयर इज मैलिग्नेंसी ओनली ऑफ एक कॉर्ड, that is T1A, A for एक. T1B, B में मतलब if there is malignancy of both the vocal cords, दोनों पे ट्यूमर है and still the normal mobility is there, मतलब vocal cord still mobile है दोनों, but दोनों में vocal cord पे ट्यूमर है, that is called as T1B, B for both. Now let's come to T2. T2 मतलब two subsites. If the laryngeal carcinoma is involving more than one subsite. अब ग्लॉटिस के अलावा और कौन सी सबसाइट होती है? या तो ऊपर की सुप्राग्लॉटिस या नीचे की सबग्लॉटिस. दैट मींस ईदर supraglottis or subglottis. We will call it as T2. Now the only thing you need to understand is कि अगर आपके complete paper में या कभी भी आपके question में ये mention है कि there is impaired mobility of cord. Impaired mobility का क्या मतलब है? Impaired mobility का यह मतलब है कि vocal cord चल रहा है पर sluggish है. The moment they say impaired mobility, it is T2 they are talking about. Okay? Now let's come to T3. T3 means now this glottic carcinoma is involving 4P. ये 4P को involve कर रहा है. What are the 4P that are involved in glottic malignancy? 4P means either it has involved pre-epiglottic space, paraglottic space, post-cricoid area, or perichondrium of thyroid cartilage. 4P. तो अगर इनमें से कहीं भी 4P मिले, that the glottic carcinoma has gone into two spaces, either the pre-epiglottic space, paraglottic space, post-cricoid or perichondrium of thyroid cartilage, तो 4P अगर involve हुए, then that automatically carcinoma becomes T3. Also, very important point, if they mention that there is fixed vocal cord, that means automatically it has upstaged to T3. यानी एक अगर vocal cord पूरी तरीके से बंद हो गया काम करना, it's fixed, it has automatically gone up to being called as T3. ठीक है? Now comes T4. T4 is divided into T4A and T4B. T4A का मतलब है laryngeal cancer अब बाहर आ गया. जब laryngeal cancer बाहर आ गया, so it has involved all surrounding areas. Surrounding area का मतलब it has involved the cartilage of the larynx, esophagus, trachea, skin, strap muscle, thyroid gland, जितनी भी एरिया यहाँ पे सराउंडेड है. तो ग्रॉसली अब याद रखना, कभी कभी क्या करते हैं, ये मैंने आपको PYQ की में दिखाया भी था. In your when I was discussing your PYQs, I showed you that when I showed you a CT scan जिसमें thyroid cartilage टूट गई है. So if the larynx cancer is coming out beyond the cartilages and surrounding structures में extra laryngeal structures involved है, if they are involving extra laryngeal structures, then it is going to be T4A. And if the patient has got involvement of PCM, PCM मतलब prevertebral space, carotid sheath, or the patient has got an involvement of mediastinum, PCM, physics chemistry maths नहीं, यहाँ पे PCM दूसरा है, then that is going to be T4B. अब इसी तरीके से सिंपल है, अगर आपको इन्होंने बोला कि इसके अकॉर्डिंग स्टेज के आप T1 और 2 में क्या करोगे, तो T1 या 2 में देयर आर ओनली सिंगल मोडालिटी ट्रीटमेंट, सिर्फ एक ट्रीटमेंट देंगे. या तो पेशेंट को रेडिएशन देंगे, रेडिएशन इज गिवन फॉर 35 साइकिल्स 5 टाइम्स अ वीक फॉर 7 वीक्स, और वी गिव द पेशेंट ट्रांस ओरल लेजर माइक्रोसर्जरी. लेजर से वी विल एक्साइज आउट द लीजन. दैट इज ओनली वन मोडालिटी रिक्वायर्ड इन द फर्स्ट एंड सेकंड स्टेज. If we come to T3 या third stage, we will again assess the patient for speech aspiration and respiration. अगर हमें लगेगा पेशेंट की स्पीच ओके है, एस्पिरेट नहीं कर रहा, रेस्पिरेशन इज ओके, देन वी आर गोइंग टू गो फॉरवर्ड विद कंकरेंट कीमो रेडिएशन. तो ये इंपॉर्टेंट चीज है. इफ आई आस्क यू व्हाट इज द मोस्ट कॉमन चीज फॉर T3, देन इट इज CCRT, कंकरेंट कीमो रेडिएशन थेरेपी. बट अगर ऐसा लग रहा है कि लैरिंक्स फंक्शनल नहीं है, then we do something called as open partial laryngectomy or transoral laser excision with neck dissection. तो इसमें हमें ओपन सर्जरी करनी पड़ेगी, where we open it and partially we take out the whole of the larynx, whichever is involved, which is called as partial laryngectomy. या फिर we go ahead with transoral laser surgery, but उसके साथ we need to do a neck dissection, क्योंकि any tumor with stage 3 onwards we have to do neck dissection. ठीक है, चलो आगे बढ़ते हैं. अगर आया T4A and T4B. T4A का मतलब है larynx is not functional, मतलब अब कोई काम नहीं है larynx का, वो जा चुका है. It has come out of the larynx, it has got extra laryngeal spread. So in extra laryngeal spread, we will do nothing but total laryngectomy with bilateral neck dissection. Now for all cases we do total laryngectomy or neck dissection. उसके बाद we have to send the patient for post-operative concurrent chemoradiation. Why? क्योंकि even if you have done the complete surgery, 26% chances are there that the tumor can come back because it is very advanced. So we have to do something called as an adjunctive approach. Adjunct to treatment मतलब ये एक extra thing है that we have to be a little cautious कि हमने इसके बाद we are sending the patient for concurrent chemoradiation also. How we do total laryngectomy? We give an incision from one mastoid to another mastoid. What is the name of this incision? ये important question है. Name of this incision is Gluck-Sorensen incision. Gluck-Sorensen incision. ठीक है? Final T4B हमारे पास कुछ नहीं है. When the PCM, prevertebral space, carotid sheath and mediastinum is involved, कुछ नहीं कर सकते. In that case, we will only give palliative treatment. Prolong the patient's life. Okay? चलो. फाइनल वॉइस रिहैबिलिटेशन. लैरिंग्स में ये फाइनल आ गया है. वॉइस रिहैबिलिटेशन इन लैरिंजेक्टमी. ये बहुत इंपॉर्टेंट है फॉर आइडेंटिफिकेशन पर्पस. ये क्या चीज है? दिस इज कॉल्ड एज ट्रेकियोइसोफेजियल प्रोसेसेस. राइट? तो ये इसको हम कहते हैं ट्रेकियोइसोफेजियल प्रोसेसेस. तो लैरिंजेक्टमी में हम क्या करते हैं? दिस इज योर नेक, राइट? एंड हमने लैरिंग्स को रिमूव कर दिया है. तो व्हाट डू वी डू? नाउ वी सूचर द रिमेनिंग ट्रेकिया एंड वी क्रिएट अ परमानेंट स्टोमा. ठीक है? यहां से पेशेंट सांस लेगा. And behind is something which is called as the pharynx and the esophagus where the patient is eating from. So patient is eating behind. ये हमारा pharynx है और ये इसका esophagus है. The junction between the pharynx and the esophagus is called as pharyngoesophageal junction. This is the narrowest area which is present in this particular pathway which is called as pharyngoesophageal junction. तो हम लोग क्या करते हैं? ट्रेकियोइसोफेजियल प्रोसेसेस जो होती है इसको हम लोग बोलते हैं ब्लॉम सिंगर. वी कॉल दिस एज ब्लॉम सिंगर ट्रेकियोइसोफेजियल प्रोसेसेस. इसमें एक फ्लैंज होती है विच इज टुवर्ड्स द इसोफेगस. वन फ्लैंज इज देयर विच इज टुवर्ड्स द ट्रेकिया. So what we do? We give an incision in the posterior wall of trachea and an anterior wall of esophagus. और इसके बीच में we keep this processes. तो इसको हम प्रोसेस को ऐसे ऐसे लगा देते हैं. Now this is a one way processes. मतलब इसमें एक सेंटर में वाल्व होता है, देखो यहाँ पे. तो इट इज अ वन वे वाल्व. तो इसमें करता क्या है पेशेंट? Whenever the patient is breathing out, मतलब पहले इंस्पायर किया, he is breathing from here through the stoma. तो inspires. So when he is expiring, जब वो एक्सपायर कर रहा है उस टाइम पे he will close the inlet with the help of a thumb. तब वो thumb लगा के इस inlet को close कर लेगा. So now what will happen? Whenever the patient is expiring, the air will go from this esophageal processes into this pharyngoesophageal junction. And it will vibrate this pharyngoesophageal junction. And once it vibrates this pharyngoesophageal junction, that will create a speech. It will create speech. जैसे आप बर्प करते हैं ना, तो बर्प करते हैं तो आप एक अंदर से एक आवाज निकालते हैं from your tube, from your esophagus. So that is what is called the principle of tracheoesophageal processes, where the patient is actually utilizing this pharyngoesophageal junction to vibrate. Another important thing, if something is shown like this, that the patient is holding this kind of an instrument over on the submandibular area, यहाँ पे, और ये एक robotic सी voice निकल रही है, this is called as an electrolarynx. इसे हम लोग कहते हैं electrolarynx. ठीक है? चलो, ये आपका पूछा गया था नीट पीजी में, दैट्स व्हाई आई हैव जस्ट पुट इट ओवर हियर. इसके बस हम लोग पार्ट्स देख लेते हैं, व्हाट आर द इंपॉर्टेंट थिंग, राइट? तो दिस इज द नेक प्लेट. दिस इज द नेक प्लेट. दिस पर्पल कलर थिंग इज कॉल्ड एज एन ऑब्ट्यूरेटर. ये बाद में रिमूव कर दिया जाता है. दिस इज अ ट्रेकियोस्टोमी ट्यूब, राइट? दिस इज अ पोर्टेक्स ट्रेकियोस्टोमी ट्यूब. दिस इज द शाफ्ट ऑफ द ट्यूब. दिस इज द बलून, राइट? This is the cuff. This is a cuff. इसी के अंदर we inject air so this balloon can inflate. Now this balloon is being given for what? ये balloon इसलिए दिया गया है so that it can prevent aspiration. It can prevent aspiration. So this is a portex cuff tracheostomy tube. Cuff क्यों? क्योंकि इसमें balloon है. Now जब balloon होगा तो obviously इसके ऊपर बहुत सारा saliva and whatever the patient will eat will start collecting. सब कुछ इसके ऊपर कलेक्ट हो जाएगा, राइट? सो वी नीड अ पाइप और वी नीड अ सक्शन सो दैट वी कैन टेक आउट ऑल दिस व्हिच हैज कलेक्टेड अबव द बलून बिफोर वी डिफ्लेट इट. So for what? For that we have been given another important line. और ये देखो, ये ट्यूब के साथ एक लाइन दी गई है and this line is called as a subglottic suction. ये आपके पेपर में आया था कि ये आइडेंटिफाई करो क्या है, दिस इज कॉल्ड एज सबग्लॉटिक सक्शन। तो हम लोग क्या करते हैं, वी कीप अ सिरिंज ओवर दिस सबग्लॉटिक सक्शन और सब कुछ खींच लेते हैं ताकि ये सारा का सारा जो एरिया है वी सक्शन इट आउट, एंड देन आफ्टर दैट वी डिफ्लेट द बलून। नहीं तो अगर हमने ऐसे ही डिफ्लेट कर दिया, ऑल दीज थिंग्स विल स्ट्रेट अवे गो इनसाइड इनटू अ लोअर एयरवे एंड द पेशेंट विल एस्पिरेट। So this is a portex tracheostomy tube, ठीक है, and the parts of it। चलो फाइनल भाई, फाइनल हो गया। अब आ गए लास्ट में, where we are going to do important tumors, जिसमें एंजियोफाइब्रोमा आता है, नेजोफेरेंजियल कार्सिनोमा के क्वेश्चन आते हैं, और कुछ चीजें अबाउट डीप नेक स्पेस इन्फेक्शन आती है, फिर हमारी पूरी की पूरी ईएनटी खत्म होती है। ठीक है, चलो तो अभी हम एक एक करके शुरू करते हैं। व्हाट आर इंपॉर्टेंट थिंग्स इन फैरिंक्स? सबसे पहले सबसे इंपॉर्टेंट ट्यूमर दैट इज रिलेटेड टू द फैरिंक्स दैट दे विल आस्क यू इज अबाउट जुवेनाइल एंजियोफाइब्रोमा। नाउ ऑलवेज रिमेंबर, इफ दे गिव यू एनी पर्टिकुलर पेशेंट हु इज an 18 to 20-year-old male with spontaneous, diffuse, unprovoked epistaxis and with worsening nasal obstruction, answer is JNA। बट ये जुवेनाइल एज ग्रुप में ही होगा, तो दैट इज व्हाई दिस इज गोइंग टू बी JNA। व्हाट इज द साइट ऑफ ओरिजिन ऑफ JNA? इट इज द सुपीरियर लिप ऑफ स्पीनोपैलेटाइन फोरामेन। सुपीरियर लिप ऑफ स्पीनोपैलेटाइन फोरामेन से निकलता है, दैट इज द मोस्ट इंपॉर्टेंट पॉइंट। Which investigation is contraindicated in JNA? आप क्या नहीं करेंगे? You will never touch the JNA and do a biopsy. Why? Because जो vessels होती हैं JNA में, that lack a smooth muscle coat, and that is why जब ये smooth muscle इनके around नहीं होती है, तो these vessels are very loose. The moment you biopsy them, they start profusely bleeding. बिल्कुल ठीक. So that is why you will not do a biopsy because of the risk of delayed vasoconstriction. What is the investigation of choice for JNA? It is contrast enhanced CT scan. ये मैं आपको ऑलरेडी बता भी चुका हूं in the PYQ session कि contrast enhanced CT scan करते हैं। Now let me come to the next questions. जब हम CCT करेंगे, these are the two signs that you should know how to memorize them. So always remember there is a fossa. See, this is what? This is an axial section. ये मैंने ऐसे काट दिया, मैं ऊपर से देख रहा हूं। So now when I see an axial section, always remember this is your center, this is your nasal cavity, right? This is your center, the septum. This is your maxillary sinus. This is your maxillary sinus. Now, maxillary sinus has air, that's why it's black. The area present behind the maxillary sinus, this area is called as pterygopalatine fossa. JNA loves this area. इसी में JNA spread करता है. So whenever the JNA comes out, behind the nasopharynx, behind the nasal cavity is nasopharynx. So ये जितना gray है ना, this is the tumor. Always remember gray is tumor क्योंकि वो एक soft tissue है. So this tumor will now go straight away behind the maxilla and it will start growing in this pterygopalatine fossa. When this JNA will involve the pterygopalatine fossa, this is behind the maxilla, behind the maxillary sinus. So that will happen. So what will happen? Once this JNA will involve this pterygopalatine fossa, it will cause anterior bowing of the posterior maxillary wall. See this? This is your posterior maxillary wall. This is anterior maxillary wall. तो यहां से ये धक्का मारेगा पीछे से. So that means there will be anterior bowing of the posterior maxillary wall, and this particular sign is called as Holman-Miller sign. That's the first important feature on CECT. Now comes the second important feature which is seen on coronal section. Coronal मतलब मैंने अगर ऐसे काट दिया सर को, तो नेजोफैरिंक्स से निकलते 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 ये ट्यूमर इंफ्राटेम्पोरल फोसा में आ जाता है. इंफ्राटेम्पोरल मतलब ये टेम्पोरल है, टेम्पोरल के नीचे मतलब जाइगोमा के अंदर there is a fossa which is called as infratemporal fossa. तो इन द इंफ्राटेम्पोरल फोसा अगर ये ट्यूमर आया तो क्या करेगा, ये मेरी मैंडिबल को साइड में ऐसे शिफ्ट कर देगा. दैट मींस देयर इज लैटरल डिस्प्लेसमेंट ऑफ द ramus ऑफ मैंडिबल. If there is lateral displacement of the ramus of mandible, so see this is the ramus of mandible, this is the ramus of mandible. Now this tumor has actually come out and it has displaced this ramus laterally. This displacement seen in the infratemporal fossa, where lateral displacement of ramus is seen, this is given the name as Horndusa sign. This is called as Horndusa sign. दोनों बहुत important questions for JNA. Okay, चलो. Now we come into the next part. Nasopharyngeal carcinoma और इससे related question. Most common malignancy that is seen in cases of nasopharynx is what? Nasopharyngeal carcinoma. Now, this occurs mostly in the Southeast Asian population. That means it is very common in Chinese. So, wherever you find a man, अच्छा एक चीज याद रखना, जरूरी नहीं है nasopharyngeal carcinoma only happens in older people. It has bimodal age distribution. It can be seen in 20s, it can be seen in 60s. Both the people. But Southeast Asian is a catch point. So, Southeast Asian patient from the northeast part of India, they have come up with very commonly nasopharyngeal carcinoma. Why? Because of the genetic predilection over that area. The second most important cause is exposure to nitrosamines यानी कि salted fish. तो ये देखा जाता था कि जो ये चाइनीज में चाइना में एक बहुत कॉमन सी चीज है कि उसमें बहुत सारी फिशेस खाई जाती हैं एंड फिश ला के बहुत बड़े डंप यार्ड में डंप कर देते थे. तो होता क्या था, उनकी स्टेपल डाइट फिश है, तो क्योंकि वो फिश खाते थे बहुत, तो वो क्या होता था, फिश खराब हो जाती थी. तो फिश खराब हो जाती तो उन्होंने सॉल्ट डालना स्टार्ट कर दिया ताकि वो खराब ना हो. तो क्योंकि वो सॉल्ट डालने लगे, दैट स्टार्टेड रिलीजिंग दिस नाइट्रोसामीन व्हिच स्टार्टेड कॉजिंग कैंसर्स. ओके, now this particular carcinoma is associated with which virus? It is associated with Epstein-Barr virus. Very important, because patients with nasopharyngeal carcinoma has been found to have raised IgA values against the viral capsid antigen and early antigen of this particular virus. So, दो important जो antibody इनमें दिखती हैं against this virus are IgA, which are against the viral capsid antigen and nuclear core early antigen of this virus. ये raised होती हैं इन patients में. That is why we usually, we take कि carcinoma भी persisting है कि नहीं है, एक screening tool की तरह use करते हैं these IgA antibodies. Okay, but always remember viral capsid antibodies are more sensitive, whereas early antigen is more specific. ये दो point है. चलो, अब आते हैं इसके इंपॉर्टेंट फीचर्स पे. हमेशा एक चीज आपको ध्यान रखनी है, जो आपके नेसोफेरेंजियल कार्सिनोमा के क्वेश्चन बनेंगे उसमें एक चीज आपको जो लिखी जाएगी वो होगी दैट इफ द पेशेंट इज फ्रॉम द साउथ ईस्ट एशियन पार्ट एंड दिस पेशेंट हैज कम विद पेनलेस सर्वाइकल लिम्फेडेनोपैथी. किसी के भी अगर पेनलेस सर्वाइकल लिम्फ नोड है एट लेवल 2 और लेवल 5, 5 मतलब पोस्टीरियर ट्राइंगल, 2 मतलब अपर जुगुलर, एंड इट इज पेनलेस. तो पेनलेस सर्वाइकल लिम्फेडेनोपैथी इज द अर्लीस्ट फीचर ऑफ नेसोफेरेंजियल कार्सिनोमा. ये मत भूलना, ये सबसे पहले दिखेगा. तो मेनी अ टाइम्स नेसोफेरेंजियल कार्सिनोमा प्रेजेंट्स एज ओनली अ नोडल स्वेलिंग. दिस इज द अर्लीस्ट फीचर. ओके, दे विल हैव नेजल ऑब्स्ट्रक्शन, एपिस्टैक्सिस, नेजल वॉइस, यूनिलैटरल सीरस ओटाइटिस मीडिया जो हमने ऑलरेडी डिस्कस किया था, मल्टीपल क्रेनियल नर्व इन्वॉल्वमेंट, बट at the same time 75% patients don't have anything and they have only painless cervical lymphadenopathy. Up, एक important thing, which part of the body is commonly involved by metastasis in cases of nasopharyngeal carcinoma? The most common distant metastasis in nasopharyngeal carcinoma happens in the thoracolumbar spine. सबसे common area ये है spinal metastasis का. What is Trotter's triad? Trotter's triad can be remembered by the mnemonic nasopharyngeal carcinoma, NPC for NPC. N for neuralgia. Neuralgia means temporoparietal neuralgia. Temporoparietal neuralgia. P is palatal palsy, which happens because of vagus nerve involvement. And C for conductive hearing loss, which happens because of eustachian tube invasion. So NPC से तीन important things that are present in nasopharyngeal carcinoma called as Trotter's triad. Okay. What is the investigation of choice for NPC? Always CCT MR with gadolinium contrast, because you need to see the nasopharynx. That remains same for JNA also. What is the screening follow-up tool? मैंने बताया था एक antibody which is against EBV. It is a very good thing to screen population. So IgA against viral capsid antigen and early antigen of EBV can tell us about as a screening tool. Also can help us as a follow-up tool कि whether the patient has got raised values or not. अगर ये value raised आती हैं after you have given treatment, that means the patient has got recurrence या patient has got persistent disease. आपने छोड़ दी है. ठीक है? What will be the treatment of choice? Always surgery नहीं करते. The treatment of choice for nasopharyngeal carcinoma always is intensity modified radiotherapy with concurrent chemoradiation. So we give radiation which is intensity modified, मतलब वहीं पे सारी radiation देंगे जहां पे है, focus to that area, intensity modified, उधर ही सारी intensity है, together with chemotherapy. Chemotherapy, drug of choice, cisplatin. Cisplatin. ठीक है, चलो नेक्स्ट, अब आते हैं डीप नेक स्पेस इन्फेक्शन पे। अब डीप नेक स्पेस इन्फेक्शन को पढ़ाने के लिए अगेन आई विल डू द सेम थिंग जो मैं हमेशा करता हूं। आई विल ड्रॉ द डायग्राम एंड वील फिनिश ऑफ ऑल डीप नेक स्पेस एंड द इंक्लूडेड इन्फेक्शंस टुगेदर। पहले मैं एनाटॉमी पढ़ाऊंगा, उसके बाद आई विल टीच यू अबाउट हाउ द डिजीजेस स्प्रेड, क्योंकि डिजीजेस के अपने इमेजेस हैं, तो आई विल शो यू द इमेजेस एंड देन वी विल डिस्कस इट फटाफट, बिकॉज दिस इज गोइंग टू बी a very easy thing. So if I cut my neck like this, if I cut my neck like this in an axial section, और मैं ऊपर से देखूं, तो मैंने ऐसे काटा गर्दन को, ऊपर से देख रहा हूं, तो सबसे पीछे होती है मेरी वर्टेब्रा, ये हो गई वर्टेब्रा। वर्टेब्रे के ऊपर होती है प्री वर्टेब्रल मसल्स, ये हो गई मेरी प्री वर्टेब्रल मसल। अब प्री वर्टेब्रल मसल के सामने होता है एक फेशिया, दिस इज कॉल्ड एज प्री वर्टेब्रल फेशिया। ओके, the space present between the prevertebral muscles and this fascia, this is called as prevertebral space. This is called as prevertebral space. Okay, now there is another fascia which is present in front of this prevertebral fascia. This fascia present in front of this prevertebral fascia, this is called as alar fascia. The space present between the alar fascia anteriorly and the prevertebral fascia posteriorly, this is called as danger space. Okay, fine. Chalo, ab. Now, because we have cut open the larynx in an axial section, आगे क्या होगा? आगे, let's say this is your tonsil. This is your tonsil. So this is what I have drawn आगे. So this is your tonsil. Right? Now, behind the tonsil, there is a very important layer which is present on the lateral surface of tonsil. And this space which is present on the lateral surface of the tonsil, this is called as a tonsillar capsule. Tonsil ke lateral surface pe, there is something called as tonsillar capsule. Okay? Now, very important. Behind this tonsil capsule, there is a very important muscle. And this muscle is called as superior constrictor muscle. Superior constrictor muscle. The space present between the superior constrictor laterally and the capsule medially, this space is called as peritonsillar space. This is called as peritonsillar space. So any infection which happens in this little space is called as peritonsillar abscess, or we give it the name quinsy. Simple. Okay? Chalo, now there is another fascia which is present behind the superior constrictor muscle, and this fascia is given the name as buccopharyngeal fascia. This is called as buccopharyngeal fascia, which is behind the superior constrictor muscle. Bucco matlab bahar, bahar ki taraf. The space present between the buccopharyngeal fascia anteriorly and the alar fascia posteriorly, this little space over here, this is called as retropharyngeal space. ये बड़ी important है. Any infection which occurs in this space is called as retropharyngeal abscess. This retropharyngeal space is basically divided by a median partition. इसमें एक छोटा सा median partition होता है, median fibrous partition होता है, and it divides these two, मतलब it divides this retropharyngeal space into two small compartments, और इन small compartment को कहते हैं space of Gillette. जैसे कहते हैं space of Gillette. इनमें होते हैं छोटे छोटे lymph nodes, and these lymph nodes are called as lymph node of Rovier. Lymph node of Rovier. ठीक है? तो कभी भी अगर रेट्रोफैरेंजियल एब्सेस किसी को भी होती है, द मोस्ट कॉमन कॉज, रेट्रोफैरेंजियल एब्सेस दो टाइप की होती है, अक्यूट एंड क्रॉनिक. द मोस्ट कॉमन कॉज फॉर अक्यूट रेट्रोफैरेंजियल एब्सेस इज ट्रॉमा. ट्रॉमा मतलब पेनिट्रेटिंग इंजरी, कोई पेंसिल खा रहा है, किसी की चोट लग गई, दैट इज समथिंग विच इज रिलेटेड टू ट्रॉमा. Most common cause of chronic retropharyngeal abscess is TB spine. TB spine मतलब यहां पे कोई इंफेक्शन हो गया and it came down into this abscess. ठीक है? Retropharyngeal abscess will always produce a paramedian bulge. देखो यहां पे होगा या यहां पे होगा, but this will produce a paramedian bulge, midline के आजू बाजू. This is retropharyngeal abscess. If there is a median bulge, so that is prevertebral space abscess. क्योंकि ये पूरी होती है, ये क्योंकि पार्टीशनड होती है, दैट इज व्हाई इट प्रोड्यूसेस अ पैरामीडियन बल्ज. वेरी इंपॉर्टेंट पॉइंट. ठीक है, फाइन. So this finishes about what is retropharyngeal abscess as well as what are the related questions. अब retropharyngeal abscess के lateral, this side is the lateral side and this is called as parapharyngeal space. Pharynx के side में. तो अगर मैं pharynx के side में आ जाऊं, this is my parapharyngeal area and if I go more lateral, I'll come to the mandible. तो parapharyngeal space का lateral limit is our mandible. Mandible के inner surface पे medial pterygoid आती है, mandible के lateral surface पे masseter muscle आती है. One side is masseter, one side is medial pterygoid. Above this mandible is a deep lobe of parotid gland. यहां पे होता है deep lobe of parotid. Okay. Now, parapharyngeal space is divided by a important bone which is called as styloid bone into two halves. एक half which is in front of the styloid, एक half which is behind the styloid. The part which is in front of the styloid is called as pre-styloid compartment. The part which is behind the styloid is called as post-styloid compartment. ठीक है. अब pre-styloid compartment में अगर कभी भी कोई भी इंफेक्शन होता है तो यहां पे अगर पस बन गया, यहां पे कोई सारा पस बन गया, तो what will happen? This will, number one, this will medialize the tonsil towards the center. मतलब टॉन्सिल मेरी मीडियल हो जाएगी, टॉन्सिल बिल्कुल सेंटर में आ जाएगी. That will be the first part. That means if you are given any patient who has got a parapharyngeal space infection, उसके क्या फीचर्स होंगे? Number one feature will be that the tonsil will be pushed medially. उसका थ्रोट खोलेंगे तो टॉन्सिल बीच में आई होगी. Second feature will be that this particular abscess will cause a contraction of the medial pterygoid muscle and this will lead to trismus. So trismus will be the second feature of parapharyngeal space abscess, pre-styloid compartment. Third feature क्या होगा कि this will trickle down और ये mandible के नीचे एक swelling करेगा. So they will be swelling at the angle of mandible. अगर आपको आपके केस में swelling दे रखी है angle of mandible पे, tonsil is pushed medially लिखा हुआ है, at the same time trismus लिखा हुआ है, आंसर इज पैराफेरेंजियल एब्सेस है. तो पेशेंट के पैराफेरेंजियल एब्सेस है. अगर आपके केस में ये लिखा हुआ है कि देयर इज पस फॉर्मेशन, टॉन्सिल इज मीडियलाइज्ड, देयर इज नो एंगल ऑफ जॉ स्वेलिंग, दैट मींस सिर्फ टॉन्सिल मीडियलाइज हुई है, देयर इज अ पस कलेक्शन बिटवीन द कैप्सूल एंड सुपीरियर कॉन्स्ट्रिक्टर मसल, आंसर इज क्विंसी या पेरिटॉन्सिलर एब्सेस. तो इन दोनों एब्सेस में मीडियलाइजेशन ऑफ टॉन्सिल दिखती है. The only difference is in parapharyngeal abscess there is angle of jaw swelling, but it is not there in cases of peritonsillar abscess. These are the two identifying features. If any person has got a post-styloid parapharyngeal abscess, post-styloid compartment contains nerves. It contains carotid sheath. तो यहां पे होती है carotid sheath. It contains internal jugular vein, vagus nerve, carotid sheath, 9th nerve, 11th nerve, 12th cranial nerve, sympathetic chain. यानी ये सारी मल्टीपल क्रेनियल नर्व पैल्सीज दिखेंगी व्हेन इट इज पोस्ट स्टाइलॉइड कंपार्टमेंट. तो क्रेनियल न्यूरोपैथीज आर अ फीचर ऑफ पोस्ट स्टाइलॉइड कंपार्टमेंट पैराफेरेंजियल एब्सेस. ठीक है, तो ये खत्म होती है हमारी तीन एब्सेस एंड द एसोसिएटेड क्वेश्चन दैट आर रिलेटेड टू देम. अब देखो, लेट मी जस्ट शो यू. ये देखो, अगर आपको ये दिखा कि देयर इज एडिमा एंड एरिथेमा ओवर द टॉन्सिल एंड द टॉन्सिल इज पुश्ड मीडियली एंड दिस पर्टिकुलर यूवुला इज डिविएटेड लैटरली, देयर इज नो एंगल ऑफ जॉ स्वेलिंग, there is severe odynophagia. What is your answer? This is Quincy. अगर इसी टाइप का आपको दिखा सेम एंड इसके साथ आपको मेंशन्ड है that there is angle of jaw swelling, that is parapharyngeal abscess. ठीक है, that is how you differentiate both of them. Okay? Now, just one second, just a second. Okay, fine. Okay, so now this is the contrast feature between the two. ठीक है, अब आते हैं मोस्ट इंपॉर्टेंट पार्ट, एक और डीप नेक स्पेस इंफेक्शन, दैट इज लुडविग्स एंजाइना. लुडविग्स एंजाइना में आपको क्या दिखेगा? लुडविग्स एंजाइना is basically a superficial spreading cellulitis which is seen in the submandibular space. Submandibular space का मतलब ये स्पेस. It is not a pus containing infection. इसमें पस नहीं बनता. It is a superficial spreading cellulitis. बिल्कुल ठीक, woody hard swelling. तो मतलब एंगल ऑफ मैंडिबल से लेकर सेंटर तक यहां पे इतनी बड़ी एक स्वेलिंग होगी विच विल बी वुडी हार्ड. And the most common route of infection in Ludwig's angina is dental infection. It is dental infection. So dental infection जब भी होता है, it will spread into the submandibular space. The submandibular space is divided into two equal halves or two important spaces. The space is divided by a muscle which is called as mylohyoid into a space which is above the mylohyoid, which is called as sublingual space, because this space contains the sublingual gland, and a space below it which is called as a submylohyoid space. So the submylohyoid space as well as the sublingual space together are called as submandibular space. Any infection which occurs because of any tooth related thing like a root canal treatment or anything related to the tooth can cause infection of this space, and this can lead to superficial spreading cellulitis over in the submandibular and submental spaces. This is not pus containing. We call this infection as Ludwig's angina. ठीक है, fine. So ये याद रखना. What is the most common cause? It is tooth infection. Whenever you see this, इतनी बड़ी swelling, एक side of mandible से other side. So there will be bilateral submandibular space swelling. It will be woody hard, and we call this as brownie neck edema या brownie neck induration. ये दबाने से दबता नहीं है. ठीक है. So because of this edema, because of this so much of cellulitis that has happened, the tongue will get elevated and there is edema which is present over the floor of mouth. Now because of this, क्योंकि tongue elevate हो जाती है, floor of mouth में edema होता है, आपका question जो इससे आएगा वो होगा कि आप इसमें सबसे पहले क्या करेंगे? What will you do first? Number 1, manage the airway, do a tracheostomy. Number 2, start IV antibiotics. Number 3, give a steroid. Number 4, wait and watch. सबसे पहले इसमें क्या करना है? एयरवे मैनेज करना है. डू अ ट्रेकियोस्टमी, बिकॉज इंट्यूबेशन हो नहीं पाएगा, बिकॉज यू कांट सी एनीथिंग. ये जगह ही नहीं है. So the first thing in Ludwig's angina is airway management. You need to do a tracheostomy and first save the airway. After that, you give high-grade antibiotics. What is the surgery that you will do for Ludwig's angina? कुछ नहीं करना है. Give an incision from one mastoid to another mastoid. Suicidal incision होता है ना, एक mastoid से दूसरी तरफ तक ऐसे suicide की तरह दे दिया. So this will decrease the compartment pressure. Nowadays, we have modified this incision. We give one on this side, one on this side. But we have to open it so that we can decrease the compartment pressure all in all. ठीक है? चलो. Final question about pharyngeal pouch, Zinker's diverticulum. So, अगर होगा, this must have been done even in surgery also, that there is something called as pharyngeal muscles या pharyngeal constrictors. Pharyngeal constrictors में दो important constrictor muscle है. One is called pharyngeus muscle, which is ऊपर जो oblique होती है, right? और thyropharyngeus के नीचे एक muscle होती है जो transverse होती है और इसे कहते हैं cricopharyngeus muscle. Thyropharyngeus and cricopharyngeus both are a part of our inferior constrictor muscle. ठीक है? अब there is a potential deficiency या space which is present between the thyropharyngeus above and cricopharyngeus below. This particular defect is called as Killian's dehiscence. So if any, because of uncontrolled contraction of the cricopharyngeus muscle, अगर cricopharyngeus बहुत contract कर गई और thyropharyngeus, is relaxed. So what will happen, because of the pressure changes through this Killian's dehiscence, the pharyngeal mucosa might come out, or it might cause a diverticulum of the pharyngeal mucosa. This is called as pharyngeal diverticulum या hypopharyngeal diverticulum या Zinker's diverticulum या pharyngeal pouch. The second common area after Killian's dehiscence is a small triangle below. This is called as Lammer's triangle. Lammer's triangle की boundaries होती हैं. It is bounded by the cricopharyngeus muscle above and the outer longitudinal fibers of the esophagus below. तो इस triangle को हम second common area कहते हैं for formation of pharyngeal pouch. Okay, fine. चलो, अब अगर किसी के, this I have already done. What are the two things? अगर किसी के pharyngeal pouch हुआ तो याद रखना laryngocele में भी swelling होती है, just lateral to the thyroid. Pharyngeal pouch में भी lateral neck swelling होती है. But how will you differentiate? Both the swellings have got their signs. Bryce sign is a hissing sound which is on laryngocele. Boy's sign is a gurgling sound which is on pharyngeal pouch. So Boy's sign is a feature of pharyngeal pouch. Bryce sign is a feature of laryngocele. This is the most important point. and this is usually on the left side because of the general curvature of the esophagus. So whenever you push that pharyngeal pouch, it will produce a gurgling sound. Why? Because it is containing gastric contents. उसको जैसे ऐसे अंदर करेंगे, it will start producing gurgling sound. What is the investigation of choice? It is barium swallow. So whenever in barium swallow, you see this kind of a pulsion diverticulum. See, this is the esophagus normally. This is the diverticulum which has formed posteriorly. This is a classical pharyngeal pouch. इसी तरीके से देखिएगा, this is the investigation of choice. ठीक है? How will you treat this particular condition? Treatment के लिए we do something called as endoscopic stapling. Endoscopic stapling, or we do something called as Dollmann's procedure. This is what you should know. This is what finishes all in all what exactly is your whole of ENT. तो हमने स्टार्ट किया ईयर से, फिर गए नोज में, फिर गए लैरिंग्स में, फिर गए फैरिंग्स में, एंड फाइनली वी हैव रैप्ड अप द कंप्लीट ऑफ ENT. दिस इज समथिंग which is your whole of wrap up. I would suggest कि आप PYQs देख लो, आप मैराथन देख लो, इससे ज्यादा आपको करने की जरूरत नहीं है, because more or less इन्हीं में से ही आपके questions फंसेंगे. Always remember, I am very happy, there are so many people still watching it, but always remember, when the going gets tough, the tough get going. That's how it is. You guys are tough. You guys have been doing all the mehnat, but these are your slogging days. इसमें आपको चौके छक्के मारने हैं. This is the time where you have to play your T20 well. तो टेंशन लेने की जरूरत नहीं है. Exam are a part of your life. Exam is not life. It's a part of your life. The best part of your life is lying outside. जब इसके just बाहर जाओगे ना, इस एग्जाम को खत्म कर लोगे, उसके बाद बहुत बढ़िया लाइफ है. That is going to be the best things that ever seen, जिसके लिए आप ड्रीम करते हो every day of your life. So manifest. अगर आप मैनिफेस्ट अच्छा करोगे तो डेफिनेटली मिलेगा. मैनिफेस्ट दैट यू आर गोइंग इनटू दैट कॉलेज, ग्रैबिंग द ड्रीम सीट. इफ यू रियली गो फॉर द मून, यू विल फॉल इन द स्टार्स. तो बस जाओ, बस वहां पे पहुंचो. यू विल डेफिनेटली ग्रैब व्हाटएवर यू हैव ड्रीम्ड ऑफ. द ओनली थिंग इज होल्ड ऑन योर नर्व्स, होल्ड ऑन योर करेज, होल्ड ऑन व्हाटएवर यू हैव डन टिल नाउ. सब बढ़िया होगा. यू विल गेट दोस क्वेश्चंस व्हिच यू हैव रेड. It's not about that, but just keep your horizon open. ठीक है? So thank you, Sanchit. Thank you. Really happy that you have joined here. But coming back, hold on to it. This is going to be just one time that you're giving this exam. इसके बाद अगर निकल गया तो फिर खत्म कहानी. उसके आगे फिर एग्जाम ही नहीं देने, फिर कुछ और होगा. फिर MCQ कभी नहीं आने वाले लाइफ में. फिर हमेशा आप बस थ्योरी पेपर लिखोगे PG में आओगे तो. That's another tension job. But अभी की भी जो टेंशन है, that's a sweet tension. इस तरीके के दिन फिर कभी नहीं आएंगे, इस तरीके की रातें फिर कभी नहीं आएंगी. That you are waking up, your friends are waking up, you are grilling every day, you are making every second count. Right? जब 19 सब्जेक्ट पढ़ना आसान थोड़ी ना होता है. Still say कि अंडर ग्रेजुएट से बड़ा ब्रेन किसी का नहीं होता. You guys are right now in the biggest brains possible. आपको 19 सब्जेक्ट को रिलेट करने. So I would still say कि अभी आपके पास सबसे अच्छा टाइम है. That you have got so much to read, so much to learn. This is how we become doctors. ये मेहनत ही है जो आती है. So it's all about discipline. It's all about not about how intelligent you are. It's all about how diligent you are. You are sitting, that's diligence. अगर यहाँ पे 25 लोग देख रहे हैं, I am happy, that is diligence. कि आप बैठे हो. अगर मन भी नहीं है तभी भी बैठे हो. So that is going to count. I would say marathons miss मत करना. Be constant on the marathon. ये मत बोलना कि बाद में देखेंगे. ये मत बोलना कि बाद में आके देख लेंगे. बाद में कभी नहीं आता. That day will never come when you come back and read a marathon. मैराथन उसी दिन बैठो, उसी समय बैठो, and just wrap it out. जो भी टीचर पढ़ा रहे, even if you hear it, 50 to 60% कहीं ना कहीं सुना आ जाएगा, और वो कहीं ना कहीं आपका आंसर सही कर देगा. So hear the teachers out. That's why we have conducted from the MedEd side these free marathons. This is just for you guys. This is just for you all. So we are also slogging with you. We are also hustling with you, so that your days and nights become, much more stronger. You come out much more stronger. Okay, fine. So wishing you all the very best from my side, and I hope you crack on all the ENT questions which have been given to you. I hope it comes within this. And any particular questions that you have, you can ping me over on my Instagram. You can ping me over on the YouTube channel or any personal chat. I'll be happy to answer, or you can actually use our Telegram group and you can just tag me. I'll come and answer your question. So have a good night. Take rest. Have a good night. Eat well. Don't eat McDonald's and not taking the names, but don't eat pizzas and burgers. But this is something, a time where you have to stay healthy. इसमें बीमार पड़ गए तो you will lose 2-3 days, right? तो मैगी मत खाना, बहुत ज़्यादा कॉफी मत पीना, अच्छा खाना खाओ. Don't hog on cold drinks right now कि स्प्राइट लेके बैठ जाते हैं, पूरी रात चलेगी, ऐसे नहीं चलता. पानी लो, have a cup of tea, 1 or 2 cup of tea or 1 or 2 cup of coffee is okay, but don't go beyond in stressing yourself out or giving your health something which it doesn't require. So eat healthy food. That is what the brain will require. In order to go long, you need to eat healthy. Okay, fine. Chalo. So we'll wrap it up. And thank you all for joining today and wishing you all the very best. Thank you. Good night.